I'm good to go, right? Okay, man. I'll let you know in case I need something. Take care. Bye bye. Hi, guys. Good to interact with all of you. So, the most important thing in life is to show up every single day. And I understand that your performance in studies can be, going up and down, just like autoimmune disorders have a waxing and a waning course. Similarly, when we doctors have to study 19 subjects, then what happens is that our performance on one day might be more and on one day would be relatively lesser. Hi, Kevin. Good to see you again, man. I think we have interacted earlier in one of our earlier sessions. Hi, Jarwin, Muhib, Kashyap, Vikrant. In case I missed a couple of names, I really apologize because the chat went up very, very fast. But good to interact with you. Hi, Priyansh, Priyesh. Okay, Dr. Kashyap, Dr. Yash Sharma. So it's a honor for me to be interacting with all of you today. And what I was saying, I'll go back to my main agenda. I really apologize if I missed out a couple of names. You have to, build up your momentum. What basically is required is to gradually peak, and peaking has to come at the right time. You see, all of us operate on adrenaline. That is not to be the case. You have to be calm, just like a monk. A doctor is supposed to be like, at that higher thought process where nothing affects him, because see, you and me have to imbibe negativity from a patient. The most important thing that I want to tell you is like these guys who go into corporate office, they have like these brilliant orange color walls and blue color walls, and there are motivational quotes that are written. There's a coffee vending machine, there's a matcha machine around. Gen Z nowadays, matcha machine. And when you and me go into a hospital, there is no matcha, there is no coffee vending machine. It's like negativity of a patient. पेट में दर्द हो गया, उल्टी हो गया, vomiting हो गया, खून का उल्टी हो गया, right? Blood, vomitous. I mean, we are starting our day by imbibing negativity of somebody. And a doctor, right, when you are gonna do that every single day, after a few years, fatigue will come in. So what I want to tell you is, I want you to be prepared mentally for that you have to operate with a certain level of, I'll not exactly call it apathy, I would say empathy, that you have to realize that the patient is sick, but at the same time, it should not be affecting you at that level that you personally are not able to perform. So coming back to the agenda, I wanted to say, what is you looking for? You are looking for bigger things in life, grit and determination. You have to sit for 8 hours. It's going to be long hours. FMG exam is 5 hours. Most guys lose the capacity to sit that long hours. NEET PG exam, again, killer, right? 3 hours. INISET, again, 3.5 hours. So a lot of people, like in the first hour of the exam, everybody is like, you man, I'm gonna do it. Second hour, the tension tends to go down. So with practice, I'll keep on guiding you, and you'll be able to get into the groove. So I can assure you today, guys, that you are on the path to glory, and today is the day when you make it, because that's a very famous quote. There are only 2 days in a year when you cannot do anything, that is yesterday and tomorrow, but you can make things happen today. So with these words, let's get started for today. In case I missed out a couple of names, Sujata, Chandrasekhar. We'll obviously do basics here. So let's start with cardiovascular system for today. And I'll give you an emergency situation at the moment, and then we'll talk about basic life support, advanced life support. That's the main objective. Okay. So I am perfectly fine. पढ़ना है भाई. You need to sit long hours, and gradually things will come into picture. Okay, guys. Fine, great. So you are posted in. This is just a background question. It's not that I am starting with a multiple choice question. I'll start from basics only, and I will be teaching you theory only. Hi, Dr. Pahuja, Neeraj. I'm getting answers also. So hit the comment button, guys. You are posted in coronary care unit. There's a 50-year-old man who's admitted with a diagnosis of an anterior wall ST elevation MI, and he became unconscious. I mean, we are talking about a crashing patient at the moment. Bhai, English Hindi का combination होगा. Paper तो English में होता ना. Questions are in English only, right? So we will be doing cardiovascular right on the slide, right? So it's emergency medicine and cardiology. The patient has become unconscious, and he has been identified by PVT. What is PVT, guys, by the way? Can guys comment quickly what is PVT, and then we have to also answer in the same thing. You can also comment regarding what is to be done in this patient, right? So what is PVT, guys? Yes, option PVT basically means that the patient would be having a pulseless ventricular tachycardia. I highlight this statement again, guys. It is not paroxysmal supraventricular tachycardia, because that is written as capital PSVT. So what we're talking at the moment is a pulseless ventricular tachycardia, exactly. And the patient is going into code blue. Now, if you look at the information that is present here, checking carotid pulse, there is no point of checking carotid pulse if the patient's ECG is showing a ventricular tachycardia. The message I want to give to you is that every year there would be at least 2 questions to 3 questions on emergency medicine with respect to basic life support and advanced cardiac life support. And if the ECG is saying that the patient is having pulseless ventricular tachycardia, so there is no point of checking the pulse. Verify scene safety. Verify scene safety is like, let me say you are at the airport and an elderly patient has collapsed in front of you. Let me say you are the young dashing doctor. Today you are flying business class, right, from Emirates, and you're flying for an international conference. If somebody collapses at the airport and you are called, that is when you will verify scene safety, because patient might have fallen at a place where, like, I can say electrical cables can be present, or like the moving parts of the escalator can be damaging him. In hospital setting, there is no point of scene safety, guys. So the answer is not B. Please appreciate the fact. Why have I started this discussion? Because we are starting from basics, that is basic life support. But in the hospital setting, it is not basic. It is the scenario is totally different. So the answer is either gonna be C or is gonna be option number D. Now, for a lot of people who are saying C there, right? You are not wrong. You have to give DC shock to the patient. But the point is, will you be able to give DC shock immediately? It will take 15 seconds, 30 seconds, maybe 1 minute for you to, load the machine and press on a button and then be able to do the task. So the most important thing is, and a simple question, दिमाग लगाना नहीं है भाई इस क्वेश्चन में ज़्यादा. Code blue. What do you do in a code blue, man? As an intern, as a resident, तुम क्या करते हो? You have to give chest compressions to the patient. The answer to the first question that I'm going to discuss before you is option number D. What I wanted to tell you is 2 concepts. If it is a field situation, if it is a situation where somebody collapses on the road at the airport, तो आप बोलेंगे कि I will verify scene safety. But if somebody is collapsing in the premises of a hospital, then what you will do is you will be giving chest compressions in the patient. No, Gautam Bache, it is not C as I explained to you, क्योंकि DC shock देने में time लगेगा ना बेटा. आपको you need to put on the pads and then you gonna be giving the DC shock in a patient. But chest compression, because CAB, it's not ABC in cardiology, it is circulation, airway, breathing. So I hope with this, let's begin with a very basic theory that you are supposed to remember. Like what they will give you is a situation where you are at the airport. Let me, on page number 2, I would like you to note with me a clinical scenario which has been asked in the exam. You are at the airport, you need to note with me whatever I am saying. The PDF of the annotated will be available at the end at the link that I put in the group. But I suggest that you write, because then you will be using all the lobes of the brain. God has given us 4 lobes, na? Frontal, parietal, temporal, occipital. So all need to be used. Okay, guys. So you are at the airport. You are flying business class today. Maybe going for an international airport. And though a business class, you can do boarding at any point of time. But out of respect, like there was an elderly person in front of you, so you did not, push him and said, oh, I am business class and मैं पहले boarding करूँगा. It's not like that. You let the elderly person board in front of you. They have just, shown the ticket at the last counter that they check, and then you are walking through that aisle through which you have to walk onto the plane. So elderly patient or an elderly man in front of you has collapsed suddenly. So there was an announcement that, any doctor is available. And आपने volunteer कर दिया, मैं हूँ ना, just like Shah Rukh Khan, you have volunteered that I am there. So the Indigo staff or Emirates staff, they said, okay sir, please come and please help us. So in those circumstances, when they give you a situation like this, elderly patient collapsed in front of you, and like what would you be doing? That is when you will answer SRS. What does SRS stand for? The first thing to be done is verify scene safety. What I mean by verify scene safety is that the patient could have collapsed near an escalator. The moving parts of the escalator can be injuring him. He could have fallen where there could be some electrical cables. He can get electrocuted. Hit the comment button and let me know why do you have death due to electrocution. बिजली का झटका किसी को लग गया. A miscellaneous MCQ to be added here. Suppose there is a child or an adult and this child was playing at the airport. And this child put finger in the electrical socket. You know, small children, they are very very playful. तो वो छोटा सा जो electrical socket होता है उसमें उंगली डाल दे जहाँ पे mobile charging port होता है. So the child can get a बिजली का झटका and it's gonna be 220 volts. So the reason for death would be very good. Prashant, Hassan, very good. I want you guys to hit the comment button within 5 seconds of I raising the question. Just by commenting has to be fast because some questions are gonna be like so easy that you want to save time for difficult questions. If you are an FMG student, देखा पिछली बार 4 line MCQ, 5 line MCQ. If you are a NEET PG aspirant, 1 liner, 2 liner, but very precise. In my opinion, 1 liner is more difficult because there is paucity of data. Electrocution, very good. Your answer is ventricular fibrillation. I'll just use a finer font. I think that will look much more attractive here. So give me a second. Yes, guys. If a patient gets electrocuted, the reason for death is ventricular fibrillation. Very good. I had a no, बच्चे, it is not respiratory failure नहीं बोलोगे. Arrhythmia में तो बड़े सारे arrhythmias दे देगा ना. If you read about electrocution, the first thing that hits a person is ventricular fibrillation. So you have to verify scene safety. That means person should not get electrocuted, moving parts of the escalator. Now what will you do? You will tap on the shoulder of the patient. Sir, on the boarding pass name can also be there. So Mr. Gupta, can you hear me? Mr. Gupta, can you hear me? And you know, sometimes somebody can be a diabetic. His blood sugar might have fallen. So he might be lying with his eyes closed like this, but he is not unresponsive. You know, if blood sugar becomes less, the patient might become very, very drowsy. Like this diabetic, he had his medicines, but like he did not have his food because he was late for the flight. Now the sugar started falling, and the person has become like I would say very weak and he's very, very drowsy, but he's not unconscious. So he might not open his eyes, but if you touch his hand and say, Mr. Gupta, can you hear me? Can you squeeze my hand? Just squeeze, touch him, touch the patient and say, sir, can you squeeze my hand? And if he squeezes your hand, that means he's okay. So what you need to do is check responsiveness. Bache, abhi it is not check pulse. The point is, he will say arrange them in the correct order. तो आपको याद क्या करना है? He will say what you should be doing is check scene safety S, responsiveness R, then is shout for help. By shout for help, it doesn't mean that you are gonna scream your lungs out. Obviously, you will say anybody who has taken basic life support training can come and assist, and most of the time the airline staff are trained in the basic life support algorithm. So when you say shout for help, yeah, the patient, like, you know, the nursing staff has come, or like, you know, the airline staff has come, nursing staff in the hospital. Here it's gonna be like the airline staff has come to you. So SRS. What will you do after SRS? That was a question in the exam. Very, very simple. So you will say that after, like, I called somebody for help, because you need 2 people for giving, you know, CPR. One gives chest compression, second gives rescue breath. If he says, what will you do next? You will ask that person to take out the phone and call 911 in America, or like in India, call 102. You see, in America, if you call 911, the ambulance will come to the house of the patient within 4 minutes. That's the rule, ideally. In India, you keep on calling 102, nobody will come. They will not even pick up the phone. But still, according to the algorithm, if the algorithm, no, doctor will not panic, bachao, doctor is not saying bachao, he's saying, come, you will ask the airline staff, and if you learn BLS, come over, right? So you need to be the boss, you need to be confident, right? The positivity has to exude from you, man, right? You will not say bachao, right? Okay, so activate emergency response here. Fine. So activate emergency response means that इसको note कर लेना. You know, point number 4 to be noted is AER. AER stands for activating the emergency response, and that means that you have to call 911. And if you have ever called ambulance services in India, तो आधा टाइम तो फोन ही नहीं उठाते. And phone उठाते तो कह रहे कहाँ आना है ना. By the time you give them directions, person may die. So it's very, very bad. And I think all of you know IIT Delhi के 2 guys, the guys who created Blinkit. They have created ambulance services. You call up the Blinkit ambulance man, it will reach you within few minutes if you are in Gurgaon. Can you beat that? If IIT Delhi, two guys in a Blinkit, which is supposed to be like a commercial platform selling masala and chai and all those stuff, if those guys can arrange an ambulance service, government of India definitely can, right? So it's all about the will to help people. Anyway, coming back to the agenda, I'm not promoting Blinkit anyway, but I want to say two chaps from IIT Delhi, brilliant guys, man. You know, if you look at Dipinder's interview, I mean, a very, very resourceful person. Anyway, coming back to the agenda, activate emergency response. And after activating emergency response, yes, guys, hit the comment button. What will you do next? What will you do next? The person who has come, usko bola, sir, take out a phone and call the emergency number. And simultaneously, what you will do is, you will ask that person to procure automated external defibrillator. I hope everybody is very, very clear that life is not saved by giving chest compression. Chest compression से जान नहीं बचता है. किससे जान बचता है? Automated external defibrillator से. So you will ask the staff, like, you know, the Indigo or the Emirates staff, that ma'am, sir, please go and get the automated external defibrillator. And I think I'm talking to a lot of people who do a lot of flying, and a lot of people might have traveled internationally. So at every boarding gate, it is mandatory to have a automated external defibrillator. Even if you travel by Delhi Metro or any metro anywhere, at every platform, there is a AED that is mandatory. So it is automated external defibrillator that will be used. I think it is very, very clear to everybody. It is not automatic. It is automated external defibrillator that has to be procured in this particular case. So it is AER, then is AEDP. Let's do a quick recap. Abhi aapko lagega, sir, it is so simple. We will remember it. After 2 months, people forget and they, you know, make a mess of the situation. So you just need to remember SRS, AER, AED. Scene safety, responsiveness, shout for help or call for help. Then is automated external, activate emergency response and get procurement of the automated external defibrillator. If you travel through, like, you know, Dubai airport would be like, you know, 100 flights going together. You know, there are 100 boarding gates at the Dubai airport, almost like close to 100. So the medical room, if you observe the airport, you will notice they made the medical room on the top. And the doctor who's sitting in the medical room, he's having so many monitors in front of him. And from that monitor, he can see if somebody crashes at the boarding gate, somebody collapses at the boarding gate, the doctor has to just press a button and the drone will be carrying a AED. A drone will be carrying a AED to the site where the person has collapsed, because see, getting 100 AEDs in place at every gate is again going to be a logistic challenge. So what they're using is tech. They're using geolocation and they're ensuring that the person gets the best medical care in the shortest possible time. So it is procure the automated external defibrillator. And meanwhile, while you are talking to the staff, your eyes will not be maintaining eye contact with that Indigo staff or Emirates staff. In point number 5, listen to my words very, very carefully. In point number 4 and point number 5, the doctor will not be maintaining eye contact with the person who has come in front of you. Normally, when you talk to somebody, you maintain eye contact. Your eyes will be on the chest of the patient. You are looking at the chest of the patient. You're saying, Mr. Gupta, you are okay. You said somebody, hey, you come here. Have you learned basic life support? He says, yeah, sir, I have. So you say, okay, man, can you just take out a phone and call 911 or 102 and get me the AED machine? And your eyes will be on the chest of the patient. Now, let me know, guys. Let me know here. Will the doctor first check the pulse? Or would you check for breathing? Hit the comment button. Hit the comment button. What is the doctor supposed to do first? Would you like to first check the pulse, or would you like to check for the breathing part? Let's not talk about the tax at the moment, right? When you start earning, I'll teach you the tax hacks also. Yes. First is you would look for evidence of breathing. Like you will look for whether the person is having any chest movements or not. So look for whether there is any no breathing present or not. I mean, any breathing efforts are present. You will keep your hand near the nose to check for the breathing efforts of the patient. And along with no breathing, you will also have to check the pulse of the patient. And which pulse will you check, guys? So you will be checking the carotid pulsation, because this would be closest to the heart. Very good, very good. First to check breathing, then is check carotid pulse. A doctor is supposed to hit the comment button again. A doctor is supposed to spend how many seconds in doing both of these activities? While I'm waiting for your answer, I'll say this again. I will not maintain eye contact with the person who had come to assist me. I will be looking at the chest of the patient to look for chest movements, and I'm checking the carotid pulsation of the patient while I'm doing the talking simultaneously. So 4, 5, 6 should be together, and a doctor should be spending how many seconds doing all this activity? It is 10 seconds for all of them, 4, 5, 6. I said, oh, you come here. And I said, okay, can you get me the AD machine? And meanwhile, my hand is on the carotid and I am checking for carotid. I'm looking for the breathing efforts in a patient. Very good. It would be 10 seconds. Great. It is not 5 seconds, but somebody commented 5 also. 10 se multiply karenge na for 1 minute, like you suppose you get 5 pulsations in 10 seconds. That means you multiply by 10, that would be 50 beats per minute. Like there can be bradycardia in the patient also. So unfortunately in my patient there was no breathing and carotid pulsation of the patient is also given to be absent. If the MCQ satisfies this statement himself, like he says, patient had collapsed at the boarding gate, the doctor is attending to the call, there is a second person coming for securing the airway, the doctor is evaluated, no breathing, carotid pulsation is absent, then you will say that I will immediately start in this patient chest compressions. That would be at a ratio of 30:2. That is 30:2. This 30:2 would mean कि 30 क्या होता है? That would be chest compressions. ये 30 जो होता है, this would be chest compressions. And 2 would be obviously the rescue breaths in a patient. So you need to start CPR in a patient at a rate of 30 chest compressions. Question for all of you, and I would like everybody to hit the comment button now. Please let me know, these 30 chest compressions should be given in how much time? These 30 chest compressions should be given in how much time? Waiting for your answers, guys. This is very elementary, very basics. I think you had anesthesia also. So can you let me know? Even there they teach you critical care. So 30 chest compressions should be done in how much time? You want me to give options? 15 second, 30 second, 45 second, 2 minutes. Okay, 1 minute. 1 minute, 1 minute is the answer coming, 2 minutes is the answer coming. No, bache, you are making a huge mistake. Some people have got the correct thing. Kastub and couple of other people, I missed the names there because the chat went up very fast. You would be spending kitna seconds? 15 seconds. A doctor is supposed to give 2 chest compressions. Mark my words there. Forget about everything else that I'm going to teach you today. This should never go wrong. Mark my words there. This should never go wrong. A doctor is supposed to give 2 chest compressions in 1 second. That would be 60 into 2, which is about 120 per minute. मैंने बोला 30 कितने में देंगे, तो आपको mathematics करना था. That is like 30 would be done in 15 seconds. 15 twos would be 30. Yeah, I did not ask the rate na, guys. Rate मैं करूंगा अभी. I'll ask you the rate. I asked you a simple fact, like our doctors will be giving, like sometimes in the question he will just say like this, in 30 chest compressions should be completed within how much time? Then your answer would be that you will do it in 15 seconds. So the chest compressions का जो rate रहता है, that is okay. I mean, if you are attempting that MCQ, suppose I ask you, the doctor, like, what is the chest compression rate required? This has been asked in FMG, this has been asked in NEET PG. Options were less than 100, equal to 100, more than 100. The answer is obviously more than 100. The answer will be that the rate will be 100 to 120 per minute. So obviously, like, no prizes for guessing that. But like, I changed the question in a different year and I found that the question was 30 chest compressions kitne time mein karenge, then would be 15 seconds. Now obviously you need to go for rescue breaths also. So at the airport, in the medical room, ambu bag is also available. In the emergency room, in the medical room of the airport, ambu bag is also available. So can you tell me how many rescue breaths should be given in 1 minute? How many rescue breaths should be given in 1 minute? You want me to give options? Okay, 4, 6, 8, 10. 4, 6, 8 and 10. You are using a artificial manual breathing unit, ambu bag, which is available. How many breaths per minute would be given? Exactly. Dipanshu and everybody else is now coming the correct data. Yes, guys, the rescue breath guidelines, the updated guidelines are that you have to remember it is 1 breath every 6 seconds. It is 1 breath every 6 seconds. Must know information for you guys today is a doctor is supposed to give 2 chest compressions in 1 second. That was per second. Here I'm saying 1 breath every 6 seconds. So like in 1 minute, there would be 10 breaths per minute. So I think, yep, here I got the correct answer immediately. But for the second one, I was able to trouble you. Now comes the question, 1 cycle of CPR will be for how many minutes? There are 3 questions. I have covered 2 at the moment. Let me complete the first 2. In 1 second, 2 chest compressions, 62 is 120, हो गया, याद हो गया? I hope so everybody has remembered that. 1 breath every 6 seconds would be 10 breaths per minute. That's the second one that is sorted. The second one was, what is the duration of one cycle of CPR? This was asked in FMG exam. What is the cycle of CPR? One duration of cycle of CPR, the duration, that would be 2 minutes. What do you mean by 2 minutes? By 2 minutes, you mean that then there will be a position swap. Like suppose I am giving chest compression, you are giving rescue breaths. After 2 minutes, I will get tired. So you will come and take my position of giving chest compressions and I will come and take your position. That would be, I will give rescue breaths to the patient. So one cycle of CPR is 2 minutes and there will be a position swap that would be done. What I imply by the word position swap primarily is, what I understand by the word technically the position swap is position swap of the rescuers. It is a position swap of the rescuers that would be done. Like I am giving chest compression, I'll bound to get tired, no? And I think everybody is realizing that the first 4 minutes are critical. Count my fingers, okay, in the camera, 4 fingers, right? First 4 minutes, sir, brain dies within 4 minutes. Irreversible brain injury. If you are trying to save somebody after 4 minutes of collapsing, you are just literally punishing the family unnecessarily with financial burden. There is no point of trying and saving the person, though it will look unethical to say that, but the guy will be in a vegetative state, guys. They'll have to keep a nurse at home, portable ventilator at home, they'll have to set up an ICU at home, no point. So everything has to be done in the first 4 minutes. That is why the American Heart Association slogan is push hard and push fast. That push hard and push fast means that hard se matlab kya? Hard se matlab kya? What should be the depth of sternal depression? What should be the depth of sternal depression? This has been asked in any set exam also. It is options were 3 to 4, 4 to 5, 5 to 6. So a lot of guys got confused. These are close options. In the paper, it's going to be close options. Remember, it is 2 inches. They've asked what is the minimum duration of sternal depression, what is the maximum amount of sternal depression. It is 5 to 6 centimeter. Yes, Karthik, Vaishnavi, Kushagra, everybody was spot on. Priyesh, everybody was spot on for that. So you need to give about 100 to 120 chest compressions every minute. That is the rate of chest compressions that I'm talking about. And then is going to be the depth of sternal compression 5 to 10 centimeter. What is the site of the chest compression? It would be the lower 1/3 of the sternum. The options in the MCQ were upper 1/3, middle 1/3, lower 1/3. So very simple, lower 1/3 of the sternum pe you will be giving chest compressions. The rationale is obviously to maintain the cerebral blood flow, and now you have to comment. No बच्चे, you are not supposed to press on the xiphoid. बच्चे वो आपने ना शायद गलत से टाइपिंग कर दिया है ना, जल्दबाजी में टाइपिंग हो गया. लोअर xiphoid नहीं करेंगे ना. It's a typographical error. I can understand. What you mean is lower 1/3 of the sternum, but you will not give pressure on the xiphi sternum. क्यों? Xiphi sternum is very pointed. If a doctor has not practiced, then he could be giving undue pressure on the xiphi sternum. The doctor could be giving undue pressure on the xiphi sternum, and that could result in damage to a solid organ. This is a question that said, what is the most common solid organ? You can note with me, what is the most common solid organ traumatized during CPR? When the question says, what is the most common solid organ traumatized during CPR, some students casually answered it as the lung. Now, when the student was talking to me after the paper, he said, sir, I screwed the answer. I said, क्या हो गया भाई? कह रहे sir, the moment I am now discussing with you, I am realizing that I did a wrong thing. I answered lung, but lung is not a solid organ. Yes, guys, you are perfectly right. Your answer would be liver, not spleen. But spleen would be left, man. Left spleen is gonna be left, right? So you are gonna be injuring the left lobe of the liver. The most common solid organ that can be traumatized during chest compressions while giving CPR in a patient is the liver. And the villain in this case is that the doctor not practiced on the dummy. So it would be the xiphi sternum, which is very pointed, and it can cause an injury. At this junction, I want to tell you that after you clear your, these exams, whether it's NEET PG or FMG, I would suggest you to do BLS and ALS course. Because if you will apply for any job, suppose at Fortis or Max or Apollo Hospital or anywhere else, the first thing in the interview that they will ask you is, have you done BLS ACLS course? If you say no, the interview is over. Obviously, like if you clear NEET PG, the result will take 3-4 months to come, then the counseling will happen. So it's gonna be like almost 6 months. You would be without any money. So you have to apply for a job. If you are an FMG student, you have just completed your internship after clearing the exam, or some of you have already done internship abroad. If you go for a JR non-academic post, they will ask you in the interview what I'm telling you at the moment. This that I'm teaching you is not only from the exam perspective, but from your employment perspective, guys. I mean, if you want to make money, if money is the motive that you want to do, if you are a first generation doctor like me, middle class, and you say, no, sir, I'm 23, 24 years of age, I need to make money, you need to learn all the aspects that I'm saying. Exam to tum nikal hi loge yaar, you are brilliant boys and girls. I mean, clearing exam is no big deal. I'm very sure you're going to do it right in the first attempt, but then employability also matters. So now, okay, Pranav, you broke the dummy. So next time, don't hit the patient so hard. Okay, what is the fulcrum movement? Fulcrum movement, right? Hitting 1, 2, 3, 4 for me. Hip joint, shoulder joint, then is the elbow joint. Elbow joint ka spelling thoda sa galat ho gaya. And then is gonna be the wrist joint. Anyway, come back to me guys with the answer. What is the fulcrum movement when you are gonna be giving chest compressions to a patient? Like, you will be interlocking the fingers, right? Interlocking the fingers. Elbows should be straight and you lean on to the body of the patient. You lean on to the body of the patient. So a lot of us would be scrunching our shoulder also, but then this is a physics concept that they're saying. What is the fulcrum of the movement? Very good guys, the fulcrum of movement is point number 1, the hip joint. So let me just move up in the slide and show you that they can give you images, and what I want you to understand is that you're not supposed to slouch like this. Most of us, we tend to go on our knees like this, maintaining a acute angle. Don't try to maintain an acute angle. Try to maintain an angle of like something hitting 90 degrees. Obviously, it would be not exactly 90, but you need to ensure that the angle that you maintain here is a bigger angle. This will automatically ensure that the hip joint will be the fulcrum. It is a physics concept that I'm saying. The fulcrum movement is that you need to push down. What I mean by push down is, don't even apply force from your shoulder. A lot of doctors do the shoulder like this, or then they do like this. Then you gonna break the ribs. That's why you broke the dummy, man. That's why you broke the dummy, because you were using your traps. Maybe Pranav is doing a bodybuilding, right? Pranav is having big traps and big latissimus dorsi. So when you are gonna apply force, you're gonna break the dummy and break the patient's chest. So you don't need to at all use your muscles, guys. The weight of your head, listen to me carefully, the weight of your head, the weight of your neck, and weight of your chest. The weight of your head, the weight of your neck, and weight of your chest is sufficient to bring down the sternum by a magnitude of 5 to 6 centimeter. You don't need to use muscle power. Especially guys who are sitting here, if you do bodybuilding, bhai, muscles use nahi karna hai. This is not a muscle flex. The weight of your head, neck, and chest is sufficient to depress the sternum by a magnitude of approximately 5 and 6 centimeter. So don't flex your muscles there. Don't become breathless. Most doctors become breathless. Most doctors, भाई तुम्हारा खुद का कार्डियोवास्कुलर सिस्टम ऐसा नहीं होना चाहिए, right? You should not be breathless at the end of 2 cycles of CPR. So you tend to become tired. Why? Because we tend to slouch our shoulders, and then obviously your elbows should be straight, your arms should be still, and shoulders should be directly above the sternum. So I've said two physics ka concepts. One is the fulcrum of movement is the hip joint. Fulcrum of the movement. These are technical statements in the MCQ. The fulcrum of the movement should be the hip joint, and the shoulders should be directly above the level of the chest of the patient, and you would be able to manage the patient effectively better. So yep guys, the fulcrum movement is answer number 1. It's the hip joint. Good answers by everybody, and yeah, keep the light banter on. That keeps the enthusiasm going. So the most common solid organ traumatized during CPR happens to be the liver. I think zoomed in for a better resolution. Now you will tell me, since all of you are saying ribs now tell me most common ribs. वही कह रहा हूँ भाई, पूरा बॉडी का वजन थोड़ी ना डालना है यार. 100 kg छाती में थोड़ी ना होगा. It's not whole of your 100 kg on the chest only. Yes. If ribs fracture, yeah, it was not. It was incorrect. But anyway, it होता है यार. You will crack a couple of ribs. It's okay. I don't need to discuss that MCQ ना. कि if you fracture a rib, what will you do? Continue CPR. Saving a life is more important. Ribs can be joined later. Ribs will join if he lives. But patient बंदा तो वापस नहीं आने वाला ना हमारा. The patient is not going to come back. Yes, the most. Very good. Even before I could ask Akshay, Sai, Ayush, Karthik, Sankalp, I love the banter. I love the spirit, man. The most common rib fracture during CPR. The most common rib that is going to be fractured during CPR is going to be the 4th to the 6th rib. So the datas are very simple and straightforward. It is just a quick practice that I have seen. Yeah, as I said, I mean, this will happen, but we need to minimize. Collateral damage bolte hain isko. Collateral damages in the crossfire, the injuries can occur. So the most common rib that would be injured is the 4th to the 6th rib. And now, while you're doing this activity, the AD arrives. This was an FMG exam question. वो बोला AD arise, what will you do? Your answer is continue CPR. The AD arise, what will you do? Answer is continue CPR. You will not stop doing CPR at any point of time. One guy is continuously to do CPR. And while I'm going to do some theory aspect here, I want to share an incident with you which happened about 2 years back at the Delhi International Airport. A guy was boarding for a flight when he collapsed at the boarding gate. The moment he collapsed, there was a CISF constable standing nearby. That CISF constable saw that the guy had collapsed. The easiest thing for that CISF constable would have been that he would have started giving chest compressions and waited for the doctor to come. He did not wait for the doctor to come. He realized the guy is not breathing. He realized that the guy's carotid pulsation is absent. So he immediately got the AED machine. He put, you will notice in the video, with one hand he's giving, with one hand, because obviously like his hands would be busy, he's the alone person. With one hand he's trying to give chest compressions, and other hand is opening the AED machine. You have to power on the AED machine. How does a AED machine look like? I'll just move on up in the slide. Yes guys, you can see here that this machine that you can see here is called as the AED machine. That is a automated external defibrillator. This machine that you can see on page number 1 is called as AED, and the second machine that you can see, this is adjacent to it, is not AED. This is in the hospital. In the hospital, the machine that we have by which we give DC shock to the patient is called as defibrillator. But in a peripheral situation, in a field situation, at an airport, at like a gym, etc., or a metro station, it is an automated external defibrillator. Yeah, Sujish, I mean, that can happen, no? Women and osteoporotic women, anyway, AED. So it is automated external defibrillator that would be present. That was in a field situation. What you are seeing is a defibrillator at the moment, and you just need to power it on. So obviously, like I'll move down in the slide. This is what I'm saying. The AED alives, continue CPR, power on the device, and then you have to put the AED onto the chest of the patient. Let me know on which side would you be putting the right pad, and on which side would you be putting the left pad. I mean the sides or the intercostal spaces. Hit that in the comment button. The point to be understood is that in the AED we use the word pad and not paddles. जो paddle word होता है, जो paddle word होता है, without AED BLS cannot resuscitate. No Gurupreet, it's not like this, but then it's not going to save the life. Now you will not be able to save, like if there's a arrhythmia occurring, the arrhythmia can't be treated by chest compressions alone. Na? If it's most of the time OHCA, out of hospital cardiac arrest, why it occurs is because of arrhythmia. So the main treatment for OHCA, that is Gurupreet, the query that you raised was OHCA, that is the out of hospital cardiac arrest. It's an arrhythmia that needs to be terminated. Very good. So I think everybody knows this, but I'll just do a quick diagrammatic representation. Like you can do this with me as well. This is the shoulder bone, the collarbone, the clavicle. This is the sternum. This would be the lower part. This is the fourth rib. Nipple is usually the fourth intercostal space. So I got very correct answers there. Your answer is going to be, you will be putting the right paddle like this. This is right pad, PAD. Right pad kahan pe lagate hain? So the right pad would be put. Most answers are correct. I wanted to give a lag period, breathing space for people who have not commented, and if you are not, then why are you not commenting, right? You need to answer all these. That would be that you would be placing the right pad on the second intercostal space, on obviously the right side. And this is going to be the parasternal line. PSL stands for parasternal line. They use short forms in our MCQs. So if you studied abroad, you might be having issues with short forms. If you studied in India, then obviously short forms is a normal thing in the jargon, in the files, and in the MCQs as well. So second intercostal space, right side, and the second and the parasternal line, and the left one will be placed at the apex of the heart. Obviously, you see, हमारा heart ऐसे होगा ना. Our heart will be like this. This is the left ventricle, right ventricle, atria, left atria, like this, the axis. So the pad would be placed now in the fifth intercostal space, and this pad will be going in the axilla. The comments of yours are perfectly fine. I'll write that once again, but I just wanted to sensitize. This is the 5th intercostal space. It's a range, 5th to the 6th intercostal space. This would be the left pad, and this would be placed in the mid-axillary line in the patient. Okay, not a problem. I'll not touch the technical part here. Fine. So this is right and the left pads that I've written. You can practice with me again. Left pad, mentally visualize karo. The left pad will not be put like this. I'll put my hand. Okay, I'm not visible. I'll little raise myself. Okay. So the pad would be, I'll use my different hand. The pad would be put not on the apex like this. Okay, not like this. It's gonna go a little laterally. You can see I'm placing my hand. Yeah, it's better in the camera now. This is going towards the axilla. So this is the side where I'm gonna put the pad. So the left pad is 5th intercostal space on the left side. This is going to be the mid-axillary line, and if it's the right pad, then it's going to be the 2nd intercostal space on the right. That would be the parasternal line. So these are the PAD, the pads that would be placed here, and then the middle of the pad in the mid-axillary line. Perfectly right. And there would be wires, man. There would be wires that would be going from the device to the AED. So I've just drawn a crude diagram here at the moment before you, and we have done the connections at the moment. And once you've done the connections, now the machine itself will be doing a rhythm check. The machine, the meaning of the word automated is that the machine itself will now be doing a rhythm check at the movement, and because it's going to do a rhythm check at the movement, it will deliver a DC shock to the patient. In your paper they said what is the intensity of the DC shock that would be given. The intensity of the DC shock that would be given would be 200 joules. To make it sound sophisticated, he may write the word uniphasic DC shock, biphasic DC shock. All AEDs nowadays are programmed to deliver at 200 joules biphasic. You have to continue doing the same activity, CPR, and if required, the machine gives a shockable rhythm, give another shock to the patient as well till the advanced life support team comes. Earlier, like, there were machines which were 360 joules monophasic also. So if you do MCQs prior to the lockdown, 2020 से पहले वाले जो MCQs थे, उनमें they used to mention 360 monophasic also. But currently it's gonna be like 200 joules biphasic as well. So I think it's very, very clear. And now my question to all of you, while I'm writing the answers once again, most common rib fracture has already been told to you. 4 to the 6th ribs, I think सबको याद हो गया होगा. And most common solid organ traumatized during the CPR is the liver. So let me know that if you are doing all the things that I've taught you till point number 9, if you are going to be doing all these things in the casualty of, let me say, Safdarjung Hospital, Delhi, AIMS Hospital, New Delhi, or in Government Medical College casualty of yours, would you be calling it? Would you be calling it basic life support, or would you be calling it advanced life support? Suppose whatever I have discussed here before you, if 360 joules, that's what the PYQ section has to be there, na sir. We can't eliminate the entire 360 joule monophasic, na. I said in the old MCQs, we can't remove all the old questions, na. That is why I sensitized you to the fact that the older MCQs used to have 360. So the query of students is this only, कि sir, वो तो आप तो बोले 2020 वाला जो data है, तो भाई we have to introduce it to you to the entire data, na. Yes, if you're doing this in the casualty of your hospital, you would still be calling it basic life support. This would still be called as basic life support. Whether you are doing it in the hospital, whether you are doing it in the ambulance, whether you are doing it in field situation, everywhere it is basic life support. So the question then arises, what is advanced cardiac life support? Yes, guys, what is advanced cardiac life support is what we are going to discuss next. That in advanced cardiac life support में क्या होता है? तो in advanced cardiac life support, it is emergency drugs. The comments that came here were divided. The comments that came here were divided. So let me clarify for those of you who did not get this correct. Most of you, 70-80% students were correct in the question that I read. If I say to you, the doctor, what is advanced cardiac life support? Then advanced cardiac life support is use of IV drugs. What are the IV drugs that you will be using? One of the most important IV drugs that we will be using for our management is adrenaline. Along with adrenaline, the second molecule that we will be using is like epinephrine. Adrenaline and epinephrine means the same. Basic life support training is for everybody. Basic life support to non-medico people can be doing. Like you might be doing training with police people. You might be doing it with school children. You might be doing it with a lady, she's 60 years of age, usko English bhi nahi aata. She says my husband had a cardiac arrest last month, and he collapsed. And now I was all sweating. I was not knowing what to do. So she has come because she says my husband is a heart patient. By the grace of God, he was saved. But I want to know what is to be done if he collapses again. So like basic life support is for everybody. but for advanced cardiac life support, it is exclusively for doctors. I've got two brilliant answers. That is, emergency drugs would be like adrenaline, epinephrine. They're used alternatively. Then emergency tray will also be containing amiodarone or lignocaine that we'll be discussing here. What is the third drug usually present? Yes, Anuradha, you are spot on for that. That the drug that would be present here is atropine, because lots of time patients will go into bradycardia. Lots of time जो patients होंगे ना, they will go into bradycardia, and for management of symptomatic bradycardia, it is atropine to be given for the person. I mean, any patient who's having symptomatic bradycardia, it would be atropine that would be done. So we need to be like, be prepared for all situations. Tachy भी हो सकता है, brady भी हो सकता है. So we need to be prepared for all of them. So in advanced cardiac life support, we are using IV drugs. The second difference is, and I want you to pay attention to the next words that I say. Since you have learnt anesthesia, please let me know the DC shock machines, though this is more of like anesthesia kind of a question, the DC shock machine fires the impulse with respect to which wave of the ECG. The DC shock machine fires the impulse with respect to which wave of the ECG. Your technical answer will be that the DC shock machine fires the impulse with respect to the peak of the R wave. You see, we have programmed the DC shock machine to search for the R wave, and if the machine will search for the R wave, then the technical word I would like to use here is called as synchronized DC shock. On the defibrillator machine in the hospital, there is a sync and a non-sync toggle button. There's a toggle button, you can just shift left, right. On one side it is written sync mode, other side it is written non-sync mode. So if in the arrhythmia of the patient or in the ECG of the patient, if R wave will be present, then you will select the sync mode, which is alternatively also called as cardioversion. You see, a non-medico person cannot be taught all this. Basic life support is for even school children. Even children are taught basic life support. But adult people, or obviously adults are taught basic life support, even children are taught basic life support. But advanced cardiac life support that we're going to be studying is exclusively for doctors or medical professionals. And the technical word is the machine will be firing the impulse with respect to the peak of the R wave. Now, my patient is having a arrhythmia like this. The ECG is all dancing all over the baseline, My patient has gone into ventricular fibrillation. If person will go into ventricular fibrillation, then you can see machine will not be able to search for the R wave, because there is no R wave, na. There's a particular shape, no. You have a Q, you have a R, you have a S. So the machine is taught by the coding team to pick up the R wave. Here there is no R wave, so the machine will get confused. If the machine will get confused, it will not fire. So what I need to do as a doctor is, I need to shift the position of the toggle button to the non-sync mode for ventricular fibrillation, guys. If he specifically says ventricular fibrillation, or if he gives you a ECG which looks like this, this is a more of a, draw it like a sinusoidal pattern, draw it like a sinusoidal wave at the moment. Though I'll teach you more about this subsequently, but the message at the moment is that if a person is having VT, that is ventricular tachycardia or ventricular fibrillation, then the wave does not look like a normal R wave, because the machine is not able to identify the R wave. For these two tachyarrhythmias, you will be selecting what is called as the non-sync mode of DC shock. This non-synchronized DC shock that you are using for the patient is technically called as defibrillation. This non-sync mode that I am teaching you at the moment is what is called as defibrillation. English se kar lo na yaar, defibrillation is done for ventricular fibrillation. So the only thing you need to remember is ventricular tachycardia. इन दोनों को छोड़ के, except for these two, for all other tachyarrhythmias, your answer will be cardioversion. I repeat my statement. Only 2 times in your exam will you be answering the word defibrillation. One is for a crashing patient of ventricular fibrillation. English, defibrillation for ventricular fibrillation. And second one for ventricular tachycardia. इसको छोड़ के, except these two, if any other tachyarrhythmia is given, whether you know the name of the arrhythmia, whether you know the ECG parameter or not, it really doesn't matter. You just answer for crashing patient. If any arrhythmia is given, except the names on the board, answer what? Cardioversion. What I wanted to explain to you at the moment is that DC shock is of 2 varieties. What I wanted to explain to you is that DC shock is of 2 varieties, the sync mode and the non-sync mode. But in multiple choice questions, what are the words used by the examiner? The words used by the examiner are cardioversion and defibrillation. आई होप मैं आपको समझा पाया हूँ. आई से दैट इन हिंदी एट द मोमेंट डिफिब्रिलेशन कहाँ पे करना है तो इंग्लिश में करेंगे डिफिब्रिलेशन फॉर वेंट्रिकुलर फिब्रिलेशन एंड वेंट्रिकुलर टैकीकार्डिया. एक्सेप्ट दीज टू, कोई सा भी एरिथमिया दे दे, कोई सा भी नाम दे दे, मैट, एट्रियल फिब्रिलेशन, एट्रियल फ्लटर, तुमने सुना है नहीं सुना है, डोंट गिव अ डैम. सीधा आंसर क्या होगा? कार्डियोवर्जन. Provided patient is crashing, right? I'll teach you drugs of choice for arrhythmia also, but most of the questions that come in the exam are so easy that if you release a crashing patient, you have to either answer cardioversion or you have to answer defibrillation. You're not supposed to answer drugs in this particular case. Please hit the comment button. Let me know if this concept is clear, guys. I hope, is it clear? Can I have quick answers at the moment whether like I have been able to explain this successfully or not, or I will repeat it. Yes, guys, waiting for you guys to quickly comment whether you were able to understand the concept or not, and I can proceed further. Advanced life support, IV drugs, and the type of DC shock that would be given in the patient. It is either cardioversion or it is defibrillation, because then I will be introducing more technical aspects at the moment. I hope, guys, that I have been able to explain this to you. I've tried to do that both in Hindi and English, क्योंकि simple सा data है. और paper यार actually क्या होता है, मैं I'll say like this, the paper is purely in hardcore British English, sadly. Hardcore British English. So a lot of people like they say कि सर हिंदी में पढ़ाओ, तो मैं routinely like I was taking a face-to-face class yesterday, तो I was going in Hindi, but then I realized, you know, when I spoke to these people who are maybe sitting for second attempt, third attempt, they said, sir, paper में ना we are not able to analyze things. So I said, no man, I'll switch to primarily keeping my primary modality of interaction as English only. Okay, guys, so I can move on to the next point. I mean, advanced life support में IV drugs are used and then we go for DC shock, and this is the difference from basic life support. The minimum that I expect you to know at the moment are the algorithm that I mentioned. तो इसकी थोड़ी photographic memory. Doctors are supposed to have a photographic memory. This organization, he will say arrange them in the correct order. So I hope that you will be able to remember SRS, AER, AED, as I've explained to you at the moment. That is ADP means the procurement of the automated external defibrillator. And after this, I'll be in a good position now to talk about more technical aspects related to what is called as advanced life support in a patient. So I will be giving you a couple of clinical situations. There is a printout which is given here, and instead of like marking in the printout, because it will become very easy for me, मैं क्या करने वाला हूँ, instead of like, you know, marking tick mark in this, I will do practicing of this entire table in front of you so that you are able to understand and remember the concepts. So hear me out for the next 1 minute, and then I will put up a question for you guys. The question goes like this. Today in my hospital, a patient has come with chest pain. The chest pain started at 8 a.m. in the morning. Now it's almost going to be 1 o'clock. So patient went to some district hospital. Now is reached our teaching hospital. And when I did ECG, the ECG is showing a very classical ST segment elevation with a T-wave inversion. I have a patient today in my hospital. He came with development of very severe chest pain. He's having a lot of sweating. Like the air conditioning is running fine. I'm not sweating. My colleagues are not sweating. The guy is sweating buckets. This guy has presented with ST segment elevation MI. So you can notice a very prominent ST segment elevation MI with a T-wave inversion has been drawn by me at the moment. This is the ST segment elevation which I want you to hand draw below this table only with me. He was talking to me. And then like I told the nurse, okay, fine, I will admit this guy, and I started writing treatment. Morphine, oxygen, aspirin, nitrate that I'll be teaching you. I told the nurse to allocate a bed to this guy. The nurse said, okay, sir, and the nurse has transported this patient on a wheelchair to the bed, nearby bed. And the moment this patient got up from the wheelchair, he like sat on the bed and then he collapsed. The daughter of this guy started crying very loudly. You know, I thought maybe she is sad because her dad is sick, but this guy got up from the chair, sat on the bed and collapsed. I tried giving CPR, but I lost the patient. You see, the question in the exam that can be put up to you guys is that after myocardial infarction in a patient, why do you have high chances of sudden cardiac death? The question will say, after myocardial infarction, what will be the cause of development of sudden cardiac death in a patient? Then the reason for sudden cardiac death in most of the cases is development of arrhythmia. The arrhythmia that will occur in the patient will be most of the time a development of VFib, and because of this VFib, ultimately the patient will go into cardiac arrest and finally will die. what I wanted to bring to you is a simple situation. It's not really simple in a sense that the person will die, but then from the exam perspective, what you have understood at the moment is sudden cardiac death in myocardial infarction. If I say the word sudden cardiac death in myocardial infarction, and he says what is the reason for development of this death in a person, then the leading cause would be answered as ischemic. Yes, it is very good. Ischemic ventricular fibrillation, or it can be a pulseless ventricular tachycardia. Sudden cardiac death in myocardial infarction is ischemic ventricular fibrillation or pulseless ventricular tachycardia. Hit the comment button, guys. If a MI patient is dying after 24 hours, if a MI patient is dying after 24 hours, this was an FMG exam question, so I give the first right of answer to FMG students listening to me. अगर हार्ट अटैक के पेशेंट की डेथ 24 घंटे के बाद में होती है, what is the cause of death? Obviously, it is not arrhythmia. Yes, guys, if you're sitting for this time's FMG exam, a question, a PYQ for you, which has not been discussed in most of the forums. I have discussed it, but has not been discussed in other forums, is MI after 24 hours. What is the cause of death? It's not going to be arrhythmia, na, because patient is admitted with us. We have started treating the patient. Yes, guys, now NEET PG, guys, hit the comment button. What is the cause of death in MI after 24 hours? Waiting. You want me to do counting? Tick, tick, 3, tick, tick, 2, tick, tick, 1. And I should say your time is over. 24 घंटे के बाद में डेथ हो गई ना डॉक्टर साहब. What is the cause of death in this case? So your answer will change over to cardiogenic shock. You see, there was a substantial amount of damage to the cardiac muscle. That substantial amount of damage to the cardiac muscle is responsible for, the unfortunate demise of the patient. That is cardiogenic shock. And I'll speak more about cardiogenic shock at the moment, but I wanted to bring to you two attentions that if death, 2 points for attention. One is that if death occurs in the first few hours or first 24 hours, most of the time it is a arrhythmia. But if he specifies in the question, patient is dying after 24 hours because we have treated the patient and treated the hypoxia and the ischemia, then the cause of death is unlikely to be arrhythmia. होने को तो एरिथमिया कभी भी हो सकता है, बट आई होप आई एम एबल टू एक्सप्लेन टू यू दैट अगर आप ट्रीटमेंट कर दोगे, इफ यू विल डू अ बलून एंजियोप्लास्टी, यू विल डू थ्रोम्बोलाइसिस, यू विल गिव एस्पिरिन, हेपरिन, स्टैटिन, सो यू हैव ट्रीटेड द हाइपोक्सिया ना. So if hypoxia has already been treated and still the patient is dying, then it is due to extensive myocardial damage. That extensive myocardial damage, the cause of death would be given as cardiogenic shock. Now, once I've covered these two questions, then he will ask you what is the management for these patients who are having ischemic ventricular fibrillation, or what is the management of a patient having a pulseless ventricular tachycardia. I mean, what are you gonna do? So obviously for any patient of ventricular fibrillation, VFib, where the ECG is dancing all over the baseline, I need to give a DC shock in the patient. I need to give a DC shock in the hospital premises. That's the only way, that's the main treatment for the patient. How many DC shocks can be given to the patient? How many DC shocks can be given to the patient? I wrote the word shocks now. So how many DC shocks can be given to the patient so that we can manage the patient effectively? So the answer for that is options were like 1, 2, 3, unlimited. So by the algorithm, if you check out, the number of DC shocks that you can give to the patient is 3. And if I move up in the slide, guys, then you will notice this is the first shock, this is the second shock, this is the third shock. So if he specifies the word, how many DC shocks can you give to the patient? तो आपका आंसर होगा कि total मिला के you will be giving 3 DC shocks. Yes, absolutely right. You can give max of 3 DC shocks for management of this patient. So I will teach you the algorithm, but the point to be understood is if it's a ventricular fibrillation or if he says the PVT, and like how would you manage the patient? The main treatment is DC shocks. The type of DC shocks that would be used in this case would be non-synchronized. The alternative term for the non-synchronized DC shock, as has been explained to you, it will look silly कि सर आप same चीज बोल रहे हो, but I'm trying to do visual reinforcement. That is, defibrillation attempts would be total of 3 for the patient. Now, having said that, let's look at the more expanded algorithm. So that we can handle this relatively better. So I will move on to the next slide and I will draw some symbols like this. Like this is the first DC shock. आपको box वाला move on to the next page and draw ऐसे 3 DC shocks. move on to this slide, that is page number 4 के बाद 5, and draw 3 symbols of DC shock so that you can remember 3 DC shocks would be given. And this is obviously the first DC shock that has been given. So he has asked in the exam, what is the next step after the DC shock has been given? You are the team leader. You are standing at the foot end. You are the team leader. One guy is giving chest compression. One guy is taking care of rescue breath. So you don't have to do chest compression. You don't have to rescue breath. You are the team leader. That's the situation that they want to create for you. And he will say कि आप सबसे पहले क्या करोगे? तो your answer is you will be starting CPR again. Why? Because when you give a DC shock, the rhythm will not normalize immediately. You give a DC shock now, the rhythm will not normalize immediately. It will take some time for the rhythm of the heart to recalibrate. So if I give a DC shock now, the rhythm will come back to normal, maybe 15, 30 seconds, 1 minute. Tab tak brain perfusion has to be done. Very good, guys. Very good. It is gonna be, we are gonna be delivering a DC shock. We are gonna be, it's a shock followed by CPR, and the CPR ratio is gonna be 30:2. One cycle will be 2 minutes. And then they changed the question and they said that first shock has been given. Chest team has started giving chest compression, rescue breaths to the patient. What is the next step to be done in the patient? If he gives you a situation, what is the next step? Then fill up in the box. You will secure a IV line because you need to give IV drugs. And if you are not able to secure an IV line, then what will you do? You will secure intraosseous access in a patient. If you're not able to secure an IV access, guys, that is 2 failed attempts. 2 failed attempts would be like, I tried putting a peripheral line. I called my senior resident, he tried putting a jugular line, and 2 people have failed and there is no IV access. I'm running out of time, so I will be using a intraosseous access here. If it is intraosseous access that I'm gonna use here, hit the comment button. If it's gonna be intraosseous access, which is the bone that you will be using for intraosseous access, it is obviously the tibia. If he will tell you, no bache, it is not, yeah, this is not intraosseous adrenaline at the moment, your answer will not be intraosseous adrenaline, your answer will be, I will secure intraosseous access. वो उसके second shock के बाद में है that it will be intraosseous adrenaline. So here your answer will be get access. इसको ध्यान रखना. In the MCQ, intraosseous adrenaline will also be given. And intraosseous access will also be given. Your answer will be, it is in the tibia, and where in the tibia, in the upper part, and where exactly in the tibia. Your answer technical will be that you will be inserting the needle lateral to the tibial tuberosity. Now let me know, yeah, tibia बहुत बड़ा है ना यार, so your technical answer would be lateral to the tibial tuberosity that you're gonna be inserting the needle. This is again a question that is for FMG students. What is the needle that you will be using for getting intraosseous access? थोड़ा आसान था question, तो इसलिए I'm putting I'll ask NEET PG students also another question very soon. What is the needle that you will be using for intraosseous access? भाई इतना कोई मोटा नीडल आता है जो बोन में चला जाएगा, बोन मैरो में चला जाएगा ना. यू नीड टू गो थ्रू द कॉर्टेक्स इनटू द बोन मैरो ऑफ द पेशेंट. वेरी गुड, दैट इज Jamshedi's needle. So we will be using this access, that is Jamshedi's needle in this particular case, and you will be able to get a intraosseous access. After 2 failed attempts of IV line, then only intraosseous. No, you will try to continue with IV access if possible, but then the veins have collapsed now. A patient is going into ventricular fibrillation, circulatory failure is there. So if it is 2 failed attempts of peripheral cannulation, if it is 2 failed attempts of a peripheral cannulation, what you will use is intraosseous access using a Jamshedi's needle, and the inserting site would be lateral to the tibial tuberosity. You can inject local anesthesia like xylocaine and then infiltrate the periosteum because that's the pain sensitive structure in the bone, and then you can go into the bone marrow, and bone marrow has a very good communication with the venous system. Now suppose the rhythm is still not normalizing, तो आप क्या करोगे? तो second DC shock देंगे. He has asked in the exam what is to be done after the second DC shock. Your answer is again CPR. The 1 cycle of CPR would be 2 minutes. That is as I've explained to you already, you need to do a position swap, and here you will answer that if I am not able to get the rhythm back to normal in spite of maybe 30 seconds have passed by after the second DC shock. My team is already giving CPR. 30 seconds have passed by, 45 seconds have passed by. Still after the second DC shock has been fired. 30 seconds have passed by, 45 seconds have passed by, and still the rhythm is not coming back to normal. I will be giving to the patient adrenaline, which is also written as epinephrine. This epinephrine that will be given is a dose of 1 milligram, and the dilution will be 1:10,000 dilution. जो epinephrine का glass vial आता है, जो epinephrine का glass vial आता है, that glass ampule that is available, that is having 1 milligram of epinephrine in 1 ml, and that is present in a concentration of 1000 dilution. How will you make it 1:10,000? The glass ampule of epinephrine, E stands for epinephrine. The छोटा सा ampule of epinephrine is 1 milligram per 1 ml. It is 1:1000 dilution of epinephrine / adrenaline that is present. How will you make it 1:10,000? You will mix it with 9 ml normal saline. You will take a 10 cc syringe. What you will do is that you will ask your nurse to use a 10 cc syringe. In 10 cc syringe, 1 ml will obviously be the epinephrine that is present, and 9 ml will be the normal saline that you are using. That will become total of 10 ml. Na? So you see, 1:1000 is three zeros. If I make it 10 ml, then the fourth zero is added. That is 1:10,000 dilution. Exactly, that would be 9 ml of saline. So that will become total of 10 ml. Na? So already 3 zeros present, mathematics, and now the fourth zero would be added. So it is 1:10,000 dilution that would be done. So this is to be already pre-mixed. Every shift the nurse is supposed to, in critically sick patients in intensive care unit, guys, the nurse is supposed to ensure that this is already available. So this is like the next best step which is to be done. And then in NEET PG, the question was, second DC shock has been given. Second DC shock given, team has already given CPR, no improvement. We have given IV epinephrine. What is the next best step that would be done for management of the patient? Lot of these questions on next best step in the patient. So if you are a NEET PG aspirant, hit the comment button immediately now. What are you gonna do in the next 5 seconds, guys? CPR दे दिया, epinephrine दे दिया, rhythm normalize नहीं हो रहा है, there's already a hypoxia present which is triggering that arrhythmia. What is the next best step in the management of the patient? You will say, I will intubate the patient. It is written as advanced airway. It is intubation of the patient. Yes, guys. No, it is intubate the patient. Everything. This is gonna be intubation. That is gonna be the advanced airway that would be using it. भाई lagging होता है तो उसको off करके on कर लो ना यार, तो वो चल जाएगा दोबारा से. If it is gonna be like if he says what is the next best step in a patient, your answer is gonna be no बच्चे, it is not amidron. वो amidron अभी बाद में आएगा. Amidron अभी बाद में आएगा. This is gonna be intubate the patient. Intubation of the patient is called as advanced airway. इसको यार mess up नहीं करना है. This was a very simple straightforward question. वो बोला कि भाई जो मरीज है मेरा, जो patient है मेरा, okay, I used the wrong buttons. The question technically was like you have already managed the patient effectively. What is the next best step in management? It is intubate the patient. Yeah, ambu bag and tube ventilation that would be done. That is the advanced airway that will be done in this patient. That's the technical aspect which is to be used here. And obviously, like to know that the tube is in the right place. To know that the tube is in the right place, what you will also do at this particular point of time is that you will be doing a capnography simultaneously to demonstrate that the tube is in the not in the esophagus as in the trachea. तो क्या करेंगे? We will be checking the EtCO2 of the patient. We will be checking the EtCO2 of the patient. The EtCO2 of the patient is going to be 35 millimeter of mercury. So at this moment, the data to be remembered is that intubate the patient is the next best answer, and you have to ensure that the tube is at the correct place. So it is capnography which is to be used. Yeah, बच्चे answer capnography नहीं होगा ना. Technical answer will be intubate the patient. I hope like if you written capnography, मैं समझ गया आप क्या कहने की कोशिश कर रहे हो. But then the technique, क्योंकि capnography भी option में था. Your answer is intubate the patient. Why? Because you have to manage the patient with hypoxia. Till now the patient was still on bag and mask ventilation. So everything is having a fixed time. कब intubate करना है? After the second DC shock has been fired, epinephrine has been given. That is when you intubate. This has been determined after multiple randomized controlled trials followed by meta-analysis that which step is effective. Look at the science we are using. Non-medical people say, "Arey, you guys have strict protocols. This is all scam." No man, we have determined the effectiveness of every step. CPR चलता रहेगा. सुजाता बच्चे, CPR बंद नहीं होने वाला है. Only time CPR stop करते हैं जब DC shock का machine fire करता है. Only when for like let me say under 5 seconds when the DC shock machine is firing, that your team member will not be giving chest compressions. Chest compression कभी बंद नहीं होगा. All the discussion is being done from the perspective that you are the team leader. आप patient की foot end पे खड़े हो. One guy is doing chest compression. Other guy is doing rescue breaths in a patient. Third person is securing IV line. So you have 3 people under you. You are the top boss. You are the big dog, right? You are the top dog. and like, you know, that's the lingo that Gen Z uses. So you are the main guy, right? So I'm just trying to glorify your position, right? The top guy, right? So you are gonna be the team leader. One guy following your advice for chest compression, one guy giving rescue breath, third is the guy securing the IV line, और आपने क्या करना है यहाँ पे capnography. Yes, guys, only one shot of epinephrine बच्चे. यश आपने बोला how many epinephrine? It is a single shot of epinephrine only. If there will be no improvement, I will move on to the next step, that is amiodarone. Epinephrine बार बच्चे, you have a very good point, यश here. Epinephrine बार कहाँ देते हैं? Cardiac arrest. We are not studying cardiac arrest. Yes, you are the alpha, man. You doctors, you medical students are the alpha. You have to be proud of the fact. See, whether you took up this course because you are a poor at mathematics and you are a biology student, you become a doctor, or whether you just came up because you thought it's a lot of money. But once you have come in, man, you need to get the feel of the system. You have to get the feel of the system, and you have to be the alpha. You are 23 years of age. Your nurse will be 35. Right? She is gonna try to boss you around. You will not get bossed around by nurses, right? What you will do is, you will say, you will be humble, right? First thing is humility. Doctors are not supposed to talk loud. Doctors are supposed to be humble. But yeah, you say technically, ma'am, this is how the things are done. She'll try to boss you around. You say, no, ma'am, these are how things are to be done. Okay, guys. So moving on. Let's not get distracted from the focus. यश बच्चे जो repeated epinephrine shots होती है वो cardiac arrest में देते हैं. अभी मैं आपको पढ़ाऊंगा cardiac arrest. अभी क्या टॉपिक चल रहा है? अभी cardiac arrest नहीं चल रहा है ना यार. अभी we are studying ventricular fibrillation. So it's a single shot of epinephrine that is given. Secure the airway of the patient. And CPR बच्चे में भी 30:2 ही होता है ना. Somebody asked, मुझे पूछना चाहिए था वैसे तो. I should have asked what is the ratio of CPR. अभी बताऊंगा, right? पर आपने पूछा तो मैंने बोल दिया. The ratio of CPR that we'll be using will be 30:2 in a child also. That is if you are the alone doctor present. If multiple doctors are present, then obviously you can be using a ratio of 15:2. But बच्चे के लिए it's gonna be 30:2 only, and newborns के लिए तो 3:1 होता है. So I'll speak about it earlier. But at the moment, like, you know, let's move on. So at this moment, yeah, that 15:2 is if there are 2 doctors available. Okay. हाँ जी प्रियेश, डाउट पूछो, फटाफट से पूछो डाउट. चलो मैं let me draw my question next. You are intubating the patient. This is the endotracheal tube. Bachcha, I'm waiting for quickly the question. Otherwise, my eyes will not be able to focus on the screen where I'm drawing. क्वेश्चन मिस हो गया क्या भाई मुझसे? ओके फाइन. ओके प्रियेश, मूविंग ऑन. हम पेशेंट को इंट्यूबेट कर देंगे. हम पेशेंट अब लाइक लेट मी डू द टॉकिंग फॉर नेक्स्ट 3-4 मिनट्स. मुझे बोलने देना तो ताकि मैं ना टेक्निकल एस्पेक्ट्स डिस्कस कर पाऊँ. फाइन गाइस. यस. ओके. My question to all of you, everybody sitting here, is that you've intubated the patient. This is the endotracheal tube in the trachea. The question for you guys is that what should be the distance? What should be the distance of the endotracheal tube tip from the carinal angle? This is the carinal angle. This is the carinal angle. Carinal angle का मतलब होता है bifurcation of the trachea. And yes guys, what should be the distance? Where to write? Side में ना, इसके बक्से के साइड में. Third box. This is the second and third box. उसके साइड में बनाना ना यहाँ पे endotracheal tube. Very good. I want single answers. Yeah, obviously above the carina. How many centimeters above from the carina? Maria said 3 centimeter. Sai says 4. 3 to 5. You have to be specific, guys. Options in the paper were 2, 3, 4, 5. Select one. 2, 3, 4, 5. No, don't give me a range, man. You have to be specific. Options in the paper were, if it was so easy, I would not have gone so specific, right? No, bacha, it is 4 centimeter. It is 4. It is a very precise answer here. You have to be precisely 4 centimeter above the carinal angle. जो endotracheal tube होती है ना, उसके ऊपर वो marks होते हैं. Those guides are there. दो vocal cord guide होता है. It tells you the tube is like gone how much centimeter inside. So the tip of the tube should be, no guys, it's not बच्चे 2 centimeter. Your specific answer is the tip of the tube should be 4 centimeter away from the carinal angle. Next question. The tube can get blocked because of the secretions. Like in Hindi, I can use the word balgam or secretions. The tube can get blocked by the secretions. You have to note adjacent to this box only. Zooming in. This small opening that you can see in the endotracheal tube is what is called as Murphy's eye. There was a simple question, I think this was FMG exam, बड़ा easy सा था, Murphy's eye on the side. NEET PG में उसने क्या पूछा, what is the angle of the bevel? आप देखो इसका जो bevel मैंने बनाया है, like the bevel that I formed, ना, this bevel, if you see, this bevel is oblique. So he said, yeah, Murphy eye is sorted. Now, next question. The question in the paper said, this was a NEET PG1, what is the angle of the bevel? Yes, comment on the angle of the bevel that is present in the endotracheal tube. Very good, bache, Nida, Murphy's eye, Dipanshu, perfectly spot on. We sorted for that. My next question, what is the normal angle of the bevel? Okay, 60 degree, Priyesh was the first one to comment. Good comment. Yes, guys. Yes, 38 degrees. Manali was there to comment there. It is 38 degrees. Two standard datas to be remembered, guys. What should be the tip of the endotracheal tube from the cranial angle? 4 centimeter. What is the angle of the bevel? That would be 38 degrees. Is the Manali, you are perfectly spot on, bache. Perfectly, very good answer given by you. The answer is 38 degrees. And obviously, this tube will be cuffed endotracheal tube. You know, this tube will always be a cuffed endotracheal tube. I mean, like I can show those balloons on the side, na? Like they would be cuffed endotracheal tube because you want to prevent microaspiration. This is the tracheal wall, and I've shown the cuff also. So they have also asked in the paper a general question, which I'm now marking here before you, that what should be the cuff pressure? The cuff pressure should be less than how much centimeter? Yes, the cuff is present because you want to prevent the chances of microaspiration. Otherwise, microaspiration will occur in a patient. So my objective is to minimize, like, you know, the tracheal mucosal damage at the same time, and I want to prevent microaspiration also. So the question in your paper said कि cuff pressure कितने centimeter, कितने से कम होना चाहिए to reduce the tracheal mucosal ischemia. Cuff pressure should be less than, zooming out. Sir, this would be 30 now. The values to be remembered are, that's why I said let me speak continuously for next 3-4 minutes because I'm covering these questions. Yeah, the range is less than 30 centimeter of water because you want to prevent. The objective is to prevent tracheal mucosal ischemia. You want to prevent tracheal mucosal ischemia because you want to prevent this tracheal mucosal ischemia. That is why the cuff pressure should always be kept at less than 30 centimeter of water. Let me repeat the questions at the moment. You are all aware the tube can usually go to the right bronchus. You can have a selective right bronchus because the right bronchus is more in alignment. So you have to place the tip of the tube exactly 4 centimeter away from the carina to prevent it from sliding into the right bronchus. Otherwise, you get a selective right lung intubation. That's point number 1, 4 centimeter. Angle of bevel is 38 degrees. Murphy eye is shown in front of you, and the tracheal mucosal pressure and the cuff pressure should be kept at less than 30 centimeter of water to prevent tracheal mucosal ischemia. Now, for question for everybody, both asked in FMG and NEET PG, if selective right lung intubation will occur, what will be the earliest sign? If selective right lung intubation will occur because you are intubating the patient, so if you do a selective lung intubation, what will be the earliest sign that will be developing? Do you want me to give options for that? I think you will all understand that the air that you will now send from the ambu bag will be going in only one lung only, no? So it will become more difficult. You will feel more resistance. You will find difficulty in bagging. Earlier when you were squeezing the bag could be squeezed very easily. If there is difficulty in bagging the patient, please appreciate when you squeeze the bag, air is to go into both the lungs. Now you are forcing the same air in one lung only. One lung is having limited capacity. Now, when you're trying to push that same air in one lung only, there would be difficulty in bagging the patient. So the question said, what is the earliest indicator that tells a doctor that it is a selective lung intubation? One method is obviously auscultate the patient. You can auscultate on left, you can auscultate on the right, and there is a difference in the breath sounds, unequal breath sounds, but that will take some time. I'll repeat that again. Suppose जो endotracheal tube आप डाले, I'll say that in Hindi at the moment, then I'll do it in English also. आप endotracheal tube डाले, वो right bronchus में चला गया. अब आप जो एयर दोनों लंग्स में जाना चाहिए था वो एक ही लंग में भेज रहे हो, तो एक लंग को जब आप डिस्टेंड करोगे तो जगह तो थोड़ा सा ही है ना, उसके अंदर आप इतना सारा हवा भरोगे तो डिफिकल्टी इन डिस्टेंशन होगा. सो डिफिकल्टी इन बैगिंग द पेशेंट, द बैग विल बिकम मोर डिफिकल्ट इन स्क्वीजिंग. The second way to pick this up is auscultation, but that will take some time. So I hope I was able to explain to you that if he says, I'm not going to write it down because this is a very generic statement, that कैसे पता चलता है कि it's a selective lung intubation, selective right bronchus intubation, difficulty in bagging the patient, कि आप बैग को दबाओगे तो मुश्किल होगा और बहुत जोर से दबा दोगे pneumothorax हो जाएगा. Doing that in English fast, guys, when you squeeze on the ambo bag, the air is distributed in both lungs. If you're gonna try and push the same air into one lung, it's going to be difficulty in bagging the patient. If I'm going to squeeze very hard, I can cause a pneumothorax in the patient also. The second way is obviously auscultate the patient bilaterally and you would be able to identify the unequal air entry in a patient. But these are a couple of generic stuff that has been asked in the exam. So I had to speak about it, though already it was not on the agenda. This last question that I put up, but a lot of errors were coming while answering this. So I think you guys have done well, but yeah, some errors did come. Last question before I move back to my third DC shock. Last question before I move out to my third DC shock. My question to you guys is that you see, जब एक बार हम इंट्यूबेट कर देते हैं पेशेंट को तो like this endotracheal tube is obviously capable of causing side effects. The biggest side effect that occurs is tension pneumothorax. The technical term for the tension pneumothorax is also the development of barotrauma. In fact, like जो number one cause of tension pneumothorax है, that is not trauma. The number one cause of tension pneumothorax is not trauma, it is ventilator induced barotrauma. I'll write it down subsequently. अगर आप बोलोगे ना सर अभी इसको लिख दो तो फिर मैं समझा नहीं पाऊंगा, तो I'll write each of these words. कुछ भी मिस नहीं होगा, but give me some time to just explain that if he says what is the number one cause of pneumothorax, तब इसको स्टूडेंट ट्रॉमा आंसर करते हैं. आपने ट्रॉमा आंसर नहीं करना है. Your answer would be ventilator associated barotrauma is the number one cause or development of tension pneumothorax in a patient. So those are like couple of aspects related to the endotracheal tube that I just wanted to touch upon. And obviously to intubate you need a laryngoscope. Laryngoscope should always be held in the left hand in the patient. If doctor is right-handed, the laryngoscope is always held in left hand, right? If you're right-handed, laryngoscope is held in left hand. If you're an FMG student, please answer for me. If doctor is left-handed, how will you hold the laryngoscope? In the right hand or still in the left hand? I'll repeat my question again. An FMG exam question again. You are right-handed, you are supposed to hold the laryngoscope in the left hand and then you intubate the patient, that is okay. If you are a left-handed doctor, how will you hold the laryngoscope? Will you hold the laryngoscope in the right hand or will you hold the laryngoscope in the left hand? The answer will be, yes guys, quickly. The question is, left-handed doctor will hold the laryngoscope in which hand? The answer will be still left only. Left-handed doctor will hold the laryngoscope in the left hand only. Whether you are left-handed or whether you are right-handed, it really does not matter. दो पॉइंट्स मैंने लिखे नहीं है, टेंशन pneumothorax वाला and difficulty in bagging the patient. I will write them subsequently. At the moment, a point that I've written is left-handed doctor hold laryngoscope in the left hand only. If you are a right-handed doctor, still you will be holding the laryngoscope in the left hand only, and obviously it will be a curved blade laryngoscope and a straight blade laryngoscope with respect to pediatric age group. So this was couple of generic information, guys, which I wanted to speak before you, and now I'll zoom out of the slide and I will come to the core aspect, that is my job as a physician is obviously to ensure the third DC shock has been delivered because my patient was not responding to the treatment. I've given third DC shock to the patient. The patient is still like without a pulse and I know that things are turning bad. Prognosis is gonna be bad. Already 4 minutes have gone by. So the last bullet that I want to fire is amidron. तो यहाँ पे अगर वो बोलता है क्या करोगे, तो देखो सबसे पहले तो इतना याद कर लेना कि after every DC shock, if he says what is the next best step, it is CPR, CPR, CPR. But now if he says what is the next best step, now the answer will change. Here you will say that I will be using amidron, that would be 300 milligram given to the patient. Dose was नहीं पूछता है, but it is amidron that would be given, or it is lignocaine that would be used in a patient, either of the two. And if he says what is the next step after this, तो आप बोलोगे I would like to treat the cause. You need to remember this verbatim. जैसे मैंने बोला verbatim, that is how you are supposed to remember the aspects which are present here. Let's do a quick recap of the 3 boxes. मैं zoom out कर रहा हूँ. आपको 3 boxes की photographic memory right now, right here बनानी है. Not on going home, not on reading the notes again. Now, CPR, 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 first entry in all boxes. If he says what after the CPR for the first box, then it is access. It is IB line access, intraosseous access. For the second box, you will utilize that IV access for epinephrine followed by intubation. That intubation part went wrong. I hope it's clear to everybody. If he specifies in the question, what will you do with respect to the third DC shock? It is amidron, and then is going to be treating the cause. The CPR part is anyway uniform. So this is like a standard algorithm that we'll be using for our patient who is having ventricular fibrillation or ventricular tachycardia. Now I will take you back to 1984. I was a student. I think I was in class 4th. One of our former prime ministers, Indira Gandhi ma'am, was shot by her bodyguards. You know, those guys, they got, radicalized. That Khalistan movement thing, they got radicalized. So the RAW had information regarding the fact that these guys have got radicalized. So they told Indira Gandhi ma'am to use bulletproof vest. They said, ma'am, we are removing these two guys from your SPG. SPG is the basic unit, that special protection group that takes the security of the prime minister. So the RAW had intelligence that these guys have got radicalized. They said, ma'am, we will remove these guys from posting tomorrow. And please, we want you to use a bulletproof vest. So ma'am agreed for a bulletproof vest, but she did not take them off the roster immediately. She said, oh, these are like my children, and I attend birthday parties of their children. So they are like family. No, they can't be radicalized. You are wrong, and your information is wrong. Both of these guys realized that this might be the last day of their duty. So on the last day of the duty, before they were removed, they decided that they had their weapons in position, and because ma'am was using a vest, right, so they could not have shot her in the chest. So they shot her ma'am in the pelvis. They emptied entire Kalashnikov rifle burst into Indira Gandhi ma'am, and she lost so much of blood that she went into cardiac arrest. So the next scenario that I'm going to discuss before you on the next page, please, that is come to page number 6, guys. I will be dealing a case of asystole management which has been asked in the exam. Like in case of our Prime Minister ma'am, she would have been just walking after she took a media briefing. After media briefing, she was walking back to her study. Her residence is almost like her current Prime Minister's residence is like about 5 kilometers from where I'm taking the class at the moment. So, what would have happened in her case is, because they've emptied entire Kalashnikov rifle burst into her, she lost so much of blood that ma'am went into cardiac arrest. She was rushed to ACE Hospital, Delhi, where the doctors were already informed that the Prime Minister has been shot and they were ready with resuscitation. So if they give you a scenario of this kind of a asystole management which can occur, like cardiac arrest is what I'm trying to say at the moment, or I am saying the word asystole, then in a flatline ECG, what are you supposed to do is you have to straight away start CPR, because if ECG is showing a flat line, if ECG is showing a flat line, then you are not, if ECG is showing a flat line, then you're not going to waste your time checking the pulse. A lot of students made mistake in the paper. They answered check pulse for this particular scenario of cardiac arrest. You will not waste your time for checking cardiac arrest. If ECG is showing a flat line, guys, then it is straight away start chest compressions in a patient. This chest compressions would be done at a ratio of 30:2, 1 cycle for 2 minutes by default, and you have to restart the heart. How would you restart the heart? Either you will take intravenous access or you will take intraosseous access. And what will you give to the patient is, to restart the heart, you will again give epinephrine. तो जो किसी ने पूछा था ना, sir, how many shots of epinephrine will be given to the patient? This is where the question comes in valid, that if the ECG of the patient is showing a flatline ECG on a asystole, then there is no rationale of checking the pulse, and we need to provide epinephrine. The dose still remains the same. So let me just write it down: 1 milligram, 1:10,000 dilution. And the question is now open to everybody: how many shots of epinephrine will you give? Like you have given the first shot, the repeat shot can be given at a gap of 3 to 5 minutes. You have given the third shot, another at a gap of 3 to 5 minutes. The epinephrine shots can be given at 3 to 5 minutes interval. The question which is open to you guys is, you have already given 3 shots of epinephrine. What will you do? Will you give the fourth shot? Will you give the fourth shot, or would you like to give a DC shock? Hit the comment button right now and let me know that if you are having a patient in whom you have already given epinephrine to restart the heart and stimulate the SA node. Yes, we have given 3 shots of epinephrine at the moment. What will you do? Will you give a fourth shot or will you give a DC shock? No, it is 3 times is okay. We have given 3 times at the moment. Will you give a fourth shot now if ECG is not normalizing, or will you give a DC shock? Okay, fine. Hit the comment button. Options are only two. Will you give a fourth shot of epinephrine? Write epi in the chat if you want to say fourth shot of epinephrine, or hit in the comment button the word DC shock. Okay, so most people have answered DC shock here, which is wrong. Most people in the chat have answered the word DC shock, which is wrong. Guys, DC shock is contraindicated. DC shock is, yes, it is the fourth shot that will be given. This is one of the most important statements that I would like to say at this moment. DC shock is absolutely contraindicated in patients of asystole. This is the wrong conception that a lot of people have, and since people did make a mistake, so I'm gonna correct you. And how will I correct you? I will fire another question at you. The question is, does DC shock machine restart the heart or does it terminate an arrhythmia? Does a DC shock machine restart the heart or does it terminate the arrhythmia? The DC shock machine terminates an arrhythmia. It does not restart the heart. It is a very common misconception that students have after watching television serials like Grey's Anatomy etc. कि उनको लगता है कि even in Grey's Anatomy they'll show like this, Meredith Grey will come or some that Dr. McDreamy, that smart guy will come and he will give DC shock in flatline ECG and the patient will recover. No man, patient will not recover. That is television serial. Indian television serials are horrible. I'm not even talking about Indian television serials. You would have seen so many reels on the same on Indian television serials. Even American television serials are horrible. They show DC shock being given in a flatline ECG. There is absolutely no role. It will terminate an arrhythmia. So what will you do, guys? You will give a fourth shot of epinephrine. You will give maybe if required a fifth shot of epinephrine. You have to give epinephrine again and again. Is there a limit on the amount of epinephrine you can give to a patient? Is there a limit? Yeah. Is there a limit to the amount of epinephrine that you can give to a patient? That was a question Yash or somebody had asked. The answer is no. In Indira Gandhi's ma'am, in Indira Gandhi ma'am case, they had used almost 50 vials of epinephrine, but a cardiac rhythm did not come back. The team tried CPR for almost 2 hours. Almost 50 vials were used, but the heart did not come back because she had lost so much of blood. That extensive loss of blood will cause hypoxia. And that hypoxia will again cause a cardiac arrest in a person. Yes. No, doctor. No role of intrathecal epinephrine, guys. No role of intrathecal, right? In the spinal cord, it will not work. You can give it an endotracheal tube in babies, newborn babies, but no role of intrathecal. So the message here is there is no limit to the amount of epinephrine you can give. If it is a prime minister of a country who has been shot by terrorists, you might be using 100 vials because you want to save the prime minister's life, because otherwise if you lose the leader, the entire country will collapse. Look at Iran, right? The Americans hit the top leader, the country is in a chaos at the moment, right? I mean, in Americans hit Venezuela, again the country went into chaos. So if it's going to be the topmost leader of the country who's injured due to military gunfight or whatever, we are going to try our best to save the person. There is no limit to the amount of epinephrine. Okay, sure man. PET is the Tarun, that's a good input. Okay, so what you need to understand is that a doctor will decide. The textbook says doctor will decide how many shots would be required. In your clinical practice, in your hospital, you will be using 3-4 shots of epinephrine, and then you say, okay, we could not save the patient. You will tell the relative, sorry, we tried, we could not resuscitate. But there is there is no limit to the amount of epinephrine that can be given. That is one. And now the question comes up is, why are we giving these repeated shots of epinephrine? मतलब ऐसा बार देने से क्या हो जाएगा? So keep your eyes glued on the board. Keep your eyes on the board, guys. If you are gonna give repeated shots of epinephrine, it will convert the flatline ECG into ventricular fibrillation. When you give repeated shots of epinephrine, it will convert the flatline ECG into ventricular fibrillation, and when you will convert into ventricular fibrillation, now you will give DC shock to the patient. Why do you give epinephrine again and again? Epinephrine is given repeated. The rationale that I have tried to explain to you is, why do you give repeat epinephrine to the patient at 3 to 5 intervals is because you want to convert You want to convert a asystole into a shockable rhythm. That is, you want to convert a asystole into VFib, and now you will be able to manage the patient by delivering a DC shock to the patient. To see that you have understood me, let me ask you once again. Suppose your ECG is showing a flatline ECG. Patient's ECG is a flatline. You are the team leader. What will you tell your team? Fire or hold the fire? Comment in the chat box, fire or hold fire. For if it's a flat line, ECG जो है वो अभी ऐसे वाला है. This particular part is what I'm focusing upon. This is the recording that is coming. Will you ask your team to fire, or would you ask your team to hold the fire? I think most guys have understood. We are not going to give a DC shock in a flatline ECG, so you will be asking your team to hold their fire. But the movement, no, bachche, you will not fire, you will hold the fire. There is no role of DC shock. There is no role of DC shock. That's what I'm trying to explain again and again. That is the one-liner question वो जो पूछा, इसको समझाने के लिए तो बता रहा हूँ यार. DC shock is contraindicated in cases of asystole, बच्चे. You will ask your team to hold the fire till you convert into a ventricular fibrillation. That's the main algorithm that you basically need to understand. Most of us doctors are under impression that epinephrine will restart the heart into normal. No, it will not restart the heart to normal sinus rhythm. It will convert the asystole into ventricular fibrillation. Yes, bache, you are all right subsequently. Okay, not a problem. There can be differences in opinion. Understood. But I hope the gist of the concept is clear, right? The gist of the concept is clear that you're not gonna fire a DC shock when it's a flatline ECG. When it gets into ventricular fibrillation, you are gonna be cool with respect to describing a DC shock. So this is very simple, straightforward, guys, as far as the data is concerned. And now we will do a summary here. So what I want you to do with me is a quick recap with respect to advanced life support. Advanced cardiac life support or advanced life support is what they usually ask you. In the hospital setting, if they ask you what is the first thing to be done in any crashing patient, he will write the word hemodynamic instability. He will write the word crashing patient in the hospital premises. In American serials, they call it code blue. We just call it crashing patient. CPR will be given at ratio of 30:2. The second thing that we will do in this patient is start bag and mask ventilation. I'm using a short form. Bag and mask ventilation would be started. The bag is ambu bag, mask appropriate for the size of the patient. The ambu bag has to be used to ventilate the patient 10 times per minute. 10 per minute is the breaths that would be given to the patient, as I've explained to you earlier. And the third step in this patient is there is no role of amiodarone, bache. There is no role of amiodarone for cardiac arrest. Amiodarone is given for, जो इससे पहले हमने पढ़ा था, ventricular fibrillation. In cardiac arrest algorithm, there is no role. You can check the American Heart Association guidelines. Let me just move the slide. You guys can do it yourself. आप देखो ना, asystole का जो algorithm है, वहाँ पे he says there is no role. You have to do CPR, you have to get an IV access, and epinephrine is to be given every 3 to 5 minutes, and then you have to intubate the patient. As you can see in the discussion, there is absolutely no mention of amiodarone. Amiodarone is for the table that I discussed on the left. I'll show you the box again, bache. This is where amiodarone is used, VFib and ventricular tachycardia that we discussed earlier. So यहाँ पे there is no role of amiodarone. It is like we have to give repeated shots of epinephrine, convert it into arrhythmia, convert it into VFib and manage the patient. So now let me do the talking uninterrupted for next about 3 to 4 minutes so that you can remember the whole thing. In any crashing patient, CPR is to be started, bag and mask, 10 per minute breaths, and attach defibrillator pads. This is the algorithm. Now there can be two possibilities. For the defibrillator pads. You can make a box like this for the left, and you can make a box like this for the right. If in the ECG, you notice that the arrhythmia is coming like this. If you notice in the ECG, the arrhythmia is coming like this, or it is a sinusoidal pattern, then you will give DC shock to the patient. So you can write the word shockable rhythms. There are two shockable rhythms. What is the name of the shockable rhythms? Ventricular tachycardia and ventricular fibrillation. But suppose in the paper he gives me a flatline ECG. This flatline ECG, as you can understand, is asystole, so I will not be firing a DC shock in this particular case, and therefore the right hand side can be written by you as non-shockable rhythm. This is again a very simple question that is asked, that what is shockable and what is non-shockable rhythm. Obviously flatline ECG is a non-shockable rhythm. Now for the left hand side, I have already drawn those boxes, but still I will do it fast. You can draw 3 boxes with me on this slide, and I'll be talking faster because I have already explained the core concepts to you for management of VFib and VT. What you can do here is draw 3 boxes and then draw 3 DC shocks. For the shockable rhythm, in each of these boxes, the first entry that you need to do is CPR, CPR, CPR. This is obviously that standard 30:2 thing that I don't need to replicate. In the first box, write the word IV, intraosseous access. In the second box, using this IV/intraosseous access, write the word epinephrine. The dose etc. has already been discussed, and the next entry that you need to make for this IV epinephrine is that you will be going for advanced airway. Advanced airway is the technical word. You will, like in the MCQ, there will be no mention of the word intubation. He will write the word advanced airway, for which capnography is used to check for the tube position. In the third, you will say, I will use the IV line to give amiodarone to the patient. If he says what next, the answer is treat the cause. Like if it is myocardial infarction, you need to remember the sequence verbatim as I've highlighted before you. The 3 boxes have been practiced at the moment. Now for the right hand side, you need to make only 1 box. For the right hand side, I want you to make only 1 box. And after making this 1 box for the non-shockable rhythm, right, you attach the defibrillator pads, it's turning out to be an asystole. I want you to draw a small symbol like a syringe. I want you to draw a small symbol like a syringe. You see, in America, where facilities are like more advanced, then in every patient bedside, we have an emergency tray. In India, we don't have so many facilities. Like if you have worked in an Indian hospital, you will be having a male ward, female ward, and between the two is the nursing station, and you have to run from one corner of the ward to the other wherever patient is crashing. Or even in the casualty, like you are sitting in the middle and 50 patients here, 50 patients other side, and you have emergency crash cart, only 1 crash cart is there. In America, where facilities are more advanced, every sick patient bedside emergency epinephrine would be available. So the algorithm says that if facilities are available, give epinephrine as soon as to the patient. The movement you are gonna see a flat line in the ECG, you will give epinephrine to the patient immediately. You don't want to save time. So in a multiple choice question in your paper, if they follow the American protocol and they write the word epinephrine ASAP and CPR, and he says what will be done first, your answer is epinephrine ASAP. But suppose the word ASAP, you see, we as doctors, like hardly you and me will ever say the word ASAP, as soon as possible, right? In India, how many times do we say the word ASAP? Hardly ever. So in an Indian scenario, if he says CPR versus epinephrine, and he says what will be done first, your answer is obviously CPR followed by epinephrine. In the AHA protocol, you will notice that there was a syringe given in the handout. In the image also the syringe was made, that is to incorporate both the scenarios. I hope I've been able to explain to you that why in some MCQs the answer is epinephrine and why in some MCQs the answer is CPR, because it depends on the language that is given. If in the question it is written epinephrine as soon as possible, that is the first thing. But if the ASAP word is missing, ASAP is the word. I'll show you the American word there, ASAP. So if the ASAP word is missing, then you will give epinephrine to the patient. The dose remains the same. So that is like a algorithm aspect which I want you to remember. And then obviously you have to intubate here also. So the word would be what next. So advanced airway. I did not speak about it earlier because airway part I've already taken care of. But yeah, advanced airway has to be secured in the first box itself, and apart from this you need to treat the cause. Yes, all tachyarrhythmias are shockable rhythms. All tachyarrhythmias are shockable rhythms, but flatline ECG is a non-shockable rhythm. Soumyajit, perfectly spot on. All other arrhythmias are shockable rhythm. All arrhythmias are shockable. AFib, A-flutter, VTAC, PSVT, multifocal atrial tachycardia, polymorphic VT. I'm going to teach you each one of them. But here we are discussing the common ones which are asked, because what we are discussing at the moment is the AHA algorithm chart. What we are discussing at the moment is the AHA algorithm chart. This is what is given in the handout to you guys. The easiest for me would have been that I would have simply done marking on this and said कि अपने आप से याद कर लेना. I have done the hard work of writing the data in front of you. I could have said ना यार go to rapid revision, go to the main video. I've already taught you that. I did the hard work of writing everything word by word. I've written every alphabet, including the word ASAP. है ना. Stat word हम लोग इंडिया में word क्या बोलते हैं? हम बोलते हैं stat. That's the order that you guys write. Stat. American word is ASAP. So in the MCQ is written the ASAP words at the moment. I'll come to PA, bache. Give me time, right? I said I'll talk about pulseless electrical activity. Give me like another few minutes. I'll come to PA. So great guys. So it is epinephrine ASAP which is to be used. It is intravenous access, then it is epinephrine, and I hope it is clear to everybody that why in some MCQs in the paper and in the recall sessions also you will say sometimes I'm answering epinephrine, sometimes CPR. I get queries कि सर कभी आप कुछ बोलते हो कभी कुछ बोलते हो सर, आंसर चेंज कर देते हो, हम कंफ्यूज हो जाते हैं. भाई कंफ्यूजन नहीं है, लिखा है भाई, लिखा है ASAP, दैट्स द वर्ड दैट इज गिवन इन द क्वेश्चन. नहीं लिखा तो फिर CPR बोलो ना, कोई दिक्कत नहीं है आपको, राइट. So once we get this agenda, okay, noradrenaline for Brady. बच्चे अभी आ रहा है, दो चीजें आ रही हैं अभी. अभी मैं तुम्हारी और जान खाऊंगा, है ना. अभी मैं तुम्हारी और जान खाऊंगा. मैं तुम्हें पढ़ाऊंगा ब्रैडीकार्डिया, मैं तुम्हें पढ़ाऊंगा पल्सस इलेक्ट्रिकल एक्टिविटी. PA अभी नहीं बताया मैंने, है ना. दैट केम इन द कमेंट. ब्रैडी बताओ, तो रुको जरा है ना, सांस लेने दो भाई, सांस लेने दो. लाइक आई एम गोना टीच यू मैन एवरीथिंग. जो भी डाउट है तुम्हारे पूछो तुम दबा के, राइट. वरना जो टेलीग्राम है उसमें पूछो ना यार, तो उसमें तो वो पता नहीं टेक्निकल चलता रहता है. एकेडमिक डाउट पूछो ना यार, उसके लिए टेक्निकल के लिए वो तो एकेडमिक डाउट के लिए बनाया हमने. वो उसमें तो चल रहा है, ऐप नहीं चल रही भाई. अब उसका तो मैं नहीं कर सकता ना कुछ भी. इट इज़ लाइक द टेक्निकल्स. यू आई वांट यू टू रेज अप क्वेश्चन. सर बच्चे में क्या करेंगे, एडल्ट में क्या करेंगे. सो आई मीन फायर योर डाउट्स एट एनी पॉइंट ऑफ टाइम एंड आई विल बी ग्लैड टू असिस्ट यू. सो मूविंग ऑन. EP, ASAP, CPR, epinephrine. Perfectly right, Pranav. You summarized it like awesome, man. Awesome, right? You summarized it very beautifully. Okay, ji. Fine. So I'll hold on, guys. Hold on. I'll give you lunch break. We just started at 12, man. First thing, if you are an FMG student, develop capacity to sit 2.5 hours. If you are an ATPG student, you need to develop a capacity to sit 3.5 hours. Forget about all the academics I am saying. छोड़ दो academics को. मैं बोल रहा हूँ भाई तुम्हारे में stamina for sitting 2.5 hours of pure focused concentration. Whether you get food, you don't get food. If you are an FMG student, you will go to the center. There will be no air conditioner working. You are gonna be sweating buckets. I had a student who said, "Sir, मेरा पसीना ना होठों पे जा रहा था, lips पे जा रहा था, खा रहा था मैं पसीना अपना." That's gonna be so hot. 2.5 hours of pure focus. ये पोमोडोरो टेक्निक होती है ना, 20%, 20 मिनट पढ़ा, 10 मिनट डिटॉक्स, 20 मिनट पढ़ा डिटॉक्स. ये होता है BCom ऑनर्स के लिए, ये होता है BA पास के लिए. यू गाइज आर डॉक्टर्स मैन. फॉर यू गाइज इट इज टैट. 2.5 hours. If you're an FMG student, 3.5 hours of back breaking. I mean back breaking तो होगा ही, because it's you're sitting at one place, you tend to get tired. And the chairs are going to be uncomfortable in the exam. So you need to be physically and mentally strong for this. Hanji, hanji. Yes, guys. Yes, guys. Moving ahead. So what I have described at the moment is the algorithm. Okay. Yes, bache, I understand. But chalta hai man, chalta hai. We are doctors, right? तो हमें फर्क नहीं पड़ता. चलो. So before I move on, I will address very bad, yeah. That center part, no, chalo, let's not get focused, distracted from the focus. I will speak about it. But there would be hardly no air conditioner, sir. Believe me, no air conditioner working. You are gonna pay so much of money. 7,000. FMG form is I think 7,000, no? And INISAT is 4,000 something. You paying 7,000. Zero service, sir. Zero service. And no redressal. And yeah, I mean one more thing, never argue with any security staff there, please. My folded hands. Whether you are an NEET PG aspirant, whether you are, they are non-medical people, वो तू करके बोलेंगे. Your ego will get hurt. रहने देना यार, मत गुस्सा मत करना प्लीज, बिकॉज आई सीन की लाइक पीपल गुस्से में आ जाते, लाइक यू आर डॉक्टर्स तो भाई यू एक्सपेक्ट समबडी टॉक टू यू विद रिस्पेक्ट. वो लाइक दोस आर बदतमीज पीपल यार. तुम बदतमीज आदमी से आर्ग्यूमेंट करोगे ना तो यू विल लूज योर फोकस. सो वेदर यू आर अ बॉय, वेदर यू आर अ गर्ल, माई हम्बल रिक्वेस्ट टू यू इज जस्ट लेट देम गो. दे आर लाइक घटिया लोग, राइट. सो ओके, चलो Chalo, let's focus guys. The next aspect that I'm going to teach you is, I'll draw line diagram representing the same, and then I'll be able to explain this to you relatively better. So give me like few seconds to just draw this here. नहीं, पीजी वाले में भी ऐसी होता है भाई, अलग ही है वो। तुम्हें सेंटर पीजी में सेंटर देता है 2000 किलोमीटर अवे फ्रॉम योर हाउस। एंड लास्ट टाइम जो सेंटर हुआ था ना, उसमें लाइक यू नो कपल ऑफ माय स्टूडेंट्स कुड नॉट रीच द सेंटर बिकॉज बारिश हो गया उस दिन। तो कह रहे सर यहाँ तक पानी था। तो कई लोग तो उस पानी में हिम्मत करके चले गए, कह रहे सर सीवर का पानी यहाँ तक। एंड द गाय वाज लिटरली वेडिंग थ्रू सीवर वाटर एंड रीच द सेंटर। कह रहा कमांडो ट्रेनिंग हो गया मेरा। ओके चलो फाइन, all eyes on the board please. Now we will not do any ranting. We'll focus on the core aspect, and I'll address what is PEA. We will not do ranting, we will do the core aspect, which is PEA, which is that this diagram that is shown to you will come up multiple times today. But what I'm showing at the moment to you is a diagram that is to be made at the bottom for cardiac tamponade. When it comes to cardiac tamponade, the heart is gonna be crushed. It's gonna be squeezed. There is so much of pericardial fluid present here due to tuberculosis, due to lung cancer, that it will crush the heart. The English word is crushing the heart. If you crush the heart from outside, the amount of blood coming in via the veins will almost be zero. The amount of blood coming in the heart via the great veins to the right and the left will basically be zero. The end diastolic volume in the patient will become less. If end diastolic volume will crash, less will come in, less will go out. If less will go out, cardiac output will fall. The blood pressure of the patient will begin to fall. The pulse of the patient will begin to disappear. The peculiar thing that I want to teach you is that the heart is beating. I'm not discussing cardiac arrest anymore. The heart is beating. Still the pulse is absent. Heart is beating, but there is no pulse, because if less blood will come in the heart, less will be going out of the heart, and the blood pressure of the patient will begin to crash. The technical term that I will like to use for this patient is pulseless electrical activity. Just to see you got me or not, what will you do for pulseless electrical activity? Would you like to give a DC shock? Or would you like to do a urgent echo-guided pericardiocentesis? I will not even ask you to comment, because I know you know the answer. If there is water outside the heart, you need to remove that water out of the heart, only then the pressure from the heart will go away, no? So for management of pulseless electrical activity, guys, we are not going to go ahead with DC shock. We are going to do a urgent echo-guided pericardiocentesis. This is the reason why pulseless electrical activity is also included in the heading of what is called as non-shockable rhythm. This is the reason why pulseless electrical activity is also included under the heading of non-shockable rhythm. Yeah, I did not even ask you to comment, because मुझे पता है कि you guys will answer spot on. The words to be remembered are PEA. There would be a non-shockable rhythm that is present in this case. The type of shock that is present in this case would be called as obstructive shock. The type of shock that would be present in this particular patient would be called as obstructive shock. The words to be remembered are PEA, non-shockable rhythm, obstructive shock. What will be the ECG of cardiac tamponade? It will be a low voltage ECG. Why a low voltage ECG? Because there is water outside the heart, so it will cause buffering. It will cause a buffering of the electrical current that reaches the recording electrode. So you will be getting a low voltage ECG. Yes, Ayush, you are right. The driver without a seat belt wala example, cardiac tamponade, that can be trauma also. Whether it is PA, non-shockable rhythm, obstructive shock, the bottom line is for this condition हम DC shock नहीं देंगे. So my request to you guys is that what you will do is that you will draw one more ECG in this box. You will draw one more ECG in this box. और उसमें आप बनाओगे कैसे? तो आपको बिल्कुल छोटा कॉम्प्लेक्स, जितना छोटो कॉम्प्लेक्सेस बनाना ना, जितना छोटो कॉम्प्लेक्सेस बना सकते हो, PQRST, उसको रिदम नॉर्मल साइनस रिदम है. बट ट्राई टू शो लाइक सिंबॉलिकली आप क्या करने का कोशिश कर रहे हो, यू आर ट्राइंग टू ड्रॉ छोटो कॉम्प्लेक्सेस टू से इट्स अ नॉन शॉकेबल रिदम इन अ पेशेंट बिकॉज देयर इज वाटर आउटसाइड द हार्ट. सो जस्ट ड्रॉन दैट symbolic representation here. It is a low voltage ECG that I have highlighted. So two patterns have been described for non-shockable rhythm. The superior pattern, which I would like to once again name, is asystole, obviously. And the second one के लिए the word is pulseless electrical activity. What I've described at this moment to you is what is called as non-shockable rhythm. The technical word is non-shockable rhythm. It's a flatline ECG and it's going to be छोटो ECG. So अभी the moment you pick that up ना, मतलब most of the time तो देखो the history will also be there sometimes in the question. No, if he himself says trauma case brought to the casualty and like he was not using a seat belt, he had trauma to the chest, or he gives you lung cancer patient brought to the casualty. So lung cancer can metastasize to the heart. Tuberculosis patient coming to the hospital with acute onset breathing difficulty and prominent neck veins. I will teach you cardiac tamponade separately also. But this is just to sensitize you to the fact that because the clinical history will also be given, so you will be immediately able to pick up that whether it is a asystole, whether it's a low voltage ECG, and therefore the algorithm will remain the same in this particular patient. That is asystole and PEA would be the non-shockable rhythms, and the algorithm has already been tried here before you. So at this moment, what I have tried to explain to you is the common technical aspects. One more query, bradycardia still pending. I'll do that later, guys. Abhi bradyarrhythmias discuss karna है ना आगे, तो we'll do that in the bradyarrhythmias component. I'll address one more query that came कि child में जो resuscitation करते हैं उसमें डिपेंड करता है कि how many healthcare workers are present. This is like optional if you want to note down. For CPR with respect to a child, if you are alone, then you will do ratio of 30:2. And if there are two healthcare workers, then obviously the ratio will change over to 15:2. This is optional if you want to note down, but I think all of you are aware of this. And for newborn babies, it is mandatory that two healthcare workers or two rescuers should be present, and the ratio is obviously 3:1. So this is optional information. If you want to note down, it is okay. Otherwise, you can let it go. But what I've tried to explain to you in the first few minutes of interacting before you is first few hours of interacting with you is the aspects of BLS and ALS, which is usually asked, right? Cardiac tamponade we will come. Okay, चलो फिर से बोल देते. Cardiac tamponade, right? Cardiac tamponade is a condition in which there is pressure on the heart, intrapericardial space. जहाँ blue arrows बना ना बच्चे, that is intrapericardial space में pressure बढ़ गया, उसने heart का गला दबा दिया आपको. When you squeeze the heart so bad, the filling of blood in the heart is lesser, input is less, output will also be less. And if the output is less, the blood pressure is crashing. 3:1 is for newborn baby, bache. Yes, 3:1 is for newborn baby. No, that is 33 chest compressions, 1 rescue breath. That is 3:1 is for newborn baby. This is the data for CPR. Coming back to the agenda. In tamponade, because the crashing of blood pressure is occurring, therefore heart is beating, pulse is absent. Very peculiar. Normally, heart electrical activity is gone, pulse is absent. So we call it PEA. We call it non-obstructive. We call it non-shockable rhythm, or we call it obstructive shock. Muffled heart sound is a good answer, but आजकल यार क्वेश्चन में बोलता ही नहीं यार muffled heart sound. अगर पूछता होता ना तो मैं आपको बोलता ही नहीं. Okay. So cardiac tamponade का अभी we'll discuss cardiac tamponade again ना, अभी disease of the pericardium में आएगा. So TB, lung cancer, those are like the common scenarios that we'll be discussing for tamponade once again. ये तो just शुरुआत है अभी. Okay guys, now we will talk about the aspect of pulse. So I will be teaching you ABCD of pulse. I will be teaching you ABCD of pulse. The first pulse that you need to remember is pulsus alternans. Alternans को कैसे याद करना है? इसमें alphabet L आ रहा है. How to remember pulsus alternans is, you can see that alphabet L is present here. So you can use at as a prop to remember the word left ventricular failure. क्या होता है pulsus alternans? It is a alternatively weak, strong pulse. It is a finding of developing left ventricle failure. As you read the name, alternance basically means that it will be alternatively weak. अभी करेंगे बच्चे, डिसेंट आएगा अभी, जेवीपी का बारी आने वाला है ना. अभी तो हमने उसको नॉन शॉकेबल रिदम का रीजन पढ़ा है. दिस डेमोन्स्ट्रेशन ऑफ tamponade वाज ओनली टू टेल यू कि व्हाई इज इट अ नॉन शॉकेबल रिदम. सो जेवीपी की फाइंडिंग आएगी तो पूछूंगा तुमसे ना व्हाई डिसेंट, बट वेरी गुड आंसर नीरज. ओके, सो कमिंग बैक टू द एजेंडा. ए से याद करना है, ऑल्टरनेंस इज एल, सो इट इज लेफ्ट वेंट्रिकल फेलियर. नेक्स्ट इज एनाक्रोटिक पल्स. तो एनाक्रोटिक पल्स के लिए आपने क्या याद करना है? एनाक्रोटिक पल्स विल राइम विद आयोर्टिक. जस्ट से द वर्ड योरसेल्फ, बोलो अभी, एनाक्रोटिक आयोर्टिक. Anacrotic, aortic. So both of them are gonna rhyme, and this is gonna be seen with aortic stenosis. So I will give you rationale also. अभी मैं रीजन भी बताऊंगा, लेकिन पहले मैं आपको याद करा रहा हूं कि कैसे याद करना है. तो ऑल्टरनेंस इज गोना बी लेफ्ट वेंट्रिकल फेलियर एंड एनाक्रोटिक aortic, they are gonna rhyme together. That is valvular aortic stenosis is a physical obstruction. Because of this physical obstruction, there would be a slow rising pulse that would be present. That would be a slow rising pulse because there is a physical obstruction. तो pressure यहाँ पे धीरे धीरे बढ़ता है. So I'll show you graphical representations of the same also. लेकिन अभी के लिए क्या याद करना है? Alternance is a feature of left ventricle failure and anacrotic pulse is aortic stenosis due to physical obstruction क्योंकि रास्ता बंद है. So the pressure will rise धीरे धीरे. That is why it's called as a slow rising pulse. The Latin terminology for this is also asked. The Latin terminology for this is called as pulsus parvus et taldus. That is just a Latin terminology. तो कई बार देखो जैसे I wish कि medical science हिंदी में होती यार, mother tongue, you know, it would have been easier for us. But yeah, because the classical Latin terms is what the examiners want to hear. So in the A alphabet, I want you to remember regarding alternance and anacrotic pulse. Now I will teach you the B, that is pulsus bispherians. Pulsus bispherians is seen in that mote wala heart. In that mote wala heart, they can also give you a post-mortem specimen of a guy who had died suddenly during a football match. Prior to that, he had gone for medical where the doctor had missed the examination finding. What was the examination finding that was missed by the doctor? It was pulsus bispherians. Pulsus bispherians is a twice beating pulse. Pulsus bispherians is a twice beating pulse. Normally, the pulse is felt in the phase of systole, but this would be a twice beating pulse. This twice beating pulse will be felt by you in the phase of systole. So what I will do is, first I will draw normal pulse before you. That is S1, S2, S1. The blue diagram is for normal pulse. The pressure will rise and then the pressure will fall, and there's a small notch also called as dichrotic notch. At the moment, everything normal. Let me draw this once again before you. This time the problem that I am showing is that when you will see the pulse tracing, because this is having a banana shaped cavity of the heart. अगर आप diagram देखते हो इसका, तो you will notice कि this condition is having this banana shaped cavity of the left ventricle. There is a lot of hypertrophy on the free wall. There is a hypertrophy of the free wall. Yeah, you're right, hypertrophic cardiomyopathy. But the pressure tracing in this particular patient would be that the recording will come like this. Let me use a different color. You can see that the recording will come like this. That would be a twice beating pulse that I've currently made before you. So normally the pulse is felt only in the phase of systole, but this is going to be a twice beating pulse where you can see two pulses. I can call this as peak A and peak B. I can call this as peak A and peak B. The problem is present where? The problem is present below the level of the aortic valve. In hypertrophic cardiomyopathy, the problem is present. In hypertrophic cardiomyopathy, the problem is present below the level of the aortic valve. So in the last time's FMG exam, they had given a diagram. In FMG exam, they had given a diagram of a twice beating pulse in systole. This was exactly the diagram. And in the options, he did not ask hypertrophic cardiomyopathy. He said where in which heart valve the problem is present. The question was not that what is the diagnosis. He knows that you will answer na hypertrophic cardiomyopathy, banana shaped cavity, heart specimen. He asked in which particular valve the problem is present. The problem is not in the valve, it is below the valve, but since he has asked it, you need to remember that this is hypertrophic cardiomyopathy. This is also called as subvalvular because the problem is below the level of the valve. इसको बोलते हैं subvalvular aortic stenosis. This particular condition of hypertrophic cardiomyopathy, which you have answered very correctly, this particular condition of hypertrophic cardiomyopathy is called as subvalvular aortic stenosis. LVH, ejection fraction will be less. Neeraj, I have a counter for that. अगर कम ब्लड आएगा ना, बाहर भी कम जाएगा, तो ejection fraction is ratio stroke volume divided by end-diastolic volume. अगर न्यूमरेटर भी कम हो जाएगा और डिनोमिनेटर भी कम हो जाएगा, तो ejection fraction can be falsely normal in these patients also. So we will not rely on ejection fraction for this patient. The point to be remembered is pulsus bispherians in English is what is called as jerky pulse. Pulsus bispherians in English is called as jerky pulse. The technical word for this pulse is ट्वाइस बीटिंग पल्स इन सिस्टोल. जर्की इसलिए बोलते हैं क्योंकि मोटा हार्ट है, जोर लगाएगा तो एकदम से प्रेशर राइज करेगा. सो यू कैन सी सडनली द प्रेशर इज राइजिंग एंड देन देयर इज एन ऑब्स्ट्रक्शन व्हिच इज कॉजिंग दैट छोटे वाला पीक एंड देन द मोमेंटम इज कॉजिंग द ब्लड टू गो इन अ फॉरवर्ड डायरेक्शन. सो व्हाट यू आर नोटिसिंग इन दिस पर्टिकुलर पेशेंट इज दैट देयर इज अ प्रॉब्लम बिलो द लेवल ऑफ द एओर्टिक valve. Let me explain this again. Pulsus bispherians in English means jerky pulse. The reason for the jerk is that mota heart will generate more force. So immediately the pressure will rise, but there is that mota part will also itself cause a physical obstruction in the exit of blood in the heart. So this would be not a slow rising pulse, it would be a fast rising pulse with an obstruction that is present, that is a subvalvular aortic stenosis. Guys, in last time's exam in the MCQ hypertrophic cardiomyopathy नहीं था. उसने ये ग्राफ देके पूछा कि आप बताओ कि कौन से वाल्व में डिफेक्ट होगा, और बहुत बारी एफएमजी एग्जाम के जो क्वेश्चंस होते हैं वो नीट पीजी में रिपीट होते हैं. सो इवन इफ यू आर सेटिंग फॉर नीट पीजी गाइस, यू नॉट सपोज टू टेक दिस लाइटली बिकॉज द क्वेश्चन में एचसीएम नहीं लिखा था. HCM का दूसरा नाम क्या होता है? सब वैल्वुलर aortic stenosis. तो बोला which is the heart valve that is having an issue. Options were mitral, tricuspid, aortic and pulmonic. The answer is it is the aortic valve that is involved. So at the moment the data to be remembered by you is two technical aspects which I'll say once again. Anacrotic pulse is a slow rising pulse. I'll show you the graph of that also. I'll draw the graph of slow rising also after few minutes, but at the moment I'm catering to the core MCQ that came last time, which is pulsus bispherians is jerky pulse. The sudden rise of pressure due to the motor heart followed by the obstruction causes two peaks to be present, and the problem is present below the level of the aortic valve. So that's why we call it a subvalvular aortic stenosis. Yes, Nadeem, you have a point. I'll address that also. Moving to the third pulse. ए हो गया, बी हो गया, ऑल्टरनेंस याद हो गया होगा, बिस्फेरेंस याद हो गया होगा. अब पढ़ते हैं कोलैप्सिंग पल्स विद पिस्टल शॉर्ट साउंड्स इन अ पेशेंट. इफ ही सेज द वर्ड पिस्टल शॉर्ट साउंड्स, तो पिस्टल शॉर्ट साउंड कहां पे सुनते हैं? तो पिस्टल शॉर्ट साउंड इज हर्ड ओवर द femoral arteries. The pistol short sounds are not heard over the heart. It is due to the to and the fro movement. It is due to the to and the fro movement of blood that is occurring in the femoral artery. To assist you, what he also did was he was raising the arm of the patient above the level of the head. The blood of the heart is going back into the heart. You see, in you and me, not a single drop of blood. In you and me, not a single drop of blood will ever go back. But in this patient, the aortic valve leaflets are not working properly. Because the aortic valve leaflets are not working properly, the blood is going back into the chamber of the left ventricle. जो aortic valve के leaflets हैं, which I can show in yellow, are not approximating properly. Because the aortic valve leaflets are not approximating properly, the blood is going back into the heart. This collapsing pulse is a feature that will be seen in patients of valvular aortic regurgitation. Collapse word क्या बता रहा है? Collapse word बता रहा है कि pulse pressure तो बढ़ेगा, but then the pressure will immediately fall. The reason for the fall is blood going back into the heart. In you and me, not even a single drop of blood, not even a single drop of blood will ever go back into the left ventricle, but in this patient substantial volume of blood is going back in the heart. Yes, Nandini, you are spot on for this one. This would be valvular aortic regurgitation. This was much more easier. Why? Because in the paper he also assisted you by writing the word pistol shot sound. So मेरे एक स्टूडेंट तो बोला कि सर मैंने तो इतना दिमाग नहीं लगाया, मैंने पिस्टल शॉट लिखा था, तो मैंने सीधा बोल दिया जो आपने पढ़ाया हुआ है, that is valvular aortic regurgitation, which can be written as aortic insufficiency as well. After all, yes bachcha, you are right. The alternative name for this pulse is also water hammer pulse. Half the problem in medicine is that they have so many names for the same disorder that every time a new name comes up, so what they're trying to do now is trying to standardize the terminology, because otherwise it becomes too overbearing for any doctor or medical student to learn. Because in a world of AI where, like, you know, the cloud is doing the heavy lifting for most of us, then I think that it has to be very precise data here. So at this moment, why pistol shot? Okay, pistol shot इसलिए ना क्योंकि खून आगे जाएगा वापस आ जाएगा ना, femoral artery में भी blood आगे back and forth. तो जैसे गोली चलती है तो जैसे आप गोली की तो आवाज नहीं निकाल सकता मुंह से, तो द साउंड दैट यू विल हियर ओवर द femoral artery इज अ बिग आर्टरी ना, देयर इज सो मच ऑफ टर्बुलेंस हैपनिंग कि femoral artery में टर्बुलेंस, सॉरी हार्ट में तो टर्बुलेंस है ही, ना, यू हैव टू अंडरस्टैंड इज दैट हार्ट में तो टर्बुलेंस है ही है, बट एट द सेम टाइम द टर्बुलेंस इज इन द femoral artery ऑल्सो. दैट इज दैट वो जो बुलेट की बात नहीं हो रहा, बुलेट के जो बुलेट के फायर होने से जो शॉक वेव क्रिएट होता है, जो एयर वेव क्रिएट होता है, दैट काइंड ऑफ टर्बुलेंस वुड बी प्रेजेंट इन दिस पर्टिकुलर पेशेंट. सो yeah, okay, so it is valvular aortic regurgitation that would be happening. So at this moment the words to be remembered are, I think अभी सब पहले प्रैक्टिस कर लेते हैं टर्म्स की, address questions in like after 30 seconds. A is alternance left ventricle failure, anacrotic rhyming with aortic. This variance is hypertrophic cardiomyopathy, the twice beating pulse of subvalvular aortic regurgitation. Then is the collapsing pulse which is present due to valvular aortic regurgitation, and the to and the fro movement is responsible for these pistol short sounds. The same to and fro movement can be seen in the carotid also. तो आप सरप्राइज नहीं होना अगर they write the word dancing carotids. Don't be surprised if they write the word dancing carotid. The word dancing carotid is because the blood is moving forward and backward. In you and me, blood goes only forward, na? In you and me, the blood goes only forward, never ever backward. Here it goes forward, backward. So dancing. Do that again. In us, the blood goes only forward. Here it's forward, backward, because the chamber of the heart is taking back the blood because aortic valve leaflets are not competent. So dancing carotid and the pistol short sounds will make it easier for you to identify that this is a question of valvular aortic regurgitation. Let me write it once again, pistol short sounds. And sometimes in MCQs they might even mention causes of aortic regurgitation. So my question to you guys is, which rheumat disease, this is for NEET PG aspirants and INISET aspirants. If you are an FMG aspirant, इस point को छोड़ देना. Which rheumat disorder will cause aortic regurgitation? I'm waiting for 3 seconds, then I will give the hint. बिना hint के बताओगे? Okay, the hint is it is HLA B27 positive. Just give me a second. The hint is that this is HLA B27 positivity. अब तो आसान कर दिया यार. या ankylosing spondylitis. नहीं बच्चे, HLA B27 positivity ना. That is ankylosing spondylitis. No, not lupus. SLE में जो हार्ट डिजीज होता है यार, वो तो माइट्रल रिगर्जिटेशन होता है ना. आपको SLE में मैडम ने पढ़ाया ना, लिबमैन सैक्स एंडोकार्डाइटिस. इन SLE मैडम वुड हैव टॉट यू अबाउट लिबमैन सैक्स एंडोकार्डाइटिस. उसमें जो वेल्वुलर लीजन होता है वो माइट्रल रिगर्जिटेशन होता है. HLA B27 positivity, rheumat disorder is ankylosing spondylitis, which is associated with aortic regurgitation. Very good. 2 points which I wanted to remember if you are a NEET PG aspirant. FMG में भी आप याद तो कर ही सकते हो, एक बार तो सुन ही सकते हो. Marfan syndrome and ankylosing spondylitis are 2 conditions which are associated with aortic regurgitation. So please note down these 3 points here separately for aortic regurgitation, dancing carotid, pistol short sounds, and association with ankylosing spondylitis and Marfan syndrome. कुणाल बच्चे, मैंने ना रेड में मार्क किया है. कुछ टॉपिक्स ऐसे हैं जो FMG में पढ़ने नहीं है. आप पहला पेज खोलो, उस पर मैंने लिखा है कि कौन से FMG के टॉपिक हैं और कौन से नीट PG के हैं. आपने लास्ट टाइम का FMG का एग्जाम देखा हो ना, तो वो बिल्कुल नीट PG जैसा था. तो मेरा रिक्वेस्ट है कि आप पूरा सुन लो, सारा का सारा डेटा. सेकंड टाइम पे सारा मत सुनना, पार्ट सुन लेना, बट अभी तो टाइम लगा रहे हो तो बेटर है ना बच्चे कि आप सारा का सारा डेटा सुन लो. Okay, जी. Common cause of death in Marfan is Sai Rohit. The commonest cause of death in Marfan's happens to be aortic dissection. You raised a query, I'll answer it, but I think that you know that answer very well. The leading cause of death in Marfan syndrome, fibrilin 1 defect, chromosome number 15. The cause of death happens to be the tear in the aorta, and that aortic dissection will also come up today evening. Aortic dissection will come up on the agenda. Okay guys, it was very hard guys. If you are sitting for FMG exam first time, आपको लग रहा होगा मजाक है. No man, it's not. I mean मजाक तो नहीं लग रहा होगा, मतलब I know it's hard, but like you know after the paper like guys were like sir this was not justified, and I agree it's not justified. And NEET PG में भी यार वो because competition is increasing now, so like they made it harder every time. Otherwise it was not so hard a couple of years ago. Coming back to the agenda. Dichrotic pulse is a twice beating pulse. This twice beating pulse will however be present in both systole as well as diastole. I'm saying a very peculiar thing here before you. Normally the pulse is palpable only in systole. Normally the pulse is palpable only in systole, but this time I want you to draw two speed breakers. This time I want you to draw two speed breakers. One speed breaker in the phase of systole, S1, S2. Second speed breaker in the phase of diastole. This time the word is again twice beating. Earlier I told you twice beating pulse in systole, but this time it is S for systole and D for diastole. This is seen in dilated cardiomyopathy. देखो क्वेश्चन तो सॉल्व कर ही लोगे यार, डी अल्फाबेट से बता ही दोगे कि डायक्रोटिक pulse is seen in dilated cardiomyopathy, but I basically wanted to give a rationale here that this is gonna be usually like a pulse which is seen with patients who are having a flabby heart, and that is dilated cardiomyopathy. Yes, Neeraj, another scenario where may be present is septic shock due to change in the peripheral resistance, but primary answer for dicrotic pulse would be dilated cardiomyopathy. It is DCM. Yes, the primary answer would be DCM, dilated cardiomyopathy. This would be also written in MCQs as like flabby heart, or you can use the word global hypokinesia to describe this. Global hypokinesia to describe it. Which toxin causes dilated cardiomyopathy? Which toxin contributes to dilated cardiomyopathy? Number one cause toxin induced dilated cardiomyopathy is alcohol. Yes, toxin causing dilated cardiomyopathy happens to be alcohol. So most of the time you may write the word alcoholic cardiomyopathy and then dicrotic pulse can be described in the question. Let's do the ABCD again, guys. A is alternance and anacrotic. B is gonna be bispherians for hypertrophic, C is collapsing, and D is the dilated cardiomyopathy ki pulse, that is called as dicrotic pulse. And now what I will do is I will show you some graphical representations, though I've already talked about them. So I will show you some graphical representations where the graphs have to be remembered. The first graph, that is A, is to be marked as normal. The pulse will peak in the middle of systole. The pulse will peak in the middle of systole, and then you will see a chota sa notch. And this छोटा सा notch that is present here is what is called as dicrotic notch. ये जो छोटा सा notch होता है इसको dicrotic notch बोलते हैं. Dicrotic notch जो होती है वो कहाँ पे मिलती है? तो right at the level of S2, right at the level of A2, P2 is the dicrotic notch that is present. निंजा स्टार नहीं बच्चे, वो तो निंजा स्टार जो है वो टॉक्सिन नहीं होगा ना, और निंजा स्टार जो है वो पूछता नहीं है, बिकॉज वो स्टार आप देख लोगे, एक ही इमेज है इंटरनेट पे जो निंजा स्टार की है, तो वो दैट इज लाइक यूजुअली नॉट आस्क्ड. इट्स द अल्कोहलिक कार्डियोमायोपैथी दैट इज आस्क्ड. Which is due to recoil of the aorta? No बच्चे, dicrotic notch is due to closure of the aortic and pulmonic valves, not due to recoil. Recoil of aorta is the falling part of the pulse, right? Dicrotic notch का आंसर क्या होता है? It is the closure of the aortic and the pulmonic valves. Next आप देखोगे तो जो पल्स है वो धीरे धीरे राइज कर रही है. नॉर्मली तो जैसे पल्स जो होती है वो फास्ट राइज करनी चाहिए. यहाँ पे what you can see is a slow rising pulse. Like if I draw normal, the normal should come like this. The normal should come like this, but in this person there is a slow rise in the amount of blood that is coming back in the heart is also relatively less. So I think everybody can pick up. If they give you a diagram like this for a slow rising pulse, then you will say this is anacrotic pulse of valvular aortic stenosis. Next comes the pulse in which two speed breakers can be seen in systole. So let us do the marking here for the speed breakers, that is A and B. Let's do the marking for the speed breakers, that is A and B. And now comes the critical part. The critical part is that if they give you those speed breakers in systole of equal height versus one bigger and one smaller, then you have to realize that there is a fundamental difference. If they give you a speed breaker of unequal size, then you will say it is pulsus bispherians of hypertrophic cardiomyopathy, also called as subvalvular aortic stenosis. But if they give you speed breaker, why dicrotic notch? Dicrotic notch क्यों होता है यार? ये तो फिजियो में पढ़ना था ना, मैं बता देता हूँ. आपने पूछा है तो मैं बोल देता हूँ. जब aortic valve बंद होता है तो जो ब्लड है वो ग्रेविटी से वापस आने की कोशिश करेगा. ये एओर्टिक वेल बंद हो गया ना, A2 और P2 मैंने बोला था, तो ब्लड जब इससे आके टकराएगा ना, नाउ द ब्लड विल स्ट्राइक अगेंस्ट दिस, इससे टकराएगा और फिर बाउंस ऑफ कर जाएगा, टकराएगा बाउंस ऑफ कर जाएगा, तो पॉजिटिव नॉच आता है जिसको डायक्रोटिक नॉच. यू आर रिकॉर्डिंग द प्रेशर इन द एओर्टा ऑफ द पेशेंट. तो पहले तो प्रेशर बढ़ा था, फिर कम हो रहा था, बिकॉज नाउ ब्लड स्टॉप गोइंग आउट ऑफ द हार्ट. बट ड्यू टू ग्रेविटी जैसे ही एओर्टिक वेल बंद होता है, ध्यान से सोचना, जैसे ही दरवाजा बंद होता है ब्लड कम्स, बाउंसेस ऑफ, टकराया, बाउंस ऑफ किया, क्योंकि वेल बंद हो गया ना, दरवाजा बंद हो गया. जैसे ही दरवाजा बंद हुआ, द ब्लड विल स्ट्राइक एंड विल गो ऑफ. सो द थ्योरी टू बी रिमेंबर्ड इज डायक्रोटिक नॉच क्यों होती है? इट इज ड्यू टू द क्लोजर ऑफ द aortic and the pulmonic valves. That is first year medical information, but anyway I've covered here before you. And now I want you to remember that if they give you a graph in which equal is present, yes guys, if the pulse pressure is present equal in systole, इसको सबसे कॉमन गलती होने वाली है ये, बिकॉज जो FMG एग्जाम में उसने पूछा था वो पॉइंट नंबर डी था, दैट इज पल्सस बिस्फेरियंस, वेयर द पल्स की जो एम्पलीट्यूड थी वो अनइक्वल थी. If he will give you equal pulses in the phase of systole, it is not a dilated cardiomyopathy, guys. This is a point to be remembered, that you will say that this is a pulse related to collapsing pulse of aortic regurgitation. Yes guys, जो collapsing pulse का line diagram रहने वाला है aortic regurgitation वाला, उसमें there would be two peaks again in systole, but they will be equal in size. This is a graphical representation. This line diagram was picked up in FMG exam from Harrison. The peaks were equal, तो तभी हो जाता aortic regurgitation, तब भी आंसर aortic valve ही रहना था. If the peaks are unequal, then it is pulsus bisphareans of hypertrophic cardiomyopathy. Yes, Nadeem got it spot on. नदीम ने बोला कि सर अगर एक पीक सिस्टोल में होगी और एक पीक डायस्टोल में होगी, चेक इट आउट, ए एंड बी, द डिफरेंस इज इफ ए इज इन सिस्टोल एंड बी इज इन डायस्टोल, देन यू विल कॉल इट डायक्रोटिक पल्स. तो आपने अभी मेरे साथ, मैं हैंड ड्रॉ भी कराऊंगा आपको, बट दीज आर ओरिएंटेशंस व्हिच आई वांट यू गाइज टू हैव, दैट इफ यू गोना बी गेटिंग पल्सेस, वन पीक इन सिस्टोल, वन इन डायस्टोल, देन इट इज डायक्रोटिक पल्स. अगर सिस्टोल में दो पीक्स है तो देख लेना कि इक्वल साइज की है कि अनइक्वल साइज की है. अगर इक्वल साइज है तो कोलैप्सिंग पल्स बोलना, और अगर अनइक्वल होगी तो पल्सेस बिस्फेरियस बोलना. एंड आई वांट यू टू हैंड ड्रॉ दिस विद मी राइट एट बिलो ऑफ पॉइंट नंबर 8. वी विल यूज अ फाइनर फॉन्ट सो दैट मल्टीपल ऑफ दीज इंटरप्रिटेशंस कैन बी स्क्वीज्ड इन. ऐसे 2-3 बार बना लेना. S1 S2, obviously after that S1 will come, then is S1 S2 again, and we are sorted for रिमेंबरिंग द शेप्स ऑफ द पल्सेस. करना क्या है, बहुत आसान है गाइस, बहुत आसान है. पहले आप स्पीड ब्रेकर बनाओ दो इक्वल हाइट के सिस्टोल में ही. पहले आप स्पीड ब्रेकर बनाओ इक्वल हाइट के सिस्टोल में ही. देन यू मेक टू स्पीड ब्रेकर्स, वन इज बिग and the second one is the छोटू speed breaker. That was that FMG exam question, that is pulsus bisphareans unequal छोटू speed breaker. Then make two speed breakers, one in systole and one in diastole, like this. Try doing this activity guys. If you look at these two datas that I have currently highlighted, that is 1 and 2 at the moment, you would be able to get the orientation right. If you look at 1 and 2 where the amplitude is equal, that the two peaks are equal, you will say collapsing. If you get a pulse in which one speed breaker in systole is bigger than the other, then you will say bisphareans. I hope everybody is appreciating that ये दोनों जो हैं, these are two speed breakers in the phase of systole only, two speed breakers in the phase of systole only. But if you get one speed breaker in systole and one speed breaker in diastole, that would be the dicrotic pulse. This is dilated cardiomyopathy. The query came for point number B. Slow rising pulse भी बोल देते हैं, physical obstruction है ना यार. आप मेंटली विजुअलाइज करो, ऑब्स्ट्रक्शन प्रेजेंट है तो प्रेशर क्या नॉर्मली राइज करेगा या धीरे धीरे राइज करेगा? इट्स गोना राइज रिलेटिवली स्लोली. कुणाल, इफ यू फोकस ऑन द इंग्लिश वर्ड्स देयर, द रीजन फॉर दिस पल्स इज valvular aortic stenosis. Just look at, Arnold Schwarzenegger, the Terminator guy, recently underwent another surgery for aortic stenosis. In the word stenosis, the left ventricle से aorta में बाहर जाने का रास्ता छोटू हो गया. नॉर्मल ओपनिंग इज 2.5 to 4 सेंटीमीटर. अगर वो 1 सेंटीमीटर हो गया, 0.8 हो गया, 0.7 हो गया, रास्ता छोटा है तो बाहर जाने के लिए ब्लड को रास्ता ही कम मिलेगा. सो द प्रेशर विल राइज वेरी 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 स्लोली इन द पेशेंट, क्योंकि रास्ता बंद है. उसको पता है कि आप एनाक्रोटिक बता दोगे. उसने जानबूझ के आपसे जो पूछे हैं वो बिस्फेरियंस पल्स पूछा है या वो डायक्रोटिक पूछेगा. और अगर आप नीट पीजी एस्पिरेंट है तो आपको कोलैप्सिंग का ग्राफ और बिस्फेरियंस के ग्राफ में कंफ्यूजन नहीं होना चाहिए. कमेंट करना बिना देखे इन द नोट्स. इफ यू आर अ नीट पीजी एस्पिरेंट, कमेंट इन द चैट बॉक्स राइट नाउ. इफ इट इज अ बिस्फेरियंस पल्स, व्हाट विल हैपन टू द टू पीक्स, इक्वल या अनइक्वल? डोंट लुक एट द डायग्राम, Just look at the comment section and type right now, in Bispherians pulse, the two peaks will be equal or unequal. Yes, very good. Cool. That's the spirit, man. That's the spirit. सर 10 सेकंड का काम है. अगर आप अभी भी आलस करके मुझे सुन रहे हो लेकिन बना नहीं रहे हो ना सर, तो आप, मेरी रिक्वेस्ट है, पेपर पेंसिल लो डॉक्टर साहब और फटाफट से ट्रायंगल्स बना लो. आप सिर्फ 5 सेकंड. पढ़ना हमेशा ध्यान से है. पढ़ाई हमेशा ध्यान से होती है, कैजुअल में नहीं होती है. बैठ के टेबल चेयर पे पढ़ाई होती है. You just have to listen carefully, get photographic memory. Doctors are supposed to have a photographic memory. I don't know what other people say. My opinion, guys, I'll tell you an experience by which you will be able to study relatively better. One of my batchmates, both of us were 22, right? You were to a medical school at 18. At 22, he cleared IES exam. I asked him, bloody, I can't even finish Robbins and all these books, and you finished geography and history and all those things also. He said, I studied the same as you, and he used to study in fact lesser than me, but still cleared the exam. Why? Because he had photographic memory. He used to study with lot of focus. ऐसे बस बैठ जाता था ऐसे और किताब में देखता रहता था. And I was like कि, and I used to be like कभी इधर देखा, कभी उधर देखा, कभी बाल में करा, and I like this, and like I used to be distracted. What I realized was that he was right, that ध्यान कम पढ़ो लेकिन ध्यान से पढ़ो. अगर पढ़ने का मन नहीं है ना, बंद कर दो यार, छोड़ दो अभी इसको. just shut it off, sleep, leave the class, go and sleep. When you wake up, come back to this और फिर फोड़ दो यार उसको. It's like you have to be like with utmost amount of dedications. Like I learned this from my batchmate. हम normally batchmates में jealousy होती है ना, कि इसकी पढ़ाई नहीं हो रही, इसकी कैसे हो गई. Like I learned that from him, that he was able to do this. Okay guys, so I think we are sorted for the types of pulses at the moment. I've had very good inputs at the moment, and what we will do next is we will talk about abnormalities of the JVP. तो एक और slide कर लेते हैं, one more slide, then we go for a lunch break, right? Deal? So another 10 minutes here. Okay, I'll summarize in English. So sure man, I'll do that. The point to be understood is, man, that if the pulse is gonna be slow rising, I'm gonna call it valvular aortic stenosis, right? Stenosis, opening is small, slow rising pulse. If you get two peaks in systole, focus on the two diagrams. If you get two peaks in systole, you need to check out the heights. If they're equal, like my two fingers are like not of the same height, so you will say Bispherians. You can make your fingers like this now, make like this, two unequal peaks in the systole. You will say, okay man, this is gonna be like pulses Bispherians. But if he gives you a pulse which is gonna be having that equal spike in the systole, then you will say collapsing pulse of valvular aortic regurgitation. For both of them, the answer is aortic valve involvement only, but then the graphical representation is slightly technical difficult, because in both of them aortic valve is getting involved. But if you get two peaks again, one in systole and one in diastole, then you're gonna call it a dicrotic pulse. Yeah, we'll come to pulses paradoxes also. Give me some time. अभी करना है, pulses paradoxes भी करेंगे. I'll come back to that part. I know it is right on the top. तो आप कह रहे हो sir, pulses paradoxes, irregular pulse. I'll come back to it. Right. So now what we will do is, we will talk about abnormalities of JVP. Then I'll come back to the upper part of the slide. Normal JVP value. नॉर्मल JVP वैल्यू इज 5 to 8 सेंट. क्योंकि देखो टेक्निकल किया ना, तो थोड़ा आई नीड टू गिव यू ब्रीदिंग स्पेस, अदरवाइज क्या होगा कि याद ही नहीं हो पाएगा. इफ आई पाइल सो मच ऑफ डेटा, अभी डेटा पाइल किया फिर, और इट्स लाइक हैमरिंग इन द डेटा इन द ब्रेन, देन यू कीप ऑन पाइलिंग, थिंग्स स्टॉप गोइंग इन द ब्रेन. ओके, if it is 5 to 8 centimeter of water, that's the normal JVP value, which will always be checked in the internal jugular vein of the patient. And you have normal waves in the JVP, that must always be remembered. The waves in the JVP would obviously be the positive waves A and V, ACV, and the negative waves that are X and Y. For those guys, yes, pulses paradoxus is a must number. Let me know, in a normal person's JVP, do you see the rise or do you see the fall? Comment in the chat box. In a normal person's JVP, do you see the rise of the JVP or do you see the fall of the JVP? Yes guys, dicrotic notch is normal, dicrotic pulse is not. Dicrotic notch is normal, but the dicrotic pulse is not. Dicrotic notch is normal, not dicrotic pulse. Notch to normal. Yes, in a normal person's JVP, I'll wait for more people to comment. Do you see a rise or do you see a fall? More people to comment. Yes, guys. It is a fall. It is a fall. In normal people, we don't see a rise. It is always a fall. If it rises, that is always abnormal. So let's write down the data here quickly. A wave is due to atrial systole. This you know from physiology, but I'll give you visual cues to remember it. A for atrial systole, so solve ho jayega. C is going to be seen with isovolumetric contraction. C and C, isovolumetric contraction. And what is the reason for this is the bulge that will be of the tricuspid valve, because JVP deals with the right side of the heart. So on the right side is the tricuspid valve. It will bulge upwards. It will cause a positive deflection. The V wave is seen with passive right atrial filling. Passive right atrial filling. If you focus on the English words at this moment on the slide, you can pick up the A and the A. You can pick the C and the C. And you can pick the V and the V, that is the passive filling, the V alphabet coming up, and now would be the X and the Y descent, which are critical. For the X descent, I want you to remember it is atrial relaxation. The word is atrial relaxation, which also means ventricular systole. When the atria is contracting, the ventricles would be, when the atrial relaxing, ventricles are going to be contracting. And for the Y descent, the word is rapid ventricular filling. This is recap of the physiology component. What I have done at the moment is I have done some filling options here. I've tried to help you pick up some of the alphabets here with respect to A, C, V, X, which you have to pick up in the theory, and they'll say which match the following or all of the following are correct, except the only one which I have not mentioned or matched with any alphabet is the theory that is to be remembered, that Y descent is down, and the down thing is due to the rapid ventricular filling in a patient. So it is A, C, V, X and the Y. That's the normal waves of the JVP. In a normal person in the JVP, you don't see the rise. नॉर्मल आदमी में आपको जुवुलर वेन की पल्सेशन फॉल दिखाई देती है बच्चे, बिकॉज वेंट्रिकुलर फिलिंग प्रेशर विल फॉल, राइट. एट्रियल सिस्टोल तो बड़ा हल्का सा होता है ना. एट्रियल सिस्टोल प्रेशर इज वेरी लेस. C wave, the bulge is very less. So you are not able to see the positive waves. You are able to see the negative waves in a normal person. I repeat that again. In normal person, you see fall. If you see a rise, that is abnormal, and that is the point that need to be noted. Kussmaul sign. Kussmaul sign means it will be a paradoxical rise of the JVP on a deep inspiration. It's a paradoxical rise of the JVP on deep inspiration that would be seen with respect to a mnemonic COPS restrict right heart. Let's use this mnemonic COPS restricting right heart. बाय कॉप्स का तो काम यही होता है ना, रिस्ट्रिक्ट करना. सो यहाँ पे नोट करना है कॉप्स के लिए CP हो जाएगा, दैट C and P is to be used. CP would stand for constrictive pericarditis. The rationale is that in constrictive pericarditis there is the calcification outside the heart. It's like a cement block outside the heart. Heart will become stiff. If it is stiff, it cannot relax, and if it cannot relax, blood cannot go in, so it will remain in the jugular vein only. So arise. Constrictive pericarditis has a reduced compliance of the heart. It's like a cement block outside the, imagine cement block outside your heart can't relax. So if your heart cannot receive blood, the blood will be damped in the jugular vein, and that's the paradoxical rise that is present. Then comes restrict. Restrict would stand for restrictive cardiomyopathy. R stands for restrictive cardiomyopathy. This is the rarest type of cardiomyopathy, the slides of which will be discussed in few minutes from now. Then comes the word right heart. Right heart means right-sided heart failure. This is the all except MCQ, and the trick in this MCQ is that the fourth option will be again starting with C, that is cardiac tamponade. What you need to remember is the C is not for cardiac tamponade, the C is for constrictive pericarditis. In tamponade, we do not get a Kussmaul sign because there the JVP becomes non-pulsatile. If you don't have pulsations, you will not be able to appreciate any rise or fall. Even if you don't get into logic, the mnemonic will solve the job for you. What are the causes of Kussmaul sign? The question will be asked in your exam both in FMG and NEET PGS, all except. 3 causes of Kussmaul sign right now, right here, are constrictive pericarditis, calcification, restrictive cardiomyopathy, fibrosis, right heart failure, calcification, fibrosis, failure. calcification, fibrosis, failure, in all three of them, the heart will not be able to relax. And if your heart cannot relax, there would be damming of blood in the jugular vein. So you get a small sin. So CRR is a way to remember it, or COPS restricting right heart is the way to remember it for the mnemonic. Now I will focus on when do you get large A waves in a patient. This question has been asked 2 times in NEET PG, 2023, 2024. So I'll draw a line diagram representing the same. Why do you get large A waves? And when you look at the line diagram here, that drawing the diagram is optional. I don't think so you need to draw because it's very primitive. This is like the tricuspid valve and there is a stenosis present here. तो क्योंकि रास्ता बंद है, because there is a physical obstruction present, the right atria will contract with more force than what it will do in a normal patient. And therefore in the patient, this column, because of the physical obstruction, will go up higher as compared to normal. So what I've shown at the moment before you is pulmonic, what I've shown before you at the moment is tricuspid stenosis. Remember, JVP deals with the right side of the heart. The statement to remember is JVP deals with the right side of the heart. So if there's a physical obstruction in the right heart, if there is a physical obstruction in the right heart, the column will go up higher as compared to normal. The statement to be noted is tricuspid stenosis. This was NEET PG 23-24, both times. Simple question. Large waves are seen in tricuspid stenosis. Even if I change the output and I say pulmonic stenosis, भाई rationale क्या है कि JVP right side of the heart के साथ में deal करता है, right? JVP deals with right side of the heart. So if there's any obstruction of the right side of the heart, whether tricuspid or pulmonic, right side will have to generate more force. More force will translate into a large A wave in the patient. The column will go up higher than what it should go in a normal A wave. So obstructive lesions of the right side of the heart contribute to large A wave in the patient. Now I will change the situation by writing the word pulmonary artery hypertension. Now I will change the situation by writing the word pulmonary artery hypertension. Pulmonary artery hypertension is not an anatomical obstruction, it is a pressure based obstruction. Whether I say the word physical obstruction, whether I say pressure based obstruction, by obstruction to obstruction ही है ना. So the right side will have to generate more force to overcome the obstruction and therefore you get a large A wave in a patient. Please hit the comment button. I had very good inputs. Most guys commented simultaneously with me. Pulmonary artery hypertension को बोलने के लिए mean pressure should be more than how much? Normal pulmonary artery pressure 15 millimeters of mercury. Normal pulmonary artery pressure 15 millimeters of mercury. Pressure of the pulmonary artery should be more than 20 millimeters of mercury to call it pulmonary artery hypertension. Very good, very good. हाँ बच्चे वो थोड़ा सा अपडेट है उसमें that it's they reduce the cut off there. तो पुराने वर्जन्स में आपने सुना होगा तो 25 मैंने बोला है, लेकिन द लेटेस्ट वर्जन्स I've said 20 millimeter of mercury. नहीं बच्चे 30 तो बहुत पहले से था वो तो. They have deliberately lowered the threshold of PAH to increase the diagnostic sensitivity. जैसे हाइपरटेंशन का थ्रेशोल्ड कम कर दिया ना यार, 140/90 था 130/80 कर दिया अर्ली डायग्नोसिस, वैसे ही पल्मोनरी आर्टरी हाइपरटेंशन के लिए भी दे हैव डिक्रीज द थ्रेशोल्ड. आई विल रिपीट दैट अगेन. द थ्रेशोल्ड फॉर पल्मोनरी आर्टरी हाइपरटेंशन हैज बीन लोअर्ड बाय 10 जस्ट लाइक द systemic hypertension threshold has been lowered from 140/90 to 130/80, 10 change, like that you can remember. The pulmonary artery threshold has deliberately been lowered by AHA to increase the diagnostic sensitivity. So causes of large A waves have been discussed. Now I will discuss with you absent A wave. Severe is 60 man. That severity is not gonna change ना. वो कह रहा है early diagnosis करो बच्चे. Severity is 60 only. वो तो it's not gonna change ना. But it is like you decrease the threshold तो early हो गया. वो वैसे ही है ना. Hypertensive crisis remains the same 180/120 only ना. But it is the thresholds that are lower to increase the diagnostic sensitivity. Left ventricular hypertrophy बच्चे LVH in a patient. No, JVP will deal with the right side of the heart, ना. So no relation with the left. तो कुछ isolated comment होगा बच्चे आपका. I missed Kunal the context that you said it. But coming back to the agenda, the next agenda is absent A waves. So absent A waves would be seen in patients of atrial fibrillation. Yes, very good answers, because atrial fibrillation would mean twitching. Twitching means loss of power. Everything in JVP deals with power. Yeah, TOF, pediatric answer, pulmonic stenosis होता है ना tetralogy of Fallot में, Humaira, you have a perfectly spot query that tetralogy of Fallot causes pulmonic stenosis, so agreed. I mean any condition where there's an obstruction of the right side of the heart will have a large A wave. Coming back to the agenda, in atrial fibrillation there's twitching. Twitching will cause a decrease in power output, and when the power will decrease, then you will get a absent A wave in a patient. Right atrial enlargement, yeah, right atrial hypertrophy ना, obstruction होगी तो right atrial hypertrophy हो जाएगा ना बच्चे. If you are having obstruction here, the right ventricle will do more exercise, so right atrial hypertrophy तो होगी ना. Like you go to a gym, you do workout daily, you will develop a bicep. Same here, obstruction present, the right atria will develop a hypertrophy. So atrial fibrillation will be having absent A waves present, and that would be like Nadeem, you said hyperkalemia. No, that is for absent P wave. मिक्स कर गए आप, है ना. एब्सेंट ए वेव वुड बी सीन इन एट्रियल फिब्रिलेशन ओनली, दैट्स द ओनली इनपुट. एंड नाउ वी विल टॉक रिगार्डिंग कैनॉन ए वेव्स इन अ पेशेंट. अभी आएगा बच्चे ट्राइक्युस्पिड रिगर्जिटेशन वाला, या एब्सेंट, perfectly right. Then comes the aspect of cannon A waves. For cannon A waves, they're called as frog sign, pulsations in the neck, pulsations in the neck. The reason for this is atrioventricular dissociation. What I mean by atrioventricular dissociation is that the atria and ventricles are not coordinating. Both are contracting together. Imagine atria is also contracting, ventricles is also contracting. Power of the two will be added and you'll get a super large JVP. That super large A wave is called as a cannon A wave in a patient. I'll say that again. A wave is due to atrial contraction. Atrial contraction is a weak contraction. You add to that the ventricle contraction. Two contracting together. Normally two chambers of the heart don't contract together. Now when atria is contracting, ventricles are relaxing, ventricles are contracting, atria is relaxing. I want you to mentally visualize that atria is contracting with force, ventricle is also contracting with force. जब दोनों एक साथ जोर लगाएंगे तो भाई कॉलम जाएगा बिल्कुल ऊपर. That is gonna be AV dissociation. And now the answer will depend upon whether there is a Brady situation given in a question or a Tachy situation given in the question. The Brady situation, which will contribute to lack of coordination and simultaneous contraction, is what was coming in the chat immediately. That is what is called as complete heart block. Alternatively also called as third heart block. Complete heart block, third heart block. I will discuss the ECG of them in the later part. If they give you a tachy, yes, then it is VT, ventricular tachycardia, or it can be PSVT, paroxysmal supraventricular tachycardia. The point is, if they mention AV dissociation, आपकी लाइफ थोड़ी आसान होने वाली है. अगर वो थोड़ा सा और टेक्निकल करेगा तो वो ब्रैडी या टैकी वाले सिचुएशंस देगा. These are the kind of like abnormal. These are like abnormalities of the heart where the coordination between the chambers is lost. All chambers are working together, and that causes super large A wave in a patient. So at this moment, we have sorted 3 questions on the A wave. That's gonna be 6 sinus syndrome will be having a large A wave. Okay, Maria Khan says, will 6 sinus syndrome be having a large A wave? No, a 6 sinus syndrome would be having rather a bradycardia. Only ventricles will be contracting. Na? The heart rate of the patient will anyway be low in the patient. So 6 sinus syndrome is unlikely to contribute to generation of like a large A wave in a patient. It is a complete heart block that will result in development of the situation, not 6 sinus syndrome. It's a complete heart block where atria ventricles are working simultaneously that will contribute to this. 6 sinus syndrome causes only a Brady component. Okay, now comes the aspect of absent X descent in a patient. So we come to NEET PG 25, absent X descent. Like in 23-24, it was large A wave, then he changed over to absent X descent in a patient. I'm having answers also spot on, but I'll just draw a quick diagram here. So give me 30 seconds of uninterrupted time so that I can just draw the X, and then I'll show you the absent X descent. So keep your eyes glued to the board. This is the tricuspid valve, mitral valve. The blood is going out of the heart. This is the ventricles contracting. So blood is going in the aorta, blood is going in the pulmonary artery. You can see that when the blood will go out of the heart, the tricuspid valve will come down to normal position, and when the valves will be coming back to normal position, the jugular venous column in the patient will begin to fall. Like this is a normal X descent at the moment. Now what I will do is I'll distort the diagram and show tricuspid regurgitation, and now I want you to stop thinking like a doctor. I want you to be a layman and think of only vector. One is the blue vector. One is a blue vector. The blue vector will be causing down and the red vector is going up. So both will cancel and you will have a absent X descent in a patient. So absent X descent is present in, as people have answered very rightly, that is tricuspid regurgitation. And yes, Epstein anomaly, yes, is an obstructive lesion of the right side of the heart. Now all cyanotic heart diseases that are having obstructive lesion of the right side of the heart will also be having a large A wave. So your point is right, Muhib, that Epstein anomaly will also cause a large A wave. That is all pediatric heart diseases. I assume the pediatric faculty has spoken about it. But yeah, obstructive lesions of the right side of the heart will contribute to this large A wave. At the moment, the focus is on a recent question, that is tricuspid regurgitation, where we will be having absent X descent. Because if you zoom into the diagram, one is the blood coming down, blue vector and the red vector, they cancel each other. So absent X descent. Now I will stretch your imagination slightly. I will stretch your imagination slightly by making this tricuspid regurgitation more severe. If I make it so severe that it will obliterate that blue wave, no, like the pink vector is so strong that it is obliterating the X. So the blue, now the column cannot fall downwards at all. Everything will go up. Why? Because there is a upward deflection of blood due to incompetent tricuspid valve in a patient. So let me draw what I said here with respect to this super large A wave in a patient. Like this is what they have also asked in the exam. This is normal recording ACV X and Y descent. This is how normal will come. Now I will show an abnormality of severe tricuspid regurgitation. Follow my purple marker. A will be normal, C would be normal, X will not be there. X क्यों नहीं होगा? Because everything is going up, so there would be no X descent in a patient, so the column will look like this. People have started commenting already. This that is currently shown with a horizontal arrow. This that is currently shown with a horizontal arrow is called as CV wave. It looks like a misprinting in the notes, but it is not. It is CV wave that is seen. Why? Because after C there would be a positive reflection by nomenclature called as V. Yes, perfectly right. That would be CV wave, and CV wave is indicative of the fact that there is a severe tricuspid regurgitation. And now where I am putting the star mark, because this is coming down very fast, so we will use the word steep Y descent in a patient. That steep Y descent is because it went up and then falling suddenly. So for tricuspid regurgitation, I want to say that there are 3 MCQs that I want you to remember. It is absent X, CV wave and a steep Y descent. I'll just write them a little bigger so that in the final output you are able to relate to this better. Give me a second. Yep. This that I've currently highlighted, okay, this is okay, fine. So I'll just highlight it, guys. You can zoom into it subsequently. This is the CV wave that I've highlighted, and this is the steep Y descent that I have highlighted. Both of them are gonna be indicative of a severe tricuspid regurgitation in a patient. But yeah, spot on answers that came up. Now comes the concept of absent Y descent. Absent Y descent, the condition is so characteristic that it is like super easy to identify. Let me just draw this before you. I'm having answers also, but for the sake of completion, once again I'm showing fluid outside the heart. We are drawing fluid outside the heart. This is the heart dancing in a bag of fluid. So you would be having electrical alternance, you would be having low voltage ECG. Yes, you picked it up very correctly, guys. This is cardiac tamponade. Blood आ ही नहीं पाएगा. If you look at the line diagram, there would be no filling of blood in the heart. Remember, I told you Y is due to rapid ventricular filling. Here rapid ventricular filling will not occur because there is presence of lots of fluid. This fluid can be due to cancer. This fluid that I am showing here can be due to TB. This fluid that is present here can have multifactorial etiology, but the fluid will crush the heart. This water, this fluid will squeeze the heart from outside, it will crush the heart from outside, and thereby cardiac tamponade is the condition in which unfortunately there would be obstructive shock developing. You will have to do a pericardiocentesis, and obviously because filling will not happen, so it will result in an absent Y descent. Perfectly spot on, guys. This was a good input. I mean, I could have avoided drawing the diagram, but then I could not stop myself from just taking another 15-30 seconds to make it. that is cardiac tamponade, which is also written in MCQs as having pulseless electrical activity, also written in questions as describe it as having obstructive shock in a patient. Baxdride अभी करते हैं guys, अभी Baxdride अभी आगे वाली slides में आएगा. Now in FMG एग्जाम उसने क्या करा, उसने सेम चीज लिखा लेकिन उसने उसको थोड़ा टेक्निकल बना दिया. उसने लिखा स्टीप एक्शन एब्सेंट वाइड डिसेंट. तो कई स्टूडेंट तो कंफ्यूज हो गए कि सर एब्सेंट वाइड डिसेंट तो कार्डियक टैम्पोनेड में होता है और पहले लिखा था स्टीप एक्स, तो इसलिए मैंने क्वेश्चन छोड़ दिया. तो उन्हें छोड़ना नहीं था बिकॉज द डेटा स्टिल द सेम. Steep X and absent Y descent. Steep X and absent Y descent is seen in patients of cardiac tamponade. In these particular patients, what will happen is less blood will come in the heart, so the less blood will be going out, and when less blood will be going out of the heart, the pulse will become so weak that you will get a feeling as if the pulse is disappearing. That feeling that comes, the pulse is disappearing though the heart is beating, is what is called as pulsus paradoxus. The word is pulsus paradoxus, is an examination finding of this patient, but it is not accurate finding. It is not an accurate way to solve the MCQ. Why? Because pulsus paradoxus can be seen in tamponade, it can be seen in constrictive pericarditis, it can be seen in respiratory conditions. Abhi, when I will move up in my slide, you will notice that I will be criticizing pulsus paradoxus and saying that again, don't use it to solve any question. It is a useless information given in the question to distract you. Students think that pulsus paradoxus लिखा है तो tamponade होगा. इसका जो अगला कंडीशन पढ़ाऊंगा constrictive pericarditis में भी होता है, इन्फीरिबल एमआई में भी होता है, सिवियर सीओपीडी में भी होता है, एस्थमा में भी होता है. यार अगर एक ही टाइप की पल्स इतने सारे कंडीशंस में होगी तो हम उसको डायग्नोस्टिक क्राइटेरिया में यूज नहीं करेंगे. That is the reason in pulsus paradoxus you will notice that when I was discussing the topic, or like I skipped pulsus paradoxus because impression that comes is tamponade, tamponade, tamponade. That's a misconception that we have. Don't use tamponade to solve any question related to cardiology because it will somewhere go wrong. I will tell you hacks how to get them right. Keep listening. Changing the question to steep X and steep Y descent. Here the word is both are turning out to be steep. That is a during the print. Okay, fine. Steep X and a steep Y descent. If it's gonna be steep X and a steep Y descent that is present. Printing तो इसके बाद में आएगा ना. अच्छा ग्रे लाइन ये वाला बोल रहा. ठीक है, got it. Steep X and a steep Y descent. So in those circumstances the data will change. And here like my student said कि सर मेरे को ना ध्यान नहीं था कि क्या पूछ रहा है steep X steep Y. मैं तो क्या देखा कि ना CT chest दे रखा था, उसमें calcification दिख रहा था सर, वो white calcification दिख रहा था हार्ट के आसपास में. तो I answered it as constrictive pericarditis. Is my answer right? I said yeah man. You did the great job. I mean, if you can pick up the calcification outside the heart, then you will be able to pick up that there would be a constrictive pericarditis present with respect to a steep X and a steep Y. आपने याद कैसे करना है? पहले याद करना steep X and absent Y. And then add the word steep X and a steep Y in a patient. The blood will hit the calcification and will bounce off. That bouncing off results in a steep Y descent in a patient. So the next entry to be made in this table is constrictive pericarditis. Abhi after the lunch I will be discussing tamponade in comparison with constrictive pericarditis. But you can see couple of differences coming up in the discussion that constrictive pericarditis has steep X and steep X. दोनों में है cardiac tamponade and constrictive pericarditis. Difference is absent Y and steep Y. याद क्या करना है फाइनली? absent Y is tamponade, absent Y is cardiac tamponade, and steep Y is gonna be a case of constrictive pericarditis. So that's the fundamental difference that I want you to remember. And yeah, auscultatory findings will be discussed, pericardial shudder, etc. Now I'm gonna move up in my slide and I'm gonna introduce pulsus paradoxus before you. Pulsus paradoxus is a misnomer term. Actually वो होता क्या है? It is a systolic fall of blood pressure by 12 millimeter on deep inspiration. It is a systolic blood pressure fall by more than 12 millimeter on deep inspiration. Pulsus paradoxus is caused due to multiple reasons, but actually में होता क्या है? It is a systolic blood pressure fall by 12 more than 12 millimeter. MCQ में जानबूझ के लिख देगा less than 12 on deep inspiration because of septal deviation. ये interventricular septum, because when you breathe in more blood comes in the right side, you get a septal deviation. Septal deviation से क्या होगा? Cavity of the left ventricle will become छोटा. If cavity of left ventricle will become small, it will be able to receive less amount of blood. And if less blood will come in, less will be going out, and because of that, the blood pressure of the patient will fall by more than 12 millimeter. नॉर्मल पर्सन में भी बीपी फॉल करता है डीप इंस्पिरेशन पे, बट इट इज लेस देन 10 मिलीमीटर. इफ इट इज मोर देन 12 वी कॉल इट पल्सस पैराडॉक्सस. व्हाट आर द कंडीशंस कॉजिंग इट? एमआर कैप. इन एमआर कैप कार्डियक टेम्पोरल कंस्ट्रक्टिव पेरिकार्डाइटिस तो तुम बता ही दोगे, तो उसको नहीं याद करना है. आपको क्या याद करना है? व्हाट आर यू सपोज टू रिमेंबर इज द रेस्पिरेटरी कंडीशंस. The respiratory conditions that can result in this and will be discussed once again in respiratory system are massive pulmonary embolism, status asthmaticus. What I want you to remember for today are the respiratory conditions which can result in development of this condition, that is massive pulmonary embolism and status asthmaticus. वो आपसे tamponade और constrictive pericarditis नहीं पूछेगा क्योंकि वो तो आप बता ही दोगे. And an additional thing is right ventricular MI, that is inferior wall MI. That right ventricular MI that I am describing is also called as inferior wall myocardial infarction. We'll discuss MI separately, but for today I don't want you to remember the cardiac conditions causing cardiac tamponade. I want you to develop respiratory conditions contributing to I want you to remember the respiratory conditions contributing to development of pulsus paradoxus in a patient. That would be a systolic blood pressure fall of more than 12 millimeters of mercury. The cardiac conditions, I'll say them for the sake of completion once again, are tamponade, constrictive pericarditis, or inferior wall MI. In all three of them, the problem is that the cavity of the heart is somehow getting squeezed, so therefore less blood will come in and less will be going out. Yeah, right ventricular MI will cause. Okay, let's do this. Okay, I expected that question. इतना तो मानते हो, like I'll do it in 30 seconds से भी कम टाइम में. ध्यान से सुनना. Inferior wall MI, right ventricle will fail. If right ventricle will fail, comment in the chat box what will happen to blood coming to left side. Less, na? And if less will come to left side, the BP will become less. In inferior wall MI, right ventricle will fail. That means less blood will go to the left, and if less will come to the left, तो बाकी तो मैंने लिखा ही हुआ ना. Everything is written on the slide here that if right will fail, additional point सिर्फ एक ही है. Right failure means less blood going to lungs, less coming to left side. If less will come to left side, all these will fall down, and therefore there would be a fall. I hope Ridhima you were able to get this. Give me a thumbs up if it is okay. Otherwise I'll say that again. ओके फाइन, हो गया. ओके, दो चार थम्स अप आ गए तो आई एम एज्यूमिंग समझ में आ गया है. इन्फेरियर वॉल एमआई में, बच्चे मैं हिंदी में बोल रहा हूँ, इन्फेरियर वॉल एमआई में बेटा होता क्या है कि द राइट वेंट्रिकल विल बी सेंडिंग लेस ब्लड टू लंग्स. इफ लेस विल गो टू लंग्स, लेस विल कम टू लेफ्ट साइड. तो अगर हार्ट में आएगा ही कम ब्लड यार, तो बीपी फॉल ही करना है ना. सो या राइट वेंट्रिकल फेलियर. एग्जैक्टली रिदिमा, परफेक्टली स्पॉट ऑन इन दिस पेशेंट. इवन इन हाइपरट्रॉफिक कार्डियोमायोपैथी, तभी तो बोल रहा हूँ कार्डियोलॉजी में हाइपरट्रॉफिक कार्डियोमायोपैथी, इंफीरियर वॉल एमआई, टैम्पोनार्ड कंस्ट्रक्टिव पेरिकार्डिटिस, सभी में पल्सस पैराडॉक्सिस कैन बी प्रेजेंट. तभी तो इट इज नॉट यूजफुल फॉर डायग्नोसिस. तभी तो ऑल्टरनेटिव स्ट्रैटेजीज हैव टू बी यूज्ड इन द एग्जाम. क्योंकि कॉमनेस्ट मिसकंसेप्शन क्या होती है स्टूडेंट्स की कि पैराडॉक्सिस लिखा है तो अभी टैम्पोनार्ड हो गया, कंस्ट्रक्टिव पेरिकार्डिटिस हो गया. भाई सारी कंडीशंस में ही प्रेजेंट है. चलो एक और पॉइंट करते हैं, देन वी गो फॉर अ लंच ब्रेक. इर्रेगुलर ब्रेक, इर्रेगुलर पल्स. इर्रेगुलर पल्स का मतलब ये होता है कि रिदम खराब हो गया. दो कंडीशंस आपके कैरियर में, देयर आर ओनली टू कंडीशंस इन योर कैरियर वेयर यू विल गेट इर्रेगुलर पल्स. एट्रियल फिब्रिलेशन, द सेकंड इज अ टैकीआर्रिथमिया. हिट द कमेंट बटन. हाँ, एट्रियल फिब्रिलेशन तो मुझे पता है यार, तुम होशियार बच्चे हो भाई, आप कंपटीशन में बैठ रहे हो, वेदर यू सेटिंग फॉर एफएमजी एग्जाम और नीट पीजी. तो यार क्वेश्चन पेपर इतना आसान तो है नहीं ना यार. एट्रियल फिब्रिलेशन तो सब बता देते हैं आजकल. तो मुझे बताओ सेकंड कंडीशन वेयर यू गेट अ इर्रेगुलर पल्स. द हिंट इज सीओपीडी का पेशेंट है, हाइपोक्सिया इन द हार्ट एंड एरिथमिया. सीओपीडी के मरीज में कौन सा एरिथमिया होता है? वेरी गुड. आई एम गेटिंग लाइक excellent outputs. The answer is MAT, that is multifocal atrial tachycardia. Multifocal atrial tachycardia is the data to be remembered. Very good. Irregular. We'll talk about इनके arrhythmias की जो ECG है, that will be discussed in the subsequent part of time. But at the moment, what I've done is summarize the different types of pulses with you at the moment, and then I've described line diagrams for pulses. I've talked about the JVP findings in front of you, and ये tamponade constrictive pericarditis will come up in the discussion again as well. So So guys, at this moment, I think we can go for a lunch break. We did a solid session of 3 hours at the moment. That is the minimum duration that you guys should ideally be sitting whenever you are studying. And 3 hour slots, they make you stronger and being able to perform. So is half an hour okay, guys? Will you be starting by like 3:30? I hope that's okay with you guys. Okay, so I assume that everybody is okay. 45 कर लो यार, आधा घंटा कर लो ना, जल्दी खत्म कर देंगे ना, टाइम पे खत्म हो जाएगा ना यार, है ना, आधा घंटा कर लेते हैं. सो लाइक आई एम राइटिंग हियर जस्ट इन केस लाइक समबडी जॉइंस इन लेट, सेशन रेज्यूम्स, क्योंकि फिर वरना शाम को यार लंबा खींचने का मतलब नहीं ना. सेशन रेज्यूम्स 3:30. तो आ जाओ यार, रिचार्ज होके आ जाओ. 8 बजे तक करेंगे बेटा जी, 8 बजे तक क्लास करेंगे. हो सकता है 8:30 हो जाए, थोड़ा सा तो सर फ्लेक्सिबिलिटी दो ना मुझे भी समझाने के लिए, है ना. सो क्लास रेज्यूम्स, सेशन रेज्यूम्स 3:30 PM. गाइस, next break I'll give you bigger, right? Let's try to do core information here. So I'm gonna come back, guys. I'm gonna come back to you in 30 minutes. So great. If you have any doubt तो पूछ लेना भाई, अगर जिसको डाउट वाउट है तो पूछ लो मुझे अभी. ओके. एंड मेरा जो टेलीग्राम ग्रुप है वो मारवा मेडिसिन के नाम से है, तो आप वहाँ पे भी पूछ सकते हो. माई ईमेल आईडी इज marvamedicine@gmail.com. अगर किसी को PDF में दिक्कत होती है, I'll say this once again to you guys. अगर वैसे तो देखो PDF will be available in the link that I've shared. If you have any issues तो परेशान मत हुआ करो यार. PDF के लिए जस्ट ड्रॉप अ मेल टू द टीचर यार, आपको ऐसे ही मिल जाएगा यार. आप बिना वजह परेशान होते रहते हो. marvamedicine@gmail.com and you'll get it. रेड में दिखाता हूँ बेटा आपको, रेड में दिखाता हूँ. शशि, आई शो यू द रेड जो मैंने बोला ना. जैसे आप नीचे जाओगे ना तो कई टॉपिक्स ऐसे हैं जो मतलब जैसे टैकी एंड ब्रैडीरिथमियाज हैं. तो अब आप FMG स्टूडेंट हो तो आप कहोगे सर लास्ट क्लास के टाइम में नहीं पढ़ना, तो मैं बोलूँगा चल जाएगा, राइट. या देखो जैसे ये वाला एक और टॉपिक दिखाता हूँ आपको, ब्रुगाडा सिंड्रोम ARVD. जो मैंने रेड में टॉपिक्स बोले ना, वो मैं ये बोल रहा हूँ कि अगर आप FMG स्टूडेंट हो, आप कहते हो कि सर मुझे नहीं पढ़ना है, या मैं अब लास्ट क्लास में मेरे पर प्रेशर बहुत ज़्यादा है, आई हैव टू फिनिश द कोर्स, तो आई कैन से कि ये रेड्स वाले को छोड़ देना. जितने भी मैंने रेड लेबल मार रखे हैं ना, ब्रुगाडा सिंड्रोम, ARVD, टैकी ब्रैडीज, मतलब दैट आइडियली तो देखो यू शुड लिसन टू ऑल द थिंग्स बेटा. लाइक ऑब्जेक्टिव इज दैट यू हैव टू बी लाइक प्रोएक्टिव एंड लर्न ऑल द थिंग्स. बट आई अंडरस्टैंड यार ना कि भाई टाइम कम है एंड लाइक यू हैव टू लीव सम थिंग्स ऑल्सो, तो चलता है यार, मतलब सम पार्ट्स कैन बी लेफ्ट ऑल्सो. Karthik says will cardiology be completed? I'll try man, I'll try, right. I'll try to complete as much as I can. How to connect these notes with the main videos? See, Lavish, at whether if you're sitting for NEET PG, if you read the same notes of your main notes ना, तो you will feel bored and नींद आएगी आपको. तो अभी मेरा रिकमेंडेशन है कि आप जो भी मतलब like 40-50 hours is what I'm gonna be interacting with you over the next couple of days. So I want you to sit all those long hours and try to finish up maximum stuff with me. तो नोट्स के साथ कनेक्ट मत करो यार. अभी आप ये देखो कि आपको याद आ रहा है या नहीं आ रहा है. जैसे मैंने बोला इरेगुलर पल्स है, तो आपको तुरंत मैट याद आया कि नहीं आया, है ना. Could you pick up the calcification in the heart? आप बोलते हो yes I could, तो बस fine, that is perfectly okay, तो अब दोनों को लिंक नहीं करना है कि आप दोनों नहीं पढ़ सकते. तो like you attending this class, तो what you try to do is you try to finish this one at the moment. में एब्सेंट ए बेटा इसलिए होता है कुणाल, क्योंकि एट्रिया ट्विच कर रहे होते हैं ना. एट्रिया में कंपन, ऐसे सोचो एट्रियल फिब्रिलेशन कंपन में तो कॉन्ट्रैक्शन नहीं हो रही. पहले सोचो एट्रिया कॉन्ट्रैक्शन, मेरे हाथ की तरफ कॉन्ट्रैक्शन, अब हो रही है कंपन. तो जब कांपेंगे तो मैं अगर कांप रहा हूं तो मैं किसी से क्या लड़ूंगा, है ना. ताकत ही नहीं है यार मेरे शरीर में, तो एब्सेंट ए हो जाता है. 149 is very unfortunate, Shashi. Beta, I can understand your hi Karthik, good to interact with you again, man. Kunal, I've answered you. Shashi 149, यार क्या बोलो, बड़ा दुख होता है, बट हिम्मत रख, right? Like keep the faith. Like God, maybe God ने ये सोचा यार तू और पढ़ेगा, तेरी प्रैक्टिस और अच्छे से चलेगी. मान ले तेरे maybe the person who was like very close to you cleared, हो सकता है उसकी प्रैक्टिस इतनी ना चले, तेरी ज़्यादा चले, because God has decided that you should read the whole syllabus again. You never know, man. Destiny. I know so many people who cleared second time, third time, नीट पीजी में second attempt दिया, third attempt दिया, fourth attempt दिया यार नीट पीजी में, फोर्थ पे निकाला, उठाई सीट अपनी वाली, है ना, कि गवर्नमेंट मेडिकल कॉलेज में ही चाहिए, प्राइवेट में नहीं चाहिए, लोन पे नहीं पढ़ूंगा. यू नो द कपल ऑफ गाइस वो गेटिंग मेडिसिन इन प्राइवेट कॉलेज, कह रहे सर नहीं लेना ना पैसा, लोन पे नहीं पढ़ूंगा. तो बैठ गए यार, 2-3 साल बैठे. जज्बा वाली बात होती है, राइट. सो इट रियली रियली डजंट मैटर. Nirmita, I have been doing like 80%, 90% English only. I try to upgrade that to 95%, Nirmita. So, but like all the theory part, man, Doctor, I spoke in English only. Like it's only the end, like I went into a bit of Hindi, but I think I have spoken core things I have spoken in English only. So, Nirmita, sure, your point well taken. Okay, guys. So let's go for lunch, right? And I'll come back to you. Come back to you at 3:30 again. So we are gonna be starting from this page. That's gonna be page number 10. Yes. Okay, guys. Take care. Take care. I'll get back to you. Done. 3:35. Not a problem. Fine. You monitoring in a separate one. Hi guys, welcome back to the discussion. So please join back and we once again get back to the usual business, and this time it's gonna be pericardial diseases on the agenda. Just waiting for a minute or so. I think it's 3:34 by my watch, so we'll start by 3:35. Okay guys, so I think it's 3:35 and we can once again get started. तो अभी जो अगला टॉपिक अब पढ़ने वाले हैं दैट इज एक्यूट पेरिकार्डाइटिस. दिस टॉपिक बिकेम वेरी फेमस एट राउंड अबाउट कोविड टाइम बिकॉज कोविड के जो पेशेंट्स थे दे वर हैविंग लाइक निमोनिया एंड एट द सेम टाइम दे वर हैविंग चेस्ट पेन ऑल्सो. सो वी आइडेंटिफाइड दैट दे आर हैविंग पेरिकार्डाइटिस component. Yes, Prayesh, we are just on the verge of starting. I'll just give a couple of more seconds for people to join in. एक बार छोड़ के exit करके दोबारा से join कर लो. I think it will work. Okay. Fine guys. So as far as acute pericarditis is concerned, the usual presentation will be that of chest pain at rest, and the question can mimic that of myocardial infarction. At this moment, I want to say that in last FMG's exam, this January 1, there was a ECG that was given and the students had to identify whether it is MI or whether it is acute pericarditis. Couple of people casually said, sir, ST elevation था तो हमने MI mark कर दिया. But one guy said, no boss, it was ST elevation, that is okay. But then it was have a concavity in a upward direction. Yes, Shashi, you are spot on and right in that. The point to be remembered by all of you is what is the ECG finding of acute pericarditis. This was a image based question that came in last time's FMG exam and can be repeated in NEET PG again. This is gonna be a ST elevation, but then at the same time the ST elevation is concave in a upward direction, unlike I can say in MI which will be convex in upward direction. I will now draw for myocardial infarction also so that you can see the subtle difference that will come up. I would suggest you एक बार हाथ से बना लेना. For myocardial infarction, it will be convex in upward direction and there will also be a T-wave inversion. You can notice कि ऊपर की तरफ जा रहा है ऐसे lid के जैसे, so it is convex in upward direction. And the second manifestation that is present is the T-wave inversion in a patient, so that difference can be present. And then another ECG finding that can be seen in patients of acute pericarditis. I'll hand draw this before you. All eyes on the board please. At the moment please stop drawing and just follow the inputs that I say. This time what I'll do is I'm gonna slightly modify the input. When you draw this तो क्या करना कि आप बनाना तो same ही, like try to draw it as same as what you draw earlier, but slightly try to show a PR segment depression in the patient. Like somebody commented in the chat box also, because you will get a PYQ that will say what is the most specific ECG finding that is encountered in patients of acute pericarditis. So when you will draw this, my suggestion is that please try to draw this in a slightly downward slope. थोड़ा नीचे को slope दे देना. Zoom in further. Try to give it a downward slope as you can see at the moment. I hope the slope is very obvious. The technical word that you will be using for this second ECG finding that I have highlighted before you is PR segment depression. Now if they give you an MCQ and he specifies the word, what is the most specific ECG finding in a patients of acute pericarditis, then the specific word अगर लिखा होगा तो then you will change your answer to PR segment depression, and if it does not say specific and says routine finding, then your answer would be ST elevation in a concave upward direction. For those of you who are joining in later, I give you one more opportunity. अगर छूट गया होगा तो I give you one more opportunity. In the first ECG, you will notice that I've shown a P, Q, R, and then when the R is coming down, try to show a concavity with the upright T wave. But then when you draw the second one, try to show a PR segment depression in the patient, which is a very specific finding. And this could not be confused with respect to, sir, it is a standard running handwriting that would be coming up. So everything cannot be short, no? Like in pathology, it's 2 words here. It is a running text that is present. So this is a ST segment elevation. It's visible, man. The English alphabets are very much visible. It would be a ST segment elevation. Whichever is the important alphabet, I write in capital. The remaining running text is like we write normally. So this would be a ST segment concave in upward direction versus a PR segment depression that is present. And this is to be differentiated from the myocardial infarction component, which is written separately. In both of these cases, the patient will be having development of chest pain. It will be given at rest only, but then at the same time, the ECG finding has to be differentiated. As far as acute pericarditis is concerned, it is not always that it is viral in etiology. I mean, it could be COVID-19 as a virus that could be responsible, but in India, it could be TB also. Apart from tuberculosis, it could be a bacha who is having rheumatic heart disease, who would be having Ashkoff nodules, which would contribute to this kind of a manifestation. So TB, rheumatic heart disease. Then the next cause of acute pericarditis can be a malignancy. The usual malignancy which is responsible happens to be oat cell cancer of the lung. The usual malignancy that would be responsible is oat cell cancer of the lung. That is because it shows micrometastasis. Please comment in the chat box which is the most common lung cancer, please. Please hit the comment button quickly. Let's see the responses. What is the most common lung cancer, by the way? You want me to give options? Small cell, squamous cell, adenocarcinoma, large cell. Which is the most common cancer? Yeah, the most common lung cancer is adenocarcinoma of the lung. Exactly. The most common lung cancer happens to be adenocarcinoma, primary malignant lung tumor. We do have metastasis, that is overall like the common mets that can be coming, but from the primary malignant perspective, it is always going to be adenocarcinoma. So people who are saying mets and people who are saying adenocarcinoma, your answers are right. Remaining answers are like going incorrect at the moment. Overall is mets and then primary lung cancer is adenocarcinoma, but oat cell cancer is the most aggressive lung cancer. Yep. The most aggressive lung cancer overall is oat cell cancer that can show micrometastasis. So I have mentioned couple of causes that can be resulting in acute pericarditis, which could range from virus, TB, rheumatic heart disease, malignancy and uremia. In all of them, the peculiar ECG findings would be present as are shown at the moment. It is not small cell cancer, as I said, it is the most aggressive one. And now I will focus on the X-ray findings in patients of pericarditis. So the X-ray findings in the patient will be perfectly normal. What I mean by normal is that the cardiothoracic ratio will be normal. So again, comment in the chat box, what is the normal cardiothoracic ratio? What is the normal cardiothoracic ratio? Normal would be equal to or less than 0.5. The heart occupies approximately 50% of the space in the chest. So in patients of pericarditis, the cardiothoracic ratio is normal, but if there is a complication by the name of pericardial effusion, then the cardiothoracic ratio will begin to increase. Now I would like to focus on very specific cause of pericarditis, which is by the name of Dressler syndrome. The reason why Dressler syndrome is given separately, is because Dressler syndrome happens to be autoimmune in etiology. This is an autoimmune pericarditis. The story in this case will be that this person suffered from MI. He was discharged from the hospital safe and sound. This patient suffered from an anterior MI. He was treated with percutaneous coronary intervention or he was treated with thrombolysis, and the patient has been successfully discharged from the hospital. But today, after 42 days, the patient has again come to my hospital with development of chest pain at rest, and he's very, very scared. He's saying, doctor, I'm thinking that I'm having a heart attack again. So initially, I also thought that he's having a reinfarction, and therefore I decided to get a ECG of this patient done. When I got the ECG of this patient done, I found that this was ST segment elevation. But the finding in this patient was that ST elevation was concave in upward direction. So I breathed the sign of relief that at least is not having a heart attack again, but I wanted to be sure. So the blood test that I decided to do in this patient is troponin I. And when I did a troponin I levels in this patient, I expected him to be having a elevated troponin I because it could be reinfarction. But thankfully, by the grace of God, what happened in this guy was the trop I values were perfectly normal. They were normal because pericarditis will only cause inflammation of the outside of the heart. It will not cause a necrosis. If there is a necrosis, then troponin I level will elevated. Here there is no necrosis, only inflammation, so troponin I will be normal or can be mildly elevated but never gross elevations that are seen. The examiner himself will give you all this story. He will himself tell you MI हुआ था, patient had recovered, he's again come back, the doctor is doing ECG, biomarkers are normal, ECG showing ST elevation, and then he will say what is the treatment of this autoimmune pericarditis. The examiner himself will try to incorporate the word autoimmunity in the stem of the question. The objective of the examiner will be that on reading the word autoimmunity, you make a mistake and answer this as steroids. Do not answer steroids for autoimmune pericarditis. I agree that the drug of choice for autoimmunity is steroids, but don't answer steroids there because steroids will interfere with healing. जब हार्ट अटैक होता है तो डैमेज इन द हार्ट विल बी कंट्रीब्यूटिंग टू नेक्रोसिस, इट विल कंट्रीब्यूट टू लाइक एक्सटेंसिव टिश्यू डैमेज, सो देयर वुड बी कोलेजन फॉर्मेशन दैट इज रिक्वायर्ड. Now you know that steroids interfere with the healing process, they interfere with the collagen formation, so the scar formation will be weak. So in this particular condition, the main treatment that you will be giving to the patient is aspirin. We will be giving like aspirin 650 milligram 3 times per day. Dose is not important. It will cause lot of gastritis. I said that dose to tell you that lot of gastritis would be there, erosive gastritis. So in those circumstances, like pantoprazole can be given. Dialgene gel and some stomach protective agents can be given to the patient, but the main agenda why I wrote Dressler syndrome separately from the routine causes of pericarditis was to sensitize you to the fact that for treatment of this condition, we are not supposed to answer steroids, we are supposed to answer rather aspirin for this patient. The reason for that is that steroids interfere with the process of healing, they will cause a weak scar formation, they will cause a aneurysm formation. Now, among all the causes that I have explained to you on this particular slide with respect to acute pericarditis, there can be a complication developing in the patient. The complication that will develop in these patients of acute pericarditis can be by the name of pericardial effusion, where water accumulation or fluid accumulation, serofibrinous exudate will accumulate outside the heart. In pericardial effusion, the fluid is accumulating outside the heart, so one, we should be knowing that how much is the normal fluid outside the heart. The normal fluid outside the heart is in a range of 20 to 50 ml, and anything more than that would be called as pericardial effusion. Because there is fluid outside the heart, therefore he will use the word low voltage ECG to describe the ECG findings here, because fluid will act like a buffer. The definition of low voltage ECG is the height of the R and the depth of the S would be less than 5 millimeter in the limb leads. LL का मतलब होता है limb leads. Meaning of the word low voltage ECG is the height of the R and the depth of S is less than 5 millimeter because there is a zone of water and a buffer fluid outside the heart. But in some MCQs, because this is again too damn easy, the examiner will try to play around with English. The English terminology that you will see in these questions is by the name of electrical alternance. In the previous session, I taught you pulsus alternans. That was a pulse fluctuation with respect to weak pulse, strong pulse. This time it is a fluctuation that is occurring in the patient with respect to the voltage. So the technical term is called as electrical alternance. The technical term is electrical alternance. That is just a surrogate term that the examiner is using. The spirit is still the same, that the voltage will be buffered because there is a layer of water outside the heart of the patient. Whether it is TB, whether it is rheumatic heart disease, whether it is lung cancer, ultimately you have to understand that there is fluid outside the heart which is more than 50 ml. That water will buffer and will prevent the transportation of current to the recording electrode, so we will get a low voltage ECG. Now low voltage ECG word, if any doctor will read the word low voltage ECG, the thought process is there is water outside the heart. So you can figure out the answer as pericardial effusion. So that is why I said the examiner will use alternative terminology, that is a fluctuating amplitude, that is called as electrical alternance. Both are in the same spirit that there is water outside the heart causing a buffering of current. But the message in this particular patient is, यार देखो what happens in pericardial effusion is हार्ट के आसपास पानी भर गया, तो जब पानी भर जाता है तो उससे क्या होता है कि द वोल्टेज रिकॉर्डेड जो होती है वो लेस हो जाएगी ना. इतना तो मानते हो कि रिकॉर्डिंग इलेक्ट्रोड चेस्ट पे लगाएंगे तो इन योर एंड माय हार्ट देयर इज वेरी लेस फ्लूइड आउटसाइड द हार्ट, सो करंट विल बी ऑफ पर्टिकुलर एम्पलीट्यूड. इफ यू हैव लॉट्स ऑफ वाटर आउटसाइड द हार्ट देन द वोल्टेज बाय द रिकॉर्डिंग इलेक्ट्रोड विल बी कॉम्प्रोमाइज्ड. तो उसको हम बोलते हैं लो वोल्टेज ईसीजी. And the same thing that is present there, the low voltage ECG part is what is called as electrical alternates. Definition क्या होती है लो वोल्टेज ECG के कि R और S की हाइट जो है ना, जैसे R ऊपर जाता है S नीचे जाता है, उसको दोनों को जोड़ोगे तो इट वुड बी, सारे जो बक्से होंगे, द बॉक्सेस वुड बी लेस देन 5 मिलीमीटर. Pericardial friction rub in pericarditis, हाँ auscultatory finding ना can be present in a patient, that is pericardial friction rub, but difficult to appreciate most of the time because scratchy sound in the chest, pericardial friction rub may not be present in some cases also. So we will, conduction won't be same as air in a fluid. भाई air कहाँ से आ गया? एयर कहाँ से आ गया? हार्ट के आसपास पानी है ना, तो एयर तो है ही नहीं ना, देयर इज वाटर आउटसाइड द हार्ट ना इस बारी तो. Okay, I get the point, Dr. Kirti. You were trying to help there by saying that there is like different conduction. हार्ट के आसपास वैसे भी पानी है ना, ज़्यादा हो गया यार. There is water versus more water, which is causing a low voltage ECG in the patient. Now, when you will be doing the X-ray in the patient, yes, we will get in tamponade also a low voltage ECG Vaishnavi, but then voltage और भी कम हो जाएगी ना. Like for pericardial effusion, if it is 4 millimeter, for tamponade it will become 2 millimeter or 1 millimeter. So low voltage ECG is a common finding in both effusion as well as tamponade. That is how we will differentiate, is what I'm going to teach you next. So when you look at the X-ray of this patient, then in the X-ray of this patient, you will be noticing that there would be a water bottle heart that would be present. Water bottle heart would mean that there is like fluid outside the heart. So that's the radiological terminology that is present. We call it a water bottle heart, or instead of water bottle heart, there's an alternative terminology. I can also say money bag heart. Yeah, it is the same finding. It is the same finding. Whether we say water bottle heart or we say the word money bag appearance, it would basically mean the same only, that there is a lot of fluid outside the heart. So these are surrogate terminologies that are present. Why this kind of situation can be seen? Then most of the time the causes in India contributing to pericardial effusion can either be TB or it can be lung cancer in the patient. Tuberculosis and lung cancer, how will we differentiate? Then differentiation can be that in these cases, what I can do is I can be going in ahead with the echocardiographic guided pericardiocentesis. I can put in a needle and we can remove the fluid which is present outside the heart of this patient. When we remove the fluid outside the heart of this patient in echocardiographic guided pericardiocentesis, I will send this fluid to the lab for CBNAT and I will be able to identify it as TB, and I can also get cytology and immunohistochemistry done, and that would help me know that I am dealing with a case of lung cancer. So especially if it is going to be tuberculosis or it's going to be lung cancer, then the two important causes in India can easily be identified, because we can do a echocardiographic guided pericardiocentesis and appropriate treatment in these patients would also be seen. The appropriate treatment for these patients would be, like for example, if it is TB, if it is a tubercular pericardial effusion, I can be starting my patient on anti-tubercular treatment. You guys tell me, what is the treatment duration? Like for how long will you be giving anti-tubercular treatment to this patient? Quick answers please. Can you let me know what will be the duration of tuberculosis treatment for tubercular pericardial effusion? Other can be lung cancer also. We can put a drain. Why would you put TB में कभी drain नहीं डालते? We never put a drain in case of TB. Yeah. Okay. Yes, more people please. You will be giving ATT for how many months in this particular patient? Okay. So most of the guys are wrong in this particular case. The answer for extrapulmonary TB is 1 year. The answer is not 6 months. The answer for this patient, the question that I am putting up before you is not 6 months. For extrapulmonary TB, we give treatment for 12 months in a patient. Please read the DOTS program again. In extrapulmonary TB, the treatment is given for 12 months. For lung cancer, we give anti-cancer treatment, that is in the form of 1, a platinum-based compound cisplatin. Comment in the chat box which anti-cancer drug is given for treatment of oat cell cancer apart from cisplatin. Yeah, extrapulmonary TB is also always 1 year. Which anti-tubercular drug is given for, anti-cancer drug is given for treatment of oat cell cancer? It's a chemotherapy regimen. The lifespan of the patient will usually be very, very less. Yes, guys. Okay, for treatment of these patients, cisplatin, and the second drug that we use is irinotecan. So I asked a couple of queries at the moment here before you, which are with respect to TB treatment for 1 year and anti-cancer treatment, that would be cisplatin, irinotecan, that would be required in the patient. Now suppose a person will not take this treatment. Suppose, let me say, if the person will not take this treatment, then the amount of fluid will keep on increasing. And if the amount of fluid will keep on increasing, then these patients will start developing a complication that is called as cardiac tamponade. The point to be understood is, first we have pericarditis, then we have is a pericardial effusion, and after pericardial effusion, if the treatment is not given, then the person will develop cardiac tamponade. The question then arises, how will you differentiate cardiac tamponade from a case of pericardial effusion? You will look at the blood pressure values. If ever in doubt whether the patient is having pericardial effusion or whether the person is having cardiac tamponade, you can easily differentiate between the two conditions by checking out the blood pressure values. Low voltage ECG, electrical alternance are common findings which will be found in pericardial effusion and tamponade also. The X-ray finding and ECG finding will be same. The only difference will be water in the water bottle will be more, money in the money bag will be more, but that is very subjective, na? If I say water bottle hard, more water. If I say money bag appearance, money is more. That's a very subjective terminology. The technical word is, how do you check? The main check would be that you will have to go on either echocardiography or on clinical findings in a patient. So what you will use is, you will be moving on to the complication of pericardial effusion, that is called as cardiac tamponade. And in cardiac tamponade, how do you differentiate? If you are ever in doubt, if in the paper you are ever in doubt with respect to whether should I answer pericardial effusion or should I answer pericardial effusion or should I answer cardiac tamponade, check out the blood pressure value. Don't rely on pulsus paradoxus, because pulsus paradoxus will be given in the question. When you write it, I want you to write like this: pulsus paradoxus is the common finding. It is a common finding which is seen in both cardiac tamponade as well as a case of constrictive pericarditis, so no big deal. The main differentiating features between how do you pick up in the MCQ whether it is tamponade or whether it is going to be a case of pericardial effusion is, one, the JVP character. In patients of cardiac tamponade, the heart will be crushed, so the JVP of the patient will be elevated. The pressure on the heart will be so extreme that now the pulsations of the JVP will totally begin to disappear and the person will develop a non-pulsatile elevated JVP. Mark my words here, the only time in cardiology when you get a non-pulsatile elevated JVP. The only time in cardiology when you get a non-pulsatile elevated JVP is cardiac tamponade. There is no other medical condition, mark my words there is no other medical condition which you will read where there is a, from the cardiac perspective, there is no other cardiac condition where you will read about non-pulsatile elevated JVP. In all conditions of cardiology, you will always notice that JVP is always elevated and it is always having pulsations. Yeah, Pranav, that is non-cardiac, na? SVC thrombosis is non-cardiac. I said from the cardiac perspective. Non-pulsatile elevated JVP is the key word that you have to identify in the MCQ. If you don't remember that, still don't worry. If you check out the blood pressure value, the blood pressure in the patient in this particular case will be unrecordable. The JVP finding is what I have already explained to you. That would be a presence of a steep X, and because the filling of blood in the heart will not occur, it will be an absent Y descent. So the question then arises, how do you differentiate in an MCQ that says low voltage ECG? This is what some doctor had commented in the chat box, that sir, low voltage ECG is finding of pericardial effusion also, it is a finding of cardiac tamponade also. How will we differentiate in the paper? Check out the blood pressure value, check out the JVP findings, check out the pulse findings. If these are the findings which are present in a patient, then we will say that this is going to be like the characteristic manifestations that are present. The column of the neck would be full. Na? I think a lot of you are like, chalo chodo. A lot of you, what you have to understand is that normally JVP mein pulsations hote na. You can see AC, V is the positive, X and Y is the negative. Normally the column always falls. Here it is rising. It will be full vein. So full that now there is no pulsations that are visible. So that's a technical terminology to be remembered. In the X-ray of this patient, you will notice that money in the money bag will be more. So he will deliberately write in the question the words like money bag heart. He will deliberately write in the question words like water bottle heart. The words will be written like this, that you will think that it is a case of pericardial effusion, but because the additional points that I have said, It is the additional points that I've said, like unrecordable BP and non-pulsatile elevated JVP, that you will be able to differentiate between the two. Most of the time he may not write the word absent Y descent because he also doesn't want to make it very, very obvious for you. So I'll say this once again: how in a MCQ in 5 seconds will you differentiate whether it is cardiac tamponade or whether it is going to be a case of pericardial effusion? What you're supposed to do is check out the blood pressure values and the aspect of non-pulsatile elevated JVP. The additional thing, if he's kind on you, he might even mention that auscultatory finding which everybody was being, has been very vocal about. So I am now gonna write that finding also before you, because I know that a lot of you would be saying, sir muffled heart sound से solve हो जाएगा ना? तो हो जाएगा, but यार अगर देता ही नहीं MCQ में तो फिर मुझे तो बाकी technical points बोलने पड़ेंगे ना. Muffled heart sounds is the best way to evaluate a question of cardiac tamponade. The reason for absent Y will be कि filling नहीं होगा ना, तो आप basic physiology पहले पढ़ो, उसमें absent Y descent होता है, and the reason why it is not happening is the filling is getting compromised. Beck's triad is an easy way to solve this particular question, but then it is a muffled heart sound which would be used for the key differentiating features in this particular patient. Now we will focus on how to identify constrictive pericarditis. Constrictive pericarditis is a condition. Muffled heart sounds has a differential diagnosis of pneumothorax. No, absolutely not. कहीं पे भी नहीं लिखा. Muffled heart sounds are characteristic feature only of cardiac tamponade. In pneumothorax, the differential diagnosis नहीं, मतलब pneumothorax will cause unrecordable BP, that is okay, but उसमें muffled heart sound नहीं होते ना, उसमें तो absent breath sounds होते हैं. What you are mixing up is muffled heart sounds versus muffled breath sounds. अगर मैं बोलूँ muffled breath sounds, then it is pneumothorax, but it's muffled breath sound. Word is breath sound. This time it is heart sound. So there is no reason why the differentiating feature would be present. And now we will focus on the word constrictive pericarditis. So constrictive pericarditis is a complication that is seen in those patients in whom they have taken ATT treatment for 1 year. Patient is arguing with you, come on sir, I took treatment for 1 year and I am having calcification outside the heart. The problem with TB is that it leaves behind lot of calcification. So what I'll do at the moment is I'll just draw a crude diagram. In fact, I can draw a different way using a thicker font size. Give me a second. Let me say this is normal heart. This is normal heart. I'm going to draw this once again. A normal heart again. Like I've drawn two hearts at the moment before you. Now what I'm saying is in one of them, I will be drawing a thick zone of calcification. Let's say this is like an eggshell. This that I've currently shown before you is like a very thick shell of calcification outside the heart of this patient. This thick zone of calcification that I'm currently highlighting before you is the representation of constrictive pericarditis. This is a complication of treated tubercular pericarditis. The guy has taken ATT for all the long duration that you had said, like you had said ATT to be taken, the patient was very compliant, the entire 1 year treatment was completed. But TB is such a bad disease, it is such a nasty disease that even when you treat the tuberculosis, it leaves behind calcification. If you had somebody in the family who had TB, their X-ray today will be showing calcification, though the TB cavity has collapsed so many years back. TB is such a nasty disease that it always leaves behind a thick zone of calcification. We'll talk about how to break it also. We'll talk about how to break the heart, right? We'll talk about how to break this calcification. TB is such a nasty disease that it leaves behind a thick zone of calcification. So therefore what will happen is the filling of blood in the heart of this patient would be compromised. Like if you look at these two line diagrams here, in a normal person when the blood will be coming in the heart like this, the blood will be coming in the heart, it will be striking the muscle. If this is a normal heart, the blood will come in the heart, it will stretch the muscle and it will cause a little bit of distension. It will cause a distension of the cardiac chambers of the patient. What you can see in the line diagram is blood is coming in the heart, it is hitting the muscle, it will distend the heart, there is a stretching of the heart because our heart is compliant. So in this particular patient, I have shown normal filling of blood in the heart, that is 130 ml. While you are sitting comfortably listening to me, the end diastolic volume for you is 130 ml. But in this particular patient of constrictive pericarditis, one, I will show the arrow to be tapering. The reason for the tapering is because the heart is stiff, like calcified, like cement block outside the heart. It will limit the amount of filling in blood in the heart, and you can see that less blood is coming in. This blood will hit the muscle, it will hit the muscle, it will try to stretch the muscle, but will fail miserably. It will fail miserably because this person is having a non-compliant heart, so the blood will hit the wall and will bounce off. I'll say this once again, blood heart mein andar to aaya, but now it will hit the muscle, it will bounce off, and this will cut off, or this will create turbulence. This will create a lot of turbulence in the cardiac chamber. This turbulence is the main reason why we are discussing this particular topic. Your patient has taken TB treatment, he is still having pedal edema, he is still having breathing trouble. He is saying, sir, I have taken treatment of TB for 1 year and still I am having a problem. The problem is calcification will limit the filling of blood in the heart. Imagine your heart is having a calcified zone, the blood will hit the muscle, try to stretch and will fail miserably. The blood will hit the muscle and will bounce off. And when it will bounce off, it will create turbulence. This turbulence is an auscultatory finding, which I want you to remember for this discussion. In place of muffled heart sound, the opposite data to be noted here is, in place of muffled heart sounds, the alternative data to be noted here is the word pericardial shudder. I do the activity again. What you can see in this patient is, if I remove these arrows, right, the amount of blood coming in the heart is less. The blood will hit the muscle, like you can see the blood hitting the muscle, and then it will bounce off because this is a non-compliant heart. It is creating turbulence. In your and my heart, there is no turbulence that is present, but in this patient, turbulence would be present. So the main thing in the MCQ that they want to pick up, or they want you to pick up, is this auscultatory finding that is called as pericardial shudder. There are alternative names for pericardial shudder also, but then what I want you to pick up is pericardial shudder is a auscultatory finding of constrictive pericarditis. Don't rely on pulsus paradoxus. The way I've written pulsus paradoxus to दोनों में present होता है. Now, what additional findings will be present in this patient is the JVP character. The JVP character in this patient will be a rise of JVP, but it will be pulsatile. So I'm writing the word Kussmaul sign. The only example in cardiology where you get elevated JVP but is non-pulsatile, जो normal pulsations ऊपर नीचे होता रहता है. Pulsation का मतलब क्या होता है? It keeps on going up down like this. Here the pressure is so high, no pulsations. But with Kussmaul sign, he will always say elevated JVP. Pulsatile word would not be written because that's a normal happening. So the only scenario in the question that you will read is non-pulsatile elevated JVP for tamponade. Here he will say the word Kussmaul sign. Yeah, shudder means turbulence only. That's the auscultatory finding ना. उसको shudder बोलते हैं. Shudder मतलब the sound is so loud that आपको stethoscope का भी जरूरत नहीं है यार. You keep your hand on the chest of the guy. You can feel the turbulence under your hand. That is why the word used is shudder, pericardial shudder. Then comes the aspect of JVP findings in a patient, that is steep X and a steep Y descent in this patient. Steep X के पीछे नहीं भागना है. स्टीप एक्स के पीछे नहीं भागना है. दोनों में स्टीप एक्स होता तो उसके पीछे भागना नहीं है. आपने क्या पकड़ना है? वाई. फिलिंग नहीं हो रहा ना. टैम्पोनाड में तो फिलिंग होता ही नहीं है. द हार्ट इज टोटली क्रश्ड. आई हैव ड्रॉन द डायग्राम ऑफ टैम्पोनाड 2 times, so I did not draw it here. I drew the diagram of pericarditis on this slide. Tamponade diagram I made 2 times. The heart is crushed, so there is no filling, so absent Y. But in this condition, because the blood will come in the patient, so there would be a steep Y descent that is present in a patient. And now you will check out the blood pressure value in this patient. So BP in this patient will be normal or will be low, but will never be unrecordable. Even in this condition, there will be a low voltage ECG. But the reason for low voltage ECG in this condition will not be water outside the heart. I hope you are appreciating the fact that in a patient of pericardial effusion or in tamponade, there was fluid outside the heart, but now on treatment, the fluid has disappeared. Can you please comment in the chat box what will happen? I mean, why is the low voltage ECG present here? Then your answer will be that this is calcification which will be causing a low voltage ECG outside the heart. The reason why low voltage ECG is again not a good way to identify the question is because low voltage ECG can be seen due to fluid, it can be seen due to calcification outside the heart as well. So it's not a very good way to pick it up. When you will do X-ray in the patient, the cardiothoracic ratio in this patient will be normal. The CT ratio is normal, but yeah, sometimes calcification can be seen outside the heart. Like I showed you a cardiac CT which was given in the paper where calcification was visible. I've written plus minus to say that calcification is best visible on a CT scan. Calcification is best visible on a CT scan, but calcification will not be visible with respect to like maybe sometimes on an X-ray. So I've written the word plus minus. And how will we treat this condition? We will treat this condition by going in with what is called as pericardial stripping procedure. Pericardial stripping would mean that we will remove the calcification. So I'll refer this patient to the Department of Cardiothoracic Vascular Surgery, and the CTVS person will operate on this patient and pericardial stripping procedure will be done. To see that you got me or not, please comment in the chat box. If they give you low voltage ECG in the paper, low voltage ECG would be RNS, that would be less than 5 millimeter. If they give you low voltage ECG in the question and pericardial effusion is also given and cardiac tamponade is also given, I agree it is present in both of them. Can you select the single best answer? Let me complete my question. If I give you a question of low voltage ECG and simultaneously say BP is unrecordable, versus suppose I give you a question in which alone low voltage ECG is given, what would you like to answer for plain low voltage ECG? If I say the word CTVS is direct cardiothoracic vascular surgery. If in the question alone low voltage ECG is given, there is nothing else given in the question, then you will say low voltage ECG is a feature of pericardial effusion. But suppose I give you a combo. Suppose in the question I give you a combo. What I mean by combo is I say low voltage ECG and I say while describing the BP of the patient is unrecordable or is usually less than 90/60. If both of these things are given, then you will say cardiac tamponade. I hope you are appreciating the fact that low voltage ECG तो दोनों में मिलता है, pericardial effusion में भी मिलता है, and it is seen in a case of cardiac tamponade also. But then how do you differentiate between the two is on the basis of the blood pressure value in the patient, that if the BP is unrecordable or he says value less than 90/60, answer it is cardiac tamponade. Otherwise your standard answer will be low voltage ECG is a feature of pericardial effusion. Guys, low voltage ECG तो even can be seen in hypothyroidism in a patient. I will be describing low voltage ECG in hypothyroidism also. Everybody in the chat box, those of you who are sitting for NEET PG, please let me know why do you get low voltage ECG in hypothyroidism. I am writing causes of low voltage ECG at the moment. Why do you get low voltage ECG in hypothyroidism? I am writing the causes of low voltage ECG at the moment. That is why low voltage ECG is a useless term. People use it to solve MCQs. Even some apps are using that, telling you this is the buzzword. It is not the buzzword. You know that word has become a fashion nowadays. Buzzword. Low voltage ECG is a buzzword. It's not a buzzword. Pulsus paradoxus is not a buzzword. Yes, very good. Mixed edema. In hypothyroidism patients, there is a mixed edema that is present, which is responsible for low voltage ECG. So the first point I want to say is that this has become a fashion nowadays to use word like buzzword. The buzzwords are what I have highlighted here. Unrecordable blood pressure, non-pulsatile elevated JVP that would be present. Low voltage ECG can be seen in hypothyroidism, pericardial effusion, cardiac tamponade, and even in cases of constrictive pericarditis, the rationales are different. What I mean by different rationales is that in the top three it is fluid and in the last one it is a calcification. In the top three it is fluid and in the bottom it is a calcification that is responsible. So low voltage ECG is a feature that can be seen with multiple conditions. I've just summarized the number of times that I've highlighted the terminologies before you at the moment. Mixed edema का मतलब lymphedema होता है. That's a feature that is always seen in hypothyroidism patients. So I don't need to write the word hypothyroidism or Hashimoto. I mean, examiner can write words like Hashimoto's thyroiditis, Riddle's thyroiditis to imply the hypothyroidism component. But like these are the conditions where this would be present. And what I've tried to do is compare before you the important diseases of the heart. What I've tried to do is explain to you the core issues for the differentiating features. I'll do salient post-trauma hemorrhagic cardiac effusion. It will cause cardiac tamponade. If it's a post-hemorrhagic cardiac tamponade, no, then it will result in that post-trauma hemorrhage will cause a cardiac tamponade in a patient. We'll discuss a question related to that in the later part of the discussion. Trauma could be like a stab injury to the chest or even a blunt trauma to the chest, but it will ultimately, the hemorrhagic effusion will result in development of a tamponade. What I want you to remember at this moment is that I have tried to explain the diseases of the outside of the heart before you. Acute pericarditis will result in development of pericardial effusion. and pericardial effusion will then result in development of cardiac tamponade. Constrictive pericarditis has been discussed separately. That separate part is where the calcification around the heart is present in this particular patient. But at this moment, what I am saying is, what are the auscultatory findings which, if given in a question, will make your life easier? If he gives you auscultatory findings, then what are the auscultatory findings that you are supposed to pick up? You see, restrictive cardiomyopathy will be discussed, as you can see in the handout in the later part, no? So I will come to that RCM part later, no? When we discussed tamponade versus, we will discuss restrictive cardiomyopathy versus constrictive pericarditis. So let's focus at the restrictive cardiomyopathy. Yeah, can cause fibrosis in the heart. A good input, Humera, from your side. If he says the word pericardial friction rub in the question, he is making my life easier. I really wish questions are so easy like this. I really wish that the examiner uses words like pericardial friction rub and says the data in front of me. What I want to say here is, here I have written the word small m to say that because less water is outside the heart, so the muffling will be very, very less. Because I have written a chota m to say that because little, like a fluid is 60 ml, 70 ml, so the muffling will be less. But suppose it is 100 ml, 120 ml, muffling will be more. So if you read the word muffled heart sounds written in a question, then you should favor it as cardiac tamponade. I'll repeat this again. In pericardial effusion and cardiac tamponade, they are both brothers. They are two brothers. Pericardial effusion is less aggressive. Cardiac tamponade is more aggressive. So all the findings that I have highlighted here before you are basically just a continuation that effusion is a condition where fluid will be more than 50 ml. Suppose it becomes 100, 150, 200, then it will get converted into tamponade. To explain tamponade, let me say, like I was taking a physical class yesterday, so there was seating capacity of 200 students. Now, if there are 200 chairs in the classroom and I take a booking for 400 students, then I can't ask the student to sit for 8 hours in 200 chairs, 400 students can't sit, no? 4-5 extra, we can, accommodate ki chal yaar baithne dete hain, but I can't like force 400 people into a 200 people hall. So what I want to explain to you is tamponade is a condition where there is a limited space around the heart. The limited space around the heart is meant for only 50 ml max. If in 50 ml you are filling in 200, look at the magnitude difference I am saying. Our heart pericardial space is having 50 ml space. In that 50 ml, if I will fill up to 100, it's going to squeeze the heart, it's going to crush the heart. That is the cardiac tamponade aspect that I have highlighted. And the auscultatory finding of constrictive pericarditis, I'll just use a separate color to give honor to constrictive pericarditis. That is going to be a pericardial friction rub. It is called as a pericardial shudder. In some MCQs, you will notice that he may not write the word shudder. In some MCQs, instead of writing the word shudder, they will write the word pericardial knock. In some MCQs, they will write the word pericardial shudder. Sometimes they will say the word pericardial knock. Sometimes they will use the word pericardial shock. They all three mean the same. I earlier just said one term because I wanted you to be used to that turbulence in the heart. The blood will come, hit, bounce off, hit, bounce off, hit, bounce off. So that causes pericardial shudder. उसी का ही दूसरा नाम है pericardial knock and pericardial shock. And those of you who sat for NEET PG last time would have noticed that in the MCQ उसने तीनों में से कोई भी term use नहीं करी. The term used by the examiner in NEET PG was, he used the word loud diastolic sound. He used the word loud diastolic sound. So that's the fourth terminology that I want you to remember. Pericardial shudder, pericardial knock, pericardial shock. एक ही बात होता है. And if he says and changes that to loud diastolic sound, it is in the same spirit. But this is a comparison between the three common diseases from the auscultation perspective. I really wish that they put up auscultation findings right in the first or second line. It becomes a piece of cake for you. But if he does not give you auscultatory findings, then you have to rely on the table that I've currently made before you. This is like a super important table. If you are an FMG question, FMG examiner, you FMG student, then you have to NEET PG to khair invariably they will ask you this. If you're an FMG student, this is a must know table for you. Cardiac tamponade versus constrictive pericarditis. Water outside the heart, calcification. Water versus calcification. The differentiation is to be picked up. S3 is a loud is picked up. S3 is a low pitch heart sound. So you hear it with the bell, and pericardial shudder is heard with the help of the diaphragm. Differentiation कैसे करते हैं? That both are heard at the same time in the diastole. Pranav, this is a NEET PG question that not exactly a NEET PG question. I think this was a NEET SS question. That how do you differentiate a pericardial shudder from a patient auscultatory finding a pericardial shudder from S3, then S3 को सुनने के लिए you will have to use the smaller side of the stethoscope, that is the bell, because it is a low pitch sound, and pericardial shudder is like that harsh sound, so it's a diaphragm that is used. So differentiation is heard on the basis of the side of the stethoscope from where it will be heard. If you are hearing the sound in diastole, the loud diastolic sound, that booming sound, that is pericardial shudder. If it's heard with the smaller side of the stethoscope, then it is third heart sound in a patient. So that's the differentiation, Pranav. Let's move on to the next one. What I'll discuss next is the aspect of murmurs, and okay, one more thing. Chalo, I'll write it separately. I'll say it verbally at the moment. Everybody to comment in the chat box, especially if you are a NEET PG aspirant. Diastolic collapse of ventricles. I'll write it separately when the time comes. Say at the moment, diastolic collapse of ventricles is a feature of. Diastolic collapse का मतलब क्या होता है? No filling of blood in the heart. And which condition have I discussed now, where there is minimal filling of blood in the heart, hardly any filling of blood in the heart? Yes guys, waiting for your answers please. Very good. Cardiac tamponade. You see, he's playing with English, man. He's not playing with our career. A lot of guys say, sir, he's playing with our career. No, man, he's playing with English. Diastolic collapse of the ventricle basically means, diastolic collapse का मतलब क्या? Diastole में filling होता ना? Collapse का मतलब there is no filling of blood in the heart, in the, like that's the first diagram that I made before you, where I showed lot of water outside the heart. That is cardiac tamponade in a patient. So I'm going to write that in the summary statement that will come subsequently. But yes, I had very good inputs at the moment. Most guys were able to pick up the word diastole, filling of blood in the heart. तो या तो tamponade होगा या pericarditis होगा. But when I say the collapse, it means that there is hardly any blood coming in the ventricle. That implies cardiac tamponade. So good entries guys, good job at the moment that you have done. And now let us focus on the turbulence in the heart, that is murmurs. And yep, this is again asked in both FMG and NEET PG questions. So we will first use the mnemonic by the name of PASS to remember the ejection systolic murmurs. Everybody wants to pass, everybody wants to get good marks. So let's look at the causes which would be responsible for the PASS mnemonic for ejection systolic murmur. Then I will draw line diagrams before you at the moment. PASS would stand for pulmonic stenosis, and aortic stenosis results in development of ejection systolic murmur. Before I draw the line diagrams, I want to say that how the ejection systolic murmur will be asked to you in the exam. He will give a line diagram like this, where S1, S2 and S1 will be written. And then what he will do is, he will show turbulence, like he will draw a graph like this, where the maximum intensity of turbulence will be seen in the middle of the diastole. Like you can increase the turbulence substantially, and then you can reduce the turbulence substantially. The English word that I want to use for this is crescendo, decrescendo murmur. The English word for this is crescendo, decrescendo murmur, which is PASS, pulmonic and aortic stenosis में the intensity of the murmur will increase in middle of diastole, and then will decrease down. So we call it crescendo, decrescendo. How will he give you pansystolic murmur? Again a line diagram. Before I fill up the causes, MTR vada. Pansystolic murmur will be having a uniform intensity all through the duration of systole. So I mean, how the murmur is asked in the paper is that they'll give you a line diagram, and then you are expected to just pick up the situations there. In ejection systolic murmur, the point to be understood is that turbulence will rise and then will fall down. अभी के लिए mnemonic याद कर लो, PASS, pulmonic and aortic stenosis. Let's work out MTR vada. Vada is that dish that we have for breakfast, very common in southern. If you go to Bengaluru or even in India, everywhere now the vada would be available. MTR is a brand by which you can make very good South Indian food in your houses. So obviously it would not be as good as the authentic one that you get down south, but then it's like lovely food, right? So MTR is mitral regurgitation. TR is tricuspid regurgitation, left and right side of the heart. I will draw line diagrams also, but at the moment I am just giving you mnemonics by which you can remember. Mitral regurgitation, tricuspid regurgitation and ventricular septal defect are the causes which are responsible for it. So there are two mnemonics to be remembered: PASS, MTR vada. PASS is pulmonic and aortic stenosis for ejection systolic murmur. And for pansystolic, it is empty or vada mitral regurgitation, tricuspid regurgitation, and VSD. Let me now draw the line diagrams at the moment before you, and you can focus on the first one. That's going to be pulmonic stenosis, or we can take up aortic stenosis at the moment. Can you tell me the cross-sectional area of the normal aortic valve, please? How much is the normal opening size of the aortic valve? The normal opening size of the aortic valve will be something in the range of 2.5 to 4 square centimeter. 2.5 to 4 square centimeter. And in this particular patient, there would be a narrowing that would be present. Because of this narrowing, no bache, 4 to 6 is answer for mitral valve. 4 to 6 is answer for mitral valve. Here it is 2.5 to 4 square centimeter. That answer that you said, no, that 4 to 6 thing, that is for that is for mitral valve. Aortic is 2.5 to 4. Okay. Because of obstruction, there will be a concentric hypertrophy of the heart. In patients of valvular aortic stenosis, because there is an obstruction, so there would be a hypertrophy of the heart, and because of the hypertrophy, the ventricle will contract with more force than normal. If you check out the diagram for the right hand side, I have drawn a single plus to say that orifice of the valve is normal. So the blood will be able to go out into the pulmonary artery, and you can see a laminar flow. You can see I am showing a laminar flow of blood here. But if you focus on the diagram on the left, I have shown that the patient is having more powerful contraction because of the hypertrophy. Reason for hypertrophy is when you will do more exercise. No, like if you go to gym and work out every day, you will build up biceps. Here aorta, left ventricle is working against resistance. So left ventricle will put on muscle, and when this hypertrophied muscle will contract against an obstruction. When the hypertrophied muscle will contract against an obstruction, there will be a turbulence. And this turbulence that is created, normally we have laminar flow. Normally, if you look at the diagram, normally across our heart, across the pulmonic valve, we are having laminar flow, smooth flow, so no noise is heard. There is no turbulence that is created. But in valvular aortic stenosis, because the opening is chota, lot of turbulence is created, noise is created. That is a feature of valvular aortic stenosis. That is the cause of murmur in this patient. The intensity of the murmur will peak in middle of systole, because then the ventricle will be contracting with maximum force. Why is the intensity more? Because in the middle of systole, max pressure is being generated. So that is why the intensity murmur will rise, and then obviously the systole will get over, and the intensity of the murmur will become lesser. The line diagram that I have drawn here before you is for valvular aortic stenosis. This particular valvular condition, aortic stenosis, is usually common either in pediatric age group or it is common in geriatric age group. This particular condition is either common in pediatric age group or it is common in geriatric age group. So the issue to be agenda to be remembered is कि या तो बच्चे में होता है या फिर adult population में होता है. Either it's going to be a child or it's going to be a geriatric age group, where like usually normally like heart disease is seen in young people. But here you will notice that valvular aortic stenosis is common either in bacha or would be common with respect to geriatric age group. You guys have been silent for a while. I want everybody to comment in the chat box. If you are an FMG student, please comment in the chat box. What is the commonest valvular lesion in a 1-year-old infant? What is the most common valvular lesion in a 1-year-old infant? Yes guys, waiting for your answers here. Commonest valvular lesion. This is an FMG exam question. Commonest valvular lesion in a 1-year-old infant is? PDA is not a valvular lesion. PDA is not a valvular lesion. Yeah, it is. I just said it, man. I just said it at the moment. Valvular aortic stenosis. Guys, the question said, what is the most common valve lesion that is seen in an infant? Answer is valvular aortic stenosis. This is what I am explaining. It is seen in extreme age group. या तो बच्चे में मिलता है, child, like small child, or it would be seen in geriatric age group. It is aortic stenosis. Another question for FMG students. What is the most common valve lesion in rheumatic heart disease in a 5-year-old child? Here I am given the age group also. It's a 5-year-old bacha, and he is having rheumatic heart disease. What is the commonest valvular lesion? Yeah, valvular aortic stenosis is perfectly right, Malshri. Yes guys, what is the most common valvular lesion that is seen in a rheumatic heart disease child who's 5 years of age? Yes guys, I'm waiting for your answers. Come on, guys, it is not mitral stenosis. How can you make silly mistakes like that? The commonest valvular lesion in children at 5 years of age in rheumatic heart disease is mitral regurgitation. It is not mitral stenosis, guys. When the same patient will be 18 years of age or older, then the same patient will develop mitral stenosis due to commissural fusion. Don't make silly mistakes there, guys. बच्चे में MS नहीं होता है. A child is not gonna have a MS. It will take some time for the fibrosis to happen, commissural fusion to happen. So these are three questions. Good that I discussed them. Obviously, NEET PG में he'll not make it so simple. He'll give you a clinical domain. But then these are a couple of one-liners which I want you to remember. Yes, guys, we need to basically, like, work out the common things which are which are asked. So I'll do the activity once again. What is the most common valvular lesion in infant? Valvular aortic stenosis. Child with rheumatic heart disease, mitral regurgitation. Same patient when he is more than 18 years of age, that is when the answer is gonna be mitral stenosis. So first and foremost, you need to get used to like the common questions. And now I'm gonna describe a case of valvular aortic stenosis. It's either gonna be child or it's gonna be adult, and he's gonna talk about SAD. What I mean by SAD is, he will say patient is having recurrent syncopal episodes because if the obstruction is present, less blood is going out of the heart. Because of the hypertrophy of the heart, there can be chest pain, that is angina. And in all cardiac patients, there would be dyspnea. So if you read a question that talks about SAD in a geriatric age group or in a pediatric age group, and then says the following information, which is, if he says the word anacrotic pulse, question is solved. Valvular aortic stenosis. But because anacrotic pulse has already been discussed, I don't need to describe the anacrotic pulse here. I will write down the murmur of this patient. The murmur of this patient is, and I'll hand draw this once again before you, that they'll give you a diagram jahan pe, try to do this with me, increase the intensity of the murmur and then get it back to normal, like the sound will disappear, it will disappear. So when the ventricles contract with force, that is when the ejection systolic murmur will be present in this case, and the investigation choice for this condition will obviously be echocardiography. The same thing that I've said for aortic stenosis will be valid for pulmonic stenosis also. Now, if I make that in pulmonic stenosis, the diagram will become untidy, but it will not change the hemodynamics. There also the opening will become smaller, turbulence will be happening. So the same story will be for pulmonic stenosis in the patient also. The main thing is the word crescendo, decrescendo murmur / ejection systolic murmur is a feature of PASS, is what I've explained for the murmurs topic. That's the first point to be remembered. PASS is a feature of ejection systolic murmur, and aortic stenosis, couple of related MCQs I have currently explained to you. Anacrotic pulse part I did not write because it has already been discussed. Now what I will do is, I will be drawing a diagram on the contralateral side. And this diagram that I'll draw on the contralateral side will be with respect to mitral regurgitation and tricuspid regurgitation. So this is a line diagram where tricuspid valve and mitral valve leaflets have been shown, and the mitral valve leaflets are not being able to approximate properly. In you and me, not a single drop of blood will ever leak across the tricuspid valve leaflets whenever ventricles will contract. Like you can see in the diagram, right ventricle is contracting, so blood is going in the pulmonary artery of the patient very smooth. When the left ventricle is contracting, the blood is going into the aorta very smooth. But there's a problem. There's a big problem. And what is the problem? The problem is the mitral valve leaflets are not able to hold their position properly. So if you look at the diagram in this particular case, you will notice that there is blood leaking from high pressure chamber to low pressure chamber. Left ventricle is high pressure, left atria is low pressure. So the difference of pressure will cause turbulence, and the turbulence will result in development of a murmur. This pressure difference will be uniform during the phase of systole. So when you auscultate, there would be a pan-systolic murmur in a patient. You can draw on the other side also. If the person is having tricuspid regurgitation, I've just changed the side, again the same hemodynamics, pan-systolic murmur. I will now modulate the diagram by showing here a hole in the interventricular septum. ये एक बच्चा है, 1-month-old baby having heart failure. Why the problem of heart failure is there? There is left ventricle is decompressing into the right ventricle. आप अगर ये तीनों डायग्राम्स को देखते हो, the red one, the blue one and the green one that I've currently highlighted, तो आप देखोगे the left ventricle or like the high pressure chamber is decompressing into a low pressure chamber. There is a continuous leakage of blood during the phase of systole. यहाँ पे जैसे ही systole start होगा, there would be continuous leakage of blood either from LV to RV और from LV to LA और from RV to RA. तो यहाँ पे जो murmur present होता है उसको बोलते हैं pan-systolic murmur, PSM, that was mentioned, and that is with MTR vada. The MTR, M is the mitral regurgitation, the T is the tricuspid regurgitation, and V is the VSD component in the patient. This is a single diagram जहाँ पे मैंने तीनों डिजीजेस को एक साथ दिखाया है. द थॉट प्रोसेस इन द एग्जाम, यू विल नॉट हैव टाइम टू थिंक ऑफ अ डायग्राम. देयर यू विल बी ऑपरेटिंग ऑन रिमोट मेमोरी. इन द एग्जाम नोबडी हैज टाइम टू थिंक कौन सा ब्लड कहां पे गया. इट इज ऑपरेटिंग ऑन रिमोट मेमोरी. एट दिस मूवमेंट व्हाट यू नीड टू फिगर आउट इज दैट द ब्लड इज गोइंग फ्रॉम अ relatively higher pressure chamber to a relatively lower pressure chamber. That pressure difference will be constantly present all through the phase of systole, so that will cause a pan-systolic murmur in a patient. But when it comes to ejection systolic, the word ejection से करो ना यार. Ejection means blood is going out of the heart. A lot of my students they said सर हम तो इंग्लिश से करते हैं. मैंने कहा कैसे. कह रहे सर इतना डायग्राम वगैरह में दिमाग नहीं लगाते हैं. आपने बोला ना इजेक्शन सिस्टोलिक. इजेक्शन मतलब ब्लड इज गोइंग आउट ऑफ द हार्ट, तो टर्बुलेंस होगी. तो इजेक्शन सिस्टोलिक मर्मर, हाउ डज ब्लड गो आउट ऑफ द हार्ट? वाया द एओर्टिक वाल्व ना. वन गाय सेड सर कि हिंदी में मेरे को कैसे याद करना है. भाई दिक्कत क्या है, इजेक्शन वर्ड पे फोकस करो ना. इजेक्शन मतलब ब्लड को हार्ट से बाहर जाना है. उस टाइम पे आवाज आ रही है तो भाई रास्ता छोटा होगा ना. आपके घर में जैसे नलका है, टैप है, आप टैप पूरा खोलते हो और पार्शली खोलते हो तो पानी, जैसे कोई भी ऐसे बोलूंगा कोई भी पाइप है ना, पाइप में से अगर नैरो कर दो तो टर्बुलेंस होती है. समबडी रिक्वेस्टेड इन हिंदी, सो आई स्पीक इन हिंदी फॉर 2 मिनट्स. द पॉइंट इज गाइस, अगर कोई पाइप है, पाइप से पानी जा रहा है, तुम अगर पाइप का जैसे आपकी गाड़ी को वॉश करना है, लाइक अ लॉट ऑफ गाइज यू नो यू माइट बी लाइकिंग बाइक्स, तो आप बाइक को जब वॉश करते हो तो यार वो पूरा टायर वायर साफ करने के लिए ऐसे प्रेशर क्रिएट करते हो ना, ऐसे थंब से यू स्क्वीज ऑन द पाइप सो दैट देयर इज प्रेशर क्रिएटेड. सेम हियर, ओपनिंग इज छोटा, टर्बुलेंस क्रिएटेड, तो टर्बुलेंस जब बाहर जा रहा है उस टाइम पे नॉइज आ रहा है, तो इजेक्शन सिस्टोलिक, इंग्लिश में लिखा है भाई, इजेक्शन सिस्टोलिक मर्मर इज अ फीचर ऑफ जब ब्लड बाहर जाएगा. कहां से? या तो एओर्टिक से जाता है या पल्मोनिक से जाता है. So there is no need for mnemonic. Just focus on English for ejection systolic and you are sorted. I hope Shashi that is sorted for you. And now I'll come back to the comparison for systolic murmurs, that is PAS and MTR VADA for the two situations that are currently highlighted. And then what I would like to do is add a term that was asked in FMG exam. उसने FMG exam में क्या करा, मेरे students को परेशान करने के लिए, मेरे dear students को परेशान करने के लिए उसने pulmonic stenosis नहीं दिया, बट उसने क्या लिख दिया, नूनन सिंड्रोम. आई थिंक सबको पीडियाट्रिक्स में मैडम ने ये बार बार पढ़ाते हैं, नूनन सिंड्रोम का कॉमन वैल्वुलर लीजन क्या होता है. इसको नोट कर लेना गाइस, इसको नोट कर लेना. नूनन सिंड्रोम में जो कॉमनेस्ट वैल्वुलर लीजन होता है दैट इज पल्मोनिक स्टेनोसिस. सो दैट वाज अगेन अ क्वेश्चन दैट आई हैव हाइलाइटेड बिफोर यू. वो सिंपल डेटा को बस ऐसे ट्विस्ट मारने की कोशिश कर रहा है कि आप पढ़ के पल्मोनिक स्टेनोसिस, वहां पे एक स्टेप एक्स्ट्रा हो गया ना कि सोचना पड़ेगा अच्छा यार नूनन क्या होता है. तो बस यहीं पे याद कर लो, नूनन सिंड्रोम में कॉमनेस्ट वैल्वुलर रीजन इज पल्मोनिक स्टेनोसिस इन अ पेशेंट. सो एट द मोमेंट वी आर सॉर्टेड फॉर द सिस्टोलिक मर्मर्स. एंड नाउ व्हाट आई विल डू बिफोर यू इज I will be describing this diastolic murmurs before you. I will utilize tetralogy, Fallot, carcinoid syndrome or other conditions where tricuspid stenosis can be occurring. Pranav, you have a good input there. Okay ji, next I'm gonna discuss one more question, but this time I'm gonna draw a line diagram. I would suggest you to make this with me. Make mitral stenosis with me. Mitral stenosis. Because this is one of the commonest valvular lesions seen in patients after 18 years of age. I think सबको clear हो गया यार, mitral stenosis बच्चे में आंसर नहीं करना होता. It is to be answered for an adult patient more than 18 years of age. Most of the time in India, diagnosis made when like a girl is pregnant. You know, she got married. उसका शादी हो गया, बचपन में उसको rheumatic heart disease with MR था, अभी she got married and then she's having breathing trouble in pregnancy. तो फर्स्ट तो थी शॉर्ट की ब्रीदिंग ट्रबल तो प्रेगनेंसी में थोड़ा बहुत तो हो ही सकता ना. व्हेन द यूट्रस विल बिकम बिगर, द डायफ्राम मूवमेंट्स बिकम लिमिटेड, सो लिटिल बिट ऑफ ब्रीदिंग ब्रेथलेसनेस कैन बी सीन इन प्रेगनेंसी इन अ नॉर्मल फीमेल, इन अ नॉर्मल प्रेगनेंसी आल्सो. बट द ब्रेथलेसनेस इज वेरी सिवियर. दैट इज व्हेन शी कम्स टू द ओपीडी, यू पुट स्टेथोस्कोप, यू हियर अ मर्मर दैट आई एम गोना शो हियर बिफोर यू. दैट इज mitral stenosis, the commonest valvular lesion being discussed. There is a venous return this is laminar flow. This is laminar flow, normal flow blood in the right ventricle of the patient. This is the left side. So the blood will come in like this, and then there will be turbulence. You can see, because whenever you force a liquid from a narrow opening, there is gonna be turbulence which is present. I'm gonna put point number A for left atria, point number B for the left ventricle. Blood is getting into the ventricle when during the phase of diastole. So the murmur of mitral stenosis is a diastolic murmur. Why? Because the filling of blood in the heart occurs in diastole. The filling of blood in the heart occurs during diastole. Now I want everybody to participate and let me know that if this opening will become more smaller. If this opening will become more smaller, forget about cardiology, forget about cardiovascular system. सिर्फ सोच के मुझे बताना. I'll use a bit of Hindi here. अगर opening कम छोटा हो गया, if the opening is smaller, to go from A to B, imagine this is a small opening, it has become more smaller. To go from A to B, will it take same time? Will it take more time? If the opening will become, suppose it is 4 centimeter, it became 3. From 3 it became 2, from 2 it became 1. As the opening will become chota, if the opening will become smaller, will it take same time? It will take more time. Yes, it will take more time. It will result in increase in the duration of the murmur. All of you guys are spot on. There was a question in your paper that said, what is going to determine the severity of mitral stenosis? The severity of mitral stenosis is decided by the length of the murmur. I will draw hemodynamics before you also. But the simple logic to be remembered is, अगर रास्ता छोटा हो जाएगा तो टाइम ज़्यादा लगेगा. ज़्यादा लगने की वजह से severity of mitral stenosis decided by the length of the murmur. In the options, intensity of the murmur was also given. You will not mark on the intensity. You guys have yourself correctly answered that the severity of mitral stenosis is decided by not how loud the murmur is. It is decided by how long the murmur is. It is the duration that will increase. So don't mark on intensity. Don't mark on the word loud. Don't mark on the word loud P2. Let me write this again. Don't mark on the word intensity of the murmur. Don't mark on the word loud P2. Loud P2 is a feature of pulmonary artery hypertension. Don't mark on the word loud S1. All of them were given in the MCQ and couple of students did make a mistake of answering intensity. Some people answered loud P2. The determinant of severity of mitral stenosis is simply the length of the murmur. It is simply the length of the murmur. It is simply the duration of the murmur that will basically decide the severity of mitral stenosis. Severity of mitral stenosis is decided by, the answer is length of the murmur, duration of the murmur, and not to be answered as the remaining two. This first question was repeated in FMG exam early again, and this time they changed the language. So first I'll tell you the hack how to remember it. Severity of mitral stenosis is directly proportional to the length of the murmur. Directly proportional. Longer the murmur, more severity. But now they changed the language because they knew everybody would have studied this. So the next point to be remembered by you is severity of mitral stenosis is having an inverse relation with S2, opening snap gap. I will give you the rationale for this also. But at this moment, what I want you to remember is the word inverse relation here. I want you to remember the inverse relation here, not a direct relation. What is the direct relation? Severity of the murmur, length of the murmur, right? Its severity of the disease is the length of the murmur. Opening is shorter, more longer time. The same question was repeated. Then your answer would be S2 opening snap gap. Now I'm gonna give you the rationale for that S2 opening snap gap also. So keep your eyes glued to the board and listen to how the mitral stenosis murmur will be represented and how I will work out the data of S2 opening snap gap. What I have done here is deliberately made diastole very long because I want to incorporate the murmur component. At the moment, what I've shown is another auscultatory finding of mitral stenosis, which is because of the higher pressure in the left atria because obstruction is there. If there's an obstruction present in the left atria, there would be a loud opening snap. The mitral valve will open with more force as compared to you and me because there is an obstruction present. So most guys are able to solve the MCQ of mitral stenosis even without the knowledge of murmur because this word is characteristic for mitral stenosis, loud opening snap. I will say this again. because of physical obstruction, rasta band hai, because of physical obstruction, the atria of this guy, you need to compare with yourself. If a MS patient is sitting on a chair next to you, his left atria is contracting with more force as compared to you and me, because there's a physical obstruction, and because of more force there would be loud opening snap present, and after that the murmur will start. This murmur, which I would like you to draw in the form of a mountain peak, this murmur, which I would like you to draw in the form of a mountain peak, is what is technically called as mid-diastolic murmur. This is what lot of young chaps were prompting in the chat box even when I started this topic, that sir, you are teaching mitral stenosis, we know the answer, this is mid-diastolic murmur. Good job guys, I was happy listening to that. I was really happy listening to the fact, or seeing the fact, that you guys are already aware of the fact that the murmur is a mid-diastolic murmur. Why mid-diastolic? Because maximum blood flow occurs in middle of diastole. You can also see that this murmur is having a chotu sa spike. This chotu sa spike that is present here, this chotu sa spike that you can see in this patient, in this diagrammatic representation, is called as pre-systolic. Why pre-systolic? Because systole will start after S1. After S1, the systole is going to start. After S1, it's the systole that is starting. So he will use the word pre-systolic accentuation. Pre-systolic accentuation. This is MSM, MDM with a pre-systolic accentuation that occurs due to atrial contraction. It's the atria that are contracting in the later part of diastole. So a pre-systolic accentuation will be happening. Now I would like to put up the question to you people only, everybody to participate. If the opening will become smaller, the pressure in this area will become even more. What will happen to the opening of the mitral valve? Will it open at the same time, or will it open earlier? Hit the comment button if the pressure will become more in this area because the patient did not get treated. If the pressure will be more, what will happen to the valve opening? Will it open at the same time, or will it open relatively earlier? Can I have answers please? Yes, same findings in TS man, same findings in TS. Yes, hit the comment button. Very good. Because the pressure is high, higher pressure will cause a earlier opening, and therefore I will draw this in red. This is again an opening snap. This is again an opening snap which is occurring earlier, and then I'm showing the murmur also. The murmur has become longer in duration. You can see the dotted red curve is occupying more surface area. The dotted red curve is occupying more surface area as compared to the black dotted curve. If I zoom into the diagram, you will notice that the red dotted curve is having more surface area. So I said this is going to be increase in the length of the murmur. And now if you check out the distance between S2 and opening snap, check out the distance between the S2 and the opening snap. Check out the black line and the red line. Is the distance between the two the same, or is it reduced? Comment in the chat box. I know it is visible. Comment in the chat box what is happening to the distance between the S2 and the opening snap. The opening snap is the red marking that I have shown, the thick black marking that I have shown. Now you yourself said very rightly, the valve will open relatively earlier. If the valve will open earlier, the gap will become lesser. Yes, very good. It will become reduced, and that is what I had said on the top, guys. This is the rationale. The easiest for me was, I would have said cram the data, do a cramming, severity of mitral stenosis is inversely related to S2 opening snap gap. I've given the rationale guys here at the moment. The easiest for me would have been to say to you that doctor, please cram the fact severity of MS is inversely related to S2 opening snap gap. I've done the hard work of hand drawing and showing how it is becoming relatively lesser. I hope it is clear. If somebody has a doubt, please let me know, and let me know I need to explain in English or Hindi. Understood guys? I hope it's clear. Somebody can just comment in the word clear, or like if it's not clear then let me know. Okay, cool man. Fine. Okay, fine. Hindi mein bol do? Hindi okay? Okay, fine. Okay, I'll do in English. First English, then Hindi, right? So let's do it again. Okay, man, let's do it. First English, then Hindi. 30 seconds, 30-second explanation. Summary. The opening is small. Right? Let me do this again. Now stop the comments and I'll get distracted. The opening is small, so the pressure will be higher. If the pressure is higher, the valve will open earlier. So cast a glance at the red marking. The reason for the red marking is the pressure is higher, so the valve is opening jaldi, and therefore the distance between S2 and opening snap has become lesser. You can see the distance between the black marking S2 and opening snap come down. You can see the marking red S2 and opening snap again. The logic is very, very simple guys. It is simply earlier ओपनिंग ऑफ द माइट्रल वेल्व. इफ यू आस्क मी इन 5 सेकंड बता दो सर क्या है, तो प्रेशर ज्यादा है ना यार, ज्यादा प्रेशर की वजह से वेल्व जल्दी खुल जाएगा तो गैप लेस हो गया ना, तो दैट मीन्स द डिजीज इज बिकमिंग मोर सिवियर. ओके, इन्फेक्टिव एंडोकार्डाइटिस हो गया था. हाँ, इनफैक्ट आईईजी समझा नहीं बच्चे, आईईजी मतलब चल, you can comment again man if you I could not follow your words. Okay, so S2 opening slab gap is becoming relatively lesser. That's the concept which you need to remember for infective endocarditis. Now is the question, यार आपका लैग, भाई मेरे में लैग नहीं है यार है ना, नहीं आप बंद करके निकाल, बैक करके आगे कर जाओ ना. ओके फाइन, चलो मैं I'll do this again. My point at this moment is चलो fine. To repeat the fact, okay, let's do this again. एक बार फिर से कर लेते हैं for those of you, then I'll address the NESET and NEET PG aspirants, क्योंकि अभी मैं FMGs को like address कर रहा था, तो I'll do this again. Okay जी, fine. अब सारे अपनी ऐप बंद करके एक बार फटाफट से ऑन करो. I'll wait for 10 seconds. Just do that. Those who are having buffering, please log out. I mean, close this and come back again so that there is no lagging again. Fine, good to go. Guys, mitral stenosis is a disorder जहाँ पे opening will become smaller, so the pressure will become higher. If there's any physical obstruction, you're squeezing the hole, you're making the hole smaller. Higher pressure, the higher pressure will contribute to the earlier opening of the valve. अब mentally visualize करो ना यार, the opening is small, so pressure will be higher. This will cause a earlier opening, and that earlier opening will result in development of that gap becoming relatively lesser. That is S2 and opening slab gap is inversely related to the severity of mitral stenosis is what I'm meaning. And okay, so fine, I think we are on the same plane at the moment. Now I'll address NEET PG aspirants. So these two questions were pure FMG. Now is NEET PG aspirants done. You have to hit the comment button, guys. This is, I think, NESET last NESET. When will pre-systolic accentuation disappear? If an FMG student, you don't need to note the next statement. It is only for NEET PG and NESET aspirants. When will the pre-systolic accentuation disappear? The logic is, reason for pre-systolic accentuation is atrial systole. Reason for pre-systolic accentuation is atrial systole. If atrial systole will disappear, the pre-systolic accentuation will also disappear. Please hit the comment button, all NEET PG aspirants. Why will the pre-systolic accentuation disappear? Very good. Sujata, Saurabh, Elias, Ridhima, Prashant, everybody was spot on. So this is an additional question to be remembered and noted down. Though I got very good answers here. Red में लिख रहा हूँ. Okay, this data you don't need to remember for FMG exam. Pre-systolic accentuation will disappear in atrial fibrillation. Very good. This has been asked 2 times, guys. One in NESET and one in the UPSC exam. I think the UPSC exam, Combined Medical Services exam, is also around the corner. So this is going to help there also. Pre-systolic accentuation will disappear in a patient of atrial fibrillation. Great job. As far as mitral stenosis is concerned, the investigation of choice for this condition is obviously echocardiography. I mean, that's the best way to identify this condition. And then for mitral stenosis, we will treat the patient by going ahead with PMBV. PMBV stands for percutaneous mitral balloon valvotomy, is the main treatment for any patient who's having severe mitral stenosis. Definition of severe mitral stenosis is size of the orifice less than 1.5 square centimeter. Normal is 4 to 6 square. Here it is 4 to 6. If it is less than 1.5, we call it severe mitral stenosis. The main treatment of the patient of severe mitral stenosis is percutaneous mitral balloon valvotomy. My patient did not get procedure done. If the patient will not get procedure done, there would be a calcification also developing in the mitral valve, and because of the calcification, now the person has again come back to me after few years. This patient of severe calcified mitral stenosis has come back to me after a couple of years. Now there is a calcification in this calcified valve. Now if I will do a balloon dilatation, the balloon will cause the valve to break into pieces, like a biscuit will break into pieces. This patient came to me, he is having calcified valve that I can see on echocardiography. If I will deploy the balloon, the force of the balloon will destroy the valve and the calcified fragments will go into the brain of the patient. There would be a cerebral embolism that will be happening. So please comment in the chat box what will be the treatment for severe calcified mitral stenosis. Please hit the comment button and let me know, would you like to continue with the same valve or put a artificial heart valve? Exactly, we will put a artificial heart valve. So a prosthetic heart valve will be required in this particular condition. The main point I just wanted to highlight before you is that if the MCQ adds the word calcified, then don't answer PMBV. We will replace the valve. Exactly, Joseph, you're spot on. No, bache, Sujesh, it's not valvuloplasty, bache. Valvuloplasty is the procedure for mitral regurgitation. Valvuloplasty is the procedure that is done for patients of mitral regurgitation. Here it will be a prosthetic valve that will be deploying for this patient. Very good Aishwarya, very good Divya. It is a valve replacement that would be doing. So we will say prosthetic valve, which can be two varieties, metallic valve or bioprosthetic valve, that would be required in the patient. So I gave the patient two options. I told the patient ki ya to metallic valve lagwa lo or bioprosthetic valve lagwa lo. So patient is asking me which is better. So I told the patient, I will inform you benefits and losses and you have to decide. With metallic valve, the point is that metallic valve will run on lifelong basis. I mean, metallic valve is very, very durable. Metallic valve is very, very durable. Obviously metal is very strong, it is very durable, but the disadvantage is that you will have to take warfarin on a daily basis. I told the patient, sir, you will have to take warfarin on a daily basis because metal and blood, when they come together, clots can be formed. So if you're okay with taking warfarin daily, cool. If you're not okay with taking warfarin, then you can go for bioprosthetic valve. So with bioprosthetic valve, the lifespan is shorter. With bioprosthetic valve, the lifespan can be anywhere between 5 to 10 years. So, I mean, it's obviously made up of a biological material. So, the wear and tear will be more, but there is no need of warfarin. The advantage of like a bioprosthetic valve is that there is no need of warfarin in the patient. But yeah, with the metallic heart valve, the need of warfarin is very much there. So, patient selected bioprosthetic valve. For this bioprosthetic valve, now there are a couple of options. One option is that we can use like a cow's heart or a pig's heart. So bovine heart valve or a porcine heart valve can be used. That bovine or porcine heart valve that we can use in the patient is what is called a xenograft, because we are doing it across species. My question to you guys is that if we are using a cadaveric graft of human being, obviously cadaver being mean humaning, then what is the technical term that will be used here? What kind of grafting? I'll zoom into the image. The question for you guys is, the patient had selected a bioprosthetic valve. For bioprosthetic valve, you don't need any anticoagulation on lifelong basis. If we give bovine cow or porcine pig, then it is xenograft. If it is going to be cadaveric, what is the word used? Yeah, options were autograft, allograft. Very good, very good. I think Saurav was the first one who has hit the answer correctly. Dr. Bhati is the second one answering this correctly. I'm still waiting. It is not an allograft, guys. Allograft will come from relative. Allograft will come from relative. In the options, it was allograft also, autograft also. All these words were combined. Yes, guys. The answer in this case would be given as homograft. Very good. Homo sapiens से आ रहा है ना. Isograft नहीं बच्चे. Isograft नहीं होगा. Isograft तो होता है कि अगर वो monozygotic twin से लेते हैं. It is a homograft that would be. Homo sapiens भाई. We are human beings, Homo sapiens, na? So Homo sapiens hai. So it is Simran, you are right there. It is Homo sapiens that we are talking about. So cadaveric graft would be homograft that would be used. So I wanted to sensitize you to mitral stenosis aspect. Two questions from FMG, one from ANICET have been covered here, including the fourth one. This was, I think, I don't recall ab kahan tha NEET ya FMG, but I did solve this question that the graft which is present here would be called as a homograft. Now we will talk about early diastolic and a mid diastolic murmur, for which the mnemonics are GAP and CAM. Before I fill up the full forms here, I will like to draw the murmurs here. I would like to draw these murmurs here. For early diastolic murmur, the triangular configuration has to be drawn. Like the murmur intensity will become lesser. The murmur intensity will become lesser in the phase of diastole, so early diastolic. And mid diastolic, though like I did draw it earlier, but I'll still do it for the completion's sake. This is S1, S2, S1. And I want you to draw bell-shaped configuration for a mid-diastolic murmur here. Then I want you to use a separate pen and show loud opening snap. Draw
in red the mid-diastolic murmur and show a secondary spike also. That secondary spike is the pre-systolic accentuation of mitral stenosis. The red line here is representing the mitral stenosis murmur specifically, which is related to loud opening snap, and the small secondary spike of a pre-systolic accentuation. So whenever you read the word mid-diastolic murmur, what should click in your mind is this bell-shaped configuration. Whenever you read the word mid-diastolic murmur, what should register in your mind is this bell-shaped configuration. But for mitral stenosis, it will always be a speciality where you have a loud opening snap and a shorter secondary spike called as pre-systolic accentuation here. In contrast, when it comes to early diastolic murmur, it will be a murmur where the murmur intensity will die down very soon. So now we will study regarding the mnemonic gap versus CAM, and the questions that have come on this are of all except variety. So let's put this to practice. The first one that I'll mention was asked in FMG exam, that is Graham-Steele murmur. Graham-Steele murmur is seen as a early diastolic murmur. This Graham-Steele murmur, the Graham-Steele murmur in this particular patient would basically identify that the person is having pulmonary artery hypertension. The reason for Graham-Steele murmur is this is a severe pulmonary artery hypertension, severe PH, which is contributing to development of a mild pulmonic regurgitation. You are expected to remember the data. In the paper, 4 combinations were present in the FMG exam. Combinations was severe, mild, severe mild and mild severe. Options were severe for both conditions, mild for both, severe mild and mild severe. Please speak out. I know you are sitting at a distance from me. I know it is not like a face-to-face class, but still I know you are online with me. So speak out yourself at the moment. What is the severe thing written here? Pulmonary artery hypertension with mild pulmonic regurgitation. So what you need to pick up is the word severe pulmonary artery hypertension and a mild pulmonic regurgitation is the final output that I want you to remember. Very good, guys. The word is, somebody commented that also, it is a severe pulmonary artery hypertension. So this was like a, I would say, a question where like people were distressed. No need to be distressed, just practice. Severe pulmonary artery hypertension with mild मतलब थोड़ा सा blood आएगा तो early diastolic murmur. Alphabet A is for the completion sake of the discussion. AR is of the mild variety, PR is of the mild variety. You will not get questions on separate mild AR and a mild PR. They will always be filler options in a question. What you need to remember is mainly point number 1 of this discussion. That is the classical name. Which is called as Graham-Steele murmur is what I expect you to remember. It is severe PH with a mild PR. Now let's move on to the right hand side. CAM. In CAM, the classical terminologies will be used. Let's fill up the data for CAM at the moment. Alphabet C would be for Carey-Coombs murmur. Carey-Coombs murmur, why it is to be remembered is 1, because it is a mid-diastolic murmur, it will start from S2. The second reason why Carey-Coombs murmur is always to be remembered is because this is the characteristic murmur of rheumatic etiology. Yes guys, please don't mix it with the murmur of mitral stenosis, because rheumatic heart disease does not always cause mitral stenosis. So if he specifically says what is the characteristic murmur of acute rheumatic fever, your answer is Carey-Coombs murmur. In a separate exam, instead of writing like characteristic murmur of acute rheumatic fever, he said patient is having rheumatic valvulitis. It is just a simpler way of saying it. Whether I say person is having acute rheumatic fever or patient is having valvulitis, the inflammation of the valve cusp will result in this characteristic murmur that is called as Carey-Coombs murmur, which is heard max in the middle of diastole. This Carey-Coombs murmur was asked in NEET PG exam, acute rheumatic fever, valvulitis or alternate terms. Now I come back to Austin Flint, which I can say, I don't know why the FMG examiner has a fetish for Graham-Steele and Austin Flint. नाम के पीछे ही पड़ गया, कभी ऑस्टिन फ्लिंट पूछ लेता है, कभी ग्राहम स्टील पूछ लेता है. तो स्पेशली इफ यूर एन एफएमजी एस्पिरेंट यू नीड टू रिमेंबर द क्लासिकल नेम्स हियर. द टू नेम्स टू बी रिमेंबर्ड इज ग्राहम स्टील, इट इज सिवियर पीएच, माइल्ड पीआर, थोड़ा सा ब्लड, सो अर्ली डायस्टोलिक. ऑस्टिन फ्लिंट इज अ मर्मर ऑफ सिवियर एओर्टिक रिगर्जिटेशन. सो आज मैंने दो कंडीशंस आपको सिवियर वाला बताया है, विच आई विल हाईलाइट एट द मोमेंट इन दिस graphical representation only. It is severe AR and severe PH. I want you to write down on a slip small chit pad at this moment, or maybe later when you are revising. If he says the word Graham Steele, it is severe pulmonic artery hypertension. ऑस्टिन फ्लिंट में ए अल्फाबेट याद कर लेना. व्हाट इज द ए अल्फाबेट? ऑस्टिन फ्लिंट में गलती कम होता है. Most guys are able to. Severe मैंने बता दिया, people are able to remember. It is A and A alphabet which is to be remembered. That is Austin Flint murmur is a murmur of severe aortic regurgitation. So that's like the clear terminology to be remembered. And for Graham Steele, no terminology there to be remembered. So then it is like severe pulmonary artery hypertension is the word to be remembered here. And then the third entry that I'll make here, continue with the banter guys. The third entry on this particular side is obviously mitral stenosis, for which I have provided inputs to you at the moment. So one gap versus cap, if they ask you MCQ, all except, you have to figure out the data. And in my opinion, पहले क्या पढ़ना है? पहले आपको right side वाला पढ़ना है CAM, Caricombs, Austin Flint murmur and murmur of mitral stenosis. बिना notes को देखे हुए मैं move कर देता हूँ. जरा कमेंट करोगे चैट बॉक्स में फटाफट से. ऑस्टिन फ्लिंट मर्मर इज अ मर्मर ऑफ सिवियर. दो ही अल्फाबेट टाइप करने हैं आपको. प्लीज टाइप फॉर माय सेटिस्फैक्शन. आई विल बी हैप्पी टू नो दैट यू आर लिसनिंग टू मी. ऑस्टिन फ्लिंट मर्मर इज अ मर्मर ऑफ सिवियर विच कंडीशन? क्विक कमेंट्स गाइस. वेरी गुड. aortic regurgitation, right? AR, very good. So happy to say that AR components coming up there. And Graham Steele वाला जो है, that is gonna be the severe pulmonary artery hypertension. Great guys. So this is a comparison between the various types of murmurs that I have present, that I have currently described before you. Now what I will do is, before I come to the next slide, I will use this opportunity to draw a line diagram before you. This line diagram is for a condition which is seen in Turner syndrome. It is called as coarctation of aorta. This is the narrowing in the aorta that I have currently shown. The narrowing of the aorta is shown at the starting of the descending aorta. The language of the question is COA, coarctation of aorta. Usually this is present distal to the origin of the left subclavian artery. Like there was an anatomy question, what is the site of coarctation of aorta? The answer is aortic isthmus. The other name for aortic isthmus is, what is the location of coarctation of aorta? The answer is distal to the origin of the left subclavian artery. Distal to the origin left subclavian artery or aortic isthmus basically mean the same. If I put it in simple words, it means starting of the descending aorta. The reason why coarctation of aorta is asked in the exam is because very less blood will be going down to the feet of the patient. Because very less blood will go to the feet of the patient, therefore these patients will end up with development of toes turning blue. The toes of these patients will turn blue because oxygen concentration will be very less, because by the time, if less blood is going down, man, the toes will become blue, though they would be cyanosis. The fingertip of the patient, however, will be pink. So one of the very good pickup points in questions of coarctation of aorta, the buzzword for coarctation of aorta is the word differential cyanosis. Normally we read central cyanosis, peripheral cyanosis, but here it is differential cyanosis. The meaning of differential cyanosis is that the toes of the patient will be blue and the fingertips of the patient will be pink. So that's a very good hint. If he assists by saying the word radiofemoral delay, if he will assist you by saying the word radiofemoral delay, it will become even much more easier for you to identify either the word is differential cyanosis or it would be radiofemoral delay. That makes your life relatively easier. And now I come to the reason why I have discussed this topic at the moment. Okay, coarctation of aorta फिर से कर लेते हैं. Rahul, we are doing this again for your sake. The topic I'm discussing is coarctation of aorta, where there's a narrowing of the aorta. Aorta की जो most, the question will say what is the most common site of coarctation of aorta, तो हम बोलेंगे aortic isthmus. Aortic isthmus is जहाँ पे descending aorta की शुरुआत होती है, that is aortic isthmus. Also the technical word is, it's gonna be distal to the origin of the left subclavian artery. I mean a subclavian artery right or left मैंने दिखाई, it will be supplying the arms of the patient. Here you can see that the blood supply would be compromised to the lower extremities of the patient, because if there's a narrowing, niche blood going is less, so therefore the toes of the patient, by the time the oxygen will reach the toes, oxygen will be finished, so differential cyanosis would come in and there would be radiofemoral delay. Why? Because normally when you feel the radial artery and femoral artery impulses come at the same time, but in this patient, because the obstruction is present, less blood is going down, so the radial artery impulse will come on time, but femoral artery impulse will be delayed, so there is a radiofemoral delay in patients of coarctation of aorta. Now, we will be checking the BP of this patient in the upper limb and lower limb. First, I am asking you for normal people, if you check the BP in the upper limb and if you check the BP in the lower limb, like if I check your BP in the upper limb, it will be less than 120/80. The way, if you are sitting on a chair at the moment, my question to you guys is, in a normal person, I'm talking about normal at the moment, then I'll come to coarctation of aorta. If I check blood pressure, or if you check blood pressure of somebody who's sitting on a chair, like I am sitting on a chair at the moment, if somebody puts BP in the middle of my thigh and auscultates over my popliteal artery, the BP in the lower limb will be same as the upper limb, or will it be, you have to answer more versus lesser. I'll put a comment here, in the lower limb the BP will be more or will it be lesser? Just comment more or less. I just want to see more versus less. Yes, yes, it will be, you have to comment more versus less. Don't tell me the values, that I will tell you. Okay, so we had a divided off, 50% people saying more, 50% people saying less. In a normal person, sir, I asked you for a normal person. In a normal person, you will notice that the BP in the lower limbs of the person will be higher because of gravity. The way you are sitting on a chair at the moment, because of the gravity component, the BP in the legs will be higher as compared to the upper limb. The difference is less than 20 millimeter of mercury because of the gravity component. So in a normal person, when you check the BP in the upper limb and lower limb, the difference will be 20 millimeter of mercury because of gravity. If you lie down, it will be same only, but if you are going to be in a sitting position, due to the gravity component, the BP in the legs will be relatively more. So the difference is less than 20 millimeter of mercury, but say it is not less. In a normal person, it will not be less. It will be more because of gravity. It will be more because of gravity. Now we will talk about coarctation of aorta. In coarctation of aorta, you will be checking the BP in the upper limb as well as BP in the lower limb of the patient. In the lower limb, the BP will be reduced. It is reduced because less blood supply will be going. You can see in the line diagram, less blood will be going in the toes of the patient. If the blood will be going less in the toes and blood is going down, then the BP in the legs will be reduced. Can you tell me, I want everybody to participate, irrespective whether you are NEET PG or FMG aspirant, what will happen to BP in coarctation of aorta in the upper limb? What will happen to the blood pressure in coarctation of aorta in the upper limb? I had one or two more contacts there. Yes, yes, yes. The point is that there would be an increase in blood pressure. The reason for this increase is increase in the peripheral resistance, because this finding is ulta of what is found in a normal person. So most of the time in the exam, he will ask you this particular aspect, BP more in the upper limb. The language to be remembered is, if you ever read a question that begins by saying blood pressure, if a question begins by saying blood pressure is more in the upper limb as compared to the lower limb is seen in, then it is always coarctation of aorta. Exactly. If a question says blood pressure in the upper limb is more as compared to that of the lower limb, the condition to be thought of is obviously coarctation of aorta. So at this moment, the step 1 was what I wanted to introduce before you was radiofemoral delay. You will be able to answer, differential cyanosis you will be able to answer, but the change in blood pressure is what I think subsequently everybody answered very correctly. It will be opposite to normal, guys. I hope it's clear to everybody. जिसने नहीं भी कमेंट किया है, नॉर्मल आदमी का बीपी चेयर पे बैठे हुए लेग्स में ज्यादा होता है, बट इन coarctation of aorta it is more in the upper limb. In a normal person, the BP in the legs is more while sitting on a chair, but in coarctation it will be ulta because less blood is going to the legs, and upper limb the peripheral resistance will be increased. That's the first point. Now tell me the murmur of coarctation of aorta, guys. Tell me the murmur that would be encountered in patients of coarctation of aorta. Yes. This is S1, this is S2, this is S1 again. Waiting for your answers there. What will be the murmur in patients of coarctation of aorta? There would be a hypertrophy of the heart because there is obstruction. there would be a hypertrophy of the heart in this particular patient, so the ventricles will contract with more force and there is a narrowing. आगे narrowing है, there is a narrowing, the ventricles are contracting with force and there is a narrowing present in a patient. Yes guys, the murmur that will be seen in this patient will be a ejection systolic murmur. I can say the word, the problem in this patient is not in the aortic valve, the problem in this patient is not in the aortic valve, but the problem is obstruction distal to the aortic valve. Still there would be a ejection systolic murmur present in a patient. So in coarctation of aorta there will be a ejection systolic murmur. Now couple of you have said the word continuous, so I'll address you now. For those of you who have answered the word continuous, in the same patient आज से कुछ weeks के बाद में, कुछ months के बाद में, कुछ years के बाद में substantial amount of collaterals will develop. When collaterals will develop, when collaterals will be developing in the patient, when collaterals will develop in the patient, that is when in the same patient the situation will begin to change. And in patients of coarctation of aorta, जब collaterals बन जाते हैं, that is when the murmur that will be present both in systole as well as diastole. That is what is called as a continuous murmur. So what you have to understand is that in the early phase of the disease in coarctation of aorta, it is still a pars वाला mnemonic ejection systolic murmur. The rationale is कि problem aortic valve में नहीं है, उसके just बाद में है ना, तो it is ejection systolic murmur. But when the collaterals will be formed, Pranav, you are spot on for that. When the collaterals will be formed, that is when the murmur will be present in systole also, and the murmur will be occurring in diastole also. So when you get a murmur both in systole and diastole, that is what is called as a continuous murmur. So I wanted you to be clear about this fact that in coarctation of aorta in the MCQ 2 answers can be there. Inicet is coming up. Those students who are sitting for Inicet, please remember coarctation of aorta can be having either of the two depending on early or late presentation. If patient is diagnosed early before the collateral formation, ejection systolic murmur. If there is a collateral formation in the later part of the illness, a continuous murmur. Early presentation, ejection systolic. In the late presentation, it is continuous murmur. Why are we getting a continuous murmur in the patient? is क्योंकि collateral से तो blood सारा time जाएगा ना यार. Through the collaterals, look at the diagram. In the collateral, pressure at point number 1 will be more at pressure than point number 2. If pressure at point number 1 ज़्यादा होगा 2 के comparison में, तो blood will be continuously flowing from this area. The word is continuous flow blood that would be happening. Why? Because pressure at 1 is more than pressure number 2. So continuous flow blood will be happening through these chota blood vessels. These narrow blood vessels are like around the heart. So therefore the turbulence of this would be conducted to the stethoscope, and therefore we shall be getting is a presence of a continuous murmur in this patient. I hope it's clear guys. Let me know whether the word continuous is clear here. The rationale मैं फिर से बोलूंगा before you hit the comment button. Pressure at point number 1 is more than pressure number 2. The pressure difference will cause a continuous flow of blood and therefore continuous murmur would be there. Just want to know if the concept is clear guys. Cool. So in the early part it is ejection, in the later part it is a continuous murmur. The investigation choice for this condition however is not an echocardiography. Why? Because the problem is not in the heart, it is much more downstream. So if he says investigation choice, your answer would be given as MRA. The investigation choice for this condition is MRA. If he says what is the treatment of choice for this condition? If he says what is the treatment of choice for this condition, then treatment of choice for coarctation of aorta is balloon dilatation. The usual reason why these patients come to us is because of hypertension and chest pain, because obstruction will cause peripheral resistance to increase so hypertension, and chest pain because of the hypertrophy. So for treatment of choice, he will say balloon dilatation is the best way. Balloon dilatation of the coarctation of aorta. यार उसको रॉकेट साइंस नहीं बनाना है बच्चे, आपको क्या याद करना है, प्रेशर एट पॉइंट, रास्ता बंद है ना, तो पॉइंट नंबर 1 प्रॉक्सिमल टू द ऑब्स्ट्रक्शन प्रेशर ज्यादा है, पॉइंट नंबर 2 पे ऑब्स्ट्रक्शन का प्रेशर कम होगा, तो प्रेशर डिफरेंस की वजह से तो ब्लड हमेशा ही फ्लो करेगा ना. बोथ इन सिस्टोल एज वेल एज हार्ट कॉन्ट्रैक्ट कर रिलैक्स करे फर्क क्या पड़ता है, ब्लड तो हमेशा ही फ्लो करता है. मैं एक और तरीके से पूछता हूँ, चलो जिन लोगों को समझने में दिक्कत हुई मुझे सोच के बताओ, व्हेन डज ब्लड फ्लो इन योर बॉडी? सिस्टोल, diastole or always? When does blood flow in your body? Systole, diastole, always. Hit the comment button. S systole, D diastole, always. Blood in our body flows always, no? ऐसा तो होता नहीं ना डायस्टोल में मैं अनकॉन्शियस हो जाऊंगा, सिस्टोल में फिर से होश में आ जाऊंगा, डायस्टोल में फिर से अनकॉन्शियस हो जाऊंगा. ब्लड इन द बॉडी फ्लोज ऑलवेज. सो अनदर वे ऑफ अंडरस्टैंडिंग इज ब्लड फ्लोज कंटिन्यूसली इन अवर बॉडी. सो कोलाटरल में भी कंटिन्यूसली फ्लो करेगा एंड देयरफॉर कंटिन्यूस मर्मर वुड बी प्रेजेंट इन दिस पेशेंट. सो दैट वाज अनदर वे ऑफ एक्सप्लेनिंग दिस. अदरवाइज प्रेशर ग्रेडियंट इज मोर देन सफिशिएंट टू गेट द डेटा राइट. Okay, great. So, जी, Connaught Place is a iconic place in India, iconic place in Delhi, where like young couples go to hang out. Though nowadays are there much better places in Delhi, Select City Walk and DLF Emporio and all these malls etc. which are like the happening thing. But before the mall culture took up India, like people started hitting multiplexes, it was Connaught Place only as the dating hub. So Connaught Place mein hum tum is the mnemonic which is gonna be used to remember continuous murmur. So Connaught Place is that CP, right? So that's the common word, CP jana hai, right? That was like a big thing in India. हाँ, आजकल it's not a good place to go. आजकल it's more of scamming happening ना. आजकल it's not a good place to go. Obviously because you know who wants to go out in the heat, man? When you have an air conditioned mall where you can check out the latest brands and everything, why do you want to go to get scammed? But yeah, old days, right? हमारे टाइम पे भाई कोई एयर कंडीशनिंग नहीं होती थी. So, coarctation of aorta is and PDA, patent ductus arteriosus. Gautam Nagar is evergreen. Okay. So, coarctation of aorta and patent ductus arteriosus are causes. Then 3, 4, 5 are filler options. May matlab it is mammary souffle. May is the mammary souffle. This is a auscultatory finding in pregnancy. Like this lady, she came to your hospital. She is pregnant. She came for a routine medical checkup. So, when you were auscultating over her chest, you found that the sound is like continuous sound happening in the heart. You were perplexed. You were like, what is going on, man? Is this a murmur? No, it is due to increased blood supply through the internal mammary artery. That sound that is heard in the chest of this lady, and yeah, Dipanshu, you are right. So that IMA, internal mammary artery flow, increased during pregnancy is the reason for this continuous murmur. And then is that hum is rhyming with that word, hum is rhyming with the word venosum. Venosum simply means dilated veins. Dilated veins will cause turbulence. Dilated veins will cause turbulence. And then is obviously a reason why we are discussing it. The word is जो आपको खासकर especially if you are a NEET PG aspirant, you need to appreciate the word peripheral pulmonic stenosis. I did not say the word pulmonic stenosis. I said peripheral pulmonic stenosis. That means blood supply in the pulmonary artery is getting affected. There is a narrowing distal to the pulmonic valve. Pulmonary valve in the pulmonary artery, the blood flows all the time. Whether it is systole, whether it is diastole, blood flows all the time in the pulmonary artery. So you will hear a continuous murmur in the pulmonary artery narrowing, that is peripheral pulmonic stenosis. The message at this particular moment is, अगर मैं ये peripheral word हटा दूँ, suppose if I remove the peripheral word from the discussion, then the answer, if I remove the peripheral word from the discussion, then the answer will become ejection systolic murmur. But the moment this word will come up, it means what you have to think is narrowing of the pulmonary artery. Blood flows always in the pulmonary artery. Otherwise तो यार lungs में saturation कैसे maintain करेंगे ना? जैसे blood in the body flows all the time, blood in the pulmonary artery flows all the time. So we will be having is a development of a continuous murmur in this patient. So if I remove the word peripheral from the discussion, it becomes a ejection systolic murmur. But if I specifically say peripheral pulmonic stenosis, then it's gonna be a case which is related to continuous murmur. So I want you to remember the following causes. I want you to remember only 3 of them. What are the 3 causes to be remembered? Coarctation of aorta, PDA and peripheral pulmonic stenosis. And yeah, obviously I'll say it verbally, I'll not write it down. Machinery murmur is a term that is used by pediatric people to describe the patent ductus arteriosus, but in medicine we use the word continuous murmur. The speciality of continuous murmur is, I'll draw the line diagram again. The speciality of continuous murmur is, this is S1, this is S2, this is S1. The murmur is heard both in systole as well as diastole. जब आप line diagram देखोगे, this would be like a giant Himalayan peak. You can see the murmur in the systole. You can see the murmur in the diastole. This is a giant Himalayan peak that is present. And for reference, I will show the murmur of mitral stenosis again. Now this will look like a very small murmur, mid-diastolic murmur with a secondary spike that is pre-systolic accentuation. So this is the giant Himalayan peak of a continuous murmur that has currently been explained to you at this juncture. You need to like remember the entire data verbatim, guys, the aspect of murmurs that I've explained to you. And at this moment, I think we can go for a break, guys, like 15 minutes, and then we can start again. It is like 5:22 by my watch, so another 15 minutes, right? We can start again. So the starting time would be 5:30, 5:35, right? I think that's an okay time to start here. Continue. I am okay, man. I am continue. But 5:18 क्या मतलब? हाँ हाँ ठीक है मतलब लाइक 15 मिनट्स के बाद में शुरू करते हैं. सो द अप्रॉक्सीमेट टाइम ऑफ स्टार्टिंग वुड बी लाइक इफ आई टेक 20 15 35, राइट. तो 5:35 शुरू कर लेते हैं, राइट. कंटिन्यू. ओके कंटिन्यू कर लेते हैं, मुझे कोई दिक्कत. अरे यार उसका ब्रेक भी बोल रहे हैं. चाय पी लेने दो यार भाई, चाय चाहिए यार, मैं बोल रहा हूँ यार इतने देर से. वी आर चाय चाहिए अभी, ठीक है. सो एट दिस मोमेंट I need tea, bhai. I need a bit of fuel in my system. So after that, I'll continue. Five. Okay. So 5:35 is what we are meeting again, man. Just give me a short break. I'll be back at 5:35, right? Okay, guys. Break time. See you. हाँ आ जाओ चाय पी के आ जाओ, फिर शुरू करते हैं. टेक केयर. 8 o'clock तक है, 8 बजे तक क्लास चलेगी. Okay. Hi guys, welcome back to the discussion. So let's get started and I'll focus on a couple of aspects related to the ECG at the moment. We'll talk about how to identify the various tachyarrhythmias and the bradyarrhythmias, and we'll talk about their drug treatments as well. So I'll give a couple of more seconds for people to join into the discussion and then we can get started. Okay, so as far as the calculation of the heart rate is concerned, what is the lead that should always be used to calculate the heart rate is when you should be using always lead number 2. And with respect to lead number 2, I want to say that, okay, so it is lead number 2 which is to be used, and when it is lead number 2, then what you have to check out is the RR interval in the patient. It is the RR interval that you need to check. It is which will be deciding the heart rate of the patient. The formula which is used to calculate the heart rate. The formula which is used to calculate the heart rate is 300 divided by RR interval, and this is the only time when you will take into consideration large squares. Everything in the ECG will always be small squares, but with respect to heart rate it will always be the large squares that you will be calculating. And what you will notice is that here it is like 4 large squares present, so 300 divided by 4 would be about 75, and if I change this, like, then obviously you will notice that the number of large squares would be changing again. That would change over to 100. I mean, what I just want to bring to your attention specifically is that I just want you to focus on these two areas where, like, while you are sitting and listening to me, I can say that the number of large squares separating R and R would be something like 4. So the heart rate would be 75. But moment you are having caffeine, or if you are doing some exercise, then your heart rate will start going more than 100 and can increase obviously to any particular limit. But I just want to highlight in the exam that if you are noticing that less than 3 large squares are separating the R and R, like you can see 2 now, 2 is like less than 3. If less than 3 large squares are separating the RR interval, that means person is having tachycardia. Now what will be the cause of tachycardia, what is the reason for development of that, we will discuss. But at this moment, the first message after the tea break is that if you are in any exam, like, you are noticing less than 3 large squares separating R and R, you know that you are dealing with a case of tachycardia. That's the basic point which is to be remembered. Tachycardia component is always less than 3 large squares. Everything else in the ECG will be small square. This will always be the large squares there. You not missed anything. We have just focused on the heart rate component here. I'll just say this fact once again. Point to be remembered is whenever you have to calculate the heart rate, use the formula 300 divided by RR interval. Peak of the R and peak of the R. And it is just that you will be able to pick up that there is a tachycardia present in the question. So this is like super easy at the moment, and most of the time, like, I can say the common cause of tachycardia would be sinus arrhythmia or sinus tachycardia. But yeah, I need to talk about couple of arrhythmias as well. The arrhythmias component are the ones which are to be focused. So let's look at the first arrhythmia on the agenda, that is atrial fibrillation. In this arrhythmia, if you check out the RR interval, I can say something like 150 beats per minute, but then suddenly the heart rate is changing to somewhere in the range of a little less than 100. So the main point which I want to say is that the ECG criteria for atrial fibrillation will be first irregular RR interval. Let's do this again. If you check out the RR interval in this area, the distance between the R and the R waves is 2 bada square. So the heart rate will be 150 beats per minute. 300 divided by 2. In paper, you don't have any facility to do any calculation, so it should be reflex movement. That distance between R and R, if it is 2 large squares, it would be 150 beats per minute, and then you are noticing that the heart rate is stabilizing to something like less than 100. Irregular RR interval. Irregular RR interval is one of the key things that you need to identify for patients of atrial fibrillation. And the second point would be that there would be absent P waves in this condition, because SN node is not the boss. I will teach you the causes of atrial fibrillation also, but at this moment the main agenda to be remembered is how do you identify it. You can see lot of twitching activity happening at the moment. I mean, this is not an ordered activity which is present. There is an absent P wave and the RR interval in the patient will be changing. There are only two arrhythmias in which the RR interval will change. One is atrial fibrillation. The second one is the aspect of multifocal atrial tachycardia. The dominant pacemaker of the heart is not the boss anymore because of the structural damage to the left atrium. Why do you have atrial fibrillation in a patient? If the question says, why do you have atrial fibrillation in a patient? The causes of that would be structural damage to the left atria. One of the leading causes of structural damage to the left atria can be hypertension. If it is not hypertension, it can be probably like, it can be ischemic cardiomyopathy. Ischemic cardiomyopathy would be like, I told the patient to get coronary artery bypass grafting done because there was a damage in the heart due to blockages of the coronary artery. This person is having triple vessel disease. I told him in 2024, get a coronary artery bypass grafting done. The patient did not get it done. So the ischemic damage in the heart because person has not got CABG done will cause ischemic cardiomyopathy. So hypertension, ischemic cardiomyopathy, long-term alcohol intake or Graves are the reason why untreated Graves disease due to excessive sympathomimetic stimulation are the leading reasons for atrial fibrillation. For those of you who said repeat, I'm going to address this once again. Atrial fibrillation को कैसे आइडेंटिफाई करना है, तो आपको एग्जाम में 12 लीड की ECG दी होगी, आपको कहाँ देखना होता है, सारी लीड नहीं देखनी होती है. एग्जाम में सीधा लीड नंबर 2 देखना, सबसे नीचे जो दे रखी होती है इन द ECG इन टॉयलेट ECG इज लीड नंबर 2. उस लीड नंबर 2 में क्या करना, लेफ्ट से राइट जाना, जस्ट चेक आउट द RR इंटरवल द फर्स्ट टाइम, चेक आउट द RR इंटरवल अगेन, एंड यू कैन नोटिस दैट अगर आप फिजिकली काउंट नहीं भी करते हो तो द फिजिकल डिस्टेंस इज नॉट द सेम. You can see the disparity in the distance between R and R, which is written as irregular RR interval, first point. The second aspect is that there is no normal P wave present. It is a twitching activity present. P waves are absent. Why? Because the structural damage to the atria is present. Reasons for structural damage to the atria can be hypertension, ischemic cardiomyopathy, alcohol induced dilated cardiomyopathy. I mean, he may not write the word dilated cardiomyopathy. He might just say alcoholic came with complaints of palpitations. Graves disease lady came with complaints of palpitations because excessive sympathomimetic stimulation will again cause structural damage to the heart. Mark my words there, structural damage to the atria is the reason why the person's SI node will no more be the boss. After giving this ECG, he will say, what is the best drug for controlling the palpitations of this patient? The patient is using in Hindi the word Ghabrahat. Ghabrahat means that I'm not feeling well. My heart is literally pounding in my chest. What drug would you be using to control the heart rate of this patient? You will be using short acting beta blockers, that is esmolol is the drug of choice for management of this patient. Now what they have done in your exam is that they have just twisted the data. They said atrial fibrillation patient, how? I mean, he did not say the word atrial fibrillation, he gave the ECG. But he did mention the fact that the patient is having poorly controlled asthma. He is testing a pharmacology. You don't use beta blockers in patients of poorly controlled asthma. Like this question of NEET PG said, Graves disease patient came with complaints of palpitations. ECG was shown, it was irregularly RR interval. The students realized that this is atrial fibrillation. In the option beta blocker was also given, but at the same time it was also mentioned poorly controlled asthma. So we will be answering in those circumstances calcium channel blocker by the name of Verapamil. At this moment I want to clarify before you that cardioselective beta blockers will act on beta 2 also. Cardioselectivity does not mean that beta 1, I mean cardioselective beta 1 will not act on beta 2, they will act on beta 2 also. So the point is that the impression of couple of doctors is that cardioselective beta blockers can be given in asthma. No, you cannot be giving cardioselective beta blockers. You have to use calcium channel blocker in the patient, that is Verapamil. Whether I say poorly controlled asthma, whether I say COPD in a patient, asthma and COPD, we do not use beta blockers in a patient. So the answer will change over to calcium channel blocker. 2 times in the exam, he has given atrial fibrillation with some condition. Asthma COPD is one of them. You know, asthma COPD is ultimately bronchospasm. So it is the same thing, but I have written it separately just to highlight the fact. If you attempt the last time's INISET and the NEET PG question, he mentioned that the patient is having acute pulmonary edema. Acute pulmonary edema is again a contraindication. Acute pulmonary edema is a contraindication for using beta blockers. How did he write the word acute pulmonary edema? He did not write like this. He wrote the word bilateral crepitations in the chest. He wrote the word elevated B-type natriuretic peptide, because whenever heart is damaged, BNP level will be elevated. Yeah, we can use diltiazem also. We can, any of the CCBs can be used. So either verapamil or diltiazem can be used. He said patient of atrial fibrillation, but bilateral crepitations, BNP level is elevated. Beta blockers are contraindicated in patients of acute pulmonary edema. So the drug that we'll be using in this particular case is digoxin. So at the moment I have handled 2 NEET PG questions. Now I will attempt the FMG exam question. That was very easy. He made it easier for FMG exam. He said recent atrial fibrillation with crashing blood pressure. I have explained to you already that every time there is a crashing blood pressure, then don't answer drugs, then you have to answer DC shock. In the DC shock, there are 2 types of DC shock, as already explained to you, that is cardioversion and defibrillation. Defibrillation is only in 2 conditions, that is PVT and ventricular fibrillation. So for the FMG exam, it was a super easy MCQ. Most guys were able to get it spot on. It was recent onset atrial fibrillation with a crashing of blood pressure. Then we will not waste our time giving drugs. We will give DC shock, that is cardioversion would be given. At this moment, I have handled 3 MCQs of atrial fibrillation. I will do them once again. Everybody knows that the drug of choice for the patient with respect to rate control is esmolol. Now, in the NEET PG, he twisted the question by mentioning poorly controlled asthma/COPD, verapamil. In a separate area NEET PG, he twisted the question by saying bilateral crepitations, BNP. Then obviously, I cannot be using beta blockers. So what will I do? I have to treat the heart failure also. And digoxin has vagus activity. Why am I using digoxin? Is because digoxin is going to have vagus activity, so it will control the heart rate, and digoxin also treats the heart failure. That is why it is being used in this condition. In FMG exam, he did not trouble the student so much. He simply said, BP crash कर गया क्या करोगे? DC shock दे देंगे. कौन सा प्रकार का DC shock देंगे? Cardioversion दे देंगे. So pretty straightforward data as far as drugs are concerned. As far as long-standing atrial fibrillation is concerned, the long-standing atrial fibrillation is a trouble, because in long-standing atrial fibrillation there is development of clots. एट्रिया में कंपन हो रहा है, एट्रिया में कॉन्ट्रैक्शन नहीं हो रहा, कंपन हो रहा है. दैट कंपन विल कॉज ट्विचिंग, दैट ट्विचिंग विल कॉज क्लॉट फॉर्मेशन. सो देयर वुड बी क्लॉट्स इन द लेफ्ट एट्रियल appendage of a patient, and these clots can go in the brain, and that is the reason why these patients can develop stroke. In a long-standing atrial fibrillation, because there is a risk of stroke in a patient, so the algorithm that we will use in this patient is called as RACE, that is rate control, anticoagulation, cardioversion, and if required, electrical cardioversion. The main point to be remembered is first go for rate control, then go for anticoagulation in a patient. RACE is the mnemonic that is used for it, and anticoagulation is what I want to discuss next. How to decide on anticoagulation? There are 2 ways. Either do echocardiography. कौन से वाला echocardiography करेंगे? तो we can do transthoracic also, and we can do transesophageal echo also. Which is better is transesophageal echo, because atria is पीछे. You see, पीछे would mean behind the heart there would be esophagus. So if I put a probe in the esophagus, I can scan the atria. Echocardiography can help me identify that there is clots present in the left atrial appendage. If I don't have a echo facility, transesophageal echocardiography, I can be using a score that is called as CHAD S2 VASC score. There are 2 ways by which I can decide the need for anticoagulation. One is echo. Echo will be able to pick clots if they are more than 2 mm in size, but if the clots are very chotu, then echo will not show any clots. If echocardiography will not be showing presence of any clots, what will you use? You will use a score called as CHAD S2 VASC score. In CHAD S2 VASC score, what I will do is I will quickly mention regarding the components which are present here. If any of these components are present, that means I need to be aggressive with my anticoagulation. C is for congestive heart failure. H is for hypertension. A is for the age of the patient, which is more than 75 years. D is for diabetes mellitus. S2 basically means stroke history. All parameters are given. All parameters are given 1 point, but stroke history is given 2 points. So I'm writing that in bracket, because normally like in one score 1 parameter is given, but stroke history is given 2, because atrial fibrillation, the clots will go in the brain. VA in this particular patient, VA would basically mean that there would be a vascular disease that is present. Vascular disease could be like peripheral arterial disease. Then would be the age of the patient. Again, the age is coming 2 times in the scoring pattern, guys. Please understand the fact that normally in a routine score, one parameter comes only once, but when it comes to age, age parameter is coming 2 times. One is more than 75, second is age more 65 to 74 years of age. Why it is coming 2 times is because age is also 2 points and stroke history is also 2 points. So I just want you to write the number 2 in front of age also. All parameters in CHAD S2 VSC score में 1 point होता है. All parameters in CHAD S2 VSC score will be having 1 point. Which are the parameters having 2 point is one, the age of the patient, and second is the stroke history in a patient. Age more than 75, stroke history, all of them are given 2 points at the moment. And as I move down, it is vascular disease, age once again, and then would be SC, would be standing for sex category. Sex category would mean like the gender being female. Obviously, gender alone will not decide whether I need to give anticoagulation. There must be some other risk factors present. So, if the score of the patient is 2, start anticoagulation. If the score is 2, so I'm writing the number 2 here. If the score on CHAD VSC score is 2 or more than 2, or if the clots are visualized, you will have to. Yes, age is 2 points. Nadeem, you're right. Age is 2 points. As I've highlighted, if the score is 2, you need to start anticoagulation. What are the drugs which are used for anticoagulation and atrial fibrillation? Very interesting data. I would like you to pick your focus at this particular point of time. Don't straight away answer apixaban. Don't straight away answer apixaban. Check out whether he has given a situation which is very Indian. The Indian situation is he's saying rheumatic heart disease with mitral stenosis. Mitral stenosis will cause structural damage to the left atria. If he specifies the word valvular atrial fibrillation and he says what drug is given for anticoagulation in patients of atrial fibrillation to prevent development of stroke, then in Indian patients we shall be using warfarin, that is VAF. The meaning of the word VAF is valvular atrial fibrillation. This is the word that will be used by the examiner because he knows if he will write rheumatic heart disease with mitral stenosis, you will understand atrial fibrillation due to structural damage and answer warfarin. So the word is VAF. If you change the data to NVAF in a patient, yes, it's Acitrom, that is the brand name for warfarin, vitamin K antagonist. But if I change the data to NVAF, like if I say it's an American patient, he drinks vodka all the time, NVAF would be like the patient is taking vodka all the time, whiskey all the time, beer all the time. So alcohol induced cardiomyopathy is there. Like he is having a beer belly and the guy, like he's an Australian, right? Australians drink a lot of beer. So it's like a beer belly and the guy is having NVAF, or it's like a Russian with the that Russian big belly and then NVAF present. So in those circumstances, the answer will obviously change over to the oral medicine which you have answered correctly, that is apixaban will be used in this particular case. So while attempting questions, just take care of the fact that if it is non-valvular atrial fibrillation, you are going to answer apixaban. If it is the Indian scenario, then we are going to be using warfarin and vitamin K antagonists for this patient. The algorithm is rate control, anticoagulation, then comes chemical cardioversion. The other name for chemical cardioversion is rhythm control, and for this rhythm control, that is chemical cardioversion, we will have to give amiodarone for the patient. Rhythm control and chemical cardioversion mean the same. Let me do this again. R is rate control. First control palpitation, that duk 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 sensation in the chest, control rate control. A is anticoagulation, reduce the chances of stroke in this fellow. C is chemical cardioversion, that is give medicines to shut down the abnormal electrical activity of the heart. Most of the time, all you can do is put this patient on long-term amiodarone. Long-term amiodarone will help in suppressing the abnormal electrical activity, and these patients will require nothing else in their life. The advantage is amiodarone easily available, pretty cheap as well, though the disadvantage is obviously that blue-gray pigmentation that can occur in a patient, and that is like cosmetic disadvantage that can be occurring. But chemical cardioversion with oral amiodarone is the main treatment for preventing the recurrence of arrhythmia because it will suppress the electrical activity in the heart. Let me know the most common side effect of amiodarone. What is the most life-threatening side effect? Life-threatening side effect is pulmonary fibrosis. What is the most common life side effect that is present? Yeah, it is ocular manifestations, that is a corneal microdeposits which are present. No, the most common side effect of amiodarone is corneal microdeposits. If he specifies the word common, then it is corneal microdeposits. If he specifies the word most life-threatening side effect, then it would be pulmonary fibrosis with amiodarone. Obviously, that blue man syndrome and blue grain pigmentation आजकल तो पूछेगा नहीं, because that is very easy for you to understand and answer. Yeah, it is like pulmonary fibrosis, the life-threatening one. The most common one is corneal microdeposits, and then obviously it will affect thyroid malfunction. So for the thyroid malfunction, I just want to write hypothyroidism and hyperthyroidism. Both can be a possibility. So these are three important side effects of amiodarone that I mentioned. It's a class 3 antiarrhythmic. Hypo and hyper both can be present in this patient. Yeah, I mean, yeah, class 3 antiarrhythmic. So I mean, all class 3, you know, amiodarone is a class 3 antiarrhythmic. So they're notorious to cause a QT prolongation. All class 3, beryllium, ibutilide, dronedarone, amiodarone, sotalol, they are like notorious. Class 1A, class 1C and class 3. Class 1A, class 1C and class 3 are notorious for causing QT prolongation. It looks very paradoxical to say that, because normally antiarrhythmic drugs are stopped to prevent an arrhythmia, but then a drug can be an angel or a villain in your hand. If you give too much of a drug, it can be a villain. If it's gonna be used in proper dosages, then it's gonna be a angel in your hand. So yup, 1A, 1C and 3 class antiarrhythmic drugs are notorious to contribute to a QT prolongation in a patient. So at this moment, I wanted to bring to your attention the algorithm for management of atrial fibrillation that is usually asked, and the trick in the question most of the time will be that he will test your knowledge with respect to contraindications of beta blockers. And now I will talk regarding another arrhythmia which is common in COPD patients, that is multifocal atrial tachycardia versus atrial flutter. I will zoom into this ECG, and what I want you to pick up into the ECG is that, I'll use a finer font, the distance between the R and the R. The distance between the R and R is not constant. Like in some areas, the distance is very, very less. Normally, in the ECG, RR interval is constant. But if you look at the purple areas and some blue areas, like I can do counting also 1, 2 large square, but then that like eats up into your time. In your exam, T4 is thyroid hormone, man, thyroid hormone. It's thyroid hormone only. T4 is less, T3 is less. Hypo and hyperthyroidism both are side effects, na? What I'm saying next is that if I get a question in which there would be an irregular RR interval, this is the second time I'll be reading the word irregular RR interval, that would be atrial fibrillation, that would be a case with respect to atrial flutter. So yeah, I mean, there would be an irregular RR interval that is present. But yep, the most important thing is in this ECG, P wave is present. Let me zoom into the ECG and highlight the P waves here or mark them here. Like this is a P wave which can be seen before the QRS complex. You can see a positive deflection. Any positive deflection before the R is called as presence of P wave. If I can move a little laterally, I can call this as a P wave as well. I can call this as a P wave as well. So P waves are present. This is obviously not a case of atrial fibrillation. The previous topic that I was teaching you, there was an irregular RR interval and the P waves in the ECG were absent. At this point of time, they are present and are of little different shapes and sizes also. Even if you don't get into that shape and size and do the calculation, I want you to remember that for your exam, if you ever get a question in which irregular RR interval is present, just check out whether P waves are absent or present. If P waves are absent, it is atrial fibrillation. If the P waves are present, your answer is multifocal atrial tachycardia. Yes, guys, P mitral also present. I can say that because see, a lot of these patients would be having structural damage to the atria. You see, if somebody is a smoker and there could be concomitant heart disease in a person also. So you could have a combination of a smoker and rheumatic heart disease together. So valvular changes would be present. But the main point I want to say is, Priyesh, you have a good point there. But what I'm trying to say is smoking and rheumatic heart disease coexist in Indian population, which can explain these varied morphologies. But then irregular RR interval, if with an absent P wave is atrial fibrillation, a P wave is present and is of varying morphology, I'll write it for the sake of completion, varying morpho. But then the most important thing is presence of P wave will make the answer as multifocal atrial tachycardia. And most of the time this would be a COPD patient, like an atrial fibrillation. Most of the time it would be hypertension, alcoholic patient, ischemic cardiomyopathy. Here he will say COPD patient is complaining of palpitation. So when he came to the physician, ECG was done, the ECG findings are shown here, and then he will say, how would you manage this patient? Once like I see that the person is having palpitations, I need to bring it to heart rate to normal. And how will I bring the heart rate to normal? Obviously I will not use beta blockers here, because yeah, three different morphologies the P wave. Nadeem, you write by the literature part, but in the exam, because I'm having shortage of time and I would like to invest the time in a different question, so I just want to say that if P wave is present, answer it as MAT along with the irregular RR interval. And COPD, if it is given, gives credibility to the diagnosis. Now what will I use for management of this patient? Then I think it is very clear to everybody that you are not will be using beta blocker, because it's contraindicated in COPD patients as well. So it is IV verapamil that would be used, and the treatment algorithm for this condition I will discuss in the lower part of the discussion also. But yes, at this particular point of time, the main agenda which I want to highlight was this ECG parameter that I highlighted, which is irregular RR interval with presence of the P wave, in contrast to what was discussed on the previous slide. Coming up once again, irregular RR interval with absence of the P wave. So that's like a quick interpretations to be remembered: multifocal atrial tachycardia versus atrial fibrillation. Now I will compare this with one more ECG. Here also he can begin by saying cigarette smoker. The peculiarity was that my student said that boss, the heart rate was normal. The reason why heart rate is normal is probably because the patient can be on medication also. No? Like if you check out 1, 2, 3, 4, if I separate the R from R, it becomes a heart rate of 75 beats per minute. If I check out again also, this would be 1, 2, 3, 4. That is again 300 divided by 4, that is 75 beats per minute. So some students were perplexed by the fact that, sir, how can you call it a tachyarrhythmia where heart rate is normal? Guys, they can give you ECG where the patient is on treatment. A person will take treatment, heart rate will stabilize. But you can see only rate control has been achieved. The abnormalities in the ECG is very much present. This abnormality is, I think couple of guys were spot on in identifying that this doesn't look like a P wave and doesn't look like a T wave. So this wave that doesn't look like a P and doesn't look like a T is what is at the moment present for sawtooth waves. Yes, this is atrial flutter. Even if I would have not started by the word atrial flutter, sawtooth waves are the main giveaway in this particular patient. That is one of the characteristic feature that will help you identify that atrial flutter is a macro re-entrant circuit which is contributing to the following manifestations. And here also the question can begin by saying COPD patient comes with palpitation. So don't be under impression that COPD palpitation is always multifocal atrial tachycardia. It can be atrial flutter also. Depends on the kind of damage that is occurring in the heart. It depends on the kind of structural damage that is occurring in the heart, that the type of atrial fibrillation in the patient can be picked up. But then sawtooth waves would always be a constant RR interval beta, like you Nadeem, you said that constant RR interval, that is not a necessity. That is not a necessity. Irregular RR interval can be present in atrial flutter also. It is not a necessity. But yeah, what is more characteristic in the patient is sawtooth waves. Sawtooth waves are present in EEG, that is REM sleep. Okay, you want that answers? Okay, ji, sawtooth waves in EEG is obviously a feature of REM sleep. And then barium enema findings or diverticulosis. So that I think you guys are well sorted with. You know, I was planning not to say that, since I know that you know the answers for that. But still, like since you said it, okay, here it is. So now coming back to like what are we going to do for these patients. So I'll mention in a chart the comparison for treatment for atrial flutter and multifocal atrial tachycardia. Let's have some inputs here. For atrial flutter, the treatment algorithm is the same. It is RACE. So you will go for rate control in this patient. Rate control will be in the form of a beta blocker or will be in the form of a calcium channel blocker. So while attempting whether you should answer beta blocker or calcium channel blocker, just be careful if he is himself saying cigarette smoker or the contraindications that I mentioned earlier in the previous question stand validated even in this particular case. Okay. Then comes the issue of anticoagulation. So for anticoagulation, traditionally the medicine that is used in this patient is apixaban. But yeah, for Indian patients, what has been for valvular heart disease, it's always going to be warfarin only. Alphabet C is the chemical cardioversion part. Alphabet C is the chemical cardioversion part. This chemical cardioversion that I am describing to you at this moment is also called as rhythm control. Rhythm control basically means that I am trying to suppress the electrical activity in the heart of this patient. Alphabet E will be the last resort that we'll be using if we are not able to suppress the electrical activity in the heart. Most of the time we are, but if not with medicines, then electrical cardioversion is the only opportunity left. Race algorithm will be used in this case only. The treatment drugs will remain the same, but if you are patiently listening to me, you will notice that now when it comes to the aspect of chemical or electrical cardioversion, when do you do electrical cardioversion? When chemical cardioversion is not working and you will be giving a DC shock. The intensity of DC shock that you will be using in this particular case, the intensity of DC shock that you will be using in this particular patient will be the lowest intensity of DC shock that you are ever gonna read in your career. So do take care of this fact. This is one of the questions that has been asked. Low intensity DC shock. The word is low intensity DC shock. Low intensity DC shock is used for management of which tachyarrhythmia? The answer is the topic of interest, that is atrial flutter. Now look at the words that are used for the right hand side of the discussion, multifocal atrial tachycardia. He says DC shock has limited role. Nowhere else, like any tachyarrhythmia that I have discussed, we have discussed DC shock as the ultimate cure. In multifocal atrial tachycardia, he says DC shock has a limited success or it has a limited role because there is a tendency for recurrence of the arrhythmia due to hypoxia. So for multifocal atrial tachycardia, treat the cause is a more appropriate solution than giving DC shock to the patient and terminating the arrhythmia. What I mean by treating the cause is that I should be going ahead and manage COPD of the patient. If I manage COPD, I will reduce the hypoxia, and if I reduce the hypoxia, then I will be able to prevent the recurrence of this arrhythmia. You guys have been silent for a while. Hit the comment button and let me know what should be the target SpO2 in COPD. Options are 95 to 98%, 92 to 95%, 88 to 92%. Hit the comment button. What is the target SpO2 that you would like to? Yeah, we can use ibutilide also. Amidron can be used and ibutilide can be used. It is the same one. No. It is 2 joules per kg. बच्चे for बच्चे में थोड़ी ना same intensity देंगे. बच्चे में तो 2 joules per kg होता है ना. It's based on the body weight. Kiddo, it's not based on the same intensity. For kid, it's 2 joules per kg. Yes, very good. The target SpO2 in the patient that we want to achieve is 88 to 92%. We want residual hypoxia to be treated. And how do you treat the hypoxia? It is long-term oxygen therapy. We shall be using LTOT. LTOT stands for long-term oxygen therapy. Then we will be using LABA. We'll be using LABA, inhaled corticosteroids. All of them are will be discussed in the later part of the discussion also, but yeah, long-term oxygen therapy will be the mainstay of treatment. That long-term oxygen therapy, we will give oxygen with help of a nasal cannula, transparent nasal cannula at 1 liter per minute for 16 hours per day. Tell me the longest acting beta-2 agonist. Which beta-2 agonist can be given once a week? Beta-2 agonist given once a week. Yes, guys. Beta-2 agonist that can be taken, not once a week, once a day. Sorry, once a day, not once a week. Beta-2 agonist that can be given once a day. Yeah, indacaterol. This is one of the longest acting beta-2 agonist. This is one of the longest acting beta-2 agonist that is called as indacaterol. Then we can use tiotropium in the patient. Yeah, we want to give low flow oxygen, but it is long term. The term used is not LTOT stands for long-term oxygen therapy. It's a low-flow oxygen. We deliberately want to give low flow to the patient. The term is not, LTOT is not like low flow. It is long-term oxygen therapy and it is given low flow. भाई नॉर्मली तो ऑक्सीजन यार 6 लीटर पर मिनट पे देते हैं ना, यहाँ पे 1 लीटर पर मिनट पे देते हैं, जानबूझ के 1 लीटर पर मिनट पे देते हैं. Yes, yes, yes. The main thing is in multifocal atrial tachycardia, I have been focusing on preventing it because it is caused by hypoxia. But yes, if we say specifically like how do you manage palpitations in a person who's having multifocal atrial tachycardia, because it is a COPD patient, by default the answer will be calcium channel blocker, that is verapamil, for management of this patient. But he says that what you should not be having to use this medicine. You should try to prevent the usage of this medicine by going on for preventive approach in these patients. If I know that COPD is the cause of hypoxia and hypoxia is causing an arrhythmia, then I will try to treat the COPD component very aggressively so that the hypoxia component can be minimized in the patient. Then the arrhythmia will not occur. So yes, Praveen, you have a point. The drug of choice happens to be verapamil only by default for all cases of COPD. But our role is to minimize the requirement of that particular drug. Question for you guys: which drug is used in asthma treatment has been withdrawn from treatment also? It is used in status asthmaticus. It causes multifocal atrial tachycardia. Pharmacology. Which anti-asthma drug has been withdrawn from treatment because of the risk of MAT? Yes, waiting for your answers. Anti-asthma drug withdrawn from the treatment because it causes MAT. When I was a student your age, this drug was used left, right and center. Even today in government hospital now, this drug is still being used. Aminophylline. Theophylline derivative है aminophylline guys. Aminophylline toxicity increases the risk of multifocal atrial. The question was which drug is withdrawn and increases the risk of MAT in a patient. Then it is multifocal atrial tachycardia. This drug is Tarbutalin तो यार मतलब emergency में use नहीं करते थे ना. Status asthmaticus में मतलब it is a parenteral bronchodilator. I understand it has issues, but then my question was which drug used in status asthmaticus is withdrawn. The aminophylline infusion is withdrawn because of the risk of MAT, that is multifocal atrial tachycardia is the answer here. Theophylline is good enough answer, but तो वो तो अभी भी मतलब theophylline की तो यार गोलियां आती है ना. सरकारी हॉस्पिटल में आप सब इंटर्नशिप किए हो है ना, तो वहाँ पे आप बाहर का दवाई लिखते हो तो पेशेंट लड़ाई करता है यार हमारे साथ में. तो आज के डेट में भी आप थियोबेड की वो टैबलेट लिख रहे हो तो 150 या 300 मिलीग्राम वाली या थियोफाइलिन सस्टेन्ड रिलीज वाली, तो थियोफाइलिन इज नॉट अ टेक्निकली अप्रोप्रिएट आंसर. द टेक्निकली अप्रोप्रिएट आंसर इज अमाइनोफाइलिन देयर. आई हैव कवर्ड 2 supraventricular tachycardias. Now we will focus on PSVT, that is a paroxysmal supraventricular tachycardia. This is one arrhythmia that will always be seen in structurally normal heart. All other tachyarrhythmias are always seen in a structurally damaged heart, but this is one arrhythmia that is seen in a structurally normal heart. What happens in PSVT is that the R and the R waves will start coming closer to each other. Understandably, when R and R will come closer, the T and the P of the subsequent complex will also come closer. When the T wave and the P wave will also come closer, the closer activity will result in development of this single wave. This blue looking wave that you can see in the handout at the moment is formed due to it is formed due to merging. This wave that you can see at the moment is formed due to merging of the electrical activity of the T and the P waves. These two waves are coming closer to each other, so the merging of electrical activity is causing the blue wave. The second thing that will happen in this patient would be that there would be a narrow QRS complex that would be developing in a patient. It will be ultra narrow QRS complex, that is like literally R and S is literally jumping on each other. Hardly any S is present here, but it is a narrow RS complex which is present in this patient. There are two things which I want you to appreciate in the ECG of paroxysmal supraventricular tachycardia. The first thing is that in these particular patients, the ECG criteria will always be, and you can hand draw with me if you are having any confusion, like said sir, I feel always confused, so I'm gonna hand draw this before you so that you are able to remember this better. Make R and S as narrow as possible. Try and show a bit of ST segment depression also, because in this condition there would be some component of subendocardial ischemia happening. So this is a narrow QRS complex, ST depression, peculiar looking wave. PSVT is one of the easiest arrhythmias to identify, because the question will begin usually by describing a young female who is coming to the doctor with complaints of palpitation, especially after like consuming tea, coffee, sympathomimetic stimulation. She went to a party, had a Red Bull, just few sips of Red Bull, and she says my heart was literally pounding in my chest. The highlight of this condition is, as somebody has commented very rightly, the most important diagnostic criteria for this condition will be one, there would be presence of the word hidden P waves. Don't comment on the word absent P wave here. Answer it as hidden P wave, because merging of the electrical activity in the T and the P is happening. And the second thing which is present in these patients would be a narrow QRS complexes. The supraventricular tachycardias by default will cause a narrow QRS complex. So I'm not saying that narrow QRS tachycardia alone is sufficient for diagnosis of this condition. It will be a combination of the two, narrow QRS tachy with hidden P waves, which will be helping in diagnosis of a PSVT, and this is more common in a structurally normal heart of a young female, or can be a young male also, misdiagnosed as having panic attacks, misdiagnosed as having anxiety neurosis. In most of the questions in FMG exam, they have made it super easy. They have just said crushing patient, unrecordable blood pressure, value less than 90/60. All you need to do is remember DC shock, and therefore you will say I will be giving synchronized DC shock to the patient. As I've explained to you multiple times, every time it's going to be a crushing patient, you are not going to waste your time giving drugs etc. So it is a synchronized DC shock, which is also called as cardioversion. The intensity of DC shock that is used here is like 120 joules, and we can upgrade the power to 200 joules if it is required. For FMG exam question, the PSVT part has been a piece of cake. Like most guys never miss it up. Young female, recurrent syncopal attacks. Today is again unconscious. She is brought to the hospital from her office in unconscious state. She was having coffee at her office canteen in the evening, and after that she started saying I'm having palpitations. Her friends thinking she's having panic attack, they brought her to the psychiatry emergency. And the psychiatrist had a look and she said, no, take her to the casualty. Lips were all pale because BP was falling. And you did ECG, it showed a run of PSVT with the unrecordable BP, DC shock. But sometimes they will give you situation where they want to test your knowledge with respect to pharmacology. Like he will say at the moment the BP of the patient is more than 90/60 and patient is at home. Now at home, how will the patient control the attack and prevent hospitalization? Now a new drug is available, which is a short acting intranasal calcium channel blocker. The name of this molecule is atripamil. Atripamil is a rapid acting blocker. It's a rapid acting calcium channel blocker. It blocks the AV node, and this is a cousin brother of verapamil, which will slow down the conduction for re-entry circuit in this condition. And this is the emergency management that would be used in a patient. Yes, doctor, you are right. Hospital management will be adenosine. If he says the word home management, if he says in your exam home management, then your answer would be given as atripamil. If he says the word hospital management where the patient has come, then I will be using a different approach. By the different approach, I mean that first I will be doing vagal stimulation maneuvers in this patient. The vagal stimulation maneuvers, yeah, we can also perform modified Valsalva, but usually requires one person's cooperation. The vagal stimulation which can be done in a patient, घर पे क्या बोलेंगे ना, उसको बोलेंगे ठंडा पानी पी लो, बर्फ वाला पानी पी लो. You know, cold water, splash cold water on the face, apply ice pack, drink chilled water, you will feel better. That's again like vagal stimulation that is happening. In hospital management, vagal stimulation, the traditional method is carotid sinus massage. A patient is not comfortable with the carotid sinus massage, a patient is not comfortable with respect to a carotid sinus massage, an alternative approach that I can be using in a patient, ice bath. Okay, थोड़ा मुश्किल रहेगा ना यार कि मतलब BP थोड़ा इतना भी comfortable नहीं है ना यार, मैं I don't want a fall or anything like that. So carotid sinus massage is a good answer. If this is not the case, then we can use a face ice pack. You can ask the nurse to get from the refrigerator gloves and she can put ice in it, put it on the face. So face ice pack would be working in this case. If in spite of this it's not working, then is this aspect which is shown. take a 20 cc syringe, 50 cc syringe and ask the patient to blow into the mouthpiece of the syringe. One part of the syringe is the plunger, other part is where the needle is present. Disconnect the needle, ask the patient to put the part of the syringe between the lips and blow out. When you will blow out with force, it is a modified Valsalva maneuver that is done, and immediately when he is blowing out, you need somebody to raise the legs of the patient to increase the venous return to the heart, and most of the time the patient will be relatively better. Both the things will require at least one person support. This that is currently diagrammatically shown before you is what is called as modified Valsalva maneuver. Otherwise it is simply breathing against a closed nostril. Now ask the patient to pinch his nostril, बाहर छोड़ने के लिए बोलो. So modified Valsalva maneuver is what is currently shown here, where a big 50 ml syringe can be used, and this can help in termination of a tachyarrhythmia. If vagal stimulation obviously is not a solution, it is a temporary tap gap, it is a stopgap maneuver. So ultimately you will have to give adenosine in this patient. This would be first a 6 milligram shot, not improving, then it is a 12 milligram shot. Here remember any set question where he said adenosine was being given and patient started having hypotension, what will you do next? So you straight away have to now go for a DC shock, because you are giving adenosine but BP is continuously falling. That means the patient's chemical cardioversion is failing. The scenario was you are giving adenosine to the patient, BP is falling to less than. In spite of your medical treatment, it was a stable patient. Now the BP is falling. So what do? So you will have to subsequently go in for a synchronized DC shock in a patient. So they gave a scenario that has been discussed here. That is, the point to be understood is patient came unconscious, I need to give DC shock. But if I notice, but if I specifically notice the fact that the person's blood pressure is beginning to fall in spite of the medical treatment, then I will have to go in for a DC shock in a patient. And last aspect is again your NEET PG aspect. He will say, what is the best management for prevention of PSVT episodes? So can I have the answer please? I would like everybody to comment. It's not a fully validated one, I would say, that long-term use of caffeine causes tolerance of adenosine. But yeah, I mean, partially we can be getting that kind of a manifestation. Yes. Electrophysiological studies would be done. What is the best way for management? No guys, I think all of you know the answer. I mean, oral verapamil is the last resort that we would like to use in these patients. The main treatment is that we can use diltiazem pill in the pocket. Na? One is this, what you are telling me is the concept of pill in the pocket. My point is simple, that if person is forgetting to put the pill in the pocket, it's not easy to keep a medicine in your pocket every single day for the rest of your life. So what will you do in this patient is, you will say that we will be going ahead with catheter ablation, because there is a re-entry circuit in this patient. That re-entry circuit will be destroyed using catheter ablation. So we will make micro cuts. Yes, RFA catheter ablation is the technically appropriate answer. The logic is that there is a re-entry circuit around the AV node, so I can fix that by we using the laser beam. Using the laser beam, what we can do is we can make micro cuts, and that can basically block the or it can interrupt the electronic circuit of the re-entry pathway, and thereby the patient will improve. So catheter ablation should be answered as the best way to be able to manage the patient. So at the moment, what I have done in this slide is summarize the core aspects for PSVT. That is the aspects related to the ECG. Then I mentioned regarding what will you do at home, what will you do in the hospital, and what is the best way to manage. And again, avoiding sympathomimetic stimulation will also work in these patients. A lot of these patients can be misdiagnosed as having panic attacks as well. Slightly technically different, Dr. Tewani. Panic attacks is the common misdiagnosis in these patients. So usually James and Kent bundle, yes, exactly. That's accessory pathway that will come up in the discussion subsequently. Every time you have to seed only lead to. Whether you are a NEET PG aspirant, whether you are an FMG aspirant, don't bother with anything else. Check out lead 2, you get the tachyarrhythmias right, you get the bradyarrhythmias right. Only in MI case will you check the limb leads and the chest leads of the patient. Otherwise, no need to check out anything else. लीड 2 अलोन विल बी सफिशिएंट. लीड 2 को रिदम स्ट्रिप बोलते हैं. उसको बनाए ही इसीलिए गया है कि आप रिदम को आइडेंटिफाई कर पाओ. आपको टैकीब्रेडी आइडेंटिफाई करना और एरिथमिया को आइडेंटिफाई करना. Max dose, no, Narendra, it's not like this. It's not like this. Max dose of adenosine before we move to DC shock is not 18 milligram. It is if the BP is falling, in spite of giving adenosine, you move on to the DC shock. So when I write the word fails, it's not the issue of the drug that is failing. Drug might have caused a temporary improvement in blood pressure. I will hold the DC shock. If BP falls, that is the time you will give DC shock in the patient. So it is, what is catheter ablation? यार PSVT में तो री-एंट्री सर्किट होता है ना. जैसे ये AV नोड है तो AV नोड के आसपास में, जस्ट सपोज दिस इज द AV नोड, सो देर इज अ री-एंट्री सर्किट. आई मीन द करंट इज मूविंग अक्रॉस and re-entering. In our heart there is no re-entry, but here the current is going and is causing a retrograde activation of the atria. So what I am gonna do is that we can like make microcuts here. We can like make microcuts here that will block. I mean, what I've said is laser beam se we are gonna make microcuts in the cardiac myocardium, in the cardiac tissue, and that will interrupt the flow of the current. Okay, that's a very good question. How do we confirm? Speculation की ज़रूरत ही नहीं है. अगर आपको एज अ डॉक्टर कभी भी डाउट है, चाहे खुद के ऊपर चाहे पेशेंट के ऊपर, कि इसको पीएसवीटी हो रहा है नहीं हो रहा है, क्या करना है? होल्टर लगाना है. 2-2,500 रुपए का होल्टर आता है यार. लोग बिना वजह पैनिक अटैक करके सफर करते रहते हैं. पता चलता है बाद में पीएसवीटी निकल रहा है. आपको कार्डियोलॉजिस्ट को पास भेजने की जरूरत नहीं है. आपको क्या करना है, आप गूगल करो आपके एरिया में होल्टर बंदा कौन सा है, तो होल्टर वाला डिवाइस ऐसे चेस्ट पे लगा देते हैं एंड इट विल, यू डोंट नीड एक्सटेंसिव सेटअप, नो, इट्स जस्ट अ स्टिक ऑन डिवाइस. It will record your ECG. The cardiologist will scan it. लैब में क्या सॉफ्टवेयर AI के बेसिस पे they scan it and they give you a report. And there, if you see PSVT runs, you know that it's a PSVT. Otherwise, it is not a panic attacks in a patient. Yeah, absolutely. That is what I'm saying, guys. Simply use Holter device. This is the most underrated devices currently as of now. If a person में 48 hours में रिकॉर्डिंग नहीं आ रही और तुम्हें तब भी लग रहा है तो क्या करोगे? लूप रिकॉर्डर लगवा लेना. Loop recorder will record the ECG for the patient for 7 days. If you're still having doubts ना, if you're still having doubts, like मेरी family में ही one person was having this panic attacks का misdiagnosis turned out to be PSVT. तो loop recorder लगाया यार, निकल आया उसको PSVT रन था. Holter device will record the ECG for 48 hours. So my point is very simple कि कभी भी डाउट हो ना तो आप, क्योंकि देखो, if you wait for the person to suffer and then come to the hospital, यार somebody can really fall sick on the way to the hospital, तो why to take a risk? उसको बोलो कि तू जितना कॉफी पीना है उतना कॉफी पी और होल्टर लगवा ले. अगर पीएसवीटी होगा ना तो 100% गारंटी है, क्यों पता चल जाएगा. चलो, कमिंग बैक टू द एजेंडा. पैनिक अटैक्स के लिए दवाई बता दो फटाफट से मुझे, क्या दवाई देंगे, एंड वी कैन मूव ऑन. वेरी कॉमन नाउडेज पैनिक अटैक्स. Reason can be manifold. Yes, guys, waiting for your answers here. Holter can identify everything, man. Any arrhythmia. Paroxysmal atrial fibrillation. Absolutely. Yes. Benzodiazepines, no? चलो, जो लोग एल्प्रेक्स कह रहे हैं यार तुमने खाई होगी कभी जिंदगी में, तो नींद कितनी आती है. एक किसी को रोज बेंजोडाइजेपिन खिलाएंगे तो नींद नहीं आएगी. क्लोनाजेपाम से तो सोता रहेगा ना. प्रोप्रानोलोल नहीं देते बच्चे. यू कैन गिव प्रोप्रानोलोल, बट पैनिक अटैक्स के लिए तो बेंजोडाइजेपिन देते हैं ना. कौन सा बेंजोडाइजेपिन देते हैं जिसका सिडेशन भी बहुत कम होता है एंड लाइक इट विल हेल्प फीलिंग द पेशेंट फील कंफर्टेबल. नो सर, प्रोप्रानोलोल इज नॉट अ बेंजोडाइजेपिन. दैट आई थिंक ऑल ऑफ यू स्टडीड साइकियाट्री दैट फॉर पैनिक अटैक, हाँ, वी कैन गिव, हम देते हैं एल्प्रेक्स की गोली, वो तो मैं मानता हूँ कि एल्प्रेक्स देते हैं, बट उसके साथ नींद बहुत आता है ना यार. तो यंग इंडिविजुअल है, वो कह रहे हैं सर सारा टाइम नींद आता रहता है. डाइजेपाम के साथ में भी नींद आता रहेगा. चलो SSR, चलो आपके लिए होमवर्क है, कल पूछूंगा फिर से, ठीक है. चेक आउट योर नोट्स देयर. क्लोनाजेपाम नहीं देते यार. रिवोट्रिल से भी बहुत देने को तो यार कुछ भी दे दो. देखो अब एल्प्रेक्स भी खिलाओ, वो भी खिलाओ. सो आई एम लीविंग इट एज अ क्वेरी टू यू गाइस. चेक आउट योर साइकियाट्री. SSRI बताओ क्या दोगे. Yeah, we give paroxetine. We are using benzodiazepines in a patient. So we can be using the SSRIs like sir देते तो सारे available है ना, zolpidem, fluoxetine, all of them have so many side effects na, including erectile dysfunction. Suppose it's a young guy and he's having like sexual health dysfunction, then again more panic attacks will occur in a person. So we have to use like fluoxetine, paroxetine are the drugs which are used, and benzodiazepine I'm leaving as a query as for you guys. Obviously not flumazenil, that is the antidote for benzodiazepines. Chalo, this was a miscellaneous question that I wanted to say, but yeah, panic attacks are very common nowadays. And like अगर आपको थोड़ा भी iota of doubt होता है कि panic attack is like not a panic attack, it is PSVT, holter लगवा देना, the patient will do perfectly fine. चलो जी, next चलते हैं. We will now talk about late ejaculation. First is late ejaculation. That is again an issue na yaar. Late ejaculation, if the person is not able to do proper sexual activity, person will think that he or she is inappropriate. He is inappropriate, and because of the inappropriate part, then the ED part will come in. If the person is not able to sexually perform, then the person will think that the person is inappropriate. So anyway, like at the moment, let's focus on the cardiology component. But yes, you have a good point there. Okay. Moving ahead, we come to VT, that is called as ventricular tachycardia, and VT is a condition in which, it's a psychological part that would come in. For ventricular tachycardia, I would like to draw a line diagram which will help you understand this better. This is the heart's diagram. This is the SA node, this is AV node, then is going to be the bundle of phase. This is Purkinje network. So what I've shown at the moment is the normal conduction system in the heart. In ventricular tachycardia, there is an abnormal focus which is created. That abnormal focus is most of the time created due to MI or due to metabolic acidosis, and the current will now utilize the intermyocyte conduction, and it will go across the cardiac chambers not via the Purkinje network, but it will utilize the intermyocyte conduction. The highlight of ventricular tachycardia is two problems. The first problem is that in VT we have a intermyocyte conduction. This intermyocyte conduction will be slower than the Purkinje network. Please read the word intermyocyte conduction is slower than Purkinje, and let me know what will happen to the QRS complex. Will it be normal duration QRS complex or will it be a relatively broad QRS complex? I did not say the word slow. I said slower than the Purkinje network. So it will be a, can I have the comments guys quickly? Intermyocyte conduction is slower. Yes, it will be broad. That is the point. This is a broad RS complexes which will be noticed in the question, and that is what was present in the ECG of this patient also. So broad or wider RS complexes would be present is the first thing. The second problem in this patient is that the atrial rate of the patient will be about 100 per minute. Atrial rate will be 100 per minute because SA node is firing. Ventricular rate will be decided by the ectopic focus, which can be huge 200 times per minute. So the second problem in this patient is lack of coordination. Lack of coordination between the atria and the ventricles, that is AV dissociation, and because of this AV dissociation component, there would be incomplete filling of the ventricles. There would be lack of coordination which will cause low cardiac output in a person. So there are two reasons why the BP will fall. The first reason is simple lack of coordination. Second is pathological tachycardia. If the heart will beat very, very fast, it will not be able to get filled with blood. The highlight of ventricular tachycardia is premature ventricular contractions. PVCs लिखा होता है कि ventricle जल्दी contract कर जाते हैं, faster beat कर रहा है ना ectopic foci की वजह से. The purple thing is the ectopic focus. It is outside the conduction system. That is why I am calling it ectopic focus. It is firing at 200 beats per minute. So there will be early contraction of ventricles, premature ventricular contractions. When I described like this, the query of one of my students was कि sir दिक्कत क्या है? वेंट्रिकल कॉन्ट्रैक्ट तो कर गया ना, तो आपको दिक्कत क्या है? वेंट्रिकल कॉन्ट्रैक्ट कर गया तो अच्छी बात है ना भाई, बुरी बात है. How is premature ventricular contraction bad? Because there is a early contraction of a partially filled ventricle. If you just focus on this English word, you will understand why ventricular tachycardia is dangerous, because it is early contraction of partially filled ventricle. Even if you don't listen to the topic at all, but if you just focus on this word that I've written here, now you understand the pathogenesis of the disorder, that there is early contraction of partially filled ventricle, which means that if the ventricles had less input, output will also be less. That is why the BP will crash. Two particular reasons why blood pressure will crash in this condition. Reason number one, lack of coordination. Reason number 2, premature ventricular contractions. The combination of the two is responsible for pathogenesis. The combination of the two is responsible for pathogenesis of ventricular tachycardia. AV dissociation and PVCs are the core aspects. Now let's look at the ECG. This is one of a very common ECG that is asked, where you are able to see what is going up is R, what is coming down is S. It is broad RS complexes. It is monomorphic ventricular tachycardia, and you can also notice a chota sa notch which is present here. This chota sa notch that is present is called as Josephson sign. Not that it has some very great diagnostic interpretation, but yeah, my students were like, nahi sir, wo present tha, so I thought I should just share that with you, that in the downswing of the R, जब बनाओगे ना इसको तो थोड़ा ऐसे बना देना, थोड़ा shelf दिखा देना, जैसे draw a R, then draw a shelf like this. So if you are hand drawing this, then just draw that chota sa deflection in the downswing of the R, and you will understand that Josephson sign present, again because of the aberrant activation of the ventricles. Ventricular tachycardia के diagnostic criteria क्या होते हैं? MCQ में लिखा होगा AV dissociation. In FMG एग्जाम मेरे स्टूडेंट ने सॉल्व कैसे किया, वो कह रहा सर मुझे ECG समझ नहीं आया पर मैं VT मार्क करके आ गया. मैंने कहा कैसे किया? कह रहा सर कैनन ए वेव लिखा था और टैकीकार्डिया था. आई सेड एक्सीलेंट भाई. द गाय सेड सर ECG ध्यान नहीं था मेरे को, बट मुझे क्या पता था कैनन ए वेव्स यू सेड, वन फॉर ब्रैडी वन फॉर टैकी, एंड द टैकी यू सेड वाज VT, सो आई जस्ट मार्क्ड इट लाइक दैट. कूल मैन, क्वेश्चन शुड बी सॉल्व्ड ना. If you say ECG is not my cup of tea, I'm okay with it, man. Like ultimately we need to add the question right. Cannon A waves in the JVP, that frog sign in the neck pulsations is sufficient to crack a question of Brady, Stokes-Adams syndrome, tachy, ventricular tachycardia. So I'm okay as long as the question is getting solved. I am okay with it. There would be premature ventricular complexes which are present. Why PVC is bad, I've already explained. Like less input is there, so therefore the output will also be lesser, cardiac output will be less. Then is this peculiarity that could be written in some question, capture beat, fusion beat, that is present. The ECG will look like this. This is broad QRS, broad QRS, broad QRS, broad QRS coming up, and then between में ना shockingly normal sinus rhythm. And again ectopic foci contributing to broad QRS in a patient. You can notice बीच में ना fraction of a second के लिए सब कुछ normal हो गया. For a fraction of a second the heart SA node was able to re-establish its superiority. The SA node was able to capture the normal electrical system of the heart. Then the ectopic focus took over. So that's called as the capture beat in a patient. Why do you say the word capture is because for a second the ectopic focus भी fire करते करते थोड़ा, for a second it missed the fire. So the SA node immediately took over the heart. SA node is like the boss of the heart. He says कि भाई तू control छोड़, मैं control ले लूँगा बीच में. So you can see like everything became normal. So this is just one of the diagnostic criteria which will be given in theory to you. They'll not give an ECG and they give a VT and बीच में normal sinus rhythm कि बताओ कि ये क्या चीज़ है. It is just the fact that I want you to appreciate the fact that in this condition in the theory capture beat word is given. So I had to explain to you what do you mean by the capture. It is again the re-establishment of the superiority. It is the re-establishment of the superiority of the SA node in a patient. Okay Pranav, I'll do the activity you said. Why premature ventricular contraction is bad is because there is the early contraction of a partially filled ventricle. अगर वेंट्रिकल जल्दी कॉन्ट्रैक्ट कर देगा तो उसे फिल होने का मौका ही नहीं मिलेगा ना. इन यू एंड मी एट्रियल कॉन्ट्रैक्शन ड्यूरेशन इज 0.3 सेकेंड, रिलैक्सेशन इज 0.5. Contraction duration 0.3, relaxation duration 0.5. Our heart contracts our whole life but takes 0.5 second for relaxation to get filled with 130 ml of blood. Let me write down the data here also, that the data here is like this. 0.5 seconds is the time it will take in one beat of the heart to get filled with blood with 130 ml of blood. 0.5 सेकेंड में 130 ml ब्लड भरता है, फेयरली फास्ट ना. 0.5 सेकेंड, लेस देन हाफ अ सेकेंड में 130 ml blood fills in our heart. Now suppose if I decrease this duration to only 0.1 second, just check out the data and let me know. Don't get into calculation कि 80% कम हो गया. My point is simple. Will you be able to fill 130 ml blood in 0.1 second? In you and me, 0.5 second में 130 ml blood is filling in. If I give you only 0.1 second, will you be able to? Will I be able to fill blood? No. 0.1 or 0.5 is 80% lesser. 80% lesser means here the blood that would come in would be hardly, if I reduce by 80%, that means only 20% filling is happening, hardly maybe 20-30 ml blood. So here the end systolic volume will be significantly low. At this moment, like this mathematics is just to explain to you what is going wrong with the heart, that this is normal and this is what is happening in ventricular tachycardia. Your and my heart takes 0.5 second to receive 130 ml blood. In 0.1 second very less blood would be. Vipin, thank you so much. मेरी मैथ्स बड़ी कमजोर है यार, मैं स्ट्रगल कर रहा था पता दिमाग में कि 20% ऑफ 130 कितना होता है, 26 ml. थैंक यू सो मच मैन. द पॉइंट इज इन वीटी देयर वुड बी लेस ब्लड कमिंग इन. 130 के जगह पे मुश्किल से 30 ml आ रहा है तो बीपी क्रैश कर देगा. कैनन ए वेव क्यों आती है? क्योंकि दोनों वेंट्रिकल और एट्रिया का रेट सेम नहीं है ना. इन यू एंड मी फर्स्ट एट्रिया कॉन्ट्रैक्ट्स देन वेंट्रिकल कॉन्ट्रैक्ट. इधर तो दोनों साथ में चल रहे हैं अपनी मर्जी से. तो इफ सपोज द टाइमिंग ऑफ द टू कोइंसाइड्स, in you and me timing will never ever coincide. Atria will contract then ventricle, atria will contract then ventricle. Here both are working at different rates na. Due to lack of coordination, both make actually time, that contraction may be timed at the same time, and that causes Canon A waves to be present in this patient. So I hope I was able to explain this to you from the mathematical domain, and also that there is a out of sync simultaneous contraction of the ventricles and the atria. The word is out of sync simultaneous contraction of atria and ventricles, because they are working at different rates. So I hope that explains the information at the moment for VT, and therefore this is dangerous arrhythmia. The treatment of this has already been discussed guys. For the treatment of PVT in a patient, वो 3 boxes मैंने बनाए थे. I told you that we will be going for DC shock in a patient. After the first box I will secure IV line, then epinephrine, then amiodarone. So I don't need to describe that once again before you. It is defibrillation that will be used for management of a pulseless ventricular tachycardia. So yep, the treatment part of this has already been taken care of. And sometimes ventricular tachycardia can degenerate into ventricular fibrillation also, that is the twitching activity. Again the algorithm for the same has already been taken care of. Now comes what couple of people were asking in the morning session कि sir वो bradycardia में क्या होगा. So if a person is having asymptomatic bradycardia, then there is no need for treatment. The best example for asymptomatic bradycardia is hypothyroidism. The best way to remember the word asymptomatic bradycardia is hypothyroidism. In those particular patients, there is no treatment required. But if it is symptomatic bradycardia, like if the person is having sinus bradycardia, not sick sinus syndrome, sinus bradycardia, let me explain that to you, right? Look at this ECG. Let us count the number of squares here. 1, 2, 3. Try to do this with me. Okay, zooming it further. 1, 2, 3, 4, 5, 6, 7. Help me with the mathematics in this particular case. It would be like 300 divided by 7. If I divide 300 by 7, the heart rate of this patient would be in 30s only, no? 300 divided by 7, it would be something like 30-35. So the heart rate of the patient is very, very slow. So one, I can say that the patient is suffering from bradycardia. Like the heart rate of this patient is 35 beats, less than 40. So it is very, very low. 300, is it 7 4s are 28? Okay, 7 4s are 28. Okay, oh fine. Mathematics, mine is bad, terrible. Fine guys, 40 per minute. Okay, fine. So approximately 40 per minute, and proves why I became a doctor. So 300 divided by 7, something like 40 beats per minute. 40 into 7, 280. So got the point. Okay, so something like 40-45 beats per minute. So it's a brady. But I hope even if you are like, you know, looking at the handout in the PDF I've put in the group, you will notice you can see a positive deflection of the P wave. You can see a positive deflection of the P wave that is coming up every time. I can just for reference even look up a couple of more leads where positive deflection is present. So in those circumstances, let me know, would you like to answer this as sick sinus syndrome, or would you like to answer this as sinus bradycardia? And at this moment I say that especially a lot of you boys who are working out in a gym, if you do marathon running, if you do cardio training, if you do weightlifting, then your resting heart rate or by daily exercise is bound to decrease. So sinus bradycardia is what is shown in this ECG. Sinus bradycardia is shown in this particular ECG. Yes, the treatment for this particular patient will depend upon whether symptom is there or not. The ECG of this patient is showing sinus bradycardia. Now listen to my words very carefully. The ECG of this patient is showing a sinus brady. If the question says any of the following things, if he says specifically patient is in altered mentation with sinus bradycardia, if he says that the patient is in altered mentation, or if he says that the patient is having chest pain, or if he himself mentions that the blood pressure of the patient is low, if this kind of data is given in a question, especially the blood pressure is decreasing to less than 90/60, then it is a cause of concern. No, bachche, this is not sick sinus syndrome. No, this is not a sick sinus syndrome ना. It is a sinus bradycardia. बेटा आपको देखो ना, यहाँ पे आपको P wave दिख रहा है ना. You can see a positive reflection here. Just because the heart rate is less does not mean that it is always going to be a question of sick sinus syndrome. Because P wave is present, we will say sinus bradycardia in the patient. वो बात अलग है कि बीच बीच में अगर P wave गायब होना शुरू हो जाए तो it will be a या साइनस ब्रैडिकार्डिया इज फिजियोलॉजिकल ना यार. जो लोग मैराथन रनिंग करते हैं उनका रेस्टिंग हार्ट रेट विल ऑलवेज बी लेस. बॉडी बिल्डिंग में ना ताकत लगता है ना सर उसमें, तो द रेस्टिंग हार्ट रेट टेंड्स टू डिक्रीज ऑन दोस पेशेंट्स. द कार्डियक आउटपुट इंक्रीजेस बिकॉज द हार्ट विल कॉन्ट्रैक्ट विद मोर फोर्स ड्यू टू एक्सेंट्रिक हाइपरट्रॉफी ऑफ द हार्ट, बट द रेस्टिंग हार्ट रेट विल डिक्रीज. इट्स अ फिजियोलॉजिकल फाइंडिंग दैट विल अकर टू कंजर्व ऑक्सीजन. जो लोग व्हाई इज दैट अ फिजियोलॉजिकल फाइंडिंग इज बिकॉज द हार्ट वांट्स टू कंजर्व ऑक्सीजन. सर मेसी, रोनाल्डो, धोनी, ऑल ऑफ दीज गाइज दे डू कार्डियो ट्रेनिंग, और उनके जो फिजिशियन है ना वो उनको कार्डियो ट्रेनिंग में रोज पुश करते हैं. क्यों? जैसे मैं आपको, आई एम द कोच ऑफ टुडे फॉर यू गाइज, आई एम पुशिंग यू गाइज. वैसे ही विराट कोहली इज नॉट अ वेरी मस्कुलर गाय, but he is like his doctor, his physio, they motivate him to do exercise. वो mask लगा के करता है ना, high altitude वाली mask लगा के exercise करता है. So they keep on pushing their limits. Why? Because then the body tries to conserve oxygen, but heart contracts more forcefully, so you are doing a efficient utilization of oxygen. Sick sinus syndrome is where the P wave would be absent. If it is sick sinus syndrome, the P wave will be absent. In this, the P wave is present. So I'm saying sinus bradycardia. If P wave is absent, suppose I gave you the same ECG, no P wave present, हम बोलेंगे sick sinus syndrome. In that particular, sinus bradycardia is good as long as it is not causing all of this. Sinus bradycardia is good as long as it is not causing any one of these things. If you have a heart rate of 30, 40, if you have a heart rate of, let me say 60 or 50, no, not a problem. As long as this is not present, not a problem. No treatment required. If this is present, you move on to what I've told you at the moment. This ECG deliberately put in to explain to you that not every ECG of bradycardia will be sick sinus syndrome. The answer in this particular case would be if he mentions the following situations. Atropine ka dose is not 0.6, it is about 3 milligrams, and then are a couple of other drugs that would be used in this condition which can stimulate the beta 1 receptor, like we can use dobutamine or we can use epinephrine. So these are like alternative drugs which can be used to increase the heart rate of the patient. And if the BP is still not picking up, then I will go for temporary pacemaker. The temporary pacemaker would be TCP, that is transcutaneous pacemaker. Yeah, isoprenaline can also be used. Then is TCP, transcutaneous pacemaker, or TVP, that is transvenous pacer can be used. It is TCP, transcutaneous pacer. TVP stands for transvenous pacer. So these are like the approaches that can be used. Transcutaneous and transvenous pacer are like approaches which would be used for patients of symptomatic bradycardia, because patient is not fit enough at this particular point of time for a permanent pacemaker. So this is like the first aspect that I wanted to bring to your attention. And now we will compare this with first degree heart block. This is again a NEET PG question that came in the paper. In first degree heart block, like he said, you are a doctor attached to a software company, and like this guy is having a prolonged PR interval more than 200 milliseconds. Normal duration of the PR interval will be under 1 large square. Normal duration of the PR interval is 120 to 200 milliseconds. Normal duration of PR interval is 120 to 200 milliseconds. One large square of the ECG will be having 5 small squares, 1, 2, 3, 4, 5. The duration of one small square is 40 milliseconds. What I want you to understand is that the P wave of yours and mine will fit in the range of about, 3 to 5 small squares. What is the PR interval? PR interval does not go up to the R wave. The name is PR interval, but it does not go to the R wave. PR interval is from the starting of the P to the starting of the Q wave. This entire duration, I hope you know this guys from your baseline physiology classes, that PR interval is from the starting of the P to the starting of the Q wave. It is called as a PR interval. The name is PR interval, लेकिन वो R तक नहीं होता है, वो starting of the Q wave तक होता है. And अगर ये duration more than 200 milliseconds होगा, तो then in those circumstances it is called as a first degree heart block in this patient. Okay, so the first degree heart block can be physiological. That is overall the most common cause, especially people who are into like I can say marathon running specifically. Like 42 kilometers is really a tall order. They are the ones who would be having prolonged PR interval. In rheumatic fever, why would we be having a first degree heart block? It is a diagnostic criteria is because Ashkoff nodules will be there between the SA node and the AV node of the patient. Like you can imagine these black dots that I'm making as Ashkoff nodules. These Ashkoff bodies or Ashkoff nodules will cause local fibrosis. They will slow down the conduction between the SA node and the AV node. So it's a rheumatic fever manifestation that would be occurring in a patient. Okay. Then a sarcoidosis, which would be having non-caseating granulomas. Then is hemochromatosis, iron toxicity, and a disease found in South India, that is endomyocardial fibroelastosis. The ECG finding would be PR interval more than 200 milliseconds. So I think you guys are done with the chit chat. Now let me know, will you give a pacemaker for this condition? Hit the comment button this time, not for a series, but for will you be using a pacemaker for this condition? What is the problem in first degree heart block? Is it a problem of the pacemaker or is it a problem of the connection? Yes, there is no need of any pacemaker. There is no need of any pacemaker in this case. It is most of the time physiological, and because the problem is not in the pacemaker, it is in the connection between the pacemaker. So as such, no pacing is required for this condition. Yes, it is a connection problem, so it becomes relatively easy. Pacing is not recommended. Pacing is not recommended for patients who are having for patients who are having first degree heart block. Now we will be comparing this with Mobitz 1 and Mobitz 2 heart block. So let's look at the informations provided. As far as Mobitz 1 heart block, I'll give the rationale also, but at this moment I want you to check out the PR interval the first time, compare this with the PR interval the second time, and then the third time the PR interval is showing a serial increase. The PR interval of this patient is showing a serial increase. Then you can see T and a P, and then it looks like this is here. This is where the QRS complex should have come. It is missing. The patient of mine is saying, the doctor, in between my pulse is missing. I'm saying, are you kidding me? मजाक कर रहे हो? कह रहे नहीं सर, देखो ना मुझे चक्कर आ रहा है. मैंने कहा क्यों? कह रहा सर आई एम नॉट फीलिंग, ऐसे टेबल को हाथ रख लिया, कहता सर मेरे को ना चक्कर सा आ रहा है सर, आई एम नॉट फीलिंग ओके. एंड ही सेज सर इन बिटवीन नो माय पल्स जस्ट डिसअपीयर्स, सो देयर इज अ मिस्ड बीट, QRS complex is not happening at the moment. Guys, I want you to mentally visualize that even for 1 second now, if your QRS will not be there, blood supply to your brain will be zero, you will feel as if you're gonna fall. So there would be missed beat present, and then you will have a resetting of the cardiac rhythm in this patient. Again the PR interval in this case will get prolonged, and again you will be having a missed beat present. So what I've described before you is called as Mobitz 1 heart block, where you get a significant increase in the PR interval. This significant increase in the PR interval के लिए most of the time the hint will be that the patient is already on beta blockers. The beta blocker dose is on the higher side. If you give too much of beta blockers to a patient, it will cause a prolongation of the PR interval, and drop beats can be occurring. All you need to do is decrease the dose of the beta blockers. What is the cause of Mobitz 1 heart block is that the problem is not in the SA node, problem is not in the between the SA node and the AV node, it is in the AV node. If you look at this diagrammatic representation, this time I'm not saying problem is between the SA node and the AV node. If you look at the data here, the problem is lying in the AV node of the patient. The conduction of the AV node is relatively slow. So I can say this was, I think, FMG exam where he did not write the word in the option Mobitz 1 heart block. He wrote the word intranodal conduction defect. Intranodal means that problem AV node के अंदर है, conduction speed relatively slow हो गया है. So intranodal conduction defect is present, and the condition will be having I mean, this condition is having slow conduction understandably. If I have shown damage, it means a slow conduction, but it is a intranodal conduction defect which is present in this condition. So we call it Mobitz 1 heart block. The fancy name for it in NEET PG, the fancy name for it that they always you would have read in questions is what is called as Wenckebach phenomenon. I'll use a thicker font to highlight that. That's the fancy terminology to be remembered. Mobitz 1 heart block is what is called as Wenckebach phenomenon. And again in this condition, as such, you don't need any specialized treatment. Just treat the cause like a beta blocker overdose. The patient will do something like patient will do fine in this case. The concept is Mobitz 1 heart block problem is in the AV node of the patient. Now comes the most critical part, especially if you are a NEET PG aspirant, you have to listen to this. If you are an FMG aspirant, you can zone off for a while. I don't have an issue because now I will be teaching you Mobitz 2 heart block versus 2:1 block. If you are a NEET PG aspirant, any said you need to be at the peak of your concentration. If you are an FMG aspirant, you can zone off for a while. Till now, FMG और NEET PG दोनों को आना है. Mobitz 1 तो पूछेगा, that is like beta blocker toxicity, वहां से सॉल्व हो जाता है. Serial prolongation of the PR interval. If you are an FMG aspirant, I want you to listen to me, but if you say I'm tired, sir, you can zone off for a while. But if you are a NEET PG aspirant, hear me out for the next 2 ECGs with utmost concentration. The PR interval in this particular case is normal. It is still normal. It is still normal. As you can see, the PR interval the first time, second time, third time, it's almost of the same size, whereas previously it was showing a serial prolongation. Most guys tend to at this moment get flustered कि सर सब कुछ तो नॉर्मल था, so I was not able to pick up. वो हार के आगे जीत होती है. हार के आगे जीत क्या होती है कि T दिख रहा था, P दिख रहा था और उसके बाद में there was a missing QRS complex here. It was a missing QRS complex here. The question still mentioned missed beat there. Most guys lose patience. 3-4 में नहीं मिलता, कह रहे अरे सर मिल नहीं रहा था. Just be patient, guys. Just check out lead number 2 and you'll be able to find out. And then the rhythm will reset in this particular patient, and again you will be getting a PR interval, which will again be normal. What I want you to now realize is that if you check out the PR interval after and before, it is equal. If you compare this with the superior ECG, आप देखोगे कि जो PR interval आप देख रहे हो यहाँ पे ना, the PR interval after and the PR interval before, huge difference है. आप देखो PR interval after the missed beat छोटू सा है and before it is very big. बार PR interval काउंट करने का जरूरत नहीं है गाइस. बार मेरी humble रिक्वेस्ट है, बार PR interval मत चेक करना. जहां पर भी मिस्ड बीट होगा, wherever is the missed beat present, just check out the PR interval right after and before. That's the rule to be remembered. Wherever the missed beat is given, just check out the PR interval. They'll put a vertical arrow for the missed beat also. Just check out the PR interval after and before, and you will realize that if it turns out to be unequal mathematically, you will say it is a Mobitz 1 heart block. If it is gonna be equal, you will say that this is a Mobitz 2 heart block. और मैं दोनों को zoom out कर रहा हूँ. So if you check it out, you will notice that the PR interval after and before in the नीचे वाला ECG is equal. So that is Mobitz 2 heart block. इसमें problem कहाँ पे होता है? Let me draw that also. I'll use a different color this time. This is SA node. This is going to be the AV node. This is going to be the bundle of phase. The problem is not in the SA node. It is not in the connection between the SA node and the AV node. Neither in the AV node. Problem कहाँ पे है? In Mobitz 2 heart block, the problem lies at point number D, that is at the level of the bundle of his in the patient. The problem lies at the level of bundle of his. Hit the comment button, guys. I think some guys have already started doing the talking. Where is the lesion present? It is infranodal. अगर you are following me at this moment, you are sorted for the topic. If you have understood the word intra and infranodal, if you understood the word infra and intranodal, you are sorted for this topic. Mobitz 1 and Mobitz 2 heart block, what are you supposed to know as a doctor is, if the problem occurs in the AV node, it is Mobitz 1 heart block. If the problem occurs below the AV node, it is Mobitz 2 heart block. Both of them together is called as second degree heart block. Both of them are called as second degree heart block. If the problem is in the AV node, it is Mobitz 1. If problem is below the AV node, it is Mobitz 2 heart block. And why in Mobius to hard block the PR interval is normal is because of the fact that PR interval is from point number A to point number C, guys. It is from point number A, that is from the SA node, to the exit from the AV node. PR interval ECG में कहाँ से कहाँ तक होता है? It is from the SA node to exit from the AV node. Problem उसके नीचे है ना, because the problem is below the level. That is why we call it a infranodal conduction defect. So at this moment, like Mobitz 1 and Mobitz 2 will be a piece of cake for you. Now obviously Inisat being Inisat, वो तो थोड़ा सा तो यार harassment करते हैं. After the paper, like I was speaking to my students, so couple of guys said, sir, Mobitz to hard block आया था because PR interval before and after the missed beat was missing. Like what this guy did was, उसने कहा कि sir ऐसे ये I could pick up, this is a T, this is a P. You can pick the T and the P separately. Height is different, na? T is 5 millimeter, P is 2.5 millimeter only. There is a missed beat that is present, and if you check out the PR interval after and before, they look almost equal in size. So he said, sir, Mobitz 2 आया था. I said, fine man, मतलब I wasn't aware कि भाई what was the actual ECG looking at. Now one of the guys, he said कि boss, there was a different pattern. तो मैंने कहा यार बता, what was the different pattern? He said, look at the markings I'll do here. He said, I could see this is normal, na? PQRST is there, so this is normal sinus rhythm. Then there is a non-conducted P wave. This is a non-conducted P wave because P के बाद में QRS complex is not coming, so I'm saying non-conducted P wave. Then check it out again. This is normal sinus rhythm. This is NSR, normal sinus rhythm, followed by a non-conducted P wave again. One guy was able to pick up the fact that this is not Mobitz 2 heart block. It is a differential diagnosis of Mobitz 2 heart block where there is a non-conducted P wave, conducted P wave. What blue वाला जो दिखाया है उसको मैं conducted बोल रहा हूँ because P is followed by QRS. P के बाद में QRS आ रहा है उसको बोलते हैं conducted P wave. After P there is no Q wave present, so there is like non-conducted P wave is the word here. This is a differential diagnosis, guys, and this differential diagnosis that I've currently highlighted is a different. This is a differential diagnosis of Mobitz 2 heart block and is called as 2:1 block. So that's the main problem with Inisat, that they do like जैसे scuba diving होता है, they tend to get a little more, in scuba diving if you've done the first time, you suddenly have to hold your breath underwater. It becomes a very very challenging aspect with that helmet on. They close their nose also, नाक से सांस ले नहीं सकते, they put a helmet on and you are like suddenly on your own and you are thinking कि भाई अब क्या होने वाला है. तो it's like 2:1 block is like, when you have studied regarding Mobitz 1 and Mobitz 2, Shashi, you had a very good point there. Normal miss, perfectly on. I mean, you can see normal conduction, poor conduction. P के बाद QRS नहीं आया. Normal, poor conduction. Alternative में चल रहा है, तो that is what we call as a 2:1 block here. And what I'm gonna do next before you is, I am gonna draw the 3 ECGs again. I'll take under 2 minutes to do that activity. Humble request, try to do this with me. बना लेना, जगह है पेज नंबर 20 पे. So we can do this activity. आपने करना सिर्फ इतना ही है, keep on increasing the duration of PR interval in the first one. Increase the duration of the PR interval further. Increase the duration of the PR interval further. This is the first time PR interval. This is the second time. This is the third time. The moment you pick this up, guys, you know that you are dealing with Mobitz on heart block, where is 2:1 block. Again, the problem is in the bundle of phase, but the bundle of phase is sometimes conducting, sometimes not conducting. Prince said, where is the problem in Mobitz to heart block? I said, na, 2:1 block is a differential diagnosis of bundle of phase. So it is a problem in the bundle of phase only. Why the difference is, suppose I say bundle of phase sometimes allows conduction, jao, and sometimes does not allow conduction. Alternatively, then it's gonna be 2:1. Whereas superiorly अब देखो conduction drop. ऐसे समझ लो स्ट्रेट ऑफ होर्मुज पे ईरान वाले ने बोला 3 शिप को जाने दूंगा, ब्रेक लगा दी. 4 शिप को जाने दिया, ब्लॉक लगा दी. ट्रंप आया, कहता है सिर्फ यूएस की शिप जाएगी, बाकी सबको रोक दूंगा. सिर्फ यूएस की शिप जाएगी, बाकी सबको रोक दूंगा. Iran is friends with India, Iran is friends with Pakistan, Iran is friends with China. So Iran ने बोला Strait of Hormuz पे 3 ships gone, then किसी फ्रांस की शिप को रोक दिया. 4 ships gone, 1 शिप को रोक दिया. 10 ships gone, 1 को रोक दिया. Strait of Hormuz पे Iran is controlling the Strait of Hormuz. 4 शिप जाने दिया, 5 जाने दिया, 1 को रोक दिया. That is Mobitz to heart block. ट्रंप आया, कहता है सिर्फ अमेरिकन शिप जाएगा. बाकी किसी को नहीं जाने दूंगा, ओनली अमेरिकन चिप जाएगा, बाकी कोई नहीं जाने दूंगा. दैट इज गोना बी अ सिनेरियो दैट वी विल से इज लाइक अ 2:1 block. I tried to explain with the geopolitics part. Okay, whatever, like let's not get into what Modi ji is doing for the country or not at the moment. The main objective is to understand that Mobit's 1 hard block has been highlighted here, guys, with a drop, just prolongation of the PR interval. In Mobit's 2 hard block in a patient, the PR interval will be normal. This is the, I would say, the number one reason why people tend to, lose patience. And what I'm saying is you don't need to lose patience because ये normal था. And then there is a drop that is happening in a patient. And then conduction, no conduction. Conduction, no conduction. Again a conduction and a no conduction. If you check out the pattern here once again, I'll mark it here. This is the conduction I was talking about. Conduction talking about the blues. And the yellows are the non-conducted P waves. That is 2:1 block. I've tried to hand draw the manifestations at this particular right. यार देखो वॉर रखवाना किसी के बस की बात नहीं होती है. किसी ने कभी भी कोई वॉर थोड़ी ना रखवा सकता है यार, वो तो कहना मुश्किल होता ना. चलो अभी लेट्स नॉट गेट इनटू लाइक वॉर. इट्स बियॉन्ड इंडिया यार. हमारी पॉपुलेशन इतनी ज़्यादा है ना, कि हमारी इंटरनल प्रॉब्लम्स इतनी ज़्यादा है कि हम जियो पॉलिटिक्स में फंस ही नहीं सकते यार. वी आर इन दैट फेज वेयर either we will grow or we will finish, right? So we are in that phase where we have to consolidate. That's the most important thing. War will finish us off, sir. Last year we fought with Pakistan, na? 5 days में सर वी गॉट डिप्लीटेड वेरी सिग्निफिकेंटली. वो तो बाय चांस है कि अब ब्रह्मोस हिट दैट नूर वाला जो बेस था उनका, तो वहाँ पे कमांड सेंटर था वो न्यूक्लियर वाला, तो दे गॉट अ लिटल फ्लमक्स्ड एंड दे डिसाइडेड टू सेटल आउट थिंग्स विद अस. Otherwise things will turn bad, sir. And it's not that we are sitting in Delhi or we are sitting in the border areas of Punjab and Kashmir that problems will occur. Next time they'll hit Bangalore, they'll hit Chennai. We have to be mentally prepared for it, right? So this is war, right? चलो अभी तो फोकस करते हैं, काम पे फोकस करते हैं. Okay. Yeah, we hit the Noor Khan base pretty bad, na? The nuclear command center. I think you noticed, na, 11th of May, 12th of May, 13th of May, there were earthquakes in Pakistan, 3 consecutive days, 3.4, 3.5 Richter scale. They were all because the nuclear weapons got hit, na? So they had to do controlled explosions below the mountain. The Central Command America flew jets into Pakistan, sir. The Central Command took care of the damaged, the weapon systems that were damaged. They were unassembled nuclear weapons, obviously not assembled ones, but they had to do a controlled nuclear explosion to get rid of the damaged nuclear weapons. Otherwise, it would have resulted in a radiation leak, which is again something which is like issue there. Okay, 2:1. Okay, Rajat, we'll do it again. 2:1 block is, आप देखो यहाँ पे, this is normal conduction, NSR, normal sinus rhythm. P wave नीचे जा नहीं पा रही ना. बंडल ऑफिस कहता है नहीं जाने दूंगा, कुछ भी कर ले नहीं जाने दूंगा. फिर कहता है चल यार, let me do so, I am friends with you, let me go, let me allow you to go. Then again उसका फिर मूड बिगड़ गया, कह रहे नहीं जाने दूंगा. I hope I was able to get the point. Bundle of his का जो mood है, it's like happy, sad, happy, sad. So when he's sad, he doesn't allow a conduction. When he's happy, he allows conduction. In Mobit's 2 hard block, the mental status of bundle of his is happy, 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 sad. Happy, 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 sad. I hope you get the concept. Happy, sad, alternatively. That is 2:1. Happy, 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 sad. Happy, 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 sad. That's like that's gonna be, yeah, bipolar, right? Priyesh said it rightly, the bipolar word. So anyway, guys, yeah, like Trump, right? I mean, the guy is crazy, man, crazy. I mean, you send your army to pick up president of a country, and you bring him to prison in your country, and then you humiliate him in New York. I mean, like, movies में सुना था ऐसे होता है, अभी तो देख लिया भाई, है ना? Like this is the most happening decade of the entire century. I mean, you are the Ukraine war, then you saw I mean, your generation though, your generation is the most, I would say, मतलब सबसे डायनामिक्स तुम ही ने देखे.
पहले देखा तुमने कोविड, फिर देखा रशिया यूक्रेन वॉर, देन यू सॉ इंडिया पाकिस्तान, यू सेइंग ईरान वाला, मतलब अर्लियर यस उमा इट्स infrarednal, so infrarednal, it is also infrarednal, so it is like you guys, your generation has been, तुम तो अपने बच्चों को बताओगे, you are gonna tell your kids, पता है ऐसे हुआ था, उस ईयर में ये हुआ था, next 4 years this, so this has been the most happening decade, man. Yeah, you study with war, that's the most important thing. Okay guys, so now we talk about third degree heart block. Okay. World Cup cricket fans also here. So third degree heart block at the moment. Okay.
Let's look at third degree heart block, guys. This is an old man and he's having postural hypotension. This old man, he went to the bathroom.
After using the toilet seat, when he stood up, तो उसे चक्कर आ गया, वो गिर गया और वो unconscious हो गया. He got up and he became unconscious. He got out from the bed. He suddenly stood up. He became unconscious. So many times in you and me also, no, when we suddenly change our position, थोड़ा हल्का सा चक्कर सा आता है, you know, for a fraction of a second you will feel like, you know, you're dizzy and then you are perfectly fine. But in this case, there is a postural hypotension in the patient. So now comes the aspect. What's going to happen in a patient of complete third degree heart block is, AV node will be saying, I will not allow any conduction. I will not allow any conduction. So if there is no conduction happening, the SN node will be able to control the atria and bundle of His will be able to control the ventricles. The atrial rate of the patient will be 100 per minute. Bundle of His max firing rate is 40 per minute. Once again, I have introduced the concept of AV dissociation before you. AV dissociation would mean that atrial and ventricular rate will be at a totally different frequency. So one way to solve the question would be, yes, Tevani, you have done a great job by mentioning the datas here as well. And meanwhile, and good you wrote it, you know, that's a good way to learn. That's a very good way to run. When you type, that means your thought process is great. So I like the spirit, you know. Okay, AV dissociation is once again highlighted. Third degree heart block is no conduction. When I describe like this, the query of lot of doctors is, sir, you said AV node is defective in Mobert's 1 heart block. By Mobert's 1 heart block, I said the word slow conduction. In Mobert's 1 heart block, I said the word slow conduction. Now, am I saying the word slow conduction? No, I am saying the word no conduction with respect to third degree heart block in a patient. So this is AV dissociation once again, but from the perspective of bradycardia. This question, when it was asked in FMG exam, it was super easy. वो खुद बोला, number of P waves and R waves is unequal. SA node will decide how many P waves will be coming, which will be 100. And bundle of His will be deciding how many R waves would be coming, that is 40. In FMG exam, he did not give the ECG. वो खुद बोला, old man comes with complaints of postural, complaints of orthostatic hypotension. And the number of P waves and R waves is not matching. What is the defect present? Answer is third degree heart block. In NEET PG, he gave the ECG, which is in front of you. But before I focus on that ECG, what I will do in this particular patient is, that is again an FMG exam question. Na? Yes, RR interval remains constant. At this moment, what I have done at the moment is, when you look at the ECG of a normal person, first this is for NEET PG aspirants. If you are an FMG aspirant, all you need to remember is number of P waves will not match with R, third degree heart block. If you are a NEET PG aspirant, you need to get the ECG hang of it. Very simple again, under 1 minute you can solve it, less than that. First count the number of squares between R and R. Suppose 4 large squares are present. So you will say that, sir, the heart rate of the patient is 300 divided by 4. That means the ventricular rate of the patient is 75 beats per minute. At this moment, I am describing normal ventricular rate of you and me while we are sitting on a chair. Now suppose I say to you, doctor, can you tell me what is your atrial rate? You will say, yes, sir, I can tell you what is my atrial rate by comparing the number of boxes between the R and the R. PP interval is 300 divided by 4 once again, that is 75 beats per minute. In you and me, the atrial rate and ventricular rate will always match. The atrial rate and the ventricular rate will always match.
Now I will hand draw the ECG of third degree heart block in this patient. The aspect in this patient to be understood is that number of P waves will not match with the number of the R waves. This is P followed by P. Why? Because atrial rate is 100, 2.5 times faster than the ventricle. So it is P followed by P. Then is going to be a broad QRS complex. Maybe a T may be positive or negative. And again you will get a P followed by P. Normally after P you don't get a P. Here you will get more number of P waves as compared to the number of the QRS complexes. If I highlight the ECG which is currently hand drawn before you, I want to say that the number of P's are much more as compared to the number of R's that are shown in this particular case. Another way to solve the question is check out the number of boxes between P and P and check out the huge gap between the R and the R that I am doing at the moment. The disparity between the PP and the RR is telling you that the atrial rate and the ventricular rate will not be matching. ECG between 2:1 and 3 is 3 has more than one QRS complex. No. 2:1 can get converted into a third degree heart block in a patient, but yeah, in a third degree heart block, the most important thing is that the number of P's and R will not match. You know, there it was like P which is non-conducted and one was a conducted P wave. Here so there are more number of P waves. Yeah, okay. So another way of understanding is Ashutosh, you have a point there. The point is the number of P's here will be non-conducted P waves will be more. Exactly. I get your point. The number of non-conducted P waves will be significantly more in 2:1 block as compared to conversion to third degree. So that's the conversion that we see in clinical practice. The 2:1 block patients evolve into a Stokes-Adam or a third degree heart block. Good point, Ashutosh. There is a complete lack of coordination is a much more better way, but yeah, I can say more non-conducted P waves as compared to the conducted P waves in a patient. Now, if you look at the actual ECG, you can see a P, again a P, again a P. I mean, it's literally going crazy. I mean, I expect it should be R complexes, R waves that should be coming, and this person's ECG is showing a very peculiar pattern. That's the number of P's is exceeding. You can see a T here also. I mean, this deflection that I marked is the T wave. So it's literally like a divorce between the atria and the ventricles. Normally atria and ventricles are like husband wife, they match each other's frequency and they go at the same rate. Both husband wife have to have the same vibes when they want to grow as a family. But if husband and wife are having a divorce and both will go their own way, then obviously, like, you know, there would be no matching of frequency and the family will break apart. And the same thing is what is happening in this condition also. The P and the R is not matching in this particular patient, and therefore third degree heart block has manifested. Okay, so third degree heart block that I have currently highlighted, the alternative name for this is Stokes-Adam. The other name for this is complete heart block. If you say one word hack to solve this question, one word hack is check out the frog sign given in this question of Brady. If you say frog sign is not given, you will have to rely on the unequal number of P. The last one is T overlapping the P. Yeah, absolutely, yes. Immediately after TP happened, no? Like where the blue arrow is present, that is the T. And then is a P that is occurring immediately after that. The P is shown in purple here. So it's a P that is happening and is occurring more frequently. So atria is firing almost 4 times faster as compared to the ventricles in the patient. So yep, exactly. So what are we going to do in this particular case where atria and ventricles are not coordinating with each other? We will say both of them to shut up. We will now put a computer in the chest and the computer will now be deciding the firing of the heart of a patient. We will be telling the patient's SNOD and bundle of phase, both of you are making a mess of the situation. Both of you are like doing your own thing. Both of you please shut up. And now it is the computer that will be doing the talking here. What I mean by the computer doing the talking is that we will use the inhibition mode and we will go for a dual chamber pacing. This is again a question of your exam, dual chamber pacemaker or dual chamber pacing. Dual chamber pacing is used for management of which of the following conditions? Your answer would be dual chamber pacing. Just give me a sec. The question says dual chamber pacing would be used in management of which of the following situations? Then you will say dual chamber pacing is used for management of third degree heart block, that is a complete heart block in a patient. So what I've tried to highlight at the moment is the bradyarrhythmias component at this moment in front of you. That was the typical brady component that I've highlighted. Yep, that is complete heart block. Okay. So as far as the summary of ECG findings is concerned, I think I will do it a little later. Since we have been talking about ECG only, what I want to do is just take a breather from the electrical activity, and I'll move down my slide. Like I'll come back to the ECG component just to take it easy so that you guys can adapt to the things, because if I continue talking about electrical activity, it tends to overwhelm the mind. So I would like to put an intermittent break in the electrical activity and talk about mechanical activities at the moment. And my question to you guys is, you can turn to page number 29 going on to 30. The scenario is that of heart failure. Because we are towards the end, so I want to just put a breather between the electrical activity and introduce some mechanical activity at the moment. So my patient is having hypertensive crisis. I think everybody knows the fact that hypertensive crisis is a terminology which is used when the BP of the patient is more than 180 by 120 and there is a evidence of target organ damage in a patient. So considering that hypertensive crisis is causing damage to the heart and there is a pulmonary edema, प्रेप में कौन से क्वेश्चन करने हैं बेटा? आपने ना कार्डियोवैस्कुलर सिस्टम में जाना है और कार्डियोवैस्कुलर सिस्टम में जाकर टॉपिक वाइज जो कार्डियोलॉजी के जितने भी क्वेश्चंस है ना, आप मेडिसिन खोलना, मेडिसिन में क्यू बैंक में जाना और मेडिसिन के जितने भी टॉपिक्स के क्वेश्चन है ना सारे कर देना, है ना. अगर आप FMG स्टूडेंट है, FMG सॉल्यूशंस किताब है उससे कर लेना. किताब नहीं है तो प्रेप लेटर में जाके जितने भी कार्डियोलॉजी क्वेश्चन है सारे कर लेना. गलत हो तो उसको लिख लेना एक लाइन में, सही हो जाए बहुत अच्छी बात है. हर बारी धीरे धीरे ना स्ट्राइक रेट बढ़ता है. पहली बार करोगे ECG में, ECG वाला क्वेश्चन मैं कहता हूँ स्किप मारना. स्किप मतलब क्या करना, अटेम्प्ट मत करना, सीधा उसकी एक्सप्लेनेशन पढ़ो, पहले देखो मैंने क्या बताया, और उसके बाद में जब सेकंड टाइम करोगे ना, आज से मैं भी 10 दिन का 15 दिन बाद, तो तुम्हारा आइज जो है सही की तरफ जाना शुरू हो जाएगी. बट आज क्या करना है, कार्डियोवैस्कुलर सिस्टम के क्वेश्चन उठा के लगाने हैं, चाहे वो गलत हो सही हो, उससे फर्क नहीं पड़ता. हिम्मत वो होती है, लाइन से 5 क्वेश्चन गलत हो गए तब भी तुम छठा सही करके आ रहे हो, छोड़ना नहीं है बीच में. आप बैठे हो तो अगर आपने 1 घंटे में 30 क्वेश्चन करने हैं, 40 करने हैं या 20 करने हैं, जितने भी करने हैं, आपकी स्पीड है वो आपके ऊपर है. बट आपको क्वेश्चंस करने हैं, रोज करने हैं, और आप धीरे धीरे अपनी स्पीड बढ़ाओगे. 50 से शुरू करना, 100 तक चले जाएंगे. अगर आप FMG स्टूडेंट हो, इनीसेट विनीसेट टैग मत यूज करना, ठीक है. बहुत सारे लोग बोलते हैं इनीसेट कर लो, ये कर लो, भाई पहले FMG वाले कर लेना. अगर आप नीट PG एस्पिरेंट हो, इनीसेट एस्पिरेंट हो, तो आपको सारे एग्जाम के क्वेश्चन करने हैं, क्योंकि क्वेश्चंस जो होते हैं आपके लिए तो देखो कोई छूट नहीं है. सो आई मीन दैट्स एन एडवाइस व्हिच आई वांटेड टू से. नहीं पहले क्वेश्चन बैंक करना है ना बेटा. PYQs तो हो ही जाएंगे, रैपिड क्वेश्चन नहीं यार. मैं करता हूँ, मैं ऐप में 1 मिनट मैं बताता हूँ तुम्हारे को कहाँ जाना है. मैं ना इससे हट रहा हूँ, चैट से. आई जस्ट कम बैक, लेट मी डू दिस एक्टिविटी. मैं ना आगे आज का जो PDF आएगा उसमें, चलो मैं लेट मी डू दिस, राइट, लेट मी डू दिस एक्टिविटी विद यू. सो आई गो इनटू द वीडियोस पार्ट, क्यू बैंक पार्ट, एंड देन आई गो टू फाइनल प्रॉफ मेजर, देन आई गो इनटू मेडिसिन. There are 90 modules that are present: heart sound, murmurs, Brugada, ECG abnormalities, ECG and arrhythmias, ischemic heart disease. जितने कर सकते हो कर दो ना यार, दिख रहे हैं ना 1 2 3 4 जितने भी हैं, वेल्वुलर वाले, हाइपरटेंशन वाले, कार्डियोमायोपैथी वाले. प्रीवियस ईयर क्वेश्चन 148 लिखा तो है, प्रीवियस ईयर क्वेश्चन 148, तो ये तो कर लो यार आज. In the cardiology section, when I'm going back, start the Q bank, it says 148 PYQs are present. तो आज 148 आप सिर्फ पेपर कॉपी में 1 2 3 4 1 2 3 4 में लिख के 1 लाइन एक्सप्लेनेशन तो कर लो यार. अगर 1 मिनट भी लगाओगे तो 148 करने में 150 मिनट्स, मतलब इट्स गोना टेक अ बिग चंक ऑफ योर टाइम. एंड सम ऑफ देम विल गो राइट, सम ऑफ देम विल गो रॉन्ग, डजंट मैटर. फर्स्ट टाइम व्हेन यू आर डूइंग, वेदर राइट और रॉन्ग डजंट मैटर, इट इज लर्निंग, इट इज डेटा चर्निंग एट द मोमेंट. सो होमवर्क फॉर ऑल ऑफ यू, you go to, I'll say this again in case you missed it. Click on the Q bank. When you go into the click bank, click on the medicine part. When you click on the medicine part, at item number 10, previous year questions 148 is what I can see. Do those 148, come back to me tomorrow again, obviously they will not be, you know, they are like, obviously they would be questions which are gonna put a lot of pressure on your mind कि यार ये भी पढ़ना पड़ेगा, अच्छा ये भी आ जाता है, तो doesn't matter यार, कोई फर्क नहीं पड़ता, like you know, our brain has to program itself to be able to adapt to any kind of a situation. जैसे पहला क्वेश्चन ही देख रहा हूँ ना, अल्कोहलिक पेशेंट विद पैल्पिटेशन इरेगुलर पल्स, तो यार ये तो एब्सेंट एवे भी हो जाएगा ना, 67% गॉट इट करेक्ट. तो इसमें क्या मतलब, ये तो आई थिंक this is a very primitive thing, guys. I think I've given you homework and for today. चलो जी, तो अब आपने क्या करना है guys, आपने मुझे ड्रग ऑफ चॉइस बताना है पल्मोनरी एडीमा का फॉर हाइपरटेंसिव क्राइसिस. वेटिंग फॉर आंसर्स गाइस. ड्रग ऑफ चॉइस फॉर मैनेजमेंट ऑफ pulmonary edema. Drug of choice for management of pulmonary edema ड्यू टू acute यार ऑप्शंस देने की जरूरत वैसे मुझे पढ़नी नहीं चाहिए इस पर्टिकुलर सिनेरियो में. The drug of choice for management of acute pulmonary edema due to hypertensive crisis, you know, the BP shoot up to 200/100 and that's why like the person is having a target organ damage. So the drug of choice in this particular condition will be answered as nitroglycerin, that is NTG drip would be used. In the MCQ options would be like nicardipine, sodium nitroprusside, nimodipine can also be given, nitroglycerin can also be given. So I hope everybody was able to figure out that this is a cardiovascular situation, and for cardiovascular situation in the question, the main thing that you will be giving is nitroglycerin. Why? Because it will treat the pulmonary edema. It will reduce the preload in the heart and thereby treat the pulmonary edema. And the second advantage will be कि nitroglycerin क्या करने वाली है? Nitroglycerin will also be able to control the high blood pressure because it is a vasodilator. It will be nitrates, na? So the nitrates would be working in this case. For management of this patient, the algorithm that we'll be using is LMNOP. It is Lasix, morphine, nitrates, oxygen and positioning. It is LMNOP, Lasix, nitrates, morphine, oxygen and positioning is the main thing that we'll be using for management of this patient. Lasix would be furosemide, that would be a diuretic. Morphine क्यों देंगे? Can you tell me the reason for giving morphine? Nitrates I've told you, it will reduce the preload in the patient. It will be a vasodilator that will be used. So okay, most of the answers came as furosemide. No sir, the drug of choice is not Lasix. Drug of choice is not Lasix. Drug of choice, if he says is nitroglycerin, yeah, it is not given for pain. Yeah, pain to hai nahi na, there is no chest pain which is present in this patient. So Lasix is furosemide, we will be used. This is not the drug of choice, guys. If a person is having acute pulmonary edema, I'll say this once again, I was struggling with the chart for a while. If he says what is the drug of choice for acute pulmonary edema due to hypertensive crisis, then your answer would be nitroglycerin drip is the drug of choice. This has been asked in the exam as like a 70-year-old man comes with hypertensive crisis, is having a bat-wing pulmonary edema. What is the drug of choice? Answer is nitroglycerin drip. That's the answer for that question of DOC. Then is the mnemonic LMNOP, Lasix, morphine, nitroglycerin that would be used, and then we will give oxygen to the patient. Please hit the comment button and let me know how will you give oxygen to the patient. Yes guys, how will you give oxygen to the patient? Morphine decreases preload also, perfectly fine. Main action is vagotonic. मॉर्फिन जो होता है वो हार्ट की ऑक्सीजन कंजम्पशन कम करता है गाइस. रीजन व्हाई मॉर्फिन इज यूज्ड इज नॉट दैट इट इज अ पेन किलर, इट इज बिकॉज इट इज गोना कंजर्व ऑक्सीजन. फर्स्ट लाइन ट्रीटमेंट, हाँ फर्स्ट लाइन ट्रीटमेंट फुरोजेमाइड ना, फर्स्ट लाइन तो फुरोजेमाइड ही देते हैं, राइट, दैट इज ओके. इफ इट इज फर्स्ट लाइन वी विल बी गिविंग first line, then it is furosemide. But if he says drug of choice, then it is anti-G drip. Yes, Nadeem was the first one to hit the right answer. We will not be using a face mask. We will not be using a venti mask. We will not be using a non-rebreather mask. We will be using a tight-fitting face mask. This is a must-know for you guys that for acute pulmonary edema, you need to use the BiPAP machine. You'll ask your nurse, ask the technician to get the BiPAP machine, and it is non-invasive ventilation that you'll be using. Saurav, perfectly right. Shashi, Ashok, perfect. Like that's the correct answer. And then obviously LMNOP, the P would stand for positioning, which means that you can adjust the hospital bed position so that the legs should be at a lower level as compared to the heart. That is to reduce the preload and give a little bit of rest to the heart also. So it is non-invasive ventilation, which is the correct answer that you will be using for management. This is acute congestive heart failure. Basically, like what I wanted to say was this entire description that I've given is written as AHF, that is called as acute heart failure. This entire description that I've given before you at the moment is called as AHF, that is acute heart failure, and it can occur due to high blood pressure. One of the leading causes of acute heart failure happens to be hypertensive crisis. One of the leading causes of acute heart failure can be hypertensive crisis in a patient. But I will now change my question to that on another cause of acute heart failure which will result in cardiogenic shock in a patient. Can you tell me what is the difference between cardiogenic shock and heart failure? In both of them there is pulmonary edema. In both of them the B-type natriuretic peptide can be elevated. My question to you guys is, since you studied pharmacology, in patients of cardiogenic shock also there will be heart failure findings in a patient. AHF stands for acute heart failure. Nowadays we don't use the word acute decompensated congestive heart failure. They simply use the word AHF, CHF, acute heart failure, chronic heart failure. What will be the difference in the patient? Yeah, BP will crash. So that's okay. BP can crash in a person who's having anytime left ventricle failure will also cause crashing of BP, na? If a person is having acute heart failure / left ventricle failure, then it will subsequently falling of blood pressure. Like initially the BP was very high, now the heart will fail, so BP will crash. Yes, the main difference will be that there would be acute kidney injury findings developing in a patient if you get a question in which the combo of the two are given. If he gives you a question in which acute heart failure findings are also given and acute kidney injury findings are also given, what I mean by acute kidney injury finding is that there would be rise of serum creatinine 1.5 to 1.9 times of normal, urine output decreasing by 50% of the normal. If they give you a question in which a combination of heart failure finding and acute kidney injury findings are present, you will say you are dealing with cardiogenic shock. Very good, Nadeem, you were spot on in that. Neeraj, you were spot on in that, but yeah, slight modification for you. It's not hypoperfusion alone, it is hypoperfusion of specifically the renal circulation, which would be a technically appropriate answer, causing a decreased urine output. Great. So now I want to ask from all of you, what is the preferred vasopressor for cardiogenic shock? Options are dopamine, dobutamine, norepinephrine. What is the preferred vasopressor of choice for management of patients? What is the preferred vasopressor of choice for management of cardiogenic shock? Is it dopamine? Is it dobutamine? Is it norepinephrine? I want everybody to hit the comment button for this one. Yes, guys. Dopamine, dobutamine. Okay, continue. Yes, we don't use dobutamine, guys. This is one question that should never ever go wrong. If you have worked in the hospital, you would be noticing what are we using? We are giving NORAD, man. We are using norepinephrine. The main vasopressor of choice for management of cardiogenic shock is norepinephrine. Why the answer is not dobutamine is because dobutamine has a alpha blocking activity as well, and that can worsen the hypotension of the patient. Dobutamine कैसे काम करता है? It will cause stimulation of beta 1. But it will block alpha. If you block alpha, it can cause a drop in blood pressure. So dobutamine is not used if the systolic BP is less than 100 millimeters of mercury. The answer is NORAD. No बच्चे, dopamine नहीं, आजकल use नहीं करते हैं dopamine. It is pro-arrhythmogenic drug. The current edition of the textbook says dopamine नहीं देना है. If I was teaching you 5 years ago, I would have said dopamine, dobutamine, norepinephrine. First answer dopamine. If I was teaching you 5 years ago and I asked you this question on cardiogenic shock, dopamine would be the winner. But at this moment, 2026, if you have worked in the hospital, a lot of you who have completed your internship, sitting for NEET, PG, etc. आपके हॉस्पिटल में नर्स या डॉक्टर मेन वर्ड क्या बोल रहे थे? नोरैड चल रहा है, नोरैड चल रहा है. दैट नोरैड इज बेसिकली नॉरएपिनेफ्रिन. यस, दीज आर आइनोट्रोप्स ना बच्चे. सो आइनोट्रोप्स आर द वंस वी आर यूजिंग. डोपामिन इज प्रो-एरिथमोजेनिक. द करंट एडिशन ऑफ हैरिसन सेज डोपामिन यूज नहीं करना है. मॉडरेट डोज तो छोड़ो, लो डोज में भी नहीं देना. वो बोलता है रिसोर्स लिमिटेड सेटिंग्स की बात अलग है कि जब सुविधा नहीं है, क्योंकि एवरीथिंग इज कंपेयर्ड फॉर बेनिफिट, मोर्टालिटी बेनिफिट. So good that we had this discussion. As of now, I hope it's clear to everybody. Dopamine is not recommended. It is NORAD that is required. Norepinephrine will be answered to 2 questions: septic shock, cardiogenic shock. Septic shock, cardiogenic shock. The preferred vasopressor of choice should be answered as norepinephrine. I will give you rationale also. A lot of students, they are like कि नहीं सर ऐसे कैसे हो गया. Norepinephrine क्या करता है? वो डायस्टोलिक बीपी बढ़ाता है. और डायस्टोलिक बीपी बढ़ाने से क्या होता है? कॉर्नरी ब्लड फ्लो बढ़ जाता है, क्योंकि कार्डियोजेनिक शॉक का कॉज क्या है? हार्ट इज गेटिंग लेस ऑक्सीजन. इफ यू विल इंक्रीज द कॉर्नरी ब्लड फ्लो. आई एम नॉट यूजिंग नॉरएपिनेफ्रिन टू इंक्रीज द सिस्टोलिक ब्लड प्रेशर. सर आई एम गिविंग नॉरएपिनेफ्रिन. मैं क्यों पेशेंट को नॉरएपिनेफ्रिन दे रहा हूं? बिकॉज व्हाट आई वांट टू डू इज आई वांट टू इंक्रीज द कॉर्नरी ब्लड फ्लो. It increases the diastolic blood pressure. You all know from physiology कि diastolic blood pressure जो होता है, that is mainly, when do you have coronary blood flow maximum? During diastole. So it is NORAD that is used for this patient. हम systolic नहीं बढ़ाएंगे. डोपामिन क्या करता है? डोपामिन के साथ दिक्कत क्या है? Why dopamine went out of of our preferences? Dopamine mainly increases the systolic blood pressure. Dopamine mainly increases systolic blood pressure, and if I increase the it will increase diastolic also, but predominantly systolic blood pressure, so it will put more load on the heart in the patient. Exactly, Ashok. The good thing is I wanna improve the fuel supply. अगर ईरान से हमारे पास में तेल आता रहेगा और साथ साथ में हम सोलर पावर को यूज करते रहेंगे, तो हमारे देश की एफिशिएंसी इंप्रूव हो जाएगी. ईरान इज गिविंग अस 20% ऑफ द फ्यूल रेगुलरली, और साथ साथ में हम सोलर एनर्जी को भी यूज करेंगे, तो वी विल बिकम अ एनर्जी एफिशिएंट नेशन. सिमिलर एग्जांपल हियर, इफ द फ्यूल इज कमिंग एंड वी इंप्रूव अवर एफिशिएंसी, इट्स गोटा बी बेनिफिशियल फॉर अस. एग्जैक्टली. मूविंग अहेड इन आवर डिस्कशन, these concepts guys have to be 100% correct, and there should be 0% errors here. Now I come to I would say the most important question for today, because you have already studied pharmacology. So I am having a patient who's having heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction, that means the ejection fraction of the heart is less than 40%. In simple English, it's a chronic heart failure patient with the ejection fraction less than 40%. Please let me know the major mortality reducing agent. NORAD, NORAD is norepinephrine only. In septic shock with oliguria, should we use low dose dopa, or still should be using NORAD? No, it is NORAD only बच्चे. It is NORAD only, norepinephrine that is used. वो पुराना डेटा हो गया ना, पिछले हैरिसन में ऐसे लिखा होता है ना. मुझे पता है, अंकित सर ने बताया है कि लो यूरिन आउटपुट इन कार्डियोजेनिक शॉक, डोपामिन बोल देना है ना, बट द करंट एडिशन सेज कि आपको सीधा NORAD यूज करना है. इवन इन सेप्टिक शॉक विद लो कार्डियक आउटपुट, इट इज NORAD. आप हॉस्पिटल में जाके देखो यार, आजकल सबको सेप्टिक शॉक में NORAD ही चल रहा होता है. मेजर मोर्टालिटी रिड्यूसिंग एजेंट इन कंजेस्टिव हार्ट फेलियर. Okay, first opportunity, first right of speaking, all FMG students, if you're listening to me, hit the comment button right now. What is the major mortality? No, bache, no, it's not digoxin. It's gonna increase the oxygen consumption of the heart. It's gonna increase the fuel consumption. We wanna conserve fuel. No, bache, it's not digoxin. Okay, yes. Fine. Now, NEET PG students, hit the comment button. Quickly, guys. What is the... I am getting dots and follows there. Beta blocker. Okay. Major mortality reducing drug in the patient. Okay, Pranav has answered a good one. There was one more person who has answered a good one. Okay, Govind, you are close. I will close the poll in 5 minutes, 5 seconds. Okay. यार ये वर्ड कभी भी नहीं भूलना है आपको, याद कर लो. आर्नी. Yes, perfect, spot on. All of you know the answer. You just had to be like, proactive in answering it, irrespective of whichever exam you're sitting on. When chronic heart failure, when you will shift the patient out of coronary care unit into the routine ward, all patients would be given ARNI, that is angiotensin receptor blocker valsartan, and along with that you will also be using nephrilysin inhibitor, that is going to be nephrilysin inhibitor is sacubitril. Both of these are the mainstay of treatments that will reduce mortality. This is the major mortality reducing drug that would be used. Yes, obviously, if in the multiple choice question that ARNI is not given, then the major mortality reducing drug is ACE inhibitors. If in the MCQ that valsartan, ARB and sacubitril combination is not given, then we will give ACE inhibitors and beta blockers. So a lot of you who were saying beta blocker, I want to say that before beta blocker, even in the older version in the app, I have taught you ACE inhibitor पहले. Beta blocker, पता किससे mix up कर रहे हो? A lot of you are mixing beta blockers with that of chronic stable angina. Guys, we're not discussing chronic stable angina here. At this moment, what we are focusing on congestive heart failure. We need to block the RAS system, because the RAS system is gonna it's gonna put a lot of stress on the heart, is what we can say at the moment. Viability, PET CT, Neeraj. Get a PET scan done. That will help you understand the cardiac viability, whether that's revascularization will be successful or not, and then we can decide that whether we should go for CABG or should we go for PCIV stenting. His ejection fraction is fairly low. I mean, ischemic cardiomyopathy se ho gaya hoga, so I don't think so they'll do a CABG. It will be risky, but stenting can be done. Okay, so PET में viability आ रहा है नहीं? अच्छा, 25% viability is there. Okay. So I think stenting is a safer option, ना? मतलब CABG थोड़ा risky भी हो जाएगा, करवाने के लिए ready भी नहीं होते हैं, तो I think it is like stenting would be required for these for him, in my opinion. Drug-eluting stenting. You can show it that Fortis Escorts, na? They have a good team there. One of my students is a cardiologist now at that place, so you can ping me. I'll send you his number, and if you want, if it's a personal relative, so ping me and you can go to him. He's working as a cardiologist there, so he'll help you out there. Chalo ji, coming back to the agenda. ACE inhibitors are going to be answered if ARNI is not in the option. So ACE inhibitor is the mortality reducing drug. Then I'll come to 2, that is beta blocker. What are those FDA approved? What are those? What is the beta blockers that are FDA approved here? So it is carvedilol. Then after carvedilol, it is metoprolol and bisoprolol. These are the major FDA approved drugs which have been again asked in the exam. Carvedilol, metoprolol and bisoprolol, that would be used. So keep talking, guys. What's the third medicines that you'll be using in these patients? That is because they would be edema component. So you will say, I will be using mineralocorticoid receptor antagonists. You will say, I will be using MRAs. That is, you will say, I will be using MRA, that is mineralocorticoid receptor antagonist, and that would be like spironolactone, or you can use eplerenone, you can use finerenone in the patient. The advantage of these drugs is that they again help in neutralizing the RAS system because they're anti-aldosterone drugs. And now comes the next drug. Yes. Somehow, guys, I was waiting for this answer that did not come. या आया भी तो मतलब शायद स्पेरिंगली मुझसे मिस हो गया होगा. आज की डेट में in your exams they are gonna be after 2 medicines, ARNI and SGLT2 inhibitor. Pharma में both of these medicines you have to literally आई मीन इसका जितना भी डेटा खा जाना, दवाई नहीं खाने को बोल रहा, आई एम नॉट आस्किंग टू ईट द मेडिसिन, आई एम आस्किंग यू टू ईट अप ऑल द डेटा रिलेटेड टू दिस ड्रग्स, बिकॉज दे लव टू आस्क रिगार्डिंग empagliflozin, they love to ask about ARNI for management of patients of chronic heart failure in a patient, because they reduce cardiovascular mortality in the patient. So SGLT2 inhibitors are used not only, they are used not only in like they are used not only in patients who are diabetic, but they are used in non-diabetic patients as well. And like, what is the advantage of this medicine is simple. I mean, you guys can help me out. Why is this medicine used in heart failure? Why will empagliflozin, yeah, side effect is UTI and mycotic genital infection. Why is it used in heart failure? It's a non-diabetic patient, na? But we are still using the medicine. So why is this medicine being used in heart failure patients? Yes, guys. It causes salt loss. The main reason why this medicine will be used is because it will help in natriuresis. It will help in salt loss from the body. It will cause a systolic blood pressure to fall only by 5 millimeter. But that systolic blood pressure fall by 5 millimeter will do wonders for the patient, because it will reduce the stress on the heart. Now I will change my data. No, not increasing urine output, bache. Not urine output, you will say natriuresis, and because it will cause salt loss. Now we have been searching for a drug that causes thoda sa systolic blood pressure fall, so this drug would be working. And now we will talk about heart failure with preserved ejection fraction. Preserved ejection fraction is where the ejection fraction of the patient is not 65%, it is more than 50% but less than 65. So it is reduced ejection fraction 40%, then is mid range 40 to 50, and more than 50 is preserved. Remember to HFrEF. If the word written is heart failure with reduced ejection fraction, the ejection fraction is less than 40%. The main drugs to be remembered is, obviously I mentioned multiple, but ARNI and SGLT2 inhibitors is what they would love to ask you. You guys can comment for heart failure with preserved ejection fraction. What is the main medicine reducing mortality? What is the main usual cause of heart failure with preserved ejection fraction is uncontrolled hypertension. It will cause a diastolic malfunction. Ejection fraction will be more than 50%. What is the major mortality reducing medicine? Major mortality reducing medicine with respect to heart failure with preserved ejection fraction. Yes, guys, you want me to give options? वही ARNI, ACE inhibitor, beta blocker, calcium channel blocker, diuretic, वही तो रहने वाला है. So what is the drug that you will be using? No, obviously not. No. Okay. Waiting. 5 seconds more and the poll will close. बच्चे ARNI, मैंने बोला ना ARNI, whether it is reduced ejection fraction, whether it is preserved ejection fraction, it really doesn't matter. ARNI is the mainstay. You block the angiotensin 2 blockers, and at the same time the angiotensin 2 receptor blocker के साथ साथ में you will be using nephrilicin inhibitor. ARB basically means angiotensin 2 का जो receptor होता है उसको आप block कर देंगे. ARNI basically means कि angiotensin 2 का जो receptor उसको block कर देंगे. Can you tell me the name of the receptor of angiotensin 2? This was asked in FMG exam. What is the name of the receptor of angiotensin 2? Yes, Nadeem, you are spot on. You have been spot on with the answers. Yes, boys and girls. I know you're tired at the end of the day. What is the name of the receptor of angiotensin 2? Okay. बोलो 5 सेकंड और दे रहा हूं. चलो, इंग्लिश मत लगाओ. इंग्लिश का पेपर थोड़ी ना एंजियोटेंसिन 2 रिसेप्टर थोड़ी ना पूछ रहा हूं तुमसे. प्रणव ने आंसर दिया 81 रिसेप्टर. देख लो चैट को. यस, इट विल ब्लॉक द 81 रिसेप्टर. कई बार क्वेश्चन इतने सिली होते हैं कि आप बोलोगे कि सर इसके लिए कोचिंग का क्या जरूरत था, खुद ही पढ़ लेते. Sometimes in the exam the paper are gonna be like so silly and so stupid that आप बोलोगे यार इसके लिए कहीं जाने का क्या जरूरत है, खुद ही पढ़ लेते. थोड़ा ध्यान से पढ़ना है. खुद से पढ़ाई ध्यान से नहीं होती है. You tend to check out your phone, chill out a bit. Yeah, the answer is AT1 receptor for angiotensin receptor blocker. Yes. Okay, ji, great. So the point is, fine. This is like cardiac emergencies which I wanted to speak in front of you. So let's do one more page, guys. One more page, and we'll quit today. Hypertensive emergency resulting in acute pulmonary edema. We will be using, as I explained to, nitroglycerin. We don't use beta blockers. We don't use beta blockers for management of acute congestive heart failure. This again is a question because tachycardia is what is keeping the patient alive. Patient's heart is beating fast to clear the pulmonary edema. ना heart में lungs में congestion हो गया, तो heart will beat very fast to clear the pulmonary edema, and now you are like putting brakes, so the person will die today. So heart failure is like I mean, like in any patient of acute heart failure, we don't give beta blockers in the patient. Okay, guys, hit the comment button. What is the drug of choice for hypertensive emergency leading to brain hemorrhage in a patient? Drug of cardiac emergency and neuro emergency will always be asked. Drug of choice for hypertensive emergency resulting in brain hemorrhage in a patient, your answer will be nicardipine. This is the calcium channel blocker that has been introduced for first time, calcium channel blocker. So cardiac and neuro, ये दोनों क्वेश्चन कभी गलत नहीं होने हैं. Whether you are an FMG student, NEET PG aspirant, cardiac emergency and neuro emergencies are always asked. Both of these are common emergencies, so the answer will go straight. Hypertensive urgency is where the BP is more than 180 by 120, but there is no target organ damage. There is no point of like rushing to reduce the blood pressure in patients of hypertensive urgency. So oral ACE inhibitors alone is sufficient for hypertensive urgency in the patient. Yeah, we can use labetalol also. That would be a second best answer in case nicardipine is not in the options. Oral ACE inhibitors would be used here. What is the management of PRESS syndrome, that is posterior reversible encephalopathy syndrome? The MCQ will always begin by mentioning visual blurring. He will say hypertension patient comes with visual blurring. Along with that, blindness can also occur. It can be binocular blindness. The person also had altered sensorium, or the person became unconscious, so neuroimaging was done. When neuroimaging will done, the MRI in this patient will be showing vasogenic cerebral edema. The patient of posterior reversible encephalopathy syndrome will be having a vasogenic cerebral edema that will be mainly involving the occipital lobes in the patient. It will be mainly involving the parietal lobes in the patient. If the occipital lobe and the parietal lobes are involved, the guy will lose consciousness, and he says, what is the drug to be used? Yes, bache, I am getting good answers there. There is a vasogenic cerebral edema, so I got Dexona also, I got nitroprusside. Mannitol नहीं देंगे बच्चे, vasogenic cerebral edema में mannitol नहीं देते, साइटोटॉक्सिक में देते. न्यूरो में बताऊंगा, बट ये तो हाइपरटेंशन की कॉम्प्लिकेशन है ना. mannitol नहीं देना है. mannitol is given in cytotoxic cerebral edema. mannitol is given in cytotoxic cerebral edema. गलती नहीं करना है. How do you lower the BP in this patient? Answer is again nicardipine. तुमको याद क्या करना है? याद क्या करना है कि चाहे ब्रेन हैमरेज हो जाए और फेशियल एसिमेट्री हो जाए, अगर हैमरेजिक स्ट्रोक होगा तो क्या लिखा होगा? हाइपरटेंशन पेशेंट प्रेजेंट्स विद face asymmetry, arm weakness, with leg weakness in a patient. So whether you get a question with a neuro emergency saying hypertensive patient का मुंह टेढ़ा हो गया with the arm weakness, leg weakness, or he says hypertension patient has become unconscious, it is nicardipine which is the mainstay of treatment in the patient. We nowadays do not be using nimodipine is used in subrectal hemorrhage यार. अभी अब subrectal hemorrhage पे तो आए ही नहीं है. Now is the aspect of malignant hypertension, जहाँ पे आप पैथो में पढ़ते हो ना, fibrinoid necrosis of blood vessels. Malignant hypertension is where you read regarding fibrinoid necrosis of blood vessels. My question to you people is, malignant hypertension कब बोलते हैं? What is the criteria for calling malignant hypertension? Obviously malignant तो कैंसर होता है ना. Your patient is educated. Malignant hyperthermia नहीं पूछा. बच्चे डैंड्रोलिन तो मैलिग्नेंट हाइपरथर्मिया में यूज करते हैं. आप देखो, अब आपको ना चीजें दिखाई दे रही हैं एट द एंड ऑफ द डे ना, व्हेन आई एम फिनिशिंग द क्लास. आप इमेजिन कर रहे हो, मैं पढ़ा रहा हूँ मैलिग्नेंट हाइपरटेंशन, आपको दिखाई दे रहा है मैलिग्नेंट हाइपरथर्मिया. विजुअल हालुसिनेशन हो रही है. ओके, चलो. हाँ, डैंड्रोलिन नहीं है बच्चे, डैंड्रोलिन इज मैलिग्नेंट हाइपरथर्मिया. वो एनेस्थीसिया की क्लास थी भाई, कल थी वो, सक्सेनाइल कोलिन, इनहेलेशनल एनेस्थेटिक, हेलोथेन, आज मेडिसिन वाली क्लास है, तुम्हें आज चीजें दिखाई दे रही हैं, आई कैन अंडरस्टैंड। हाँ जी, हाँ वेरी गुड, नीरज वाज द फर्स्ट वन टू आंसर। अगर रेटिनोपैथी है, अगर रेटिनोपैथी हो रहा है, that is when you are saying malignant hypertension, so there would be retinal bleeding that would be present, there is a retinal hemorrhage that will be described in a question। तो जैसे ही आपको क्वेश्चन आता है जिसमें रेटिनोपैथी, क्योंकि आईज की फीचर तो मैंने पहले भी बोला था, उसको ब्लाइंड हो गया था, लेकिन अगर आप क्वेश्चन पढ़ते हो जिसमें रेटिनल हेमरेज लिखा हुआ है, पैप्लेडिमा लिखा हुआ है, तो आपने malignant hypertension के बारे में सोचना है। एंड फॉर दिस malignant hypertension द ड्रग दैट विल बी यूजिंग, कोई बात नहीं बच्चे, गलतियां होती है, माई जॉब इज टू सेंसिटाइज यू टू द फैक्ट that under pressure भी आपको perform करना है, like it's the end of the day, so you're imagining malignant hyperthermia, it is malignant hypertension that is present, so the treatment in this particular patient would again be given as nicardipine। and the query is कि sir फिर sodium nitroprusside क्यों नहीं बोले, because sodium nitroprusside causes a very fast fall in blood pressure, therefore there would be under perfusion। आप एकदम से बीपी गिरा दोगे, एकदम से बीपी गिरा दोगे, तो एकदम से बीपी गिरने की वजह से देयर कैन बी अंडर परफ्यूजन ऑफ द ब्रेन। सेकंड प्रॉब्लम विद सोडियम नाइट्रोप्रोसाइड इज कि उसको लाइट प्रोटेक्टेड इन्फ्यूजन सेट से देना होता है, अदरवाइज व्हेन इट इज एक्सपोज्ड टू लाइट it gets disintegrated and it causes cyanide toxicity। To give sodium nitroprusside to the patient, you will have to use not that white wala infusion set। This is again a question, I think NEET PG में था ये, that which infusion set, I mean like the question was which antihypertensive drug is given via a light protected infusion set। नॉर्मली तो इन्फ्यूजन सेट वाइट वाला प्लास्टिक वाला ट्रांसपेरेंट होता है ना, इसका तो काला होगा, ब्राउनिश होगा, एम्बर कलर का होगा, टू प्रोटेक्ट द लाइट। ट्यूबलाइट से भी वो जो दवाई है वो डिसइंटीग्रेट हो जाएगी एंड इट विल कंट्रीब्यूट टू रिजल्ट इन डेवलपमेंट ऑफ साइनाइड टॉक्सिसिटी। If he says how do you manage scleroderma crisis, if he says how do you manage scleroderma crisis, तो crisis वर्ड पढ़ के यहाँ पे सारे स्टूडेंट्स जो हैं या मोस्ट डॉक्टर्स जो हैं वो थोड़ा परप्लेक्स्ड होके दे स्टार्ट आंसरिंग आईवी ड्रग्स, क्योंकि भाई आईवी चल रहा था। दिस इज द ओनली सिनेरियो, दिस इज द ओनली सिनेरियो वेयर in spite of the word crisis will be given, you will not answer as IV drugs, you will give oral drugs for the patient, that is oral ACE inhibitors। सोडियम नाइट्रोप्रोसाइड जो होता है इट शुड बी गिवन फ्रॉम अ लाइट प्रोटेक्टेड इन्फ्यूजन सेट एंड नाइट्रिक ऑक्साइड इज द मॉलिक्यूल दैट इज रिलीज्ड, बट देन देयर कैन बी साइनाइड टॉक्सिसिटी दैट इज हैपनिंग इन अ पेशेंट। एंड इफ ही सेज व्हाट इज द एंटीडोट फॉर साइनाइड टॉक्सिसिटी, देन द एंटीडोट फॉर साइनाइड टॉक्सिसिटी इज नॉट अमाइल नाइट्रेट। द एंटीडोट फॉर साइनाइड टॉक्सिसिटी इज नॉट टू बी आंसर्ड एज antidote for cyanide toxicity is not to be answered as amyl nitrate inhalation। Third one, okay, Dr. Ajmeri, I'll just come back। Third का थोड़ा नाम लिख दो, you know, I could not pick up the third name। Yes, we use vitamin B12। Again, this is an FMG exam question। Antidote for cyanide toxicity is, then your answer would be that I will be using sodium thiosulfate and I'll be using hydroxycobalamin। Third one means which one, bache? I could not understand the third one। 1 2 3 urgency। If you mean urgency, तो it's like not a crisis situation na, so we can use ACE inhibitors in it। Okay, encephalopathy in scleroderma। No, if the person became unconscious, it's a different thing na, but if he just says posterior वाला, एक बार बेटा फिर से टाइप करो, जरा फटाफट से टाइप करो, वे टुवर्ड्स द एंड आई जस्ट एक्सप्लेन दैट अगेन। ओके, क्विकली वेटिंग फॉर योर कमेंट डॉक्टर। Fine. At this moment, what I have done is I have mentioned core aspects, guys, which have tested your pharmacology as well as some of the medicine aspect। अभी कर रहे खत्म कर रहा हूँ। प्रेस, अच्छा प्रेस पूछ रहे हो, पोस्टीरियर रिवर्सिबल, ओके फाइन, प्रेस फिर से बोलता हूँ, प्रेस, ओके फाइन, आई एम डूइंग इट अगेन। पोस्टीरियर रिवर्सिबल एन्सेफेलोपैथी सिंड्रोम में ब्रेन का ब्लड वेसल बर्स्ट नहीं करता। ड्यू टू हाई हाइड्रोस्टैटिक प्रेशर इन द ब्लड वेसल, देयर इज ट्रांसड्यूडेशन ऑफ फ्लूइड आउट ऑफ द ब्लड वेसल्स इनटू द ब्रेन पैरेन्काइमा। इन posterior क्या बोलते हैं, occipital lobe, रिवर्सिबल बिकॉज द स्पैजम इज रिवर्सिबल. वेजोकॉन्स्ट्रिक्शन से तो बीपी बढ़ता है ना. The BP is very high, hydrostatic pressure is more. So yeah, got it. That's what I'm explaining, बच्चे. Press. The meaning of the word press is that what you are doing is posterior मतलब occipital lobe. Reversible because the spasm of the brain blood vessels is reversible. What is happening is that the high blood pressure will cause transudation of fluid out of the blood vessels into the brain parenchyma. So that will be called as vasogenic cerebral edema. For management of vasogenic cerebral edema, that is PRESS, we will not be using mannitol. Mannitol is used in cytotoxic cerebral edema. यहाँ पे why will be used also not use steroids is because you can treat the hypertension, not treat the increased hydrostatic pressure. If you decrease the increased hydrostatic pressure, then the chances of further worsening of cerebral edema will reduce. The question will begin with person. Known case of hypertension comes with blurring of vision. Along with that, the person has become unconscious because the blood supply critically is reduced due to the spasm of the brain blood vessel, which is a protective spasm. This guy is super lucky. वरना दिमाग का नस फट जाता. This guy is super lucky. How is he different from stroke is, in hemorrhagic stroke, the brain blood vessel boom. In hemorrhagic stroke, written superiorly, boom, brain blood vessel gone. Here blood vessel has undergone a protective spasm. Difference. I hope it's clear, guys. Can I have a quick thumbs up? Hemorrhagic stroke, bursting of blood vessel, press, spasm, high pressure contributing to increased hydrostatic pressure, and that high hydrostatic pressure is causing leakage of fluid into the interstitial space of the patient. Treat the patient by contracting that, taking care of that spasm. Posterior बोलते हैं occipital lobe की वजह से. MRI will be showing vasogenic cerebral edema in the occipital lobe as well as in the parietal lobe of the patient, and that's why like there can be sometimes difficulty in speaking also, and then the guy will become unconscious. ओके दिवांशु, I'll come to you. रिफ्रैक्टरी हार्ट फेलियर तूने अभी पूछा, अभी बताता हूँ, जस्ट 2 मिनट दे दे. या Charan Tej, now you getting a hang of it, ना. Pregnancy induced hypertension, they're gonna put up situations like this. Okay जी, malignant hypertension will have retinopathy findings given. Even nephropathy can be present. I mean all kind of pathies will be there. So these are a couple of miscellaneous datas which are present. Okay, so like you asked for refractory heart failure in a patient. Refractory heart failure means the Y is not improving. So for refractory heart failure, what we can do is CRT, that is cardiac resynchronization therapy. What do you mean by cardiac resynchronization therapy is that left and right ventricle in heart failure is not working together. So we will be putting a pacemaker in the heart which will ensure both ventricles will be contracting together. That will reduce the pulmonary edema and improve the cardiac contractility. So cardiac resynchronization therapy can be used, that is ensuring that the ventricles will be able to fire simultaneously. If the person is having arrhythmias, then I will use CRTD. CRTD होता है cardiac resynchronization therapy with implantable cardioverter defibrillator that ICD will deliver a DC shock and will terminate the arrhythmia. Another approach is we can use LVAD. LVAD होता है left ventricular assist device. Medical science is years away from manufacturing. Medical science is years away from manufacturing an artificial heart, but we have manufactured an artificial left ventricle. So this comes with the brand name of HeartMate. When you will do the Google search for HeartMate, तो उसमें तो पहले तो वो डेटिंग वाली साइट्स आ जाएंगी, है ना. HeartMate ना, दिल का मेट बना रहा है तो वो डेटिंग वाली साइट्स मिल जाएंगी. लेकिन जब और नीचे गूगल में सर्च रिजल्ट में देखोगे तो HeartMate का मतलब होगा लेफ्ट वेंट्रिकुलर असिस्ट डिवाइस. हितेश किस चीज का रिपीट करना है? अच्छा चल CRT में फिर से बोलता हूँ भाई. लेफ्ट और राइट फ्लैबी हार्ट है, डैमेज्ड हार्ट है, लेफ्ट और राइट वेंट्रिकल एक साथ कॉन्ट्रैक्ट करते हैं. इसका एक कॉन्ट्रैक्ट किया फिर दूसरा किया, ये कॉन्ट्रैक्ट किया फिर दूसरा किया. दोनों को एक साथ कॉन्ट्रैक्ट कराना है. CRT, कार्डियक रीसिंक्रोनाइजेशन थेरेपी. योर एंड माय वेंट्रिकल contract together. So the pacemaker that does that activity of making them contract together, cardiac resynchronization therapy. Some patients have tendency for arrhythmia, so we will put ICD system again in the same device that can deliver a DC shock. So CRTD, and the last is LVAD, that is left ventricular assist device. Ejection fraction, बच्चे ejection fraction एक फॉर्मूला होता है, stroke volume divided by end diastolic volume. Stroke volume होता है 80 ml, end diastolic volume होता है 130 ml. दिक्कत क्या होती है कि अगर दोनों कम हो जाएं, नॉर्मल वैल्यू है 65% ना, इट इज अ रेशो. In patients who are having hypertension, what happens is less comes in the heart, less goes out of the heart also, so ejection fraction remains falsely normal. It is not gonna be a very good way to identify that how the heart is performing. That is why, no, like somebody was saying क्या करेंगे, तो हम PET scan करते हैं ना viability of the cardiac tissues के लिए. Ejection fraction is just one of the way that would be helping here to identify the aspects there. So refractory heart failure doubt आया तो वो पूछ लिया. तो अभी फटाफट से हिस्टोपैथोलॉजी करनी है गाइस. वी विल बी डूइंग वन मोर स्लाइड, दैट इज द एंड ऑफ द टुडे. आई थिंक इट्स ऑलमोस्ट गोना बी 8 o'clock. ओके, सो आई एम गोना टेक अबाउट 3 minutes of your time, 2 to 3 minutes of your time, and we're gonna do this. And because tomorrow I'm gonna start with cardiomyopathy, so let's do one more slide, the last one for today. And I think everybody can identify the helter-skelter appearance. Everybody can appreciate the helter-skelter appearance of the myocytes, like in a very crisscross fashion. Like this is not how the cardiac fibers are supposed to be. They are supposed to be working in a synovium. And then you can also notice the hypertrophy of the septum. You can notice the free wall hypertrophy. So this is a specimen of hypertrophic cardiomyopathy. Moving to the next one. Hit the comment button for your diagnosis. Hit the comment button for your diagnosis. Yes. हाइपरटेंसिव अर्जेंसी बेटा इज एमरजेंसी होती है जहाँ पे आईवी दर्द रख देते हैं. अर्जेंसी होती है जैसे पेशेंट आया सिर दर्द के साथ 250/150, चलते चलते आए, अंकल जी कह रहे गैस की प्रॉब्लम है. मैंने बोला शाम को क्यों आया एमरजेंसी में? कह रहा गैस सिर में चढ़ गई. हैं? कह रहा सर गैस सिर में चढ़ गई. हाइपरटेंशन में हेडेक होती है ना, तो नॉन मेडिकल लोग पता क्या बोलते हैं, गैस की प्रॉब्लम ना, गैस जो है मेरी दिमाग में चढ़ गई, उसको होता है हाइपरटेंसिव अर्जेंसी. 250/150 वॉक इन इनटू द कैजुअलिटी, नो अनकॉन्शियसनेस, दैट इज अर्जेंसी सर. या बनाना शेपर्ड कैविटी ऑफ द हार्ट कैन बी प्रेजेंट. परफेक्ट. आई होप इट्स क्लियर बच्चे. द हाइपरटेंसिव अर्जेंसी पार्ट, अर्जेंसी इज व्हाट द पेशेंट इज क्रिएटिंग. BP is 250/150. He doesn't take medicines for hypertension regularly. Yes, the second one please. Atria are bigger. Atria are bigger than the ventricles. If you check out the size here, they given a specimen जहाँ पे atria का size ventricles को exceed कर रहा है. That is because of the fact that there is a fibrosis in the ventricles. The atrial side, peripheral resistance तो बेटा blood vessels है ना, arterioles constricted होते हैं. आपने बोला पेरिफेरल रेजिस्टेंस कैसे करती है हाइपरटेंशन. आयोटा को नैरो कर दो ना, कोई भी ट्यूब है नैरो कर दो, पेरिफेरल रेजिस्टेंस ट्यूब को नैरो कर दोगे तो आगे का प्रेशर, पीछे प्रेशर बढ़ना शुरू हो जाएगा. Atrial size is more than the ventricular size. This is a characteristic feature of restrictive cardiomyopathy because there is a fibrosis in the wall of the heart. Even if there is gonna be fibrosis, there's gonna be like fibrosis may not be visible on a like a routine naked eye examination, but when you look at the data, you will notice that there is lot of pink material present between the myocytes which are undergoing a lot of atrophy. This pink material that is present is amyloid protein. The rarest cardiomyopathy का जो most common cause है, that is amyloidosis. This is the rarest cardiomyopathy. I should write on this side RCM. This is restrictive cardiomyopathy. This is the rarest cardiomyopathy और इसका जो most common cause होता है, that is gonna be answered as amyloidosis. Now I will come to the third one in which there is a big patla heart. Patla heart matlab there is a, like you know, if the muscle wall has become relatively more thinner, the muscles of the heart have become, no ये Congo red वाली stain नहीं है ना यार, ये तो routine हेमोटॉक्सिलिन नियोसिन वाली stain है. It's not a Congo red. वरना तो एप्पल ग्रीन बायो रेफ्रिजरेंस आ रहा होता ना. सो दिस वुड बी यस. यहाँ पे यूजुअली जो टर्म लिखा होता है दैट इज ग्लोबल हाइपोकाइनेसिया. सो इसके टेक्निकल एस्पेक्ट्स भी कल डिस्कस करेंगे, बट फॉर टुडे आई वांट यू टू रिमेंबर दैट द वर्ड्स यूज्ड इन द क्वेश्चन विल बी ग्लोबल हाइपोकाइनेसिया. Yes, it is global hypokinesia. And what is the histopathology finding here? Yes, what is the histopathology finding here? और यहाँ कोई स्टार वार नहीं है तो प्लीज टाइटन स्टार मत बोलना. वेटिंग फॉर आंसर्स है. ग्लोबल हाइपोकाइनेसिया, डायलेटेड कार्डियोमायोपैथी. व्हाट इज द हिस्टोपैथोलॉजी फाइंडिंग? वेटिंग फॉर आंसर्स गाइस. ये मायोसाइट मोटे लग रहे हैं ना, कुछ पतले हो गए हैं. नो नो नॉट लीकी, कुछ तो डैमेज हो गया ना. जैसे ये ज्यादा पिंक है तो डिस्ट्रॉय हो गया और ये वाला ज्यादा मोटा हो गया. दिस इज हाइपोट्रोफी ऑफ द मायोसाइट्स. आपके एग्जाम में सिर्फ ये स्लाइड दी थी और पूछा कि कौन सी कार्डियोमायोपैथी के, तो मोटे मोटे सेल दिख रहे थे तो स्टूडेंट्स ने मार्क किया हाइपरट्रॉफी कार्डियोमायोपैथी. नो, इट इज अ कॉम्पेंसेटरी हाइपरट्रॉफी ऑफ द वायबल सेल्स. या इसमें देवर मोटा मोटा सेल्स विजिबल. सो इट इज हाइपोट्रॉफी ऑफ द वायबल मायोसाइट्स, क्योंकि बाकी तो मर गए ना, तो बाकी वाले जो सेल्स है वो तो डैमेज हो गए क्योंकि पेशेंट ने CABG नहीं कराया था. जैसे अभी एक यंग डॉक्टर ने केस पूछा था मुझे ना कि सर वो उनका इजेक्शन फ्रैक्शन सिर्फ 25% आ रहा है तो हम क्या करें. तो उनमें हुआ क्या है कि देयर इज अ डायलेटेड कार्डियोमायोपैथी हैपनिंग बिकॉज उनका सर्जरी टाइम पे उनका CABG हुआ नहीं था टाइम पे. तो अभी डबल वेसल डिजीज जो है वो प्रोग्रेस कर गया. Come on, come back. So there is a hypertrophy of the remaining myocytes, of the viable remaining myocytes. This is a feature that will be seen in patients of dilated cardiomyopathy. Yep. Fragmented, हाँ बेटा, fragmented nuclei इसमें दिख नहीं रहा है. वो जो स्लाइड मैंने आपको उसमें दिखाई है ना मेन वीडियो में, उसमें अनफॉर्चुनेटली इस वाले में दैट फ्रेगमेंटेशन वाज नॉट प्रेजेंट, सो दैट्स व्हाई आई थॉट आई शुड मेंशन इट. तो चलो जी, लास्ट स्लाइड है आज के लिए. I'll not say anything. I give you 15 seconds and I expect you to answer in this particular case. इसका केस 2021 में आया था. There is a football, especially boys and those of you love football. This guy was playing football for a European football club. He collapsed on the pitch. He was given CPR and luckily he recovered, and then it was found that he was having this particular condition where there was fat deposition in the right ventricle. There was fibrosis also present. For fibrosis you need a Mason trichome stain, but at this moment it's not a Mason trichome stain. So this is ARVD, arrhythmogenic right ventricular dysplasia. The highlight of arrhythmogenic right ventricular dysplasia is that there is a fibrofatty deposition in the right ventricle of the patient, in which the ECG finding is called as epsilon wave. I will be showing the ECG finding with you or discussing the ECG finding with you tomorrow. But for today, what I want to do is like end at this particular point of time from the histopathology perspective. जब ये PDF आएगा तो what I will do is कि ये जो 2-3 स्लाइड्स मैंने करी है ना, इनको कैसे डालूंगा मुझे समझ नहीं आ रहा क्योंकि बीच में कुछ एरिया तो वेकेंट है. तो what I can do is I can send up to page number, I will send files up to page number 33, जहाँ तक मैंने मार्किंग सारा कर दूंगा. बीच में जो ब्लैंक है, आई होप इट इज क्लियर दैट वी विल बी कवरिंग दैट अप टुमारो. सो आई विल बी सीइंग यू टुमारो अगेन एट द सेम टाइम, दैट इज 12 o'clock ऑनवर्ड्स. वी आर गोना बी रिज्यूमिंग एंड वी विल टेक केयर ऑफ सम मोर कार्डियोवास्कुलर एस्पेक्ट्स एंड आई ट्राई टू इनकॉर्पोरेट न्यूरो नहीं करेंगे फिर क्योंकि स्ट्रेस हो जाएगा. तो आई ट्राई टू डू एंडोक्राइन वाला सिस्टम. सो डू रीड अप डायबिटीज मेलाइटस एक्सेट्रा इफ यू गेट टाइम and like try to do the previous year questions, those 140 150 which are present here. One more slide, you want to discuss one more slide? Okay, यार 12 o'clock ही start करेंगे यार, otherwise ना logistics मेरे workout नहीं होंगे. So we start at 12, we do till 8, right? 11 to 7. चल कल मेरी बात मान जाओ, परसों मैं आपकी बात मान जाता हूँ, है ना. कल 12 to 8 कर लेते हैं. मैंने शेड्यूल एक्चुअली भेज दिया था अपना. सो इट इज़ 12 to 8 फॉर टुमारो. परसों से आपकी बात मान ली मैंने, 11 to 7 कर लेंगे, राइट. सो थैंक यू गाइस एंड द PDF विल कम इन द लिंक विच इज़ प्रेजेंट इन द वीडियो इज़ प्रेजेंट. अगर आप दिक्कत हो तो marvamedicine@gmail पे मेल कर देना. आई विल बी ग्लैड टू सेंड यू द ईमेल अक्रॉस. बट अभी 1-2 घंटे का टाइम दे दो यार, इमीडिएटली तो नहीं कर पाऊंगा बिकॉज आई हैव टू सेंड अ मेल अक्रॉस एंड देन दीज गाइज विल प्रोसेस. सो कोई नहीं यार, वो तो इट्स म्यूचुअली एडजस्टेबल, ऐसा कुछ भी नहीं है. सो इट वॉज रियली फन गाइज इंटरेक्टिंग विद यू गाइज आफ्टर इनफैक्ट इंटरेक्टिंग विद यू फॉर द फर्स्ट टाइम एट द मोमेंट. तो कोई बात नहीं, राइट. See you guys. Tomorrow is 12 o'clock, guys. 12 to 8 is the tomorrow's time. I'll write it over also just in case there is any confusion due to English and Hindi part. So this 12 to 8 is the time that we are discussing for tomorrow. God bless you. If you have any doubts, marvamedicine@gmail.com. Telegram is another way. But after 2 hours, the PDF will be available in the link as day 1 annotated. If you click on the unannotated link, it would be total. If you click on the day 1 annotated, up to page number 33 would be coming. So see you there. I missed a couple of chats there. Okay, so I missed couple of things there, but it's okay, guys. I think. Chalo, take care. Bye bye.